Good morning, everyone. The topic of my paper is comparative study of prenatal ultrasound markers for prediction of respiratory distress in early preterm newborns. Um, as we know that preterm delivery has become the leading cause of perinatal mortality and morbidity worldwide, and it complicates 5 to 18% of pregnancies. Among all complications, the most immediate and common complication is the respiratory distress, which is reported in 0.69 to 8.3% of the neonates. So effective prediction of respiratory distress has become very important, and it can be done by prenatal ultrasound markers, that is fetal lung biometry and pulmonary artery Doppler. The sample size of my study was 100. The type of study was analytic prospective study. The inclusion criteria were antenatal women with a period of gestation between 28 to 34 weeks and who were expected to deliver within 72 hours, singleton pregnancy, and those who were giving consent for this study. We excluded those who had oligohydramnios, any kind of fetal malformation, presence of chorioamnitis, and meconium stained liquor. A two-dimensional transabdominal ultrasound was done, and the fetal lung biometry parameters were evaluated, which included thoracic circumference to abdominal circumference ratio, lung head ratio, the lung length of the right side of the fetus, and fetal lung area of both sides, fetal lung volume. A color Doppler was performed from the main fetal pulmonary artery for evaluation of parameters, pulsatility index, resistance index, systolic to diastolic ratio, and acceleration time, ejection time ratio. The figure 1 shows the fetal lung length being measured in sagittal section, and figure 2 shows the Doppler parameters being recorded from the main pulmonary artery, identified by its characteristic spike and dome pattern. Now coming to the methodology, 100 antenatal women between fulfilling the exclusion and the inclusion criteria were taken as subjects, and the ultrasound was performed for evaluation of fetal lung biometry and pulmonary artery Doppler parameters. After the delivery, which had to happen within 72 hours, the newborns were evaluated for respiratory distress. Those newborns who had respiratory distress were grouped under cases, where the rest of them who did not have respiratory distress were grouped under controls. The comparison of the prenatal ultrasound markers done before were done between the cases and controls using appropriate statistical analysis. Now, coming to the result, there were 36 cases and 64 controls. On evaluation of fetal lung biometry parameters, we found that all the parameters were statistically significant with p-value less than 0.01. And on construction of ROC curve, they showed a fair to high degree of accuracy. The most sensitive parameter, the highest sensitivity and the negative predictive value was that of fetal lung volume, and the highest specificity and positive predictive value was that of right lung area. Overall, the highest diagnostic accuracy was that of fetal lung volume, being 78%. This is a figure showing the ROC curve of fetal lung length and fetal lung volume, which showed area under curve of zero point 0.8, having high degree of accuracy in predicting respiratory distress. On comparison of pulmonary artery Doppler parameters, we saw that only acceleration time ejection time ratio was statistically significant with a p-value less than 0.001. Rest of the parameters did not attain clinical statistical significance. However, the pulsatility index has highest sensitivity, whereas the specificity and negative predictive value was highest for resistant index. The positive predictive value was highest for acceleration time ejection time ratio, with overall highest diagnostic accuracy of 68%. This is the ROC curve of acceleration time ejection time ratio, with area under curve being zero point 0.8. Now, coming to the discussion, very few studies have evaluated some of the parameters of fetal lung biometry. Our result was comparable to those obtained by Yoshimura et al., who evaluated TC by AC ratio and fetal lung area, and they have also got high diagnostic accuracy of these parameters in predicting respiratory distress. Similarly, Robert et al. Had just evaluated fetal lung length, and he found that it was a useful predictor for respiratory distress. We have used a new parameter, that is lung head ratio, in predicting respiratory distress. Earlier, these parameters have been used for prognostication of congenital diaphragmatic hernia. And the new, fetal lung volume in our study was calculated by the formula given by Moiglin et al. That was in two-dimensional formula. Now, coming to pulmonary artery Doppler, many studies have been done, but variable results have been found. The result of our study was comparable to that obtained by Kim et al. And Duke et al., who also found only acceleration time ejection time ratio to be statistically significant, whereas the rest of parameters did not prove so important in predicting respiratory distress. However, Moiti et al. Also did the same similar study, but he found pulsatility index and resistant index to be also useful predictor of respiratory distress, unlike our study. Now, the strength of our study lies in simultaneously estimation of multiple fetal lung biometry and pulmonary artery Doppler parameters, which is a new study. in the Indian population, and the comparison and external validation of all our markers for prediction of respiratory distress was done. The limitation lied that the prediction of respiratory distress has not been done according to standard scoring system. So I would like to conclude by saying that the fetal lung biometry and pulmonary artery Doppler can offer an excellent non-invasive approach for assessment of fetal lung maturity, which we have clinically assessed by respiratory distress. Among all prenatal ultrasound markers that we have studied, we found fetal lung volume and AT-AT ratio showing highest degree of accuracy, being 78 and 68% respectively in prediction of respiratory distress. So we propose that the above parameters can help in determining the optimal timing of the delivery and can help us to take timely intervention and appropriate referral to the higher center. This is more important in a low resource country like India, where already the burden of neonatal morbidity and mortality is very high. Thank you, ma'am.
Was Shama. I think Shama, you were very nice, but I just wanted to ask you something. You have considered IUGR and twins also in your study?
No, ma'am. It was
No.
singleton pregnancy. The inclusion criteria was singleton pregnancy, and we have included FGR, but they had to have. They were supposed to be between 28 to 34 weeks only, and
Because I,
without
Can't
any
hear you
pregnancy.
well. Speak a little
Uh,
louder. What
ma'am,
was
am
the,
I?
yes,
yeah, yeah, better.
the
Yeah.
duration of
Okay,
pregnancy was from
ma'am.
28.
28 to 34 weeks.
28 to 34. That was
And
okay.
steroids were given to all of them.
Yes, ma'am. That is by the general protocol of our study that in of our management also that any patient before that any period of gestation before 34 weeks are given steroid cover.
Because, in IUGR, the chances of RDS are much less as compared to non-IUGR
Yes,
babies.
ma'am. Oligohydramnios was the only exclusion criteria because there the chances are invariably high of MSL and consequent respiratory distress, but FGR was included in our study.
So,
Doctor, you
Shama,
said
I
that
have a.
you, please go ahead.
Ma'am, please, you please first answer.
Okay. So, Dr. Sharma, you said that you expected delivery within 3 days, right?
Yes,
72
ma'am.
hours.
Yes, ma'am.
So, would you think that it would have been better to do these ultrasound markers at the time of delivery? That will be difficult. You're
Yes,
working
ma'am.
in a good center.
Yes, ma'am. It was a bit difficult. That is why we kept the time to be.
So,
We
those
kept
who did not
time
deliver
of
within
CCR.
72 hours were excluded
Ma'am,
from the study.
yes, ma'am. Yes, ma'am.
And did you think of getting the texture of the lung volumes also done? Because there's a lot of study on this.
Yes, ma'am. The texture of lung volume was considered at first, but later it became technically difficult. So we
Okay,
went ahead only with the lung volume only,
lung
and that
volume.
too was calculated on a two-dimensional using a
I think ma'am, her
two-dimensional
time is over.
formula.
Yeah.
Yeah, I think we can move to next.
Thank you, Dr. Sharma.
Thank you, ma'am.
Well done.
Yes, thank you so much, ma'am.
Now, can I ask Dr. Nilofer if you're ready?
Shama, you stop
Yes,
sharing your screen
ma'am.
first.
Ma'am, I've stopped.
Yeah. Dr. Nilofer, are you ready?
Yes, ma'am.
So please start sharing your screen.
Ma'am, is it visible now?
No, we still don't see you.
Ma'am, it is again showing the share screen has been failed. I don't know why.
No, I think I'll move on to Dr. Alpana Singh. Dr. Alpana, are you there? Dr. Alpana?
Hello. Hi. Yes, ma'am.
Dr. Alpana, you start sharing your screen. We'll start with you then.
Okay, fine, ma'am.
Okay. So I welcome Dr. Alpana. Her title of topic is Rare and Deceptive Cause of Hypertension in Pregnancy. And her paper code is HRP, that is High Risk Pregnancy 0103. Right,
Ma'am, my
Alpana?
screen is visible. Ma'am, my screen is visible.
No.
No.
Okay, just wait, ma'am.
Yeah.
Now it's
Yes.
visible.
Yes,
Yeah, we
please
can
start.
see you, Alpana. Please start. Your time starts now.
Good morning, everyone. Myself, Dr. Alpana Singh from GTB Hospital. I'm going to present an interesting case on a rare and deceptive cause of hypertension in pregnancy. I'm presenting a case of Mrs. X. She was 19-year-old, primary gravida, booked at the dispensary, and she was presented in GTB hospital at 29 weeks period of gestation with complaint of pain, abdomen, bleeding, PV, decreased fetal movement for 3 hours. Along with that, she was having severe headache and the blurring of vision for 15 days. But there was no history of epigastric pain, nausea, vomiting, decreased urine output, and edema. And there was no past history of hypertension, diabetes, TB, or seizure disorder. Family history was also not significant. In the trimester-wise history, she was booked in the second trimester in the nearby dispensary of her home, and her BP was normal in the first and second trimester. In spite of that, she was having off and on headache and the blurring of vision, which was gradually increasing. But in the third trimester, she was having episodic hypertension and headache and loss of vision, along with the complaint of bleeding and pain abdomen. At admission, her BP was 200 by 135. Other than that, her basic antenatal investigation was and ultrasound was normal, and she received iron, folic acid, and immunization. At admission, her GCS was 15 by 15, pulse rate was 19, and BP was 200 by 135, and repeat was also suggestive of malignant hypertension. There was no pallor, ictus, and pedal edema. Pupil was also normal size and normally reacting. Breast, thyroid, chest, and CVS were normal. In her per abdominal examination, uterus was 30 weeks size, stone was raised, and breech presentation with fetal heart rate was 138 beat per minute. In per speculum examination, cervix and vagina were normal, mild bleeding PV through the os. In PV examination, cervix central, medium consistency, os was closed, uneffaced, and suggestive of poor biceps, pelvis was adequate. So provisional diagnosis of breech presentation with impending eclampsia with the query revealed abruption was made, and in her investigation, LFT had the mildly deranged liver enzymes. ECG was suggestive of ST segment depression, and urine albumin was 3, and in the fundus there was a grade 4 hypertensive retinopathy. So in the line of impending eclampsia, we have started a management by giving the Maxad loading and followed by the maintenance dose, IV labetalol, and induction of labor with misoprostol was started, and 5 doses was given, but she landed in the failed induction. Section was done, and retroplacental clot of 100 cc was noticed, and the baby was 1 kg, which was expired due to the extreme prematurity. So in her postpartum course, she was on the antihypertensive like amlodipine, Lasix, but we have also started on the Enla pill because BP was not controlled. You can see here clearly. So in hypertensive workup, echo was suggestive of the cardiomyopathy, and ultrasound was eye opener for us. It was suggestive of right adrenal adenoma. So further confirmation was of the diagnosis was planned by the urine catecholamines and MIBG scan, but it was not available in our hospital, and patient was not affording. So decided for the go for the CT abdomen for the diagnosis, which was suggestive of 4 into 4 centimeter right adrenal adenoma. So we were able to make her final diagnosis on day 15 of LSES with the right adrenal pheochromocytoma. So our further plan of management was the surgery, definitive treatment, but pre-operative optimization of the patient is very challenging in these patients of the pheochromocytoma, because we have to monitor her supine and standing BP to prevent the orthostatic hypotension and optimize the patient for the surgery. It takes around 2 to 3 weeks. So we have to give 2 to 3 liters of the water per day and the 6 gram of salt daily, and we have to correct the hyperglycemic episodes by giving the intermittent insulin. So this BP chart of the supine and standing position very clearly depict that in the initial part of the optimization, her gap between the supine and the standing were more, but in the later part of the control, it becomes just overlapping in the systolic as well as in the diastolic part, which was suggestive of the good control of the BP and orthostatic hypertension. Her surgery was done by the open method. Right adrenal anelectomy was done under GA, and this is the gross specimen, and diagnosis was confirmed by the gel valent pattern on the histopathology. Post of course was uneventful, and she was discharged on the day 8 of the surgery. In the follow-up period, immediately after the post-op, from the very first day, her blood pressure becomes normal. She was off all the antihypertensive. Blurring of vision improved from the second weeks of the after the surgery, and fundus also suggestive of the grade 3 hypertensive retinopathy, which was improved. ECG and echo become normal. So this case was brought here because of the rarity of the this entity, and also the challenges we faced in the management and the diagnosis of this patient. As we all know, pheochromocytoma is a catecholamine secreting tumor. It may be the adrenal origin or the extra-adrenal origin. Most likely it is sporadic in the nature. It is in etiology around 75% cases, but in the hereditary in 30% cases may be associated with the MEN type 2, multiple endocrine neoplasia 2, or the von Hippel-Lendau syndromes. In the pregnancy, pheochromocytoma is a very rare 1 in 54,000, and in the hypertensive disorder of pregnancy, it is 0.1 to 0.6%. It is very lethal tumor, you can say, because if undiagnosed and untreated, it can cause a 40 to 50% mortality. If you treat properly and diagnose timely, then 5 to 15%. So pregnancy with PCT is a dangerous combination, and in pregnancy, it can causes to the mother hypertensive crisis, or maybe the cardiomyopathy, like in my patient, acute coronary syndrome, arrhythmia and stroke, in the fetus, abruption, hypoxia, IFD, or the FGR. So how to diagnose clinically? Like if any patient having the hypertension, persistent hypertension, and from very early gestation, you have to rule out by the proteinuria and ankle edema. It is not present in the cases of pheochromocytoma like in our case, but it has a combination of headache, sweating, and palpitation. This is, or maybe the episodes of the hyperglycemia and cardiomyopathy like in our patient. Family history, because it runs in the hereditary, it has a genetic in origin also in the 30%, and some phenotypic features like the Kaposi spots, freckles are also the diagnostic for this. Orthostatic hypertension, if like in our patient, the
Over
first.
now. Dr. Alpana, your time is over. Please keep 2 minutes for the question and answers.
Ma'am, can I just have
Yeah,
a one?
finish it off in 5 seconds.
Okay. So for the diagnostic purpose, like in our case, we use the CT scan. Otherwise, gold standard is the metanephrine, blood or the urine levels, and alpha blockers. Like in the our case, prazosin was the drug of choice for that. And in the pre-surgical optimization, like we have done, is very important. You should be very cautious about giving the beta and dexamethasone, because it can cause the aggravate the pheochromocytoma crisis. And in the timing of delivery, if diagnosed early, less than 24 weeks, you can do the laparoscopic removal of tumor in the pregnancy. In advanced cases, you have to do after the surgery or along with the cesarean section. So mode of delivery is the preferable is now is the vaginal delivery, because complication with cesarean has a more, and in the vaginal delivery, if you use the epidural analgesia, the patient will be quite safe, and we can avoid the post-op complications. So carry home message is this: if timely diagnosis of the pheochromocytoma, we can manage it, and we can improve the fetal-maternal outcome. And always the pregnancy in hypertension cannot be the gestation or preeclampsia. It may be something else, like in our case. So we have to think other than the normal causes of the hypertension in the pregnancy. This rare entity can be.
Thank you, Dr. Alpana. Judges, you can please start the questions.
I think Alpana, you made a diagnosis on the 15th day, na?
Yes, ma'am.
Yeah, because with the loss of vision and everything, it took a little long time to settle. But I do understand sometimes the sources are not available. So
Yes.
Because, ma'am, we kept the diagnosis of impending eclampsia, and in the post-op period, we tried to just manage on the antihypertensive, and we are expecting for the normal recovery, like in the normal PIH patient. But from the day she was started having the hypertensive episodes and all, in spite of the day 9 post-op, then we started the working for other thing also.
So basically, if the patient doesn't respond in 48 to 72 hours after the delivery, one should look for other causes.
Yes, ma'am.
Yeah.
So we have to, and the blurring of vision she was having from the first and second trimester, that was also the alarming sign of the
Yes.
orthostatic hypertension.
That was ignored.
Yeah,
It was
it should
ignored.
always be.
And there was history of headache also in
Yes,
the
ma'am.
previous
But the headache
trimesters.
was very, she went to the private practitioner also in the dispensary, also consulted for the headache and the blurring. They said it is a non-specific pregnancy changes, because she was having normal BP. So because she was in the pheochromocytoma, catecholamine release is episodic. So she have a episodic rise of BP initially. In the third trimester, it aggravates the symptom. So she might be missed in the first and second trimester.
Yes.
That time she was in the phase of orthostatic hypotension rather than the hypertensive phase. So that's why the diagnosis was missed. So you have to think a rare thing also, if there is something unusual or something common persisting in your case.
I think we can move on to the next one.
Yes.
Okay, thank you, ma'am.
Yeah, you can stop sharing your screen.
Yeah.
And all participants, please note, stick to your time, because you are being judged on the basis of the time utilized by you. Okay, so please stick to your time so that you get enough time for the judges to ask questions. Okay, so Dr. Nilofer, are you ready yet? Dr. Nilofer,
Yes, ma'am.
can you share your screen?
Ma'am, can you see it now?
No. Start your video first. Start your video first.
I think, Sharmishta, there is some problem.
I think, ma'am, I'll call the next candidate. I'll take her at the last. I mean, I'll give her the last slot then. Okay.
Yeah.
Dr. Saloni, please start sharing your screen.
Yes, ma'am.
The topic of her presentation is maternal and fetal outcomes in pregnancy with COVID-19, a retrospective analysis, and her paper code is HRP 0104. Is it all right, Saloni?
Yes, ma'am.
Yeah. You can straight away start with your presentation.
Yes, ma'am.
Okay, good. All the best.
Thank you, ma'am. Good morning, everyone. The topic of my presentation is maternal and fetal outcomes in pregnancies with COVID-19. It was a retrospective analysis conducted in UCMS and GTB Hospital. So as we all know, the last few months have been tough for all of us. COVID-19 virus has gripped the entire world into its tight claws, and the virus is new. So we need more and good studies for the better treatment prospects. So there is definitely a need of evidence-based medicine for the treatment prospects. As it is thought to be in pregnancy that there are physiological, immunological, and anatomical changes which can make a pregnant population more vulnerable to severe outcomes. But as far as now, we have insufficient information on this. In the review of literature, we have few systematic reviews and studies also that showed that majority of the mothers had no complications, but vertical transmission could not be ruled out in some. Some suggested no vertical transmission.
Saloni, sorry to interrupt. We can't see your slideshow.
You can't see, ma'am?
No, no.
Just a minute. Now, ma'am?
No.
It was... Ma'am, just a minute. Now, ma'am?
No.
I think we can see only your desktop.
Yes.
Ma'am,
The winters are coming. A lot of snow on your desktop.
I don't know why it is not showing. It was earlier showing.
You have shown us previously.
Yes, ma'am.
Yeah.
Sharmishta, can we tell them just to go ahead and read out because there's no point?
I think, Saloni, you continue with your presentation because there is only 4 minutes left.
Oh,
Okay.
yes, ma'am.
So be
But
loud
can you
and
see
clear.
now?
No. We still don't see you.
But you can hear me, ma'am, right?
Yeah.
Yes, we
see
can hear you.
So you continue with your presentation and be a little loud and clear. Okay.
Okay.
And, okay. So that the message goes to the judges so that they can ask you a question later on.
Okay, ma'am. So the aim of our study was to study maternal and fetal outcomes in pregnancies with COVID-19 infection with objectives of studying socio-demographic characteristics, obstetric profile, clinical disease pattern, and to identify risk factors which were predicting for adverse maternal outcomes. It was a study retrospective analysis conducted from 1st April to 15th August at GTB Hospital, and sample size was 99 pregnant postpartum females within 6 weeks with COVID-19 infection. We selected study subjects which were positive either by RT-PCR or by rapid antigen test for SARS-CoV-2 on nasopharyngeal and oropharyngeal swabs, and patients who were negative by rapid antigen and they were showing high clinical suspicion, they were subjected to RT-PCR test for confirmation. So information was collected retrospectively from department database and case record files of all the pregnant postpartum females. And they were further classified into 3 categories according to the hospital policies. Asymptomatic mild were category 1, moderate were category 2, and severe were category 3. Severe category included which had severe respiratory distress, those who were in shock, those who were having subnormal mentation, respiratory rate was high, fever was more than 101.5, and SpO2 was less than 90%, and who were in ARDS. We used SPSS version 23 for data analysis. Descriptive statistics were elaborated in the form of mean, standard deviations, and frequencies and percentages for categorical variables. And group comparison was done using independent sample t-tests and non-parametric tests. And statistical significance was kept at p-value less than 0.05. So we classified the results into 3 headings: socio-demographic profile, obstetric profile, and clinical disease profile. So around 230 females with clinical suspicion of COVID-19 were screened at our emergency. In our gynae emergency, testing was done either RT-PCR or rapid antigen. Those who were positive, they were included in the study, which was 99 in number. Those where test could not be conducted or the test result was negative, they were 131 in number, they were excluded. So there were, out of 99, 62 antenatal patients and 37 postnatal patients, which were further classified into mild, moderate, and severe category. Mild were most of them, which was 92 in number, moderate were 4, and severe were 3 in number. In the socio-demographic profile, because you cannot see my charts, I'll just elaborate the salient features. The median age was 26.76 years. Majority were educated, 74% of them. Majority were from urban background, 74%, and majority were not practicing yoga and exercise, 96%. In the obstetric profile, majority were multiparous, 54%. All of 62% of them were antenatal, mostly presenting in 3rd trimester, 53%, and majority had no associated medical or obstetric complications. However, incidence of preeclampsia was high, which was 11%, oligo 3%, GDM 2%. In the overall pregnancy outcome, 39% of them delivered vaginally. However, incidence of LSCS was also high, which was 36%, and 2 most common indications of LSCS were fetal distress and non-progressive labor. There were 3 medical abortions and 2 laparotomies because of ectopic pregnancy. In the clinical disease profile, the mean SpO2 of admission was 98.1%, and 5% of them had significant clinical findings in chest. In the laboratory and radiological parameters, 58% of them had anemia, 10% had abnormal TLC, 4% of them had transient liver dysfunction, 8% of them had thrombocytopenia. However, 90% of them have no COVID changes on X-ray. So overall, 96 of them recovered with no maternal morbidity and mortality, and 3 of them had maternal mortality. When I concluded it, that it was not statistically significant, but there were few risk factors for severe disease, which were all of them presented with moderate to severe symptoms at admission. All of them had SpO2 less than 80% at admission. All required ICU and ventilation from the beginning. They had medical, which was anemia, obstetrical factor, which was preeclampsia, and they all underwent LSCS. So these 3 patients had mortality. In fetal outcomes, testing for virus was performed on all neonates with only one neonate testing positive by RT-PCR, and 30% of the babies were low birth weight. They were either iatrogenic or they went into spontaneous preterm. No neonate had asphyxia. There was no neonatal mortality. HCQS and azithromycin was given to 82% of them. Oxygen requirement was less, 7%. Steroids were also given to less of them, 10%. However, we gave low molecular weight heparin to 75% of the patients. So it was a good study, as in terms it was an adequate sample size. Limitation of the study's incidence could not be known. There was changes over the time in disease patterns, criteria, and the treatment of the disease. So I conclude that COVID-19 infection causes mild disease and does not pose a significant risk to the low-risk pregnant population in India. And likely risk factors for adverse maternal outcomes are anemia as medical condition, preeclampsia, and operative intervention as obstetrical factors for moderate to severe category of disease.
Saloni, your time is up now.
Thank you, ma'am.
Okay, so Dr. Saloni, I have 2 questions for you.
Yes, ma'am.
First thing is, you said that the incidence of preeclampsia and GDM was higher in these COVID positive patients. So
No,
was
it
it
was not higher than the normal population?
So it was not statistically significant, right?
It was not statistically significant, ma'am.
Okay. The second question was, 3 cases were severe cases.
Yes, ma'am.
Were they electively delivered?
Ma'am, one of them was postnatal, 2 of them were postnatal, 1 of them was antenatal.
So antenatal patient was delivered early, prematurely?
Yes, ma'am, because of severe respiratory distress.
At how many weeks?
At 32 weeks, ma'am. But the baby could not survive and the mother also could not survive.
Okay. And the 3 mortalities were first this patient and the 2 patients who had severe symptoms post-natally, right?
Yes, ma'am. They were referred from somewhere else after delivery, day 1 of delivery.
Okay. So mortality, all 3 cases had mortality. All 3 severe cases, only mild to moderate had good outcome.
Yes, ma'am.
Okay, thank you.
Saloni, did you find any patient who had a deep vein thrombosis or a pulmonary embolism out of your 99 cases?
Ma'am, clinically it was not suggestive and we could not conduct CT scan on any of them. Clinically it was not indicated.
Okay. But you gave thromboprophylaxis to all of them after the delivery?
Yes, ma'am. The 75% we gave low molecular weight heparin. The remaining were only the early pregnancies who were not given the thromboprophylaxis. Rest we gave in all.
And how many continued with the pregnancy? Like they became negative and continued without any problems and they delivered later on also?
Ma'am, I have to follow them up. I have still 25 undelivered females.
Okay.
Which I have to follow them up.
So after August, in 1.5 months, if you have delivered somebody, did you find any changes in them? Whether those babies were IUGR or the mother developed preeclampsia? I just wanted to see in 6 weeks, did you find any other further changes in the mother and the baby after the COVID infection?
No, ma'am, I did not do a follow-up yet.
Okay, that's okay.
And only one baby was COVID positive post-delivery?
Yes, ma'am. Only one baby.
Otherwise, all the babies were tested for COVID?
Yes, ma'am. Yeah. It was a hospital protocol to test every neonate.
Yeah. I think we can move on to this next one.
Thank you, ma'am. Okay, Saloni, you can stop sharing your screen because we are still seeing the next topic here.
Ma'am, I have lost the control. I think you can please do it. The tech team can do it.
Let's see. Dr. Ranjan, can you hear me?
Good morning, ma'am.
Good morning. Dr. Ranjan, you can start sharing your screen. Our next, Dr. Ranjan is the next.
It says you cannot share your screen while the other participant is already sharing. So I think, yeah.
She's on board now.
Yeah, fine. Is my screen visible, ma'am?
No.
No.
Yeah, yes. It's visible now.
Yeah.
Okay. Good morning, esteemed judges and organizers. I am Dr. Ranjan from AIIMS, New Delhi, and I'll be presenting on the role of roller gauze abdominopelvic packing in intractable hemorrhage after cesarean hysterectomy for morbidly adherent placenta.
Ranjan, please continue.
Ranjan, your time has already started. You please continue.
Okay, ma'am. Okay. So, coming to the introduction, placenta accreta spectrum includes a spectrum of disorders with abnormal placental invasion. It is a major cause of severe maternal morbidity and mortality, and the incidence and prevalence of this disorder is increasing with global increase in the number of cesarean sections. So, excessive and uncontrolled hemorrhage is the main cause of morbidity and mortality in the situation. In the present case series, we present the role of combined intra-abdominal and pelvic packing as a life-saving approach to manage such a condition. So we present a series of 4 cases with adherent placenta managed by combined abdominopelvic packing with 2 to 4 roller gauze pieces. And 3 of these patients had placenta percreta invading into the bladder and 1 had placenta increta. So this was the case series, and in this retrospective outcome of 4 women with morbidly adherent placenta was done who underwent packing in view of diffuse and intractable oozing from the vault and adjacent areas even after the cesarean hysterectomy. In these patients, 2 to 4 povidone iodine or saline soaked roller gauzes were used, and removal of the gauzes was done 48 hours later through exit sites of the gauze without a need for re-laparotomy for pack removal. A cesarean hysterectomy was done between 31 to 34 weeks gestation in the patients. Prophylactic uterine artery catheterization was done in 2 out of 4 patients. Bladder was injured during separation in 3 cases with placenta percreta, with bladder invasion. And massive bleeding was encountered, and despite cesarean hysterectomy, bleeding from the vault and surrounding areas continued. All medical measures like blood and blood product transfusion and intravenous tranexamic acid were given in all the patients. Immediate repair of bladder rent was done after cesarean hysterectomy in patients with bladder rent, and all attempts to stop bleeding failed. So packing was done, as mentioned before, with 2 to 4 100 centimeters povidone iodine or saline soaked gauze, roller gauze pieces, And the packs were rolled up in the area to be packed, and the tail was brought out of the abdominal wall by passing it through a 1.5 centimeter stab incision in the abdominal wall while it was mounted on a slim hemostatic clamp. So tail of the gauze was knotted to prevent it from slipping back into the abdominal cavity. Patients were kept in ICU for observation till 48 hours when the pack was removed, and again for the next 24 hours after the pack removal. While in the ICU, 12-hourly hematocrit monitoring was done along with monitoring of vitals. Broad spectrum antibiotics were given in all the patients. Pack removal was done 48 hours later in the operation theater under IV sedation without need for laparotomy. On-table observation was done for another half an hour after pack removal. And when no further bleeding was observed, stab incision was closed under local anesthesia. So we have a series of 4 cases. The minimum age of the patient was 23 years and the maximum was 32 years. Previous cesarean, there was previous 1 cesarean in 3 patients and 2 cesareans in 1 patient. Indication was antepartum hemorrhage in 2 patients, preterm labor with antepartum hemorrhage in 1 patient, and preterm labor in 1. All patients were covered with dexamethasone for fetal lung maturity. Blood loss was around it was 10 liters in 1 patient. That was the maximum blood loss, and rest of the patient had a blood loss of around 2 liters. And in the patient with 10 liters blood loss, she received 27 units of packed red cell transfusion along with FFP and platelet transfusion. And febrile morbidity was present in 1 patient, the one with maximum units of blood transfusion. And rest of the patients, like maximum ICU stay was 5 days. So this picture shows the specimen of uterus of one of the patient with placenta percreta. As you can see in the image, the placenta is invading through the serosa. And the second image shows combined abdominal pelvic being done with a roller gauze. This is the post-packing picture. As we can see here, the gauze ends are knotted to prevent relaparotomy and operative mortality due to excessive primary hemorrhage was avoided in all 4 patients. Foley's catheter was removed on day 14 of repair in cases with bladder repair. There was no further complications noted in any of the patients. So coming to the discussion, traditional management of troublesome and refractory hemorrhage of abdomen and pelvis include insertion of topical hemostatic agents and bilateral ligation of uterine or internal ileus. Tackle many bleeding emergencies, but it is not readily available in all settings, and sometimes it is not suitable. So rarely, when a large retroperitoneal vein is involved in an unstable patient with coagulopathy, packing may be the easiest way to control the bleeding, just by a simple effect of tamponade. So temporary packing it is used virtually in all body cavities when uncontrollable hemorrhage is encountered during surgery. It can help control venous hemorrhage when other measures have failed to act as a tamponade. However, traditional packing techniques require a relaparotomy for removal of the packing material. So this modified packing technique presented in this series eliminates the need of relaparotomy for pack removal associated with traditional packing, except in case of ongoing hemorrhage. So none of the 4 patients in our case series had to undergo repeat laparotomy after pack removal. So there are 2 studies, one by Awunuga et al., who performed this technique in 1 patient with cesarean hysterectomy and 3 patients after debulking surgery for advanced gynecological cancer, and none of the patients needed relaparotomy in their study. Another study by Kumar et al. Performed the similar technique in surgery for ovarian cancer, and they could avoid operative mortality due to excessive primary hemorrhage in 14 out of 16 patients. Unfortunately, 2 patients could not survive in their case series. So strength and limitation of the study. Strength was it was a different method of technique, a packing technique, and it omits the need of relaparotomy for pack removal and morbidity associated with it. And limitations being it is a case series with no
move
control.
your slides. Move your slides.
Yes, I'm moving, ma'am. I'm moving. Yes, ma'am. Coming to the conclusion, combined abdominopelvic packing can achieve acceptable results in patients with severe primary hemorrhage during surgery for past disorders. Being a simple technique, inserting the pack as described should be considered early before the patient becomes unstable, so that the amount of blood transfused and ICU stay post-operatively can be reduced. Yes, ma'am. Because of the concerns regarding possibility of secondary intra-abdominal infective complications, broad-spectrum antibiotics should be given in all cases, and packing should be used in rare clinical situations where discrete bleeder is not identified and patient's hemodynamic state worsens while on the operating table. Thank you.
Thank you, Ranjan.
Thank you.
I request to everybody on time, otherwise you will lose your marks on that.
So, Dr. Ranjan, the decision to do the hysterectomy was done. What is the interval between the cesarean and hysterectomy?
Ma'am, in all
C-section, yes.
Yes, ma'am. All patients, 3 patients had placenta accreta, so decision for hysterectomy was taken immediately after that, and one with increta also. In her also, decision for cesarean hysterectomy was already taken, ma'am. Increta was diagnosed pre-operatively, ma'am.
So there was not much of time gap.
Yes, ma'am. Just all the bleeding, massive bleeding happened after cesarean hysterectomy in all 4 patients, ma'am.
Were the patients assessed for any abdominal compartment syndrome?
Yes, ma'am. There were no other complications post cesarean, ma'am. Post cesarean hysterectomy.
So, Dr. Ranjan,
Yes,
was internal iliac artery ligation done before deciding to put a roller gauze?
ma'am, it was done in 2 patients, ma'am.
So, internal iliac artery ligation was done, followed by packing.
Yes, ma'am. Yes, ma'am. And these were 2 patients who did not have uterine artery embolization, ma'am. 2 patients had uterine artery catheterization followed by embolization on the table. And 2 patients did not have, because they came with a massive bleeding before delivery. So in those 2 patients, internal iliac ligation was done.
And once the packing was done, was any other resuscitative measure taken? Or that was it? You felt that once the packing has been done?
Transfusion. Yes, ma'am. Just blood and blood product transfusion. And yes, ma'am. Yes, ma'am.
Just the pharmacological treatment support was given.
Yes,
so, yes, Dr. Ranjan, 4 roller gauze, 100 centimeter was sufficient for packing?
Yes, ma'am. Yes,
because you said abdominal packing also. So where you packed actually?
4 gauze.
It was basically a pelvic packing, ma'am. It was basically a pelvic packing just to give more support to the pelvic pack. Abdominal packs were inserted, not fully covering the abdominal area, ma'am. Just more. It was more of a pelvic packing, ma'am.
Because you took out everything from the abdomen, you can have you compared with if you take it out from vagina, which one is better?
Ma'am, in vaginal packing, we will have to observe for vaginal wall dehiscence later. In this, we were sure we could close the pack removal sites with just one suture, with 3-0 nylon. In case we are inserting a vaginal pack, then we will have to check for the vaginal dehiscence, wall dehiscence later on. So, or we can, I never have an experience, I don't have an experience with the pack being removed from vaginal end, ma'am.
Because if you remove from the vaginal end and give a traction, that gives a better compression.
Yes, ma'am. Yes.
Hello?
Yes, ma'am. Yes, ma'am.
Yeah, are we done, ma'am?
Yes.
Okay, so should I call the next candidate?
Yep.
Okay. Thank you, ma'am. Okay, thank you.
Thank you. Thank you for the wonderful presentation. Now I invite Dr. Paridhi. Our topic is effectiveness of low dose versus high dose oxytocin regimen for induction of labor. And her code is 0106. So Paridhi, are you ready with your presentation? Paridhi?
Yes, ma'am.
Yeah, start sharing your screen.
Ma'am, is it visible?
No, your camera is still off.
It's coming. Yeah, it's there. Please start.
Yeah, it's there. Yes. Okay, Paridhi, you start.
Good morning. Good morning, everyone. I'm Dr. Paridhi Gupta from RML Hospital. Respected judges, my topic is effectiveness of low dose versus high dose oxytocin for induction of labor. Induction of labor is the artificial stimulation of uterine contraction before the true onset of spontaneous labor. The incidence of induction is approximately 25%. That is, 1 out of every delivery is an induced labor. Oxytocin is the commonest inducing agent used worldwide. It has been used alone or in combination with amniotomy or following cervical lightening agent. Current evidence is not strong enough to recommend low dose or high dose for routine induction of labor. So further research is required to be carried out for betterment of maternal and neonatal outcome along with successful induction rates. There are mainly 2 regimens widely studied: low dose that starts with 1 to 2 milliunits per minute with increment of 1 to 2 milliunits per minute every 30 minutes up to a maximum of 32. High dose starts with 4 to 6 milliunit per minute with increment of 4 to 6 every 30 minutes up to maximum of 32. The primary outcome of my study was estimation of induction to delivery interval. Secondary outcomes include rate of cesarean section, duration of second stage of labor, tachysystole with or without fetal distress, failed induction, maternal outcomes like incidence of instrumental vaginal delivery, PPH, and chorioamnitis. Neonatal outcomes like admission to NICU, Apgar score at 1 and 5 minutes, umbilical cord pH, perinatal morbidity, and mortality. Inclusion criteria in the study was termed nulliparous women with single live fetus and Catholic presentation. Exclusion criteria was uterine scar or any previous uterine surgery, weight of the fetus more than 4 kg, fetal malformation, and medical conditions like severe heart disease or anemia, or any other contraindication to vaginal delivery. The study was approved by Institutional Ethical Committee and Research Review Board. It's included 100 participants, which were divided into 2 groups. Group 1 high dose, group 2 low dose. If the Bishop of the patient was less than 6, then we used pre-cervical ripening agent. And if it was more than 6, the patient were directly induced with oxytocin. The low dose regimen, it starts with the 2 units of oxytocin in 50 cc of RL, and the infusion rate was 3 ml per hour, corresponding to the standard rate of 2 millunit per minute, and it was increased every 30 minutes by 3 ml per hour up to a maximum of 48 ml per hour. High dose starts with 6 ml per hour, and it was taken to maximum of 48 ml per hour. It can also be prepared by using 4 units oxytocin in 50 cc and starting on 3 ml per hour up to a maximum of 24 ml per hour. The result was induction to delivery interval in high dose was 6.96 plus minus 3.77 hours, and in low dose 9.05 plus minus 4.65 hours, which shows that the high dose has shorter duration induction to delivery interval by 2 hours and 9 minutes, and this was statistically significant. The 22% patients in group 1, that is high dose, and 20% in group 2 had incidence of they required cesarean section, and the data was not statistically significant. 10% patient from group 1 and only 2% patient from group 2, that is low dose, had tachysystole. So the incidence of tachysystole was more in group 1, but the data was not statistically significant. And other outcomes were not significant among the 2 groups, that is the maternal fetal outcome and the incidence of failed induction. There were many other studies that showed that induction to delivery interval was slightly shorter in high dose in a study by Temesa NG et al. In 2020. L. Selin in 2018 also showed that the duration was 23 minutes shorter with high dose. Cochrane review in 2016 also showed that significant reduction in high dose. But a study by B. Manjula et al. In 2014 stated no such difference between the 2 groups. With respect to incidence of cesarean delivery, Cochrane reviews and a study by N. Pritchard and L. Selin also found no significant difference between the 2 groups. But a systemic review by V. SQ et al. In 2010 reported a moderate decrease in the risk of cesarean section in high dose. The incidence of tachysystole was found to be raised in high dose in studies by B.G. Manjula, Aaron Budden et al., L. Selin, and various other studies also showed the same result. The primary outcome in my study, induction to delivery interval, was found to be statistically shorter in high dose by 2 hours and 9 minutes, and the data was significant, but the duration of second stage of labor did not differ among the 2. Although high dose had increased incidence of tachysystole, but the data was not statistically significant. And also there was no difference, significant difference between the 2 regimens with respect to cesarean delivery, failed induction, instrumental delivery, fetal distress, maternal and fetal outcomes. Limitation in my study was the sample size, small sample size. Thus, the result of the study cannot be extrapolated to general population. The effect of some of the outcomes like uterine tachysystole could have been more significant had the sample size been more. And also the study included only nulliparous women. So the effect of regimen was not studied on multiparous women or the women with previous cesarean scar. Thank you.
Paridhi, was there any precipitate labor with the high dose?
Ma'am, no, there was no any incidence of precipitate labor with the high dose.
Okay. So you gave it by an infusion pump only, no?
Yes, ma'am. I used infusion pump in all the cases.
So as okay. And Dr. Deepti, Dr. Nima, will you like to?
Yeah. Okay, so yeah. So Dr. Paridhi, what I wanted to know was that you mentioned that the rate of incidence was almost similar in incidence of C-section.
Yes,
Was the same in both the study groups?
Yes, ma'am.
The incidence of C-section. Any difference in the indication for C-section? Was it tachysystole leading to non-reassuring fetal heart rate in the high dose group and prolonged labor or failed induction in the second group? Any difference in the indication for C-section?
No, ma'am. The incidence of failed induction was also calculated and it was also not statistically significant. And the incidence of fetal distress among the two groups were also noted and it was also not statistically significant. But the tachysystole, the incidence means only that cases in group 1, high dose had tachysystole and 2%, only one patient had tachysystole in low dose. So the incidence was more in high dose, but the data when calculated statistically was not significant. That might be due to the small sample size of my study. Because other studies have shown that tachysystole was more in high dose.
Yes, yes. And the dose, the maximum dose used by you in the high dose group was of oxytocin was? You went up to 40?
Cases, no, ma'am, I took up to 32 milliunits per minute only.
Okay. And you did not go beyond that? Not up to 92?
In both the cases, no, ma'am.
So both the cases were restricted to 32 units only?
Yes, ma'am.
Milliunits, okay.
Yes, ma'am.
So because the studies have mentioned up to going as high as 90 in the high dose group, and maybe that is a reason for more incidence of C-sections in the high dose group for distress. So was that a conscious decision to restrict the dose?
Yes, ma'am, because some of the guidelines also said that the maximum dose can be, the maximum safety dose is 32 and it can be taken up to 40. The guidelines have also shown the RCOG, ACOG studied, they took it up to 32 only. And many 32. Of the studies, they were taking up to that only because of the safety profile.
Safety profile, okay. Fair enough. Okay.
Thank you, ma'am.
Sure. Thank you, Saloni. You were very much on time. Great job. Ma'am, should I call the next participant? Dr. Surbhi?
Yes.
Yeah. Dr. Surbhi? Acha, Saloni, you please stop sharing your screen. Yeah. Dr. Surbhi, are you there?
Good morning, everyone.
Yeah. Good morning, Surbhi. The title for Surbhi's presentation is Role of Lipid Profile in Early Second Trimester for Prediction of Preeclampsia. And her code is 0107. Is it all right? Surbhi?
Yes, ma'am.
Yeah, you can start with your presentation. The allotted time is 6 minutes for you. Okay?
Can you see my presentation, ma'am?
Yeah, we can see. Please start.
Okay. Good morning, everyone. My topic for today is role of lipid profile in early second trimester for prediction of preeclampsia. As we all know, hypertensive disorders of pregnancy has a worldwide preeclampsia incidence of 3 to 5%, and in India it is 5.4%. Pregnancy is a physiological hyperlipidemic state, and in preeclampsia it increases to twofold. Preeclampsia and atherosclerosis has common pathophysiology, and for association of serum lipids, lipid profile analysis to be done as a potential predictor. And with the early identification of preeclampsia, prophylactic intervention with low-dose aspirin to be given to reduce the risk of early onset preeclampsia, IUGR, and preterm births. Hypertensive disorders of pregnancy include gestational hypertension, preeclampsia, chronic hypertension, superimposed preeclampsia, and eclampsia. For diagnosis of preeclampsia, blood pressure should be more than 140/90 at least 4 hours apart after 20 weeks of gestation with proteinuria, or in absence of proteinuria, new onset hypertension with any of the severe features. Objective of study was evaluating association of abnormal lipid profile in early second trimester, that is 14 to 20 weeks, with development of preeclampsia and its prevalence in low-risk pregnancies. Study was conducted in Department of Obstetrics and Gynecology and Dr. Arimal Hospital. It is a prospective observational study which includes 260 women over a period of 1 year. The inclusion criteria was a maternal age of 18 to 35 years and with gestational age 14 to 20 years, irrespective of their parity. Exclusion criteria was diabetes mellitus, chronic hypertension, or any other cardiovascular disease, smoker, history of renal disease, liver disease, and thyroid disorder, multiple gestation, and BMI more than 25. At the time of enrollment, written and informed consent was taken and fasting blood sample was withdrawn for serum lipid profile analysis. And on the basis of lipid levels, control and study groups were made. And women were followed up till 48 hours after delivery. The outcome measured were difference in mean lipid levels in study and control group and accuracy of abnormal lipid profile to predict preeclampsia. In the results, this is the table showing the distribution of baseline characteristics. The mean age at enrollment was 27.52 years, and which includes the 171 prime gravidas, and 43 developed gestational hypertension, and 29 developed preeclampsia. In this table, this comparison of history of preeclampsia between preeclamptic and normal subjects was taken. Out of 29 patients who developed preeclampsia, 5 had previous history of preeclampsia, while 6 has no previous history, which is statistically significant. In this figure, it shows comparison of preterm deliveries between two groups. Out of 29 patients, 13 patients, that is 44.83%, developed had preterm deliveries as compared to term, which was statistically significant. And similar results were also shown by Abha Singh study. In this table, I have compared the lipid profile between two groups. Total cholesterol was higher in preeclampsia's group as compared to normal, which is statistically significant, while the other lipid levels were non-significant. In the study conducted by Vidyabhatti et al., concluded that with 1 unit increase in total cholesterol, triglyceride, VLDL, and LDL, the probability of developing PIH increases. And with 1 unit increase in HDL, 11.4% less chances of developing PIH. This figure shows the comparison of a lipid profile between different groups. And total cholesterol, triglyceride, VLDL, LDL shows statistical significant difference between the 4 different groups, and no difference was seen in significant difference was seen in HDL. VLDL has a highest sensitivity of 68.97%, while HDL has a highest specificity of 86.15%. Total cholesterol has highest positive and negative predictive values with the diagnostic accuracy of 80.38%. The strength of my study was that it is a prospective study with high follow-up rates, and limitation includes that only 1 sample has been taken for lipid profile measurements, and small number of preeclampsia patients hindered in inferences from some of our analysis like pregnancy outcomes. Out of 260 women, 29 patients developed preeclampsia, and makes the incidence of 11.15%. Total cholesterol was statistically significantly increased in preeclampsia group, while others are non-significant. In the prediction of preeclampsia, VLDL has highest sensitivity, HDL has highest specificity, and total cholesterol has the highest positive and negative predictive values. An abnormal lipid profile in early second trimester can be a good non-invasive and economical test for prediction of preeclampsia. Aspirin prophylaxis can be given to prevent preeclampsia and better surveillance to optimize maternal and perinatal outcomes. Thank you.
Okay, so Dr. Surbhi, few questions. Are there in normal pregnancy, do you expect some lipid profile changes?
Yes, ma'am.
Yeah. So what are the changes?
Ma'am, it increases
normal pregnancy.
In normal pregnancy, it increases less than total cholesterol should be less than 200 milligram per deciliter, and triglyceride is less than 150, and LDL is less than 100, VLDL is less than 30 milligram per deciliter, HDL is more than 40.
Dr. Surabhi, sorry to interrupt. Dr. Neema doesn't want to know the levels, I'm sure.
Yeah.
We just want to know the change in the physiology. I think Dr. Neema wants that answer, not the levels. Levels we are aware. We just want to know the physiological changes vis-a-vis lipid profile, or it is considered to be hypercholesterolemia in pregnancy. So why does that happen? You heard of reverse cholesterol transport
Yes,
in
ma'am.
pregnancy? Yes. So that is what she wants. So did you take any, once you did a lipid profile of 16 weeks and you found that the levels were altered, so aspirin was started in all patients, irrespective of the blood pressure reading?
No, no, ma'am. I have only ma'am. I have not started any ecosprin in these patients.
Okay, you just
I was just predicting it. Not
that if the lipid profiles are altered at 16 weeks, so many patients would land up in preeclampsia.
Yes, ma'am.
So basically, you have not given any kind of a treatment to these patients for a prevention.
No, ma'am.
And what about any diet and exercise?
Ma'am, we have advised for the diet and exercise. Normally we do in pregnancies.
And so, have you seen that at any? Okay, you took only one lipid profile. Okay.
Yes, ma'am.
Okay, so you didn't know what happened, the changes after the diet and exercise, you know?
No, ma'am.
You followed these, your study is for 1 year.
Yes, ma'am.
This is a 1 year case study. So the follow-up was done irrespective of any treatment.
Yes. I have not given any treatment to the patients.
I think the further lipid profile would have helped, you know, in each trimester.
Yes, ma'am. This is the limitation of my study, that I have taken only one sample.
I think we can move on to the next one.
Yes, yes.
Thank you, Dr. Survi.
Thank you.
Yeah, it's a panel call for Dr. Nilofer, because you are the only one who is left. Dr. Nilofer, are you there?
She's muted herself.
Dr. Nilofer?
Shamishta, you can tell her if she wants to talk about it, it's okay.
Yeah, instead of showing us the slides, she can, yeah.
Yeah. Let's give her this chance.
Nilofer?
She can read out her slides.
Yeah.
It's an interesting topic.
Is she there or not?
Yeah, she is there, ma'am. I just had a word with her. She's trying to connect again. I think there's some technical problem for her from her end, ma'am.
There must be a net issues, you know.
Maybe her system is not supporting it.
Oh.
Nilofer, can you hear us?
Because then the time is up, basically.
Our session 1 is over, ma'am. She's the last one.
We just have 10 minutes more. She can do it.
Yeah, ma'am.
Do we have 10 minutes? I don't think so.
Ma'am, between the sessions, we have got a breathing space of 10 minutes.
Oh, we can give her a chance then.
Yeah, exactly.
If she's prepared, then I think we should speak out.
That was a thesis topic.
Oh, a rather interesting topic, because Rotem is something which, well, at least I didn't know. So at least she made me read that.
Yeah, it's an upgraded version of TEG, which we are routinely doing, na, ma'am. So Rotem is an upgraded version of TEG now.
It was interesting.
Anji Nilofer, yeah, we can see you.
Yes,
yeah. So Nilofer, listen, there is one instruction for you. If you cannot share your screen, if you cannot show your presentation to us, at least you can read your slides. Okay, and you will be marked on them. Yeah, very well. Very good.
Oh,
Nilofer,
yes.
we can see your screen.
Yes, yes.
Please start now.
Yes, ma'am. Can you see it now?
Yeah, we can see you, and please start your presentation, Nilofer.
Okay, ma'am. Good morning, esteemed judge. I'm Dr. Nilofer from Sir Ganga Ram Hospital. I am presenting.
You'll have to speak louder, Dr. Nilofer.
I am presenting a paper on correlation of rotational thromboelastometry, that is ROTAM, and plasma fibrinogen levels, and its utility to predict the postpartum hemorrhage. As we all know, the PPH is one of the leading causes of maternal mortality worldwide, responsible for around 1.27 million deaths annually. The 40s of PPH are already known to us. However, whatever may be the initial cause of PPH, ultimately it is the conceptive and dilutional coagulopathy which determine the severity of PPH. So early assessment and diagnosis of coagulopathy in PPH is the key. The standard coagulation tests which are available presently are prothrombin, INR, APTT, platelet count, and fibrinogen level. However, the turnaround times for these tests is usually 45 to 60 minutes, which is not acceptable in an obstetric emergency like PPH. The literature which is currently available on the study of PPH shows that the fibrinogen level is the first one to decrease among the markers of coagulation, with levels less than 2 gram per liter as having a positive predictive value of 100% for progression to severe PPH. Thus, a point of care test which correlates with fibrinogen level has the potential for guiding targeted therapy. Such an equipment is ROTAM, which has 4 assays available for the extensive pathway as EXTEM, intensive pathway as INTEM, FIBTEM for the fibrinogen levels, and APTEM for hyperfibrinolysis. ROTAM measures the viscoelastic properties on multiple aspects of coagulation from a sample of citrated whole blood, which gives a global picture of the patient's hemostatic capacity, and it just takes 12 to 15 minutes from the start of the measurement. This diagram is showing the apparatus of the ROTAM. As we can see, there are 4 different chambers. So the 4 assays of APTEM, FIBTEM, ROTAM can be at the same time run. And at the last, it gives an image, a graph, which is screened on the monitor. This is the graph which we get finally. It has the parameters or the assays which we measure as CT clotting time, clot formation time, and then the amplitude of the graph as at 5, 10, 15, and 20 minutes as A5, A10, A15, and A20, and maximum clot firmness. The aim and objective of our study was the study correlation between FIBTEM parameters and the fibrinogen level in obstetric patients, and to compare the values of ROTAM with the standard lab coagulation tests in prediction to severe PPH. The study was conducted in the Institute of Obs and Gynae along with the Institute of Hematology at Sir Ganga Ram Hospital. It was a pilot observation study, and the study was conducted over a period of 1 year. All the pregnant women in 3rd trimester at 34 plus weeks of period of gestation were included in the study, and the patients with hematological disorders, whether congenital or acquired, and the patients on anticoagulant therapy were excluded from the study. So the study plan was that all the patients who were admitted in labor room for delivery at 34 plus weeks POG were enrolled in the study after obtaining written informed consent, detailed history, physical examination, and the sample was collected for PT, INR, APTT, and an extra sample was collected for the ROTAM. So this was on admission. A second sample for the ROTAM was taken post-delivery or at the onset of PPH. So the results and observations of our study were that the 62% of the patients belonged to age category of 30 to 39 years. 58% of the patients in our study were primaries and 30 were para 1. The 44% of the study population was between the gestation age of 36 to 38. When we compare the demographic characters between the group A, that is the study group, that is the patients who had PPH, and control group, that is the patients who didn't have the PPH. So all the demographic characters were comparable. There was no statistically significant difference. When the antenatal risk factors were compared, anemia, thrombocytopenia, multiple gestation, placenta previa, morbid adherent placenta, and HELLP syndrome were statistically significantly increased in patients with group A, that is the patients who had PPH. The hemogram and the biochemical parameters supported the clinical criteria. So HB, PCV, and platelet count were significantly decreased in group A. We also studied the D-dimer levels, which were significantly increased in the patients with PPH. When we compared the PT, APTT, plasma fibrinogen in these patients, PT, there was no statistically significant difference, but the plasma fibrinogen was almost half in patients who had PPH than the patients who didn't have the PPH. The FIPTIM parameters, when compared between the two groups, clotting time and clot formation time was significantly increased in patients with PPH, with the amplitude at 5, 10, 15, and 20 minutes significantly decreased. The plasma fibrinogen levels, when we compared in patients with PPH, those patients who had less than 2 grams per liter of fibrinogen, almost all the patients, in 6 patients we had this level, all the 6 patients landed up in PPH. So supporting the previously studies that less than 2 grams per liter of fibrinogen is 100% predictive of the PPH. Same in case of post-delivery. When we correlated between the plasma fibrinogen and the FIPTIM parameters on ROTEM, which was the aim of our study, the FIPTIM, CT, and CFT showed a negative correlation, whereas the amplitude and maximum clot firmness showed a positive correlation. This is the scatter diagram showing the correlation between the fibrinogen and FIPTIM A5. The ROC curve, again, it showed an area under curve of 0.7 with 95% confidence interval between 0.6 and 0.9. The ROC curve of FIPTIM A5 showed again an area under curve of 0.9 with 95% confidence interval of 0.9 to 0.10. So to conclude our study, we found that plasma fibrinogen levels increased during the course of pregnancy from a value of 2 to 3 in non-pregnant to a value of 4 to 8 grams per gel in pregnant women treated by third trimester. There is a fall in level of fibrinogen after delivery, with a fall more pronounced in patients with PPH. And previously study showed less than 2 gram is 100%. In our study, it was seen that less than 2.79 gram per liter is 100% predictive of PPH. The FIPTIM parameter showed a strong and significant correlation with the plasma fibrinogen level, with CT and CFT showing a negative correlation and clot amplitude showing a positive correlation. FIPTIM A5 value of 16.5 mm had a sensitivity of 75%, specificity of 82%, positive predictive value of 44%, and negative predictive value of 94%, and accuracy of 81% for the prediction of PPH.
Okay, Nilofer, your time is up.
Thank you, ma'am.
Thank you, Nilofer.
Nilofer, and what time you get the fibrinogen level report and the report from your ROTEM?
Yes,
what is the cost involved with both of them?
The fibrinogen levels, when we send, we usually get because it has to be detected in the serum, so they had to centrifuge the sample beforehand. So it usually took 45 to 60 minutes. The sample report, but the FIPTIM values or the overall ROTEM values, once we upload, because we have 4 different chambers, so we can at the same time run all the parameters, that is FIPTIM, EPTIM, EXTIM, and INTIM. So usually the graph starts to show up on the screen in 5 to 10 minutes, because we have the graph amplitude at 5 to 10 minutes. So at the amplitude at 5 minutes, we can first detect if there is decrease in the fibrinogen level, because the A5 values will be decreased. Though the overall graph takes usually 45 minutes to show up, but the initial results we can get at 5 minutes.
And cost involved with both?
Yes, the cost.
Ma'am, usually, because this was the first study in India of the ROTEM, so we had to run it free because it was sponsored by some, so it was run as free.
So you don't know the cost of the test or a machine, so how much this?
So yeah, at least the cost of the machine. And this is available where all in Delhi, the machine?
Ma'am, in Sargamga Ram Hospital.
Okay. Any other questions, Dr. Deepti? And otherwise we can wind up, Nima?
No, I think it's okay.
Okay. I think then we
Thank you,
wind it up. Okay, great. Thank you. Thank you. Best of luck, everyone.
Yes, thank you to each one of you. Did a good job. And it was so cute to hear their voices, you know, the young voices. And a bit of shiver in the voice. It was very cute.
Thank you, Deepti ma'am.
Yeah,
Achha,
thank you so much.
all the judges are requested to mail their scoring sheet to aogdvirtual.com, ma'am.
Okay, AOGD, yes.
Yeah, thank you, ma'am.
Thank you so much. Thank you so much.
Okay, ma'am. So let us start with the second session, because we are already 7 minutes going behind the time. So for the second session, I would like to invite my judges, Dr. Rachna Agarwal, ma'am. She is a professor of Department of Obs and Gynae in UCMS and GTB Hospital, Delhi. Dr. Sumedha Sharma, ma'am. She is professor in Hamdard Institute of Medical Sciences, and Dr. Ramandeep Kaur ma'am. Ramandeep ma'am is, where is she? Yeah. Ramandeep ma'am is senior consultant in unit head, Department of Gynae Endoscopy in Artemis Hospital, Gurgaon. Hello, have all the judges joined?
I'm joining.
They're all joining. So it's a request that you start giving them the calls like 10 minutes before their session. So it's all the participants and judges, they are ready beforehand because we're already running behind.
They are already at attendees. I am promoting their 2 panelists.
Yeah, promote them to panelists.
Yeah.
So do I have the participants? Dr. Neela. Good morning, Rachna ma'am.
Sure, Mishra, hi.
Hi, Ruma.
I think we are doing well so far. Yeah,
but 7 minutes, yeah.
5 to 7 minute delay in this session. But it's okay, I guess.
थोड़ा सा late हुआ मैम.
Technical
problem था starting में. अभी भी जैसे मैम सब attendees से panelists में आएंगे, तो it will take transition time मैम है 2-3 minutes का ना.
But maybe Shubham, are you in this room or who is in this room?
Ma'am Shubham.
Yeah, Shubham, you can maybe allow them to move to the panelist status.
Yeah.
5 minutes
I'm promoting.
before. Yeah.
Do it beforehand, yeah, before we start the second session, no?
Like 10 minutes before, you can move them as panelists. Great.
Okay. So I see Dr. Ramandeep, Dr. Sumedha, Dr. Rachna, all are there.
Good morning.
Good morning, Ramandeep ma'am. So I think we are all ready. So I would like to invite my first participant, Dr. Neela. I see her. Dr. Neela, are you there?
Yes, ma'am. Good morning.
Good morning, Neela. Can you please start sharing your screen?
Yes, ma'am.
Yeah. So with the permission of my judges, shall I request Dr. Neela to start her presentation, ma'am?
Sure.
Okay, Dr. Neela, please start sharing your screen. Her title for today's presentation is Assessment of Maternal Abdominal Subcutaneous Fat Thickness Measured by Ultrasound as an Independent Predictor of Adverse Pregnancy Outcome. And her paper code is 0208. Am I right, Dr. Neela?
Yes, ma'am. Ma'am, is my screen visible?
Yeah, we can see you. We can see you very well. So again, Neela, to remind you, you have got 6 minutes for presentation and 2 minutes for question and answers, okay?
Okay, ma'am. Okay, ma'am.
And you will be marked on your time first. So please stick to time. So your time, 6 minutes starts now. Okay? Yeah.
Yes, ma'am. Good morning, everyone. As ma'am has already said, my topic is assessment of maternal SFT as measured by ultrasound as an independent predictor of adverse pregnancy outcomes. As we all know, maternal obesity over the past few decades poses a major challenge to obstetric practice because it causes a lot of risk in the mother as well as the baby. In the mother, it causes increased incidence of GDM, preeclampsia, and increased rates of C-sections, whereas in the fetus, they are at the risk of stillbirth, preterm birth, postdatism, and congenital anomalies. Obesity in pregnancy can also affect the health of the mother as well as the child later on in life. We have a lot of methods to quantify obesity. These include BMI, which is the most commonly used, abdominal circumference, body fat percentages, and subcutaneous fat thickness. BMI has a lot of disadvantages, which include it does not reflect in fat distribution. It does not account for gender, ethnicity, muscle mass, or frame size. From retrospective studies, we have some evidence that abdominal subcutaneous fat thickness measured at mid-pregnancy, that is between 18 to 22 weeks gestation, is superior to BMI to identify the risk for obesity-related pregnancy outcomes. Hence, my study aims to establish abdominal SFT as an independent and reliable marker of obesity. So the materials and methods are, it was a prospective cohort study and it was performed in the obstetrics and gynecology department of ESI Basai Darapur. The study period was from December 2018 to Feb 2020. The age of my study population, 20 to 40 years, and the sample size was 150. Inclusion criteria included pregnant women with simpleton intrauterine pregnancy presenting to the OPD in the first trimester. Exclusion criteria was history of cardiovascular disease, pregestational diabetes mellitus, chronic hypertension, and smoking. The demographic data was collected about each participant from their first visit in OPD, and these included age, height, weight, smoking habits, parity, etc. Informed consent was obtained from the patient as well as the relatives. Ultrasound for abdominal SFT was done at 18 to 22 weeks period of gestation. All the scans were performed by the same operator, and 3 readings were taken 5 millimeter apart in the midline, and their average values were also calculated. Now the participants were followed up to the labor, and their adverse pregnancy outcomes were noted, and they were correlated with the SFT measured during the study. These outcomes were PIH, GDM, cesarean section, preterm delivery, postnatal, neonatal respiratory distress, and NICU admission. The same outcomes were correlated with BMI, and analysis was performed. So the results. The first table here shows the frequency distribution of all the patients according to their BMI category, and we can see the maximum patients belong to the normal BMI. This here, this table 2 shows the anthropometric and demographic characteristics of the population. Now here we have compared the SFT measures according to the BMI, and as we can see, there is an increase in SFT as we move on from the underweight, normal, overweight, and obese category, and these were statistically significant. The yellow colored are the p-values shown. Next, we try to correlate SFT with BMI. We could see that by using Pearson's correlation, all the correlation coefficients were between 0.5 and 0.6. The same thing was plotted on graphs here. This is SFT1 versus BMI, SFT2 versus BMI, and SFT3 versus BMI. In all these, we could see a steady direct correlation, and it was a moderately positive correlation. Next, we tried to correlate BMI with PIH, and we could see that the incidence of PIH was more in the overweight and obese category. That is, their percentages was increasing as we move from normal to increasing BMI. The same thing was plotted on the graph. When we tried to correlate PIH and SFT, we could see a direct correlation, the average SFT being 11.45 for no PIH group and 16.48 for the PIH group. And all these values were statistically significant. Next, we had a correlation between GDM and BMI. Here again, we could see that as we moved from the low BMI to high BMI, there was an increase in the percentage of the occurrence of GDM. Next, we tried to correlate SFT and GDM, and we could see a direct correlation that is 11.68 for SFT average in the no GDM group and 16.24 in the GDM group. Next, we tried to correlate preterm birth and BMI, but what we could see was we could not obtain a linear relationship. Increased preterm was seen both in the underweight as well as the overweight and obese category. Whereas when we tried to correlate SFT and preterm, we could see a linear relationship with increasing SFT among the preterm groups, and these were again statistically significant. Next, we tried to correlate the NICU admission and the maternal BMI, and we could see that there was an increase in the NICU admission among the overweight and obese groups, but these values, however, could not reach statistical significance. Whereas when we tried to correlate NICU admission and the SFT measured, we could see a direct relation, an increase in SFT in the group requiring NICU admission, and these values were statistically significant. Now, to summarize, we compiled all our data and put it into this table. We tried to derive a correlation coefficient using Spearman's correlation between the outcome variables and the BMI as well as the SFT. We tried to compare the correlation coefficients. What we could see that the correlation coefficient of PIH for BMI was 0.284, whereas for SFT it was 0.454. For GDM, it was 0.266. For SFT, it was 0.432. For preterm, it was 0.172. For SFT, it was 0.226. So in all the variables, we could see a doubling of the correlation coefficient in SFT compared to BMI. And the p-values were much lower for SFT. So moving on to the discussion, we could see that the patients were categorized into the BMI categories, that is underweight, normal, overweight, and obese. We measured their SFT, and we tried to derive a positive correlation between SFT and BMI using Pearson correlation. Next, we compared the PIH and maternal obesity. We saw positive correlation with both BMI as well as for SFT. The mean SFT was 11 point. Please, ma'am.
Yeah, Dr. Neela, your time is up. Wind up
Okay,
another 5 seconds. Yeah.
Okay, ma'am. So basically, we proved that SFT is a more reliable and much more predictable marker for BMI, for obesity than BMI. That was the conclusion of my study, ma'am.
Judges, she has got 2 minutes for her question and answers. Please proceed with the questions.
Dr. Neela,
Yes, ma'am.
so you have taken one SFT at 18 to 20 weeks.
Yes, ma'am. Yes, ma'am.
Right, one sample was taken, and then this 1, 2, 3 you have chosen according to the midline and
Yes,
the
ma'am.
lateral.
I took the first measurement in the midline, in the mid-sagittal plane, and 2 other measurements were taken 5 millimeter apart on either side. So these are my SFT 1, 2, and 3, and then I calculate the average also.
Okay. And were there any landmarks chosen so that there is no, variation in the values?
Ma'am, no, we just do it just above the symphysis pubis in the midline, in the mid-sagittal plane, and we try to focus on the cervix, the placenta, and the uterus. When all these 3 are seen clearly, that is the plane where I choose my SFT measurement. And then I took the measurement from the skin line to the peritoneal fascia.
Okay, so what extra, information we get from SFT compared to BMI? Because BMI is so easy to take. SFT, you need
Yes, ma'am.
expertise, machine, cost, everything.
Yes, ma'am. The thing is that, as in my study, the value when we try to compare the adverse outcomes, the values were much more. The correlation was better, and the statistical significance was more for SFT. And SFT is an objective method, ma'am. BMI can be. It does not really talk about the central obesity, or it does not account for any variations according to your ethnicity or your race, or it's not a very objective method of measurement, BMI. And SFT is something which is more, I think there'll be less error when you take an SFT. It is more reliable, ma'am. It's more reproducible also.
Okay, thank you.
Yes, ma'am.
Any other questions, ma'am? Dr. Rachna, Dr. Sumedha. Dr. Amandeep, I think the time is also up. Should I proceed with the next candidate?
Yes, yes.
Okay. Thank you, Dr. Neela. It was a wonderful presentation. And I would now like to call the next participant, Dr. Nupur. She is presenting her paper on amniotic fluid lactate dehydrogenase, a reliable marker for subclinical chorioamnitis in preterm premature rupture of membranes. Her paper code is 0209. Dr. Nupur, are you there? Yeah, Nupur, we see your presentation now.
I'm there. Ma'am, am I audible?
Yeah, you are very much audible. You have got 6 minutes for presentation and 2 minutes for question and answers. Okay.
Thank you, ma'am.
Yeah.
Good morning, everyone. My topic of presentation is amniotic fluid lactate dehydrogenase, a reliable marker for subclinical chorioamnitis in preterm trauma. As we know, preterm trauma is a rupture of fetal membranes in the absence of uterine contraction. Those occurring before 37 weeks, we call this preterm trauma, and those occurring after 37 weeks is term trauma. And the incidence is around 5 to 10%. Preterm trauma is strongly associated with intraamniotic infections, clinical and subclinical chorioamnitis. Prevalence of subclinical chorioamnitis in preterm trauma is 50 to 70%, and it is difficult to diagnose antenatally due to absence of the clinical signs and symptoms. And it is associated with significant neonatal morbidity. Hence, there is a need to search for a marker which can detect the subclinical chorioamnitis, and we can terminate the pregnancy timely. In this study, we evaluated the amniotic fluid lactate dehydrogenase in relation to histological chorioamnitis in a vaginally obtained amniotic fluid samples. So, the study was conducted in Department of Obs and Gynae with the Department of Biochemistry and Pathology in Lady Hardinge Medical College and Sucheta Kriplani Hospital. The period of study was from December 2018 to March 2020. The study design was prospective observational study. And the study population included the pregnant women who were admitted with preterm trauma between 28 to 33 plus 6 weeks of gestations, and sample size was 115 women. Inclusion criteria included all pregnant women with single live pregnancy with preterm trauma between 28 to 33 plus 6 weeks of gestation, cephalic presentation, duration of leaking 24 hours or more. The exclusion criteria included overt signs of chorioamnitis at presentation, presenting an active labor, known case of any medical disorders, or subjects were selected for the study using the inclusion and exclusion criteria. In the study, on admission, patients vaginally obtained amniotic fluid samples were collected. after fulfilling the inclusion and exclusion criteria, and LDH was measured in the biochemistry lab using spectrophotometric analysis. Most of the women went into spontaneous labor or were induced at 34 weeks of gestation or earlier if obstetrically indicated. Post-delivery, the placenta was sent for histopathological examination for diagnosis of histological chorioamnionitis. So what we found was that out of the 115 women, 58 women had the histological placenta showing the features of histological chorioamnionitis. Of them, 10 women also developed clinical chorioamnionitis. The mean concentration of amniotic fluid LDH in women with histological chorioamnionitis was significantly higher than women without chorioamnionitis. But we can see in the result the distribution. Most of the women were presented with on the age group of 26 to 30 years of age with a mean age of 24.6 years. And most of the women presented to us were the primary gravidas.
Hello?
That was 39.1. Yes, ma'am?
Okay, sorry, I was checking my mic. Actually, I was not audible in between. Okay, continue.
Yes, ma'am. Most of the women presented between the 24 to 48 hours of leaking, that was 71.3%. And the most of the women were in the gestational age of 32 to 33 plus 6 weeks of gestation. And out of the 115 women, most of the women went into spontaneous labor, that was 69.5%, and delivery, and most of the women delivered within 7 days of admission, and the rest who were induced, the most of the indication was the restarted 4 weeks of gestation and chorioamnionitis in 9 women, abruption in 1 woman, and anhydromnias in 2 women. Here we can see the distribution out of the 115 women, 49.6% women had no histological as well as clinical chorioamnionitis test. 41.8% women had subclinical chorioamnionitis, and clinically symptoms were developed in 10 women. On comparison of mean amniotic fluid LDH in women with and without chorioamnionitis, we found that those who had histological chorioamnionitis, the mean amniotic fluid LDH was 2100, and without chorio, it was 580. That was significant. On taking the mean values, the cutoff of amniotic fluid LDH was determined, and that came out to be 1034 international unit per liter for diagnosing subclinical chorioamnionitis. So on this is the distribution I got of these 57 women who had no chorioamnionitis. Most of them had amniotic fluid LDH less than 1034, and the sensitivity and specificity came out to be 93% and 91.2%. So we compared the maternal and fetal outcomes based on these amniotic fluid levels, and the mean those women who had puerperal sepsis, there was a significant increase in the amniotic fluid LDH in their on the samples collected, and the total number of women who developed puerperal sepsis in this present study were 8, and all of them were the study group was actually divided into 2 based on the cutoff levels, and those who had the puerperal sepsis all belong to group 2. Sorry. On comparing the neonatal outcomes, we can see that neonatal sepsis, those women babies were developed neonatal sepsis, the amniotic fluid LDH in those women were significantly higher. Although the RDA for RDS and birth asphyxia, it was not significant, and the for composite neonatal morbidity, it was significant. We divided into 2 groups, and for the neonatal outcomes, we can see that it was significant for NICU admission for neonatal sepsis and duration of hospital stay and composite morbidity. Otherwise, it was not significant for birth asphyxia and RDS. So we can say that for discussion, most of the women presented, as we have already said, it was 24.6 year was the average age of presentation, and most of the women were primary gravidas. Yes, ma'am?
Yeah, time is up, Nupur. Wind it up in another 30 seconds.
Okay, ma'am. Most of the women went into spontaneous. So these all we have already said, and the mean amniotic fluid level were 1034. So what we found was maternal and neonatal sepsis was significantly higher in those who had amniotic fluid LDH more than 1034. Strength of study was that their sensitivity and specificity was high for diagnosing histological chorioamnionitis, and sample size was 115, so we can apply it to the general population. But limitation was that we cannot take the repeat samples as the subclinical chorioamnionitis was diagnosed after delivery, no other intervention could be done. So the confusion is that amniotic fluid LDH cutoff of 1034 may be used to trial children who are at risk of developing subclinical chorioamnionitis so that early delivery can be initiated. Thank you, ma'am.
Yeah, judges, please proceed with the questions.
Okay. Ankita, I'll ask you one question. What was the treatment given to all your cases?
And they were kept on conservative management, and we gave the steroid cover. The antibiotics, what we give is prophylactically ampicillin. We give IV 1 gram 6 hourly for first 48 hours, and then erythromycin for QID 250 mg QID for 10 days. Or otherwise, if the culture reports come out to be like, we give send the urine culture, the high vaginal swab twice weekly, and based on the culture reports, whatever we change the antibiotics. And if any time the signs of yes.
So did you correlate with the culture report any of your study?
Yes, ma'am, we did. And the placental membrane actually is not in this slide, but the placental membrane cultures which we sent after delivery, that correlated.
Okay, so because
but the high vaginal,
because that is the gold standard. So
yes, ma'am.
You haven't correlated with that. That is my one point. And Dr. Ramandeep?
Yeah. So how many cases we have missed with the with the clinical signs? So how many extra patients we got with this subclinical?
Ma'am, actually, out of the 58 women who had histological chorioamnionitis, only 10 developed clinical symptoms. So what we saw was, although the patient had no signs, but after delivery, we see that there was a histological evidence, and then newborns also developed sepsis or other neonatal morbidities, increased hospital stay. So we think that we should use a marker which can help us to know earlier if the patient is developing infection, but she hasn't developed the overt signs, so that early delivery can be initiated. Yes.
Sorry to interrupt, Mukul. So second thing is, if LDH is, should we stop?
Yeah, ma'am, her time is over now.
Yeah, okay.
Thank you.
Thank you, ma'am.
Okay, thank you.
You can stop sharing your slide so that I can call the next participant.
Yes, ma'am. Yes, ma'am.
Thank you, Rupal. Yeah, so I would like to call Dr. Neena Parashar. Her title is COVID-19 in Pregnancy, and her paper code is 0210. Am I right, Neena?
Yes, ma'am.
Yeah. Okay, Dr. Neena, you can start with your Okay, Neena. So you have got another 6 minutes for your presentation and 2 minutes for your question and answers. Please stick to time, okay? Because you will be marked on the time utilized.
Okay, ma'am.
Okay, fine. All the best. Carry on.
Myself, Dr. Neena Parashar.
Yeah, she is Dr. Neena Parashar.
Good morning, everybody. I'm giving presentation on the topic COVID-19 disease management in pregnancy. In December 2019, a novel coronavirus, Wuhan, since then spread worldwide, being declared as a pandemic on March 11th by the World WHO. Since then, more than millions of people were infected and many have died. This transmission incubation period is 5 to 6 days. Range is 1 to 14 days. Transmission occur person to person by the respiratory droplets after coming in contact with an infected person, direct contact with contaminated surfaces through the infected feces. Cases have been reported in which the placental infection due to COVID-19 infection has resulted in the inflammation and death of the fetus. Vertical transmission has not been reported. Horizontal transmission is very rare. Disease symptoms. Most of the patients have the mild symptoms, 15% severe and 5% critical. Frequent symptoms are the fever, cough, myalgia, soreness of throat, and the loss of smell. Other symptoms are the loose motion, expectoration, etc., etc. Headache. Signs: oxygen saturation mostly less than 94%, pulse more than 94, temperature more than 100, respiratory rate more than 24 per minute. Diagnosis: the women are less likely to or infected due to the COVID-19 rather than the man. Investigations, respiratory samples are taken from the upper respiratory tract, that is nasopharyngeal. Swabs are taken for the PCR testing. If negative, PCR testing can be done from the lower respiratory tract also. Chest imaging, we find the bilateral infiltrates or consolidation. In CT scan, we find the bilateral and peripheral ground glass opacities. Blood sample, in hematology, we find the lymphopenia, leukopenia, thrombocytopenia. Biochemistry, transaminase level increased. There can be proteinuria, LDH level increased, C-reactive protein levels increased. Coagulation profile, prothrombin time, APTT, FTP, all increased. Severity markers are the ferritin, troponin, G-dimers, procalcitonin, they all increased. In medical history, we take the history, the travel history to the endemic areas, immunocompromised conditions coming from the hotspot areas, and exposure to the people with COVID-19 symptoms. Severity classification. In mild infection, the patient should be isolated at home, adequately hydrated, temperature control by the paracetamol, oxygen saturation by the pulse oximeter. Indications for the emergency consultation should be explained. No prolonged bed rest because thrombosis can occur, which is mostly associated with COVID-19 as well as pregnancy. Telehealth checkup visits in 24 to 48 hours for the assessment, and routine pregnancy visits, tests, and screening of the ultrasound will be postponed until the end of the isolation period. In moderate to severe cases, patients should be hospitalized. In high dependency isolated units, oxygen support should be given if saturation is less than 94%. Admission. Admission criteria, major and minor. In major criteria, when there is a need of ventilator and vasopressors. Minor criteria, when the respiratory rate more than 30 beats per minute, multilobular infiltrates present, confusion, disorientation, uremia, leukopenia, thrombocytopenia, hypothermia, and hypotension. Management. Antenatal care. Routine antenatal care should be tailored to the minimum, that is 12, 20, 28, and 36 weeks. Appointment should be given after the end of the isolation period. Fetal kick count should be maintained. Patient should take its own transport to visit to the hospital. Self-quarantine appointment should be deferred for 14 days. Antenatal ultrasound is recommended after 14 days of the acute illness. Infranatal care. Patient should be monitored. Patient should be isolated in the should be kept in the isolated delivery rooms in the high dependency units, and oxygen saturation should be kept above 94%. Mode of birth should not be influenced by the COVID-19 infection. Continuous CTG monitoring should be advised. Monitoring of the temperature, blood pressure, respiratory rate, and oxygen saturation should be done hourly. Vaginal examination should be minimized. Neuroaxial analgesia is not contraindicated. Material which is generated during the labor should be considered as the contaminated and should be thrown in a proper bin. Second stage of labor should be cut short, and early cord clamping should be done to minimize the severity of transmission. Cesarean delivery. Cesarean section should follow the usual obstetric indications. Maternal indications in severe cases where there is respiratory compromise, maternal hypoxia can lead to fetal distress. In that case, we can also do cesareans. Treatment protocol. Pharmacological treatments. No definitive pharmacological drugs have been approved till now, but the drugs which are most commonly used are the doxycycline, hydroxychloroquines, azithromycin, ivermectin, ceftriaxones, antibiotics, zinc, Montreal HC, Dolo, antiviral drugs, remdesivir. Antiviral drugs are the lopinavir, ritonavir, remdesivir, tocilizumab, and steroids, which are most commonly used as the dexamethasone in low dose, that is 6 mg for 10 days. In premature cases, betamethasone can be also used 12 mg injection followed 24 hours later to promote the maturity. Do's and don'ts. Until the patient report comes, patient should be considered as a positive patient and should be treated accordingly. Management should not be delayed waiting for the patient's report. Ultrasound equipment should be contaminated after seeing a postnatal care. Temporary newborn can be temporarily isolated from the mother, and if needed, physical bridges can be also used for it. Breastfeeding should be always encouraged, and if needed, breast pumps can be used.
Excuse me, Dr. Nina, time is up now.
Yeah.
Dr. Nina, you haven't done any study on COVID-19 in pregnancy. It was you just presented the overview of what is COVID-19 in pregnancy. Did you study it?
Yeah, studies I have did, but the trial are going on, so I was a bit confused.
Actually, it is one of the research, like if you have done any research and your data has to be presented. It is not the lecture which has to be taken on COVID-19. So it is not up to the guidelines, I suppose. Any question, Dr. Ramandi? Dr. Sumedha?
Yes, can you tell us what's the impact of COVID-19 on fetal outcome? Are there any increased incidence of, say, abortions or anomalies or anything?
Anomalies have yet not been found, but the miscarriages have been reported in some of the patients, and even the fetal deaths, stillbirths have been reported.
Okay. Do you want to share one of your experience, some experience of yours regarding COVID-19, of some patient that you dealt with or something?
Yeah, 5-6 patients I have seen in first semester, and they came out to be positive, and they all had abortions.
They all had abortions?
Yeah.
All 6 of them?
Or not all 6, 5 of them had.
So, but literature does not actually does not support this, that so many abortions, like almost 100% you're saying abortions.
5 abortions?
Yeah, 5. Okay, 80% abortion rate with COVID-19 in pregnancy.
Pardon?
I'm saying literature actually does not support this. You're reporting a very high incidence of abortions with COVID-19, right?
Maybe by chance, but found is this.
Fine.
We should, Dr. Ramandeep, you want to say anything?
No.
Okay. Next.
Thank you, Dr. Nina.
Welcome, ma'am.
Yeah, now I would request Dr. Nana Gautam.
Yes, ma'am.
Hi, Nana. Good morning. So, Dr. Nana.
Good morning, ma'am.
Study of estimation of vitamin D in first trimester of pregnancy. Her paper code is 0211. Am I right, Nana?
Yes, ma'am.
Yeah, Nana, you can start your presentation. You have got 6 minutes.
Yes, ma'am.
For presentation and 2 minutes for question and answers. Okay. Start sharing your screen now.
Ma'am, is my screen visible?
Yes.
Hello,
yes, it's visible.
Yeah, please start.
Good morning to all of you. Myself, Dr. Nana from Lady Harding. The topic of my paper is to study of estimation of vitamin D in first trimester of pregnancy. So the introduction, vitamin D3 is a powerful regulator of process named decydolization that correspond to the preparation of uterine cavity with modification of endometrial cell for establishment of pregnancy. It is a main regulator of gene named HOXA10, essential for the regulation of endometrial development and receptibility during the window of implantation and fertility. It is believable that a higher concentration of vitamin D in early pregnancy promote the successful embryonic and fetoplacental development. Thus, it has been sought to promote a more favorable environment for pregnancy through various mechanisms such as enhancement of the shift toward Th2 cell and regulation of immune cell differentiation and cytokine secretion. Therefore, it seems that vitamin D deficiency influence the balance toward a worse outcome and may play a part in recurrent pregnancy loss. So the aim and object of my study to compare the vitamin D3 level in the first trimester in pregnant women with recurrent early pregnancy loss with that of pregnant women without history of pregnancy loss. And the objective is to determine the vitamin D3 level in first trimester of pregnancy in women with history of recurrent early pregnancy loss and those women who had no prior history of pregnancy loss. The exclusion criteria as women, the exclusion criteria was women with thyroid disorder, diabetes mellitus, autoimmune disorder in first trimester of pregnancy, and the history of vitamin intake in last 6 months, and those women who refused consent. It is an observational cross-sectional study was conducted in Department of Ops and Gynae in Lady Harding Medical College from November 2018 to 2020. After a prior approval of Institutional Ethics Committee was taken, a written informed consent was taken from all the women enrolled in the study. In present study, 120 women with first trimester pregnancy between 7 to 9 weeks single life intrauterine fetus were enrolled and divided into the two group of 60 patient in each group. In case group, the women included with the previous history of recurrent pregnancy loss, and in control without history of recurrent pregnancy loss. The sample of vitamin D taken and were estimated in case and control, and all the patient were enrolled up to 14 week of gestation, and these are the normal, insufficient and deficient value of vitamin D. So the result of my study is maximum number of participant was in the deficient range of vitamin D3 level. In case group, out of 60, 46 had vitamin D3 level deficiency, and the mean standard value was this. And in control group, 47 out of 60 had vitamin D3 level deficiency, and the mean value was this. So there was no significant difference between the group in term of vitamin D3 level. In the study, 60% of participant in case group and 76.7% participant in control group were continued their pregnancy beyond 14 week in both groups. In the case group, most of participants had come in deficient range, out of which 22 participants had continued their pregnancy up to 14 week, and 24 participants had lost their pregnancy. So there was a significant difference between the patient in which pregnancy continued when 14 week as compared to the patient in which abortion occurred. In control group, 47 out of 60 had come in deficient range, out of which 33 participants had continued their pregnancy and 14% participants had aborted. So the difference was also found to be a significant. Discussion. Vitamin D3 level was detected 46 out of 60 patients in case group and 47 out of 60 patients in control group, and the mean standard deviation was the study was this in case group and this in control group. So in the present study, there was no significant difference found in both case and control group. Maximum number of participants in both group were come in the deficient range of vitamin D3. So the table shows in the present study, there was no significant difference between the group in the term of vitamin D3 level. The level of vitamin D3 were low in both case and control group. However, the number of abortion were more in case group, but the difference was not significant. The study conducted by Howe et al. Shows that there was a strong association between low vitamin D3 with the pregnancy loss, which was comparable to the present study. Limitation, it may be suggested that study with large number of subjects should be undertaken in order to draw conclusion evidence regarding to the role of vitamin D3 in recurrent pregnancy loss. Conclusion, it concluded that the vitamin D3 deficiency is a risk factor of first trimester pregnancy. Majority of the women in the both group case and control were vitamin D3 deficiency. There was a significant difference in abortion rate in women who had deficiency of vitamin D3 in both group. So the estimation of vitamin D3 level may be recommended in women who are planning to conceive, and if found deficient, then vitamin D3 supplementation may be advised. These are the references of my study. Thank you.
Nana, your time is up.
Yes, ma'am.
Okay. Nana, your title is estimation of first trimester vitamin D in pregnancy. It doesn't mention about recurrent pregnancy loss.
Yes, ma'am. Yes, ma'am. My title is this, but I had included the ma'am two group in case
okay.
group.
So it should have been included in your title. Next, I want to know, you said history of vitamin D intake was taken. How do you take that history of vitamin D intake? Is it in diet or you take it as a therapy of session?
No, ma'am. Is it in no, ma'am. Ma'am, I had taken if there is any prior history of taking vitamin D sachet or
so do you know how to calculate vitamin D in diet? Are you aware of any questionnaire or anything else which can evaluate vitamin D in diet?
Ma'am.
Okay. Dr. Sumedha and Dr. Amandi.
So how have you calculated the gestational age at which you have taken the vitamin D levels? Is it by ultrasound or is it by the LMP of the patient?
Ma'am, by the LMP and also by the first trimester scan.
By both. Okay.
Nana, so have you done any intervention, like so patients who are deficient, you given medication?
No, ma'am. I'm just only observe the patient and the outcome up to the 14th week of pregnancy.
Did you get the level at the enrollment or you did at the end of the study?
No, ma'am. With the ma'am, actually, when the patient come in the OPD and the ma'am, I was divided the patient into the two group, case and control group. If the patient come with the problem of recurrent pregnancy loss, firstly,
I'm just asking, did you store your sample or you did there and then?
No, ma'am, I stored my sample.
So you were not aware of the levels, no?
Yes.
They must have been evaluated at the end of your study.
Yes.
Okay.
Any other questions, ma'am?
So, Nana, there was more number of abortions in case group, right? So compared to the control group.
Yes, ma'am.
Right. So that means vitamin D is not associated with the pregnancy loss, which is significant, right? Because the recurrent pregnancy loss, you said there were number of abortions were more compared to the control group, but both the groups were deficient in vitamin D.
Yes, ma'am. Both the group had deficient range of vitamin D3, but the number of abortion is maximum in the was maximum in the case group.
So that means vitamin D is not associated with abortion. It's something else which is unexplained in the recurrent pregnancy group. So they said vitamin D has nothing to do with abortion. That means, according to your study.
Okay. What do you think are the other factors you think?
Ma'am, the other factor of recurrent pregnancy loss is, ma'am, 40 to 50% cases is unexplained, and the ma'am 20% cases of endocrinal endocrinal factor can also cause the recurrent pregnancy loss, and ma'am 20%.
So did you evaluate for other factors so that you can associate it to vitamin D only?
Ma'am, these are the ma'am in my exclusion criteria, ma'am. जो endocrinal factors थे मैम, जैसे diabetes and मैम thyroid disorder and autoimmune disorder, this was the exclusion criteria.
So mention किया था, mention किया था.
Yes, ma'am.
So basically your cases were unexplained losses?
Yes, ma'am.
So that is why how you could correlate to vitamin D, isn't it?
Yes, ma'am.
So I am asking, what were the factors? Like you have excluded other factors. So what do you think? Was it only vitamin D? Or can you think of some other factors which are present and unexplained?
Yes, ma'am. It might be other factors which...
Like? Okay.
And the age of women.
What else?
I think, ma'am, we have exceeded the time.
Yeah.
So thank you, Dr. Nana.
Thank you.
Okay. And now I would like to call the next participant, Dr. K. Aparna Sharma. Are you there, Aparna?
Yes, I'm there.
Hello, Dr. Aparna. Ma'am's title for presentation is Improving Care of Pregnant Women During COVID-19 Pandemic Using Telemedicine Services. And her paper code is 0212. Over to you, Dr. Aparna. We can see your slides.
Yes. So can I start now?
Yes, please.
Okay. So basically, our project was to see how technological interventions can address the knowledge gaps in pregnant women during the COVID-19 pandemic. And we all know about the pandemic, and the currently available data suggests that pregnant women may be at increased risk of severe illness, ICU admission, and mechanical ventilation. So in such a situation, providing prenatal care becomes very essential, and connected care solutions and telemedicine may be useful tools.
So provision of a broad spectrum of obstetric service needs to be carried out with the help of a combination of care as well as telemedicine. So our objective was to assess the knowledge and awareness of pregnant women about COVID-19 and to evaluate the feasibility of using a smartphone application for patient education. So this was a cross-sectional studies in April to July in our hospital, and we included 58 pregnant women who were already registered with us under the Swasth Garbh application. So the registered women were given a baseline knowledge survey, then we identified the gaps in the knowledge and we generated an educational video and which was sent to them, and a feedback assessment was taken. So just to give you a baseline, so this is a Swasth Garbh app which we have developed in association with IIT Roorkee, and he is the co-investigator for the study as well. Now in this, we are already recruiting pregnant women, making sure that their quality of antenatal care is better. So what we did is we did a baseline assessment which comprised of 10 close-ended questions with a yes or a no response, and a score of 1 was given to each yes, and a total baseline score was calculated. A baseline anxiety level was asked by asking the woman to rate it on a scale of 1 to 10. Now, these were the 10 questions which related to knowledge of the woman regarding COVID-19 and also pregnancy. This is the app which, when opened, this area shows where we introduce the COVID-19 advice to the patients, which is in the form of a video. And this is a snapshot from the video where it was taken in a bilingual language and it was recorded, and various information like how COVID can affect you was actually delivered in a bilingual manner. Option of Hindi and English was taken. What all can be done to prevent yourself from COVID-19. In addition to this particular video, because of this application, we were in continuous touch with those patients. Push notifications were sent from time to time. Videos were shared on diet and yoga to improve their morale, and trimester-specific advice was given, and also treatment for specific complaints would be given to them through this app. And how did we take the feedback? We carried out a structured questionnaire which included an assessment of the patient knowledge and awareness, and a score of 1 was given to an answer of yes. And patient satisfaction was assessed in terms of the quality of care, the ease of accessibility, and the information which was provided. And the outcome measures were improvement in knowledge, effect on anxiety level, and patient satisfaction. So 58 patients were recruited, as we've said before. Mean age was 25 years. Mean POG ranged from 18 weeks to 39 weeks with a mean of 26 weeks. And we received a feedback from 83.9% of the patients. The patients did have a good baseline knowledge in terms of the COVID-19 infection, but their assessment of the effect of the pregnancy on the infection on pregnancy was not very good. And also the danger signs were something which were lacking in the awareness of the patient. According to the anxiety levels, due to an ongoing pandemic, the anxiety was reported to be around 85%, and on being asked to rate the anxiety levels on a scale of 1 to 10, a mean of 6.2 was seen. In terms of patient satisfaction, overall, the quality of healthcare as good or above, with around 45% calling it excellent, the green part. Regarding the information provided, again, 98% felt that it was good, very good, or excellent. In terms of accessibility, this patient said that throughout the pandemic, they felt connected to the provider in terms through the app, and regular information was provided to them. So more than 98% felt that it was good or above, with around 38% feeling that it was quite good. And mean satisfaction rates were 4.2, 3.7, and 3.6 out of a score of 5 in all of them. And we see an improvement in the knowledge scores in terms of the danger signs in pregnancy, effect of pregnancy on COVID, methods of infection prevention, and preparedness for hospital visit, because this was something which had changed, that you cannot just walk into the hospital. You need to be more prepared. You need to be prepared about where do you want to go. So all of these factors were something that we really worked upon, and we gave that message to those patients. And we did see an improvement in these parameters in terms of a pre and a post intervention. Knowledge scores also improved from 6.25 to 7.5 overall knowledge scores. So in our study, we found that the awareness among patients about the disease spread and symptoms was high. However, certain areas with low awareness were identified. Anxiety was high. Feedback on the overall satisfaction was good. In one of the other studies, most of them have just taken a knowledge attitude questionnaire in which 80% of the women reported an overwhelming distress. In another study from China of 161 women, there was a high level of knowledge. However, effect on pregnancy was also not noted. But these studies are not something in which an intervention was done depending on a gap analysis. So our study aimed to address the stressors to mitigate anxiety among pregnant women and utilize telehealth for the purpose as well as for this purpose and as well as to educate women, because misleading information and information from unreliable sources has immense potential to cause anxiety. So to conclude, to our knowledge, this was the first study in India to explore the possibilities of a use of a web-based mobile application for educating and counseling pregnant women to evaluate improvement in their knowledge. It was, however, cross-sectional in nature, had a small sample size because we only took the women we had already in the Swasthya application. And definitely the validation of the knowledge assessment scales remains to be done, which we are in the process of.
Yeah, sorry, Dr. Aparna, your time is up now.
Yes, I said thank you before the time.
Yeah. You are very nice and innovative idea, Dr. Aparna. And I'd like to know, did you follow them later on or just one time only?
Oh, so as I said, as I mentioned, there was one baby
Actually, there was an interruption. Yeah. No. Study I understood, but later on, did anybody develop COVID or anything like that?
No, so basically, patients developed. 20 patients were delivered, and some of them are still on follow-up, but none of them have actually developed COVID.
Okay, just for my information.
Dr. Panna, so was it only for the COVID disease? So what happened to the normal antenatal care of the patients? They followed somewhere or?
No. So Dr. Ramandeep, so basically these patients were already following on this app for their routine antenatal care also. So this app was a supplement for routine antenatal care as a reminder for them that you need to come, you need to do these investigations. So we were already connected for routine antenatal care. So we supplemented an information on COVID-19 for these patients.
Okay, so this study was basically to see the COVID, to counseling for the COVID and apprehensions for the COVID, but not for the normal antenatal. This topic is not for the antenatal care of the patient.
The study that we are doing, and we have actually seen that because 8-visit model of WHO was devised. Now we have shortened that to 4-visit model, and we are seeing the rest of the 4 can be done through telemedicine. So this app is also helping us to do that in those sense because we are connected to those patients. So, but in this particular part of the study, I have not presented those results.
Yeah, because your topic is improving care of pregnant women during COVID-19 pandemic using telemedicine. But here you're focusing mainly on the COVID disease.
Yes, so basically it is when, yes. So using address, so basically I think there has been some distinction because my topic should have been like technological intervention to address knowledge gap.
Yes.
My title and presentation here today.
Yeah.
The first.
I thought you will tell me about your pregnant, the normal antenatal care which we do through telemedicine. How you followed up the patient, high risk patients को हमने कैसे separate किया and those things.
Title is a bit deceptive, otherwise study is good.
Yeah, study is good. Yeah. Okay, thank you.
Thank you.
Shall we move on to the next participant, ma'am?
Yes.
Thank you, Dr. Aparna. Now I would like to call Dr. Anjali Mantri. Our topic of presentation is method of delivery of baby and maternal and neonatal outcomes in second stage cesarean sections. And the paper code is 0213. Dr. Anjali, are you there? Dr. Anjali Mantri. Dr. Anjali Mantri.
She just joined.
Dr. Anjali, are you there? Or with the permission? No, Dr. Anjali, she is there.
Hello.
Yeah, Dr. Anjali, we can hear you. We can see your presentation also. You please start with your slideshow.
Hello.
Hello, Anjali.
Hello.
Anjali, you are audible. Start the slideshow. Yeah.
Anjali, please start with your presentation. You are given only 6 minutes. All the participants, please be ready with your presentation.
Hello, ma'am. Am I audible?
Yeah, you are very much audible and we can see you also. Please start with your presentation.
Ma'am, good morning all. My topic of presentation is method of delivery of baby and maternal and neonatal outcomes in second stage cesarean sections. So the introduction, cesarean delivery is the delivery of the fetus through surgical incisions via the abdominal wall and the uterine wall. The most common indications for primary cesarean delivery were labor dystocia, abnormal or indeterminate fetal heart tracing, fetal malpresentations, macrosomia, arrest of descent of head, CPD, and pelvic tumors. So second stage cesarean section, it is an emergency. So this research was undertaken to see the shortcomings which were faced pre-operatively and intraoperatively, which were going to influence the maternal and neonatal outcomes, and to reduce those shortcomings so that we could have a beneficial and a positive outcome on the mother and the baby. It was a prospective observational study of 60 patients, all singleton pregnancies with cephalic presentations, more than 36 weeks gestation, who were recruited from labor room, who were planned for second stage cesarean and first stage cesarean over a period of 1 year. Patients with growth or fetal growth restriction, antepartum hemorrhage, and previous cesarean delivery were excluded. The patients were observed intraoperatively for the method of delivery of baby, the surgical complications found during delivery, the neonatal outcomes, and the post-operative outcomes of the patients were also observed till their discharge from the hospital. So the results showed here that in second stage cesarean, the Patwardhan technique, out of 60 patients, 36 patients were delivered by Patwardhan technique in second stage cesarean, and out of 60 patients, 51 patients were delivered by cephalic technique in first stage cesarean, which were both found to be statistically significant. So now seeing the maternal neonatal outcomes, complications, we saw the extension of uterine angles, the features of obstructed labor, the NICU admission, GCA in baby, and need for resuscitation, which were all higher in second stage cesarean group as compared to the first stage cesarean group, and were statistically significant. Rest of all the complications of maternal and neonatal were also found to be higher in second stage cesarean group, but were not statistically significant. So in second stage cesarean group, Patwardhan technique was the most opted one, along with the modified Patwardhan in obstructed labor. It did not cause extension of uterine angles and PPH, and which was statistically significant. Cephalic technique did cause more extensions of blood transfusions and hyperbilirubinemia in baby, but was not statistically significant. Breech extraction did cause more extensions, 14 times, 17 times more PPH, 7 times more blood transfusions, bladder injury, higher risk of NICU admissions, higher need for resuscitation, which were all statistically significant. So higher surgical time, we also saw that the surgical time also caused more maternal and neonatal complications. So higher the surgical time did cause higher development of extension of angles or bladder injury and PPH, which were all statistically significant. It also had an impact on blood transfusion, NICU admission, higher APGAR less than 7 in baby, and negative impact on resuscitation of baby and hyperbilirubinemia. So here in this study, we saw that Patwardhan technique was the most opted preferably and was the most statistically significant in delivering the baby in second stage cesarean, followed by cephalic technique, and it did cause less maternal and neonatal complications, which were similar to studies done by Kumarasan et al. And Moodley et al. Respectively. So when we saw the comparison of various maternal complications as well as the neonatal complications, we found that all the maternal complications like extensions, bladder injury, PPH, pyrexia, all were higher in second stage in my study, which was comparable to study done at Lurie et al., Samal et al., Ibrahim et al. And even the neonatal complications like GCA and NICU admissions, need for resuscitation, APGAR less than 7, hyperbilirubinemia, all were found to be higher in second stage compared to first stage, compared to other studies. So in this study, breech extraction technique had the greater risk of maternal and neonatal complications. Patwardhan technique was the most commonly used measures with minimal maternal complications, like the study similar to Kumarasan et al. Done in 2018. But on contrary, neonatal complications had no approval in the study since most patients were unbooked, some had GCA, some had prolonged labor, but in longer outcome, neonatal complications were minimal. So comparison was also done between the surgical time and the maternal and neonatal complications. So it was found more the surgical time, more were the maternal complications, like similar to a study done by Sebekula et al. But it had a minimal impact on the neonatal complications since in the study, any trial of instrumental delivery was excluded. So concluding, we saw that surgical time in second stage cesarean was more than the first stage cesarean, because since it was mostly carried out during emergency hours by the residents, there was a lack of expertise and training of the residents and various constraints of the hospital, which were the main cause behind this prolonged time. Patwardhan technique was the most opted in second stage compared to the first stage, and Patwardhan technique caused minimal maternal complications, but neonatal complications were slightly high in the study, minimal when observed for a prolonged period of 2 weeks. Since the patients were mostly unbooked, it was carried out during emergency hours by residents, and it was a prolonged labor with deeply impacted hair. Breech extraction had higher chances of maternal and neonatal complications in this study. Length of urinary catheterization in second stage was higher, more than 7 days, because of the edematous and the higher bladder. And the maternal complications and the neonatal complications were both higher in second stage compared to the first stage cesarean section. So since this study was time constrained, had smaller sample size, some of the results were bound to be inconclusive, but even in the small sample size, technique of delivery, length of urinary catheterization, maternal complications like post-operative stay and features of obstructed labor, they were all found to be statistically significant in second stage cesarean over the first stage cesarean. So from this study, it could be concluded that lack of expertise, the training, and the residents were of training of the residents were one of the flaws of the maternal neonatal complications increased in second stage cesarean. So emergency sections, unbooked women, and constraints of the hospital were the major flaws who added to the complications. So we require more training of residents, women getting booked earlier, decisions by increasing the MOT, and efficient and trained working staff will positively influence and reduce the maternal and neonatal outcomes and compared to the first stage cesarean section. Thank you.
Thank you, Dr. Anjali. Very much on time.
Yeah.
So in this study, have you compared the different methods, like the Poshanda Pol technique for second stage cesarean, or you have just compared the first and the second stage cesareans?
Ma'am,
in terms of complications and other things?
Ma'am, I compared the complications between the first stage and the second stage cesarean, various complications.
And out of your study group, in the second stage cesarean, only three patients had a breech extraction done.
Yes, ma'am.
So I think that number is too small to actually conclude that breech extraction has more complication as compared to the Patwardhan technique.
Yes,
ma'am. It is a very minuscule number, right?
Yeah.
And what about one thing that you mentioned about GCA, that in second stage cesarean GCAs were more? It must have been coincidental, I think.
Yes, ma'am. It was coincidental. So not due to the delivery method of delivery or due to second stage, it was coincidental.
And it was done by all one type of resident, like third years, or by a second years, or was it uniformly? Was anything like, were the surgeons uniformly trained, or study? It was done by different kinds of people every time.
It was all done by senior residents, basically.
Okay.
And assistance was done
Like
by
senior resident, I want to know first year, second year, some uniformity in pattern so that you can compare.
Ma'am, mostly the second year senior residents and the third year did the second stage cesarean section.
Okay. It would have been better if some uniformity in the surgeon would have been kept. So less of variation would have, uniform study would have been, because that is one of the biggest factor in deciding the complication rate, isn't it? Okay, anything else, Dr. Ramandi? You want to say anything?
No.
Okay, otherwise, it was very nice study, more practical and clinical based study. Okay, thank you.
Thank you, Dr. Anjali.
Thank you, ma'am.
So, ma'am, with your permission, can I call the last participant, Dr. Charu Sharma?
Yes, please.
Dr. Charu Sharma, she's our last participant of the session. Yeah, she's speaking on QF-PCR for perinatal diagnosis of chromosomal abnormalities in amniotic fluid samples, a substitute for conventional karyotyping, or is it complementary? The paper code is 0214. Dr. Charu, are you there?
Yes, ma'am, I'm there.
Yeah, please start sharing.
Is my screen off?
No, we can't see your screen. Dr. Charu, we can't see you.
Ma'am, is it?
No, we still don't see you.
Technical team can guide her, please.
Yes, ma'am. Dr. Charu, there is an option of share screen, right?
Yeah, I've clicked that option.
Yeah, please click on that option.
Have you opened your PowerPoint presentation?
Yes, it is open.
And
It is
that,
open.
and that
Then please click on that button.
I'm clicking on share screen.
You're still not visible.
You have some option, click on the desktop option. Yeah.
Yeah, now we can see you, Charu.
Okay, ma'am.
Yeah. Please start your presentation because you have only 6 minutes for presentation. Okay?
And please do slideshow.
Yeah.
So my topic is QF-PCR, that is quantitative fluorescence polymerase chain reaction for prenatal diagnosis of chromosomal abnormalities in
Dr.
amniotic
Charu?
fluid samples.
Dr. Charu, sorry,
Yes,
I'm
ma'am.
interrupting you again. Half of your screen is still not visible.
Click another slide. Yeah. Present
No,
like this only. Yeah.
Okay, ma'am. Is it visible, ma'am?
Now move on to next slide. Maybe it's visible then. No. So you go back to the previous option. Yeah. Do it like this one.
Okay. So for the chromosomal abnormalities, the prenatal diagnostic tests that we offer, these are basically the karyotyping, FISH, QF-PCR, the targeted sequencing, clinical exome, whole genome sequencing, and chromosomal microarray. So here we are basically confined to the karyotyping and QF-PCR. So basically there is a shift from cytogenetics to molecular genetics. In all the countries, the gold standard for prenatal diagnosis of chromosomal aneuploidies is commonly the standard cytogenetic methods, that is the karyotyping. So the advantage of using karyotyping is to analyze the structural chromosomal abnormalities also apart from aneuploidies, like balance translocation, inversion, deletion, etc. But the limitations are that embryonic cell cultivation has to be done, which takes around 2 weeks for culture, and there is long waiting time, psychological anxiety, and delay in decision in high risk pregnancies. On the other hand, the QF-PCR method is a rapid method which can detect aneuploidies but not the structural abnormalities or mosaicism. So our primary objective was to evaluate the potential advantages and limitations of using rapid tests as a replacement or as an adjunct to traditional karyotyping. And the secondary objectives were to observe the pattern of genetic disorders while offering prenatal diagnostic testing. So this was a prospective observational study, and it is just an interim analysis of an ongoing project. The study duration is 1 year. It was done in the Department of Obs and Gynae at AIIMS Jodhpur. All cases attending the antenatal or genetic clinic who were screened positive for aneuploidies and who fulfilled the inclusion criteria were included. So this was the inclusion criteria. That is the patients having history of chromosomal abnormalities in the previous baby, high risk on aneuploidy screening. If the nuchal translucency was more than 3.5 millimeter, previous syndromic baby, parents with balanced translocation, or any structural abnormality on the ultrasound. Females not giving consent or the gestational age if it was not fit for the procedure, that those patients were excluded. So this was the workflow. All patients underwent pre-test genetic counseling, and then the amniocentesis or the CVS was done and the sample was collected. For amniocentesis, we used to collect 18 to 20 ml of the amniotic fluid, and one part, that is around 1.5 to 2 ml, was sent for QF-PCR, and the other part was sent for karyotyping, and the results used to come for QF-PCR within 48 hours, whereas for karyotyping, it used to come in 2 to 3 weeks. And then the results were compared by both the methods, and post-test counseling was also done. So these were the results. A total of 78 cases, out of which 72 amniocentesis and 6 CVS were done in the last 1 year. The median age of the participants was 27 years. The median gestational age for amniocentesis was 16 weeks and CVS was done between 11 to 13 weeks. 62 out of 78 samples were sent for both QFPCR and karyotyping. The remaining samples were basically not for aneuploidies but for some single gene disorders. As far as aneuploidy was considered, QFPCR had 100% sensitivity and specificity, but when the mosaics and other chromosomal rearrangements were considered, QFPCR failed to detect these structural abnormalities and mosaicism. So this was the comparison of QFPCR and conventional cytogenetics. By QFPCR, we could detect 6 cases of trisomy 21 and all 6 were also detected on cytogenetics. Similarly, there was no case of Edward or Patayu syndrome, but one case of monozymy, that is Turner syndrome, was detected by both these methods. So the total detection of abnormalities was 7 in case of QFPCR, but when the karyotyping was compared, we had 3 further cases which were normal on QFPCR, but they had some chromosomal rearrangements. That is, one had inversion defect on chromosome 4, one had Robertsonian translocation on chromosome 14 and 15, and the other one had a unbalanced translocation on chromosome 1. The total abnormalities were 11. When distribution of cases were compared according to the risk ratio, so if the risk ratio was equal to 1:250 or higher than this on combined screening or quadruple screening, the detection rate was 2 cases in QFPCR and 2 cases had structural abnormality, so they were detected on karyotyping. And in the intermediate risk category, none of the cases were found to be abnormal, whereas those cases who had abnormality on ultrasound, we could detect 5 cases by QFPCR and 1 case on karyotyping which had structural abnormality. So where the problems encountered, in case of QFPCR, all 62 samples had the report, but in case of karyotyping, 3 cases could not be analyzed because there was maternal cell contamination, and in 1 case, the metaphase cells could not be found. So these were the ultrasound abnormalities that we had detected, and this case had no combined screening or any biochemical screening previously. This was only the ultrasound features had mild ventriculomegaly, echogenic bowel, and protruded tongue in the same patient. And
Dr.
this case
Charu,
was found to be.
Yeah, you're running out of your time. Your time is almost up now. Okay, you are another 30 seconds. Please complete your presentation in that.
So these are just the reports, how the reports look like. And discussion, this was a study done in Iran in 2015, and this was a big study done on around 4,058 patients, and they have also concluded that where large-scale conventional cytogenetics is hampered by its high cost and lack of technical expertise, QFPCR may be used as a first-line prenatal diagnostic test. And this study was done in 2019, which concluded that QFPCR method is especially important because it is fast, accurate, low cost, and has a short turnaround time. So the conclusion is that QFPCR should not be used as an alternative to karyotyping, but it should be used as an adjunct because it decreases the anxiety of the patients to a great extent, and decision has to be tailored according to the patient. If a patient comes late in gestation, it is well justified to do QFPCR owing to its rapidity. Thank you.
Dr. Charu, this was you said an interim result of your ongoing study.
Yes, ma'am.
So what were the outcomes like of these detected when they were finally confirmed by karyotyping?
Yes, ma'am.
Yeah.
Ma'am, 5 cases were confirmed by karyotyping, and in 2 cases, because 5 cases they were terminated, so they were confirmed on karyotyping, and in 2 cases the patients they continued the pregnancy.
Okay.
So they even after post-test counseling, they continued the pregnancy and they delivered a baby with a Down syndrome. And then clinically, when they were examined, they had features of Down syndrome. And in one case, the patient had an intrauterine death. So that case could not be confirmed because she delivered outside.
Dr. Charu, what is the cost difference between the two tests, getting a karyotype done as compared to a QF-PCR?
Ma'am, the cost difference is only 500 rupees. QF-PCR cost around 3,500 rupees and karyotyping cost 3,000 rupees.
So not much a cost factor there.
Yes, ma'am.
But you rightly concluded it's a ancillary.
Complement.
Yeah, it's not diagnosed with a completely gold standard, but yes, it can delay the anxiety because it's rapid test. Yes.
Yes, ma'am.
Charu, I missed one slide. So you have done both the test, QF-PCR and karyotype in all the patients?
Yes, ma'am.
In all the patients?
Yes, yes.
Ma'am, because we have excluded those cases in which we could do only one test because of the cost of the test. Because some of the patients, they said that they have time. They were at 15 weeks, so they said they will go for only karyotyping. So we have excluded those cases. We have included only 62 cases here in which both the tests were done.
And there was one baby who was born with the Down syndrome. So that
Yes,
was
ma'am.
based on both, on QF-PCR as well as on karyotype.
No.
Yes, ma'am.
Charu, you said.
Ma'am, the baby who was born with Down syndrome, that was positive on both.
But they continued. They chose to continue.
Yeah.
She was 44 years old and that was an IVF pregnancy. So everything was explained to her, but then still she wanted to continue.
Okay.
A nice study.
Thank you, ma'am.
Thank you, Dr. Charu.
Thank you.
So I
Thank
think
you.
we're done with this session. Yeah.
Thank you, everyone, for giving us the opportunity. And Dr. Shamishta, you are from Gangara? Dr.
Yes,
Shamishta?
ma'am.
Okay.
I'm a consultant over there.
Okay.
Yeah,
nice.
I'm a consultant in Gangara.
Okay, nice. You're keeping everybody in time. Very nice.
Yeah, that's the most important thing, ma'am, because we're very tightly
packed. Yeah. And doing a very good job virtual platform.
Thank you, ma'am. It's a new thing for every one of us. So, ma'am, it's a request. Please mail your scoring sheet to augdvirtual.com.
Yeah,
okay,
sure.
ma'am? Okay, Sumita, ma'am. Thank you.
Okay.
Ramandeep,
Thank
ma'am.
you so much.
Okay,
Thank
ma'am. So, okay, Dr. Charu, thanks a lot, dear. It was a great presentation. So now we are moving on to session 3. I think all judges are there. I request Dr. Shakuntala Kumar. She's our senior consultant in Fortis Hospital, Shalimar Bagh. Dr. Tina Verma, she's again consultant in Doda. Yeah, in Doda's Diagnostic Center. She's a consultant fetal medicine over there. I welcome Dr. Tina. And we have Dr. Jyotsna. She's senior consultant in Jahangir Hospital and Jupiter Hospital, Pune. So they will be my esteemed judges for session 3. Yeah, I see all of them. A very good morning, ma'am.
Good morning. Good morning.
Yeah, so without any delay, I would like to welcome my first presenter, who is Dr. Ritika Prasad. Dr. Ritika, are you there?
Good morning, ma'am. Am I audible?
Morning, Ritika. Yeah, you are very much. We can see you. You have got a beautiful face. So, Ritika, you can start with your presentation. Her title for presentation is Study of Feto-Maternal Outcome of Patwardhan Technique for Deeply Impacted Fetal Head during Second Stage Cesarean Section. And her paper code is 0315. Okay, here you go, Ritika. Yeah, definitely. Acha, Ritika, you have got 6 minutes for presentation and 2 minutes for question and answer, okay? So try to be on time. You will be marked on this.
Yes.
Okay. Yeah.
I'll be presenting. My title of the thesis was Study of Feto-Maternal Outcome of Patwardhan Technique for the Delivery of Deeply Impacted Fetal Head during Second Stage of Cesarean Section. Co-authors were Dr. Prabha Lal Ma'am, Institution at Lady Hardinge Medical College and Associated Hospitals. Introduction. Second stage cesarean section is a difficult procedure and associated with deeply engaged head, less liquor, and thinned out lower uterine segment, leading to high risk of maternal morbidity and neonatal morbidity. Maneuvers that have been tried during second stage cesarean section are like conventional method, Keflik first method, push technique, reverse breech extraction, and Patwardhan technique. The first three methods, they are associated with higher chances of colporexis, extension of uterine incision, traumatic PPH, and fetal complications. Patwardhan technique was introduced to reduce these complications. The only disadvantage of this technique is that minor chances of injury to brachial plexus. So, although Patwardhan technique appears to result in reduced maternal and neonatal morbidities, the data in this support comes from a very small number of studies. Materials and methods. It is a prospective observational study. 60 women were included in the study. Inclusion criteria were period of gestation more than 37 weeks, all uncomplicated pregnancies, singleton pregnancy, cephalic presentation, second stage arrest with deeply impacted fetal head. Exclusion criteria were multiple pregnancies, IUDs, fetal distress, GCA babies, APH, medical disorders like severe anemia, previous cesarean sections, FGRs. An informed consent was taken from every woman. Maternal and fetal monitoring were done as per protocol in labor. And then Patwardhan technique was used for delivery of fetal head during second stage of cesarean section. For back anterior, delivery of the anterior shoulder was done, followed by delivery of the posterior shoulder, then followed by delivery of the trunk, and delivery of head was done at the last by Patwardhan technique. For back posterior, first available shoulder is delivered, introduction of hand towards the fundus, foot is gripped and gently pulled out. Assistant applies fundal pressure, breech is delivered, head is delivered out, lifting the legs. Outcome measures were recorded as maternal outcome and neonatal outcome. Maternal outcome consisted extension of uterine incision and intraoperative and postoperative complications. Neonatal outcome were birth trauma, asphyxia, neonatal septicemia. Observation and results. In demography, mean age of the population was 25 years. Mean height of the population was approximately 148.95 centimeters. Mean BMI was 25.89. 70% of the women had gestation age 38 to 40 weeks. Distribution of women according to gravity, primary gravitas constituted 71.7% and grand multi was 10%. Labor characteristics, majority of the women, 70% had spontaneous onset of labor. 76.7% required augmentation of labor with oxytocin. Duration of labor, mean duration of first stage of labor was 3.21 hours, while mean duration second stage 2.4 hours. Indication of second stage cesarean section in DTA was in 58.3%, direct occipito-posterior position 15%, and fetal distress 6.7%. Maternal outcomes, intraoperating findings of the women undergoing second stage cesarean section. Bladder advancements was noted in 63.3%, thinning of the lower uterine segment 70%, ballooning of lower uterine segment in 33.3%, sorry, obstruction in 10%, and 100% of the cases had deeply impacted fetal head. Level of the surgeon performing the surgeries, 53 out of the 60 women, they were operated by surgeons of senior resident caliber, and 11 women were operated by consultants. Duration of the surgery, average duration of surgery was 1.49 hours. Intraoperative complications, broad ligament hematoma was not observed in any case. None of the cases required cesarean hysterectomy or ICU admission. Bladder injury was noted in one case, and 2 cases had a uterine extension, incision of the uterine extension. Postoperative complications, fever was noted in 21.7% cases, paralytic ileus in 10%, prolonged catheterization more than 48 hours in 15% case. Wound sepsis was noted in 11.7% cases out of this, which 8.3 required resuturing, and hospitalization for more than 7 days were needed in 20% of the cases. In neonatal outcomes, birth weight of the neonates, mean birth weight of the neonate was noted as 3.13 kgs. Neonatal complications, Apgar less than 7 at 1 minute was noted in 10%, birth injury in no case, severe birth asphyxia in 6.67 cases, respiratory distress in 25% case, requirement for resuscitation required in 16% cases, HI no case, and need for mechanical ventilation in 8.3% cases. There was no case of neonatal death. 91.7% cases of the babies, they were shifted to mother, and NICU admission was noted in 8.3% cases. Correlation of intraoperative complications and level of surgeon. P-value of the difference was not significant as the number of cases included were not many. Discussion, mean age of the population in study was 25 years, comparable to other studies. Major percentage of women landing up in cesarean section were primigravida gravida, and which can be due to dysfunctional labor or late diagnosis of CPD or abnormal positions. Mean BMI in our study was 25.89, which was comparable to other studies, suggestive of obesity being a risk factor for increased rate of cesarean section in
Pardon
second
me,
stage.
Ritika.
Hi,
You're done with your time. Yeah, your time is over now.
Yes, ma'am.
Wind up your presentation another 30 seconds. Yeah.
I'll just conclude. So second stage cesarean section is a complicated surgery predisposed to complications leading to fetal-maternal morbidities. Use of Patwardhan technique for extraction of deeply impacted fetal head in these cases, when done skillfully, lead to complications significantly less than various other methods, hereby having less fetal-maternal outcome.
That was a good presentation, Dr. Ritika.
Thank you.
Just have a question. That is, why the previous cesareans were excluded? Why it was an exclusion criteria in your study?
Ma'am, previous cesarean sections already have many high-risk factors.
Right.
The intraoperative time increases. They can have scar dehiscence, with further increase lead to fetal distress and intrauterine deaths. So there, because of various other morbidities which are increased operative time and post-operative complications, we had excluded previous cesarean sections.
Okay.
Ritika, I just wanted to know how many were booked and how many were unbooked, because your first stage was pretty short. The mean first stage of labor was short.
Yes,
so for a person to go into obstruction and take up for a second stage section,
Yes,
is
ma'am.
it that they are mostly unbooked and they're coming late to the hospital?
Yes, ma'am, that was a limitation of the study because we are a tertiary care center, so many cases were referred from other institutes. So approx 46% cases, they were referred from other institutes. That constituted a large number.
Okay, one question I also have. Sharmishta, do I have time to ask one question? Yeah, so I just had one question that, see, Patwardhan technique is known from quite years and it has been well established. So how has your study added to the new information about the use of Patwardhan technique?
Ma'am, it is practiced, but in many cases, the practicing surgeon is not very versed with the technique. So it is many at many setups, Keflik first method is being tried because because it actually depends on the caliber of the surgeon and how familiar he is with the technique.
Yeah.
So promoting Patwardhan technique would be a better thing because it would lead to less extension of the intrauterine incision and further less injury to the bladder.
Okay.
Thank you, Ritika.
Thank you, ma'am.
Thank you, Ritika. It was a wonderful presentation.
Thank you, ma'am.
And yeah, okay. Can you please stop sharing your slides so that I can call the next participant?
Yes, ma'am.
Now we have Dr. Ankita Singh, who is presenting her paper on placental migration of mid-trimester low-lying placenta, a retrospective analysis. Her paper code is 0316. Dr. Ankita Singh, because we have got two Ankitas in this session. One is Ankita Singh, another is Ankita Kumari. So I'm requesting Ankita Singh with a paper code of 0316 to start with her presentation.
Ankita Singh has not joined, right?
Has not joined.
No.
So without wasting time, I will move to the next participant. Dr. Shilpa Singh, are you there? Dr. Shilpa Singh? Dr. Shilpa Singh? Dr. Ankita Kumari?
Yes, ma'am, I'm here.
Are you ready with your presentation, dear?
Yes, ma'am. May I start?
Yeah, definitely you can start. With the permission of my judges, Dr. Shakuntala, Dr. Tina, Dr. Jyotsna.
Definitely, please start.
Please
start.
He's the fourth one because
Ma'am,
we have got two Ankitas.
Ma'am, is my screen visible?
No, Ankita, not yet.
Okay.
You have to share your screen, Ankita. Open your presentation and press the button, the green button, sharing.
Ma'am, now is it visible?
Yeah, we can see you now. Okay, so you've got 6 minutes here. Yeah, start your presentation. Ankita,
Yes, ma'am.
code is 0318. Am I right?
Yes, ma'am.
Okay, Ankita, start with your presentation.
Good morning, everyone. I, Ankita Kumari from Lok Nayak Hospital, will be presenting a paper on obstetric hysterectomy. Obstetric hysterectomy is removal of the uterus performed at the time of cesarean section following vaginal delivery within the puerperium or for complication following termination of pregnancy. Its most common indication was atonic PPH, but with advent of new pharmacological agents, balloon tamponade, and conservative surgical techniques, its incidence due to atonic PPH has decreased. However, it is still performed as a life-saving procedure in current obstetric practice with similar or even increased incidence worldwide. The objective of this study is to assess the role of obstetric hysterectomy in current practice and its predisposing risk factors. Primary outcomes are incidence and indications. Secondary outcomes are risk factors, maternal morbidity, mortality, and perinatal outcomes. It is a retrospective study conducted over a duration of 2 years from April 2018 to March 2020 in Department of Obstetrics and Gynecology, Lok Nayak Hospital, New Delhi. Out of total 26,500 deliveries in 2 years, 26 women underwent obstetric hysterectomy, making an incidence of 0.98 per thousand. 3 case files could not be retrieved, so data analysis is done for 23 cases. In this study, we observed that adherent placenta was the major indication leading to obstetric hysterectomy, seen in 16 cases, followed by ruptured uterus, seen in 6 cases. One obstetric hysterectomy was performed for pyometra. From the available data, we observed that no hysterectomy was performed for atonic postpartum hemorrhage at our center. On further analysis of maternal characteristics, we observed that previous cesarean section is the most common risk factor associated in 87% of cases, out of which 60% of cases had history of previous one cesarean section. Here, I would like to emphasize that even a history of previous one cesarean section is a predisposing factor. Other maternal characteristics like antenatal anemia were seen in 83% of cases, multiparity in 65% of cases, and placenta previa in 39% of cases. It is noteworthy that all cases of placenta previa were associated with previous cesarean sections. Obstetric hysterectomy is a major operative procedure associated with significant morbidity. The frequent complications we observed were intraoperative blood loss of more than or equal to 1 liter, seen in 78% of cases, ICU admission in 61% of cases, and ventilatory support in 48% of cases. Other frequent complications were febrile morbidity in 30% of cases, bladder injury in 26% of cases, massive blood transfusion and wound infection in 17% of cases. Less frequent complications were bowel injury and pelvic abscess, seen in 1 case each. Features of multi-organ failure like pulmonary edema, DIC, acute renal failure leading to mortality was seen in 1 case, which was the case of ruptured uterus with massive hemorrhage. Other 22 patients were recovered and discharged from the hospital after a median duration of 16 days of hospital stay. Live births were present in 14 cases. However, 7 cases suffered from perinatal mortality, out of which 4 fresh stillbirths were seen in cases of ruptured uterus. After analyzing the results, we compared our study with some other Indian studies and studies conducted in developed countries, and we observed that our study is similar to studies recently conducted in India by Bala et al. And Setia et al., where the major indication is morbidly adherent placenta, but it is comparable to studies conducted in developed countries even a decade ago. Previous cesarean section is the major risk factor in all such studies. In our study, it has even higher association, that is 87% cases of obstetric hysterectomy, all cases of morbidly adherent placenta, and 66% of ruptured uterus. The limitation of this study was its retrospective nature, and there may be increased cases of morbidly adherent placenta as our center is the preferential referral center due to availability of embolization services. Finally, I would like to conclude that morbidly adherent placenta has surpassed atonic PPH in recent years as the commonest indication, followed by ruptured uterus. Obstetric hysterectomy in morbidly adherent placenta or ruptured uterus has increased morbidity due to increased vascularity of the uterus or distortion of anatomy of the uterus. So previous cesarean deliveries predisposed to both these conditions of morbidly adherent placenta and ruptured uterus. Hence, judicious approach to cesarean delivery is need of the hour, and the patient should be informed about its impact not just on the current pregnancy but also on future pregnancies, especially to those who demand cesarean delivery. Ultimately, prevention is better than cure. Thank you.
That was a good presentation, Dr. Ankita.
Thank you, ma'am.
Anybody has questions?
Yeah.
Yeah.
I'd like to ask one question. See, obviously, obstetric hysterectomy will end the fertility of the patient. So, internal iliac ligation is a better alternative to obstetric hysterectomy in morbidly adherent placenta. And have you ever thought of any of the indications in which obstetric hysterectomy could have been avoided?
Ma'am, internal artery ligation is a better option because it conserves
if
the
you would have
uterus.
tried that, probably obstetric hysterectomy would have been avoided.
Ma'am, actually, in 90% of cases, internal artery ligation is successful, but there are still some cases when we need to do obstetric hysterectomy. So, ma'am, most of these cases were referred cases, so they needed obstetric hysterectomy, and on an emergency basis mostly.
Ankita Kumari, there is a question. So in your study, most of the cases were those of previous cesarean section. So
Yes,
there's
ma'am.
always a risk of morbidly adherent placenta. Okay.
Yes, ma'am.
So that I think proactively we have to prepare ourselves in case there is a morbidly adherent placenta. In these cases, how would you approach the surgery in terms of the anesthesia that you would like to use, the kind of incision you would like to go for? Have you ever heard of triple P procedure?
Ma'am, in terms of anesthesia, because the surgery may be prolonged, so we'll prefer general anesthesia for the patient. And since it is a case of morbidly adherent placenta, we would like to do placental mapping for the patient to plan our incision. Whether the placenta is anterior or posterior, that also influences the incision site. And ma'am, first we would if it is bleeding, we would like to go for stepwise devascularization, and then if it is uncontrolled, then we would like to proceed for obstetric hysterectomy.
So I would like to take this opportunity to suggest one. Like suppose you were not prepared for it, like it's a totally unbooked patient who has come with say some amount of bleeding, or you thinking about an impending rupture, and you go in and you find that those grossly enlarged vessels and all. Then what you I would suggest is you can extend into a T incision, convert into a midline incision, and compress the aorta, the infrarenal portion. If you compress, if your assistant keeps the aorta compressed with 2 fingers against the vertebral column, then you can substantially reduce the bleeding. So we in Pune are doing dissection and clamping the aorta by the vascular surgeon. And that way we are dealing with placenta increta, percreta hysterectomy without even blood transfusion. So in case you are in a situation where there is torrential bleeding, please don't hesitate, but just compress the aorta. It is life-saving. And you can easily keep it compressed for 2 hours, nothing happens.
Okay, thank you, ma'am.
Yeah.
Thank you, ma'am.
Thank you.
We can move on to the next presenter.
Okay, thank you, ma'am. I think Dr. Ankita Singh is ready. Dr. Ankita, are you ready with your presentation?
Unmute yourself, Ankita.
Ankita Singh. Yes, Ankita, you can start with your presentation.
Yeah. Hello. Good morning, ma'am. Am I audible?
Yeah, we can hear you. Your paper code is 0316. Am I right?
I'll just check it out.
No problem. Your presentation is placental migration of mid-trimester low-lying placenta, a retrospective analysis, right? Yeah, you can start with your presentation.
Good morning, ma'am. My topic is placental migration of mid-trimester low-lying placenta, retrospective analysis. Placenta previa is defined as a placenta that lies wholly or partially within the lower uterine segment. Approximately 1.5 to 4.2% of placenta is found to be low-lying on routine anomaly scan, and this alarms the obstetricians regarding the possibility of placenta persisting in the lower uterine segment and its associated maternal and fetal morbidity and mortality. The predisposing factors, as we all know, are previous placenta previa, advancing maternal age, increasing parity, endometrial damage due to previous surgeries, smoking, and assisted reproductive technology. The formation of lower uterine segment, or what is called the placental migration, results from differential growth of placenta towards a well-vascularized fundus and degeneration of the peripheral villi in the lower uterine segment that receives less blood supply. This is also called placental trophotropism. The most studies I saw have demonstrated prevalence of low-lying placenta in mid-trimester and chances of migration on follow-up. The factors that may contribute to it, like maternal age, parity, location of placenta, and previous uterine surgeries, have been evaluated, but only a few studies are available on the role of initial distance of placenta from os and probability of migration in future. The objective was to assess the prevalence of low-lying placenta at 18 to 20 week scan, and then follow it till 38 weeks or till the time of delivery, whichever is earlier, and evaluate the factors affecting it, especially the distance of the placenta from os at level 2. So the sample for the study was 936, and it was a retrospective cross-sectional study. The inclusion criteria was singleton pregnancy having level 2 done between 18 to 20 weeks and who delivered at more than 28 weeks gestation. Cases with multiple pregnancy and IUD were excluded. The demographic information, relevant history and other data was taken from the medical records. Antenatal women with low-lying placenta, that is the distance between leading edge of placenta and the internal loss of less than 2 centimeters, were taken for the study, and they were followed until either the lower edge of the placenta migrated beyond 2 centimeters or the patient had delivered, whichever was earlier. Out of the total 936 cases, only 72 cases, that is 7.69 cases, had low-lying placenta in the mid-trimester, and follow-up of these 72 cases indicated that in 59 cases, it had migrated to the upper segment by delivery. As we can see, if the initial distance was more than 1 centimeter from os at level 2, 92% of the placenta had migrated by delivery. If it was 0.5 to 1, 79% cases had migrated, and if it was less than 0.5 centimeter, we had 4 such cases, and in all the 4, placenta did not migrate. Taking the location of placenta, anterior placenta migrated in 75% cases and posterior in 87% cases. In cases with primary or previous NVD, 88% cases the placenta migrated, and it was obviously lesser in previous cesarean cases, 70% migrated. The overall rate of migration was 81.94%, and in 77.77% cases, the migration was over by 32 weeks. No migration was seen in cases where either the placenta was covering os or less than 0.5 centimeter from os. So the prevalence of low-lying placenta in mid-trimester was 7.69%, which reduced to 1.38% at term due to placental migration. The data is on the higher side, the standard data, which was 4% at mid-trimester and 0.5% at term. The higher incidence nowadays may be due to increased number of women going for mid-trimester ultrasound and increased number of cesarean section nowadays. In a study by Durst et al. 2017, which analyzed the initial distance of placenta from os, the probability of resolution was inversely proportional to the distance from os, 99.5% where the distance was more than 1 to 2 centimeter, 95.4% where the distance was 0.5 to 0.1 to 1 centimeter, and just 72% where it was less than 0.1 centimeter. Here we have compared other studies, and we can see the prevalence is almost similar to the studies by Shravya Jyotsna et al. And Saujanya Kumari et al. 8 to 10%. The migration was more in cases of posterior placenta, but in the study by Saujanya Kumari, it was however found to be higher in anterior placenta. And the rate of migration was in the range 60 to 80%. To conclude, low-lying placenta is a matter of concern for the obstetrician. In most cases, placental migration is over by 32 weeks, and in almost none of the cases seen after 36 weeks. Initial distance of placenta from os at mid-trimester ultrasound is an important predictor of possibility of migration on follow-up. Anticipating the complication and prognosticating the patient regarding warning signs, prematurity, and need of blood transfusion, etc., and if required, timely referring them may help to reduce peripartum and perinatal complications. The limitation was that the sample size was small, and if we take the larger sample size, like the study by Durst et al., it had a sample size of 20,000 cases. The data may be used extrapolated for the general population and better prognosticate the cases. Thank you.
That was a good presentation, Dr. Ankita. Reached well in time. Apart from the distance from the lower segment, from the os and uterine scar, did you have any other predictors? Did you have any other factors to predict the placental migration? For example, the socioeconomic strata or previous infections, anything of that sort. Did you have any other predictors?
Ma'am, we mainly took three things: initial distance of placenta from os, and whether the location of placenta was anterior or posterior, and one group was a primary or previous normal delivery, and the other group was mainly previous cesarean, myomectomy, or hysterectomy, other cases all clubbed together.
Okay.
I have one question. You have not mentioned in your methodology whether you have done the distance away from os from transvaginal scan or transabdominal scan, or both were done.
Yes, ma'am, I understand this because this was a retrospective study, but in our hospital, it is a practice, like if they see the placenta suspicious, like low lying, they do a TVS in that.
So have you evaluated in which of the, by the images, that in all of the cases it was done by transvaginal scan?
No, ma'am, no, not all the cases were confirmed by TVS.
And the follow-up done at third trimester was at what gestational age exact? Did you call for a specific time, 28 weeks or 32 weeks, to get it done on a transvaginal scan and then confirm?
Ma'am, most of the cases it was around 32 weeks because it was a retrospective study. So we followed when it is done routinely after level 2 ultrasound is done at 28 weeks around, and then at 32 weeks.
Okay, so suppose the key message from you, what I derive is that you need to counsel a patient if you find a low-lying placenta from distance away from us at 18 to 20 weeks. So what will you counsel her at 32 weeks? What will you tell her exactly, that what is the rate of migration of placenta, anterior and posterior placenta, both differently? What will you counsel her?
At 32 weeks.
At 18 weeks, you found you did a TVS. You have to bring it in clinical practice.
Yeah, yes,
so
ma'am.
how does it?
We can take the three factors together. The patients who in whom the distance is less than 0.5. Obviously, that patient has a high probability that it will persist, especially if the placenta is anterior and she has a history of surgery. So that patient obviously needs to be taken as a potential placenta previa. And in the cases like it is more than 1 centimeter, no previous surgery, and in case it is posterior, in that case, I will take it as around more than 95% chance that it will migrate. So accordingly, we can
placental migration, you are saying?
Yeah.
Okay. Thank you.
Okay. Thank you, ma'am.
Jyotsna, any question from your side?
What are the features that would predict whether the placenta is going to migrate or not when you see in the ultrasound?
The features ma'am, obviously how far is the edge, the distance, and the thickness of the placenta. I mean, the angle it is making with the uterus. It in some way it helps to predict.
Any changes or echogenicity within the placenta which can suggest that it is going to be a morbidly adherent placenta? Can you make out from the ultrasound?
I'm not sure, ma'am. I need to read about that.
Okay. You have definite features that you can make out from
she
the...
has excluded previous cesarean sections in her study. You have excluded, that was an exclusion criteria, previous cesarean section and placenta?
No, there is no exclusion.
Then you have to rule out, yeah, placenta accreta spectrum actually.
So should I move on to the next participant, ma'am?
Yes, please.
Definitely, please.
Thank you. So I think Dr. Shilpa Singh is ready with her presentation. Dr. Shilpa, are you ready? Dr. Shilpa Singh. Dr. Shilpa Singh, we can't hear you.
You have to unmute.
Yeah. Yeah, we can see your presentation, Dr. Shilpa. Dr. Shilpa, please unmute yourself and please start sharing your screen here. Yeah, we can hear you, Dr. Shilpa. Dr. Shilpa Singh, are you ready or should I skip? Dr. Shilpa Singh. We can see your slides, Dr. Shilpa. The backend team, can you please help Dr. Shilpa?
Yes, ma'am.
Please help Dr. Shilpa to start her presentation.
And please move to the next presenter. She might having some problem with his mic.
Then please tell her to stop sharing her screen. Then I will call Dr. Suvidya Singh.
Yeah.
Dr. Suvidya.
Yes, ma'am. Yes, ma'am.
Are you ready with your presentation, dear?
Yes, ma'am. Yes, ma'am. I will just share.
Please start sharing your screen.
Yes, ma'am.
We have 6 minutes for your presentation and 2 minutes for your question and answers.
Ma'am,
Okay?
my screen is visible, right?
Yeah, we can see you. Okay, please start your presentation.
Good afternoon, everyone. The title of my presentation is Maternal and Perinatal Outcomes in Critically Ill Pregnant Women Infected with COVID-19. COVID-19 has been associated with severe morbidity and mortality, and its clinical course has been an enigma, especially in pregnant women. And therefore, it is pivotal to understand clinical challenges of COVID-19 to devise potential strategies for optimal fetal.
Dr. Suvidya, excuse me.
Yes, ma'am.
Dr. Suvidya?
Yes, ma'am. Yes, ma'am.
See.
Hello. Yes, ma'am.
I can't see your slides properly. It's a presentation, yeah.
Is it visible?
Screen.
Is it visible now?
Yeah, we can see you. Continue, please.
The objective of my study was to observe clinical course, maternal and perinatal outcomes in critically ill pregnant women with COVID-19 in Lok Nayak Hospital. The primary outcome was to see maternal mortality, and secondary outcome was to finding out the obstetrical outcome, perinatal outcome, incidence of ARDS, multi-organ dysfunction syndrome, DIC and shock, and also to find out the proportion of patients requiring mechanical ventilation. We did a combined retrospective and prospective observational study from May to September 2020 in Department of Obs and Gynae and Department of Anesthesia. We included all antenatal or postnatal patients who were admitted in ICU of LNH with confirmed COVID-19 infection or high index of suspicion for COVID-19, and who had and who required mechanical ventilation or had required FiO2 of more than 60%, who had shock that was identified either by use of vasopressor therapy, or who had elevated lactate levels, or who had multi-organ dysfunction. A total of 739 COVID positive obstetric patients.
Excuse me, the slides are not moving. Are they moving? Dr. Shamishta, are they moving for you?
They are not moving.
Yeah, they are not moving actually.
Ma'am, please click enable
editing. It is stuck at introduction only. Dr. Suvidya?
Yes, ma'am. Ma'am, it's moving for me, ma'am.
No, it's stuck at introduction only. Yeah, now we can see the methodology. Yeah,
is it visible now, ma'am? Okay,
yeah.
Okay, ma'am. I'll do it like this. So a total of, ma'am, should I start from earlier or should I continue, ma'am?
Please tell your methodology.
Okay, ma'am. We did a combined retrospective and prospective observational study from May to September 2020 in Department of Obs and Gynae and Department of Anesthesia, LNH. We admitted all antenatal, postnatal patients who had a confirmed COVID-19 infection or who had a very high index of suspicion for COVID-19 and who were admitted in ICU and required mechanical ventilation or an FiO2 of more than 60%, who had shock that was identified either by use of vasopressor therapy or who had elevated lactate levels or who had multi-organ dysfunction. So a total of 739 COVID positive obstetric patients were admitted, out of which 23, that is 3%, were critically ill. The overall mortality in the obstetric COVID patient was 1.4%. However, mortality in the critically ill group of obstetric COVID positive patient was 43.5. The mean duration between symptom onset and ICU admission was 7 to 8 days, and Q SOFA was positive in 70% of the critically ill COVID obstetric patients. So we had a total of 23 critically ill COVID positive obstetric patients, out of which 19 were antenatal and 4 were postnatal. Out of these 23, 11 were directly admitted to the ICU. Primary outcome, out of these 23 critically ill COVID-19 patients, 10 deaths occurred, 6 were antenatal and 4 were postnatal, and all of these 10 deaths occur within the 7 days of onset of illness. We also compared month-wise mortality, and it was seen that as we moved from May to September, the proportion of critically ill COVID obstetric patient who died significantly decreased from May to September. The most common cause of death among them was ARDS, which was alone responsible in 7 out of the 10 cases. 6 out of these 10 deaths, these patients eventually developed shock and they died. Perinatal obstetrical outcomes, total 12 deliveries were conducted, out of which 7 were cesarean sections. 2 of these cesarean sections were done to alleviate maternal respiratory distress. Total deliveries were 12, out of which 1 was a twin cesarean section, so total number of births were 30. So we had 5 healthy neonates, 2 IUDs, 2 neonatal deaths, and 4 low birth weights. Out of these 13, 10 had a confirmed COVID negative report on the sampling that was done on day 1. 14 out of these 23 patients had one or the other comorbidity, out of which the most common association was seen with anemia, the hypertensive disease of pregnancy, and GDM. 5 patients required mechanical ventilation, and out of these 5, 4 patients died within in less than 24 hours of intubation. 1 was intubated for an elective cesarean section, and she survived afterwards. All the patients received steroids and antibiotics. Plasma therapy was indicated in 2 patients, but it could not be given due to non-availability of the compatible group plasma. Coming on to discussion, mean duration between symptom onset and ICU admission was 7 to 8 days, suggesting that increased surveillance is required during the initial 10 days after symptom onset. Mortality in the COVID critical obstetric patient was 43.5. However, we saw that more mortalities occurred in the initial months, suggesting that with improvement in knowledge, experience, and evolving treatment options for the disease, mortality rate decreased. ARDS was one of the most common cause of mortality in our study, and which can be explained by the fact that the pre-existing physiological factors that occur in a parturient predisposes her to poor outcomes during any respiratory illness. 2 out of the 12 deliveries were indicated to alleviate maternal respiratory distress, and both were by cesarean section. And whenever an emergent delivery is required in a critically ill parturient, with in view of rapid maternal deterioration or difficulty with mechanical ventilation, a cesarean delivery is most appropriate. The most effective treatment for COVID-19 infection is not yet clear. Treatment is still evolving, as we saw that hydroxychloroquine, which was given to all the critically ill patients till May and June, is not given universally now. Antibiotic, supplemental oxygen, and steroids are given to all in the critically ill group. Antiviral drug is considered in severe cases if they're not responding to steroids and supplemental oxygen. A study was done at one of the largest COVID centers in India, that being the strength of our study. However, our study was limited by inability to report on the long-term outcome, and also the data collection was much impeded by the high infectious nature of the disease in question. I would like to conclude by saying that close surveillance is required during the first 10 days of the illness, and increased rate of cesarean section among the critically ill group was seen as compared to the mild and moderate COVID pregnant patients, mainly to curtail time of labor. We suggest that large prospective cohort studies are needed to develop potential strategies for intensive management and fetal-maternal surveillance in critically ill COVID-19 pregnant patients. And as we saw that one of the most common associations with COVID, severe critically ill COVID pregnant patient was hypertensive disease of pregnancy. It is important to know that elevated blood pressure is very commonly seen in COVID-19 infection because of the interaction between the virus and the angiotensin converting enzyme.
Excuse me. Yeah, your time is up now.
Yes, ma'am. Ma'am, just last line. Severe COVID-19 disease in a lot of pregnant female can masquerade as preeclampsia. So we suggest that further studies should be done to better differentiate between the two conditions. Thank you, ma'am.
Thank you.
Dr. Suvidya, you did not give antivirals to all the patients?
Ma'am, actually antiviral came into hospital supply from mid-August to end of August. So by like during that time, after that time, 2 patients received ma'am remdesivir.
So before that, what was the pattern of mortality before antivirals and after antivirals?
Ma'am, before antiviral, which was started in August, ma'am, in May and June, we saw 100% mortalities in the critically ill COVID obstetric patient who were admitted in ICU. And afterwards, July, there was no mortality. In August, there was just 2 out of 6 mortalities, and September, we had 1 out of 6 mortalities, ma'am.
And how did you monitor these patients? What were the investigative modalities which were regularly done in these patients?
Ma'am, some of the routine investigation that we did included CBC, doing CBC for those patients, doing LFT, KFT, and serum electrolyte. Decoagulation profile was routinely done for all the patients to look for any rise in D-dimer. If any, for the patients who were in the critically ill group, we also did inflammatory markers like interleukin-6 and procalcitonin and LDH, CRP, and ma'am, these were also being done. But ma'am, these were started only after July and August, ma'am. Before that, these were not being done in our hospital. It was only after July and August that we started doing interleukin-6 and procalcitonin levels also. So
were drugs like tocilizumab and etc. were available in your center?
Yes, ma'am. It is available, ma'am. And in cases, in patients who are moderate to severe and who have very high levels of interleukin-6, more than 70, or who have D-dimer, which is more than 5 times the normal value, or ferritin levels more than 1000, in those patients, we consider giving them tocilizumab to basically tackle with the cytokine storm that is very commonly seen with critically ill COVID patients, ma'am.
Was it repeated in anyone?
Ma'am, interleukin-6, ma'am.
No, tocilizumab.
Tocilizumab, ma'am, we in our group, ma'am, none of the patients have been given, ma'am, but it is being given to other patients who are admitted in ICU, ma'am.
Considering it's a thrombotic disease, have you given?
Yes, ma'am. Anticoagulant was, ma'am, given to almost all the patients. Only 4 patients who were admitted in May, they did not get Clexane, but after that, all the patients got, ma'am, anticoagulants.
For how many days?
Ma'am, 10 days in obstetric patient. Ma'am, like we gave it for 10 days, ma'am.
Right.
Any other questions, ma'am?
Have you done the histopathology of the placenta to see if there is any evidence of thrombosis in the placental bed?
Ma'am, actually, it is starting to be done. It is now done, ma'am, but all the patients that we who are included in my study, for them, the histopathology has not been done, ma'am. But we have started to do for patients who are admitted now, ma'am. Even the routine patients who are admitted and delivered normally, who are not in the critically ill group, for them also we are doing, ma'am, placental.
Okay. Have you identified any better prognostic marker in critically ill patients of COVID positive? Any predictor that if it is critically ill and COVID positive, and if this parameter is high, then the recovery rate is high for COVID positive patients? Something like that? Have you identified any risk?
Ma'am, actually, in our study, we did not include any parameters because it was not like even the inflammatory parameters that we are doing now, that was not uniformly done in all the patients who were in my study, because we started our study in May, ma'am. And that is why, ma'am, it's not, ma'am, like it is, ma'am, I don't know of any predictor, ma'am. It was not in my study.
Dr. Suvidya, what you have done will lay the foundation for more studies, probably. It was a good study.
Thank you, ma'am.
So, ma'am, shall I call the next participant?
Yes, please.
Yeah, Dr. Kirti Chandra. Dr. Kirti, are you there?
Dr. Shilpa, am I audible now?
Dr. Shilpa, I think I'll give you the last slot. Let me finish with Dr. Kirti.
Okay, fine.
Then be ready with your presentation.
Okay.
So, whose slide are we viewing now? Is it Dr. Kirti?
Good afternoon, ma'am. This is Dr. Kirti Chandra.
Okay.
Good afternoon to all. I'm Dr. Kirti Chandra presenting my free paper on the topic of ophthalmic artery peak ratio, a novel marker of feto-maternal outcome in severe preeclampsia. As we all know, preeclampsia is a pregnancy-related condition which is characterized by placental dysfunction arising from defective remodeling of the uterine spiral artery in early gestation. It is also associated with hemodynamic changes that may affect the internal carotid and ophthalmic artery circulation with consequent neuroophthalmic manifestations. Hence, assessment of vascular bed outside the uteroplacental unit is alternative adjunct for assessment of disease process. Owing to the anatomical and functional similarity between the ophthalmic artery and small cerebral artery, the application of Doppler flow studies of maternal ophthalmic artery to indirectly measure the changes in hemodynamics of the cerebral vasculature has emerged as a promising tool to predict the neurological events in preeclampsia. Hence, ophthalmic artery Doppler study is an indirect tool to assess the cerebrovascular perfusion and might give an insight into the altered hemodynamics of the cerebral circulation. I can't move my slides.
Start the slideshow.
Yes, ma'am, I'm trying. Ma'am, can I share it again from my laptop?
Yeah. Will it take time?
No, ma'am, it's already, I think it was just now it was visible.
Please share again.
Ma'am, is the slide visible?
Yeah, now we can see.
The image shows how ophthalmic artery Doppler parameters are calculated. The image shows a dichrotic waveform, which is due to the diastolic peak in addition to the systolic peak. In this way, the RI, PI, and peak ratio of the ophthalmic artery Doppler were calculated. The RI and PI were calculated from the ultrasound directly. However, the peak ratio were calculated by the manually by the ratio of first diastolic peak and the end diastolic velocity. It was found out that in patients of preeclampsia, there is cerebral vasodilation. Hence, there is a decrease in pulsatility and resistivity index, while there is an increase in the peak ratio. Therefore, the objective of this study was to assess the relationship of ophthalmic artery Doppler indices with feto-maternal outcome in women with early onset severe preeclampsia. We include, in this cross-sectional study, we included 60 women in the age group of 20 to 35 years, which had early onset severe preeclampsia. The patients were admitted and their ophthalmic artery Doppler parameters were done. The RI, PI, and peak ratio were calculated twice, one at the time of admission and 5 days postpartum. And the patients were divided into two groups. The first group was the group with peak ratio less than 0.89, and the second group was included women with peak ratio more than 0.89. The adverse maternal and fetal outcomes were compared. The adverse maternal outcomes included were HELLP, eclampsia, DIC, acute renal failure, pulmonary edema, abruption, CVA, etc. And the adverse neonatal outcome that were monitored were small for gestational age babies and intrauterine fetal demise. Image 1 shows the patients included in, it shows the Doppler image of patients which were included in group 1. Sorry, in group 2, it shows that the RI was in the range of 0.443 and the peak ratio was in the range of 1.13. And image B includes women with peak ratios more than 0.89. We can also see that there was a difference in the peaks of the patient. The peak systolic velocity and first diastolic peak were higher in the second group. Coming to the observation, the bar diagram shows the comparison of maternal outcomes in group 1 and group 2. It was found that 57.14% patients in group 2, that is, they had peak ratio more than 0.89, and 38.89% patients in group 1 with peak ratio less than 0.89 had partial HELLP. However, 2.38% patients in group 2 had eclampsia, while 5.56% patients in group 1 had HELLP syndrome. However, 40.48% patients in group 2 had no complication, while 55.56% patients in group 1 had no maternal complication. On comparing the composite maternal outcome in group 1 and group 2, it was found that out of 18 patients in group 1 and 42 patients in group 2. 8 patients in group 1 had maternal complications and 25 patients in group 2 had maternal complications, which made up to 59% of the total study population. On comparing the fetal outcome in group 1 and group 2, it was found that 26 patients out of 42 patients in group 2 had adequate for gestational age babies, while 10 patients out of 18 patients in group 1 had adequate for gestational age babies, while in intrauterine fetal hemolysis was found in 2 patients in group 2 and 3 patients in group 1. On comparing the patients who suffered small for gestational age babies, 14 patients out of 42, that makes it 61% of the patients in group 2 had small for gestational age babies, and 5 patients out of 18, that is 33% patients had small for gestational age babies in group 1. Sorry. Hence, the present study concluded that women with higher ophthalmic artery peak ratio suffered more adverse maternal outcomes. Small for gestational age babies were significantly higher in group 2, that is peak ratio more than 0.89. It was also found out that in patients who delivered and the ophthalmic artery Doppler was repeated at 5 days postpartum, the cerebral hemodynamics started coming back to normal. So hence, we concluded that ophthalmic artery Doppler study is a simple, accurate, and objective technique with a discrete predictive value for development of early onset severe preeclampsia. The adverse maternal as well as fetal outcomes were more in higher peak ratio group. Hence, the strength of the study was that ophthalmic artery Doppler is a simple, readily available tool to predict the early onset preeclampsia, which is comparable with the uterine artery Doppler study in predicting the early onset preeclampsia. It can be done in a low source setting, and there was no loss to follow-up since we kept the patient admitted till 5 days postpartum and we did an ultrasound on them.
Excuse me, your time is up now. Please wind up in another 30 seconds.
Yes, ma'am. The demerits of the study was that the sample size was low, so we could not get statistically significant results. Thank you.
Very nice presentation. I have one question specifically, Kirti. The methodology which you had followed, you were not the primary person who was doing the Dopplers. So the expertise is entirely dependent on the radiologist who is performing the test, isn't it?
Yes, ma'am. Yes, ma'am.
So have you considered the pitfalls in doing the B mode and pulse wave Doppler velocimetry, taking the angle of measurement consideration and peak systolic video and the PRF, etc.? Have that been taken into consideration?
But since we had allotted just one radiologist for the entire study, so
all the patients were done by single radiologist.
Yes, ma'am.
At a specific time and in both the eyes.
Yes, ma'am. For both the eyes at the time of admission and 5 days postpartum.
And what was the angle of insonation which was used for measurement of Doppler velocimetry?
Ma'am, the angle was at 15 degrees.
So ideally it should be, so that 15 degrees error you have taken for all the patient. Ideally it should be near 0, isn't it?
Yes, ma'am. Because
so
of
why have you
various
taken that error of 15 degrees for every patient?
Ma'am, to generalize the study, if we take this error of 15% in every patient, then we can get the results somewhat similar.
So does your peak systolic peak ratio depend upon the angle of insonation, and how does it differ?
Ma'am, on observing the angle of insonation and the peak systolic velocity, I found out that it was not very different. When we had a doubt, we took an average of 3 readings and we calculated the peak ratio and peak systolic velocity like that.
So, Dr. Kirti, what are the exclusion criteria of your study?
Ma'am, in the exclusion criteria, we included women with chronic hypertension diabetes mellitus, and any patient with a chronic comorbidity, and obese patients.
Were there any other factors that could have affected the peak flow in the ophthalmic artery?
Yes, ma'am. The factors which could affect were the symptoms in the patient. Like if the patient comes to us with the symptoms of blurring of vision or signs of impending eclampsia, in those patients we found out that the peak ratio was even higher.
Okay. Thank you. It was a good study.
Thank you, ma'am.
Thank you, Dr. Kirti. Now, can I call Dr. Bhanu? Dr. Bhanu Priya?
Yes, ma'am, I'm here.
Yeah, are you ready with your slides?
Yes.
Yeah, you can start your presentation.
Slideshow is taking little time.
No, we can see you. You can start your slideshow. Yeah.
Good afternoon, everyone. I'm Dr. Bhanupriya from UCMS and GTB Hospital. So in the COVID pandemic, everybody is talking about COVID positive patients. My study is on COVID negative and COVID probable women who came with the COVID-like symptoms. So we have evaluated the maternal and neonatal outcomes in COVID negative and COVID probable obstetric women who presented with COVID-like symptoms. So as I already told you, the world has largely focused on the COVID positive cases, and the COVID and a large proportion of COVID suspect are reported as actually COVID negative or COVID probably as per the WHO criteria. But there are many non-COVID conditions like pneumonitis, ARDS or sepsis, which may simulate COVID infection. And no study till now has compared the outcomes of COVID negative and COVID probable cases with COVID positive obstetric women. So as per the WHO guidelines, the case definitions are: a negative case is defined as laboratory confirmed case of negative report of COVID-19. A positive case is defined as a laboratory confirmed COVID-19 case of COVID-19. And a probable case is defined as a suspect for whom the testing was done, but it was either inconclusive or the testing could not be performed. So the aim and objective is to study and compare the maternal and neonatal effects, maternal and fetal outcome in the COVID negative, COVID probable, and COVID positive obstetric women. So this is this study flow chart. It was a retrospective study done from 1st April to 10th of June 2020. And after 10th June 2020, our hospital turned COVID. So we have included the patients till 10th June only. So all the patients who were having COVID-like symptoms and were pregnant at any period of gestation or postnatal or post-abortal up to 6 weeks were included in the study. So that's make it 135 women with COVID-like symptoms. Another 5 women were excluded because the data was irretrievable, which finally includes the 130 obstetric women. The data was extracted from the hospital record, and as per the COVID RT-PCR report, it was divided into COVID negative, who were 99, COVID positive, which were 22, and COVID probable, which were 9 people in our study. The outcome measures were maternal morbidity, like spectrum of the disease, oxygenation status, etc. The proportion of women with mild, moderate, and severe disease at admission, maternal mortality, and neonatal outcome, which includes live, stillbirth, or NICU admissions. So appropriate statistical analysis tests were applied, and the observations and results were noted. So as we can see, the mean age in all the groups were almost equal, but the maximum obstetric women came from the antenatal group. Approximately 60% of the sample came from the antenatal group. The commonest clinical presentation in our study group were fever, breathlessness, upper respiratory tract infection, and among the severe one was the shock. Fever was the commonest clinical presentation in all the groups, followed by breathlessness. But if we talk about the shock, which was the severe clinical presentation, it was present only in the COVID negative and the COVID probable group. It was not there in the COVID positive group. So as per the disease severity, the women were categorized into mild, moderate, and severe disease. Mild disease were common in was commonest in all the group. So the maximum people were of the mild category disease only. However, the COVID probable has the maximum severe disease. approximately 33.3%. The anemia was the commonest comorbidity which was present in the study group, followed by hypertension. The spectrum of the maternal disease in our study group ranged from the isolated febrile illness to the multi-organ dysfunction syndrome. The lower respiratory tract infection, pulmonary edema, and multi-organ dysfunction syndrome, which were the severe form of the maternal disease, were more commonly seen in the COVID probable group. But although the finding was not statistically significant. The oxygenation status also, the mean oxygen saturation was also lowest in COVID probable group, which was statistically significant, and the oxygen requirement and the need for mechanical ventilation was also lower, maximum in the CPRO group or the COVID probable group. The normal chest X-ray was also more in the COVID probable group, and the commonest finding in the COVID probable group was consolidation. Maximum number of women were discharged in all the group, and if we look at the mortality, then the highest mortality was noted in the COVID probable group. So now coming on to maternal death data, there were total 21 deaths in the population of 130 women, which makes it 16.1%. The mean age was almost comparable in all the groups. The maximum mortality happened in the postnatal group, and the maternal diagnosis ranged from the sepsis with MODS and pulmonary edema and ARDS. Maximum maternal mortality was seen in the COVID probable group, and in this the cause of the maximum mortality was ARDS. In COVID positive, it was also again ARDS, and in the COVID negative, it was sepsis with MODS and pulmonary edema. The neonatal outcome was also worst in the COVID probable group, where the stillborn were highest and the NICU admissions were also highest. So to summarize, more than 2/3 of the women with COVID-like symptom presented with COVID negative and having mild disease. The fever was the commonest clinical presentation, and the spectrum of maternal disease ranged from the febrile illness to MODS. The commonest cause of death was sepsis with MODS and ARDS. So to conclude, we can say the severe disease, MODS, need for oxygen and artificial ventilation and maternal mortality were highest in the COVID probable group. So so the take-home message of my study is that even if that this COVID probable group is an unexplored group and needs more scientific research, and maybe we can change our testing policy so that this COVID probable group may enter into some kind of category, either COVID negative or COVID positive. Thank you, everyone.
Thank you, Dr. Bhanu.
Are we testing for swine flu also in these probable group?
No, it was not tested. It was not tested. Actually, the COVID probable were 9 individuals. Out of that, 3 were they came very sick and they died. These are the one who died and were categorized into the maternal mortality group. And the rest of the 6 came in that period where actually the government stopped the testing policy for the patients with COVID-like symptoms. So these are those 9 individuals which has come into the COVID probable group.
Dr. Bhanu, majority of your mortalities happened postnatally, right?
Yes, ma'am.
So
yes.
Could you follow these patients up post
discharge, ma'am? Ma'am, your sound is not coming. Ma'am, the signal is...
I think she has lost connection. Dr. Tina, Dr. Jyotsna. Any question, Dr. Tina?
I think she wanted to ask that what was the morbidity after post-discharge? How have you followed up post-discharge?
Yes, we have followed up. We have called them telephonically, and maximum females were having a normal life. But approximately there were 5 individuals who had symptoms, and they were readmitted to some other hospitals. But rest of the women remained okay.
Okay. Thank you.
Thank you, Dr. Bhanu.
Thank you, ma'am.
Okay, any more questions, Dr. Tina, or shall I move to Dr. Shilpa?
Yes, sir.
Yeah, Dr. Shilpa, yeah, you can start sharing your slide.
Okay.
Judges, she is the last presenter.
Right.
Yeah, she's the last presenter for this session.
Is my screen visible?
Yeah, we can see you, Dr. Shilpa. Please start your presentation.
My PPT is visible, right?
Yeah.
Okay. I'm Dr. Shilpa. I'll be presenting a case series on maternal near-miss events in COVID-positive pregnancies. COVID-19 has created an extraordinary global health crisis, and its effect on pregnancy and its outcome is an enigma. Altered maternal physiology, slight immunocompromise, and decreased lung volume due to gravid uterus can cause rapidly deteriorating clinical course for the mother. The case series of these 4 near-miss cases aims at reviewing how COVID has affected maternal and fetal outcomes in severely ill patients. For every woman who dies from pregnancy or childbirth-related causes, 20 more suffer from pregnancy-related illness. 20 more suffer from pregnancy-related illness or severe complications, and these are categorized as near-miss. Maternal near-miss has been defined as a woman who nearly died but survived a complication that occurred during pregnancy or childbirth or within 42 days of pregnancy termination. Our hospital has been converted to COVID hospital since last 4 months, and we have witnessed 10 maternal deaths, of which 3 were COVID positive, and 6 maternal near-miss, of which 4 were COVID positive. So coming to case 1, case 1 was a 22-year-old P0L0A1. She was referred to us on day 3 of exploratory laparotomy, which was done for ruptured corneal pregnancy with hemorrhagic shock with burst abdomen. Patient had history of 3 episodes of cardiac arrest intraoperatively and receiving 5 units RCC. Her pre-op period was entirely asymptomatic. She was undiagnosed in pre-op period. When the patient came to us, she was intubated, was in hypertension and had hypoxia, though her chest X-ray was normal. She was started on high flow oxygen, high-grade antibiotics, noradrenaline, dexamethasone, and admitted to ICU. Maternal near-miss events in this case were hemorrhagic shock, administering 5-unit RCC, intubated state, and the severe respiratory compromise. The patient recovered from hypertension and hypoxia. A laparoscopy bag was inserted and she was planned for laparoscopy closure after stabilization. By day 10, she was weaned off inotropes, extubated, and by day 20, her RT-PCR was negative and she was discharged. The second case was a 28-year-old postpartum presenting to us at day 8 of normal vaginal delivery with purple sepsis with hepatomegaly and AKI. She had complained of fever, shortness of breath, altered sensorium. Her antenatal course was uneventful. When the patient presented to us, she was in hypertension, febrile, and in hypoxia. And the chest X-ray had ground glass opacities. The patient's urine output was recovered after fluid challenge. She was started on high flow oxygen, noradrenaline, high-grade antibiotics, dexamethasone, enoxaparin, and shifted to ICU. These are the maternal near-miss events: the severe respiratory compromise, use of inotropes, and ICU admission. The patient recovered from hypertension by day 5, and her DNC was done because of the RPOC that was present. By day 10, the patient was maintaining SpO2, but there was persistent fever and tachycardia, so her antibiotics were changed as per Pascal sensitivity report. By day 18, she became afebrile. Her CT severity score was still 14, and by day 20, the patient was discharged on hematinics. The third case was a 28-year-old postpartum on day 4, referred with complaint of shortness of breath and fever. She was also in hypertension with hypoxia, fever. Her chest X-ray was normal. The patient was admitted in ICU, started on noradrenaline, and dexamethasone, enoxaparin, and oxygen was started. By day 6, her tachypnea settled. The patient started maintaining oxygen, SpO2 at normal flow, and by day 10, the patient was shifted out of ICU, but she had persistent bradycardia and her pulse rate was around 56 per minute. And by day 28, the patient recovered from this. Her RT-PCR came to be negative and the patient was discharged. Fourth patient was postpartum day 4 of emergency LSCS, and she also came to us with fever, sore throat, admitted as mild COVID positive, but after 12 hours of admission, the patient developed shortness of breath and was in hypoxia. Patient was started on oxygen, dexamethasone, and she subsequently recovered by day 5 with on and off fever, loose motion settled, but there was recurrent bradycardia. On day 10, when the suture were removed, there was stitch line infection, which was treated conservatively, and by day 15, patient was discharged. So the key observations of our case series were the maternal near miss indicators, that a maternal near miss ratio was 0.07 and the maternal near miss mortality ratio was 0.75. We found that day 8 to day 12 of COVID infection is crucial in determining the maternal outcome. The mode of delivery has no role in determining the COVID course. When we see synopsis of our case series, most of our patients were in the age group of 22 to 28 years. They were postpartum. They presented with fever and shortness of breath. The maternal complications associated were hemorrhagic shock, burst abdomen, pulpal sepsis, AKI, anemia, and surgical site infection. We found that chest X-ray findings were not synonym with the clinical presentation, and all our patients responded to oxygen, inotropes, dexamethasone, and enoxaparin support. We did not use remdesivir in any patient, and the neonatal outcome was good in all the patients. Driba et al. Has done another, has reported in August 2020 that the most common complication reported is preeclampsia, and they found ICU admission rate of 31.3%, NICU admission rate of 11.3%. Their patients responded to hydroxychloroquine, ribavirin, and oxygen. Jekan et al. In Sudan published a study in April 2020. Their patients were mostly in third trimester with fever and cough. ICU admission rate was 0.03% and perinatal mortality was 0.01%.
Dr. Shilpa, excuse me, your time is up. Please wind it another 30 seconds.
Okay, so they also found that ICU admission rate was around 14% in both. The take-home message I like to give is M&M events in COVID positive pregnancy usually complicates postpartum period. Radiological findings are not always synonymous with clinical presentation. Oxygen support, steroid, and enoxaparin are effective. Neonatal outcomes are good despite critically ill status of the patient, and timely intervention is key in converting these maternal mortalities to near-miss events. Thank you.
Thank you, Dr. Shilpa. Judges, please proceed with the questions. We're already running late.
Dr. Shilpa, it was a good study. What in your methodology, were there any exclusion criteria?
Ma'am, no, we took all the patients. Ma'am, there were many patients with SARI which came, but subsequently their COVID report came out to be negative. So we have to exclude it. We took all the patients from in last 4 months which were came in maternal near miss criteria and were COVID positive.
I have one question. I just want to ask this, that the near miss criteria which you have used, that was of WHO. Anyway, being positive or not, the outcome would not have differed. Because you're already treating in the same management of near miss criteria what WHO has given. So how does doing COVID test influence your study?
Ma'am, like our last patient, she came as a stable patient in purple sepsis, but then she deteriorated. She developed severe respiratory compromise. She was mainly affected by COVID only.
So how many patients of yours did end up in multi-organ inflammatory system disease, MIS?
Multi-organ, ma'am, there was definitely severe uterine infection in most of the patients.
That is your obstetrical complication. How does COVID influence that?
Ma'am, COVID has, like our first patient, she had 4 maternal near miss criteria fulfilling. She received multiple transfusion. She was in hemorrhagic shock. She was intubated. And then the COVID added to that M&M event. Ma'am, you want to ask something else if I'm not able to decipher?
Were there any mortalities?
Yes, ma'am. In the same duration, there were 10 mortalities, of which only 3 came out to be COVID positive. Rest were referred as SARI, but came out to be negative.
Thank you.
Okay. Thank you.
Yeah, Dr. Shilpa, I just wanted to know, are we also doing the inflammatory markers to suggest that these are the ones who are likely to have the cytokine storm and, determine your outcome? The severity?
Ma'am, we have started doing these COVID markers, D-dimer and CRP, only from the last 2 months. So in those cases, there were increase in these markers.
2 घंटे से चल रही है.
Who is this in between? Who is this Ishnavi? She's also participating. She's a second standard student. Okay, Shilpa. So yes. I think we are done. Yeah. So we're done with the session 3. Thank you, judges, and thank you, participants.
Thank you, Dr. Sharmishta, for giving us the opportunity.
Thank you, Dr. Tina, and thank you, Sharmishta.
Thank you, ma'am. So without any further delay, I will begin with session 4, and I would like to invite my esteemed judges, Dr. Neeti Tiwari. She is Senior Consultant, Department Institute of IVF, Sir Gangaram Hospital. Dr. Meenakshi Ahuja, ma'am. She is the Director of Fortis Law Firm. And we have Dr. Reema Bhatt, ma'am. She is Senior Advisor in Department of Obs and Gynae and Fetal Medicine Center, Army Hospital, New Delhi. So I think we have all of them. And with their permission, I would like to invite my first participant, Dr. Shreya Bhattarai. Dr. Shreya, are you there?
Yes, ma'am.
Yeah, please start sharing your screen because we're already running late by 22 minutes.
I have shared, ma'am. Is it visible on your screen?
Shreya?
Okay, ma'am.
So just to remind you all, you have got 6 minutes for presentation, followed by 2 minutes for question and answers. Okay.
Okay.
And you will be marked on the time, like you have to stick to your time. Okay.
Sure, ma'am. Okay, ma'am.
Okay, Shreya. So with the permission of my judges, I'm asking Shreya to start her presentation. Is it all right, Dr. Neeti, Dr. Reema, Dr. Meenakshi?
Yeah, sure. Please go ahead. Yeah.
Yeah.
Very good afternoon to one and all. My title is Maternal and Fetal Outcomes in Early and Late Intrahepatic Cholestasis of Pregnancy. So we all know that intrahepatic cholestasis of pregnancy is also known as recurrent jaundice of pregnancy, cholestatic hepatosis, or icterus gravidarum, which is a pregnancy-specific benign liver disease presenting in 2nd and 3rd trimester, characterized by pruritus with a predilection for palms and sole, and biochemical tests that demonstrate an elevated serum aminotransferase or elevated serum bile acid level without any underlying liver pathology such as HELLP syndrome, hepatitis, or obstructive jaundice, with spontaneous relief of symptoms and laboratory abnormalities promptly after delivery or within 1 month postpartum, so, which is it is thought to be relatively non-threatening to women, but have been associated with increased perinatal and morbidity and mortality, such as increased risk of preterm delivery, meconium staining of liquor, fetal bradycardia, fetal distress, and fetal demise. Incidence of IHCP has found to be variable, ranging from 0.1% to 4% in Central and Western Europe, North America, Chile, and Bolivia. However, in India, we have seen a rising trend in IHCP with the reported incidence rate ranging from 2.59% to 9.3% over the last 10 years. So we have conducted this study to study the maternal and fetal outcomes in early and late intrahepatic cholestasis of pregnancy in a tertiary care hospital in New Delhi to see whether the period of gestation at diagnosis or an earlier onset of symptoms affect the feto-maternal outcomes. And we also evaluated the maternal serum bile acid levels and correlated it with the maternal and fetal outcomes. So we conducted a prospective cohort observational study in Department of Obs and Gynae ESI Basai Darapur, where we recruited 196 women who fulfilled the inclusion criteria, out of which 40 patients were diagnosed before 32 weeks, were grouped under early IHCP, and 156 patients diagnosed after 32 weeks who were grouped under late IHCP. And these same patients were further divided into 4 study groups on the basis of their serum bile acid levels into group A, B, C, and D, with bile acid levels ranging between 10 to 19, 20 to 29, 30 to 39, and greater than 40 millimole per liter. So we included patients, antenatal women who had pruritus in palms and sole with deranged liver function tests, raised aspartate and alanine transaminase, serum bile acid level greater than or equal to 10 millimole per liter, and normal serum total bilirubin. And we excluded patients with other causes of pregnancy-specific liver dysfunction, such as preeclampsia, HELLP, acute fatty liver of pregnancy, and women who had underlying skin disorders, allergic disorders, and women with chronic liver diseases such as cholelithiasis and cholecystitis, and those affected with acute liver conditions such as hepatitis A, B, cytomegalovirus, and herpes simplex virus. Now, these patients were followed up till the delivery, and their blood samples for biochemical evaluation were taken at the onset of symptoms, and all of them were advised topical emollients and also deoxycholic acid on OPD basis. They were managed according to standard operating protocols set for the department, aiming to achieve completion at 37 weeks of gestation, and their decision for admission or termination was based on the diagnosis, period of gestation, severity, maternal and fetal well-being. We found that 80% of patients were diagnosed with obstetric cholestasis after 32 weeks of gestation, with the median gestational age at diagnosis of obstetric cholestasis being 36 weeks, and the majority of patients had serum bile acid levels at the lower range ranging from 10 to 19 millimoles per liter, followed by 20 to 29 and greater than 40 millimole per liter, and only 6.6% had bile acid ranging from 30 to 39 millimole per liter. So first of all, we started with a comparison of maternal outcomes between patients who were diagnosed before and after 32 weeks. And the parameters that we took were, we saw that there was a higher rate of cesarean delivery, instrumental vaginal delivery, postpartum hemorrhage, prolonged hospital stay, and blood transfusion in patients who were diagnosed before 32 weeks as compared to those diagnosed after 32 weeks. And a statistically significant difference in maternal outcomes was seen, with p-values less than 0.05 for each of these parameters. Further, these outcomes were compared among groups that were formed on the basis of maternal serum bile acid levels. And we found that the rates of adverse maternal outcomes increased with increasing maternal serum bile acid levels. Further, we also compared the fetal outcomes in between patients of early IHCP and late IHCP, where we included factors such as low birth weight, low APGAR score, meconium stain Leica, preterm, neonatal death, and NICU admission and intrauterine death. And we also compared these outcomes according to the serum bile acid level, and we found that there is a statistically significant difference in fetal outcomes between early and late IHCP group, and the rates of adverse fetal outcomes also increase with increasing maternal serum bile acid level. When I compared the adverse fetal-maternal outcomes in IHCP patients of my study as compared to those conducted by Haag J et al., Alkananda et al., and Pegu B et al., I found that the rates of adverse fetal-maternal outcomes that I mentioned beforehand, my study, to be congruent with those found in the IHCP patients in these other studies. Jin J et al. In 2015 conducted a retrospective study to analyze potential predictors for fetal outcomes on the basis of the trimester in which IHCP first occurred. They also studied outcomes such as stillbirth, meconium aspiration, green staining of placenta, neonatal death, low APGAR, preterm delivery, and ICU admissions. Adverse fetal outcomes between early onset, late onset, mild IHCP, and severe IHCP was recorded, and it was found that majority of patients were diagnosed in third trimester, and women with early onset, which was taken as less than 28 weeks, and severe IHCP with bile acid more than 40 millimoles per liter had worse outcomes. This was further supported by a prospective study conducted by Glantz et al., which showed that an increased rate of fetal complications was related to a total serum bile acid concentration greater than 40 millimole per liter. A similar finding was observed in our study with an increased rate of adverse fetal-maternal outcomes in patients diagnosed at an earlier gestation. And in this study, yes, ma'am.
Excuse me, yeah, your time is up.
Okay, ma'am.
Please wind up with conclusion.
Okay, ma'am. I would like to conclude by saying that gestational age at the onset of symptoms and diagnosis affect the fetal-maternal outcomes, and patients who are diagnosed at an earlier gestation have a more adverse outcome as compared to those diagnosed later, and higher rate of adverse outcomes are observed in patients with bile acid level greater than 30 millimole per liter. So an earlier onset of symptoms and gestational age at diagnosis should be kept in mind to predict the disease course and probable outcome, and also to decide an appropriate gestation for the termination of pregnancy in these patients. Thank you, ma'am.
Okay, Shreya.
Yes, ma'am.
It's a nice study. I just want to ask a few questions. What was the earliest gestation at which you noticed IHCP? You said before 2 weeks, but what is the earliest gestation?
Ma'am, we had only one case out of the total 196 where there was a patient at 26 weeks who came with deranged OTPT and pruritus, but her serum bile acid levels, were not raised then. But when we followed up, I noticed that with time, there was a change in her serum bile acid level, and it was greater than 10 only after 28 weeks. So, but she had the symptoms at 26 weeks.
Did you take history of previous pregnancies in this patient? What happened in their previous pregnancies? Because ICP is known to recur.
Yes, ma'am. Actually,
you can include that. And did you take any history of any intake of medication which might be common in these patients? Because it has been suggested that progesterone supplementation can lead to IHCP.
Yes, ma'am.
So
But
have you found out any such correlation, or have you looked into that?
No, ma'am. I did not take any history of previous drug intake or previous history of IHCP in this study particularly.
Okay, thank you.
So was there any overlap between your cases of preeclampsia and IHCP in the particular number of cases that you've taken?
No, ma'am. So in the exclusion criteria itself, we excluded all patients with preeclampsia or who were diagnosed with acute fatty liver and who were in HELLP syndrome.
Okay, good. It's a nice study that you've done. It's good.
Yeah, even I wanted to ask a question because definitely now that we are seeing more and more cases of IHCP, this becomes very, very interesting. But what I want to know is that when you said that your aim was to deliver the babies by 37 weeks, was that the aim, or had you put a criteria for particular bile acid level when you would deliver the babies?
Ma'am, so generally we induce the patient. We would by this I wanted to say that we would never extend the pregnancy beyond 37 weeks. But if the bile acid levels were greater than 40 millimole per liter after DEXA coverage after 34 weeks, we have terminated pregnancy as early as 35 or 36 weeks in this case also. And even in patients who had complaints of decreased fetal movement, we had induced them, and in view of failed induction, when they underwent cesarean section, meconium stain liquor was found in many of the cases now.
Were there any cases in which the bile acids had increased to much more than 40 by the time you detected it, and did that
ma'am the maximum
affect the outcome of the neonate?
I'm sorry, ma'am, would you please repeat the question once?
Yeah, I said that was there any case in which the bile acids by the time you detected it was much more than 40, and when you delivered them, and did that also affect the outcome with the neonate?
Yes, ma'am, absolutely. So there was the rate to percentage of IUD was around 3% in our case, and the IUDs that occurred were in patients who delivered much later in third trimester and whose serum bile acid levels were found to be 60 to 75 millimole per liter, and they were diagnosed with IUD, and immediately they were induced with mifepristone.
And how often were you doing the bile acids?
Ma'am, bile acids, ma'am, I had done just one reading of bile acids depending on. Sorry.
Meenakshi, ma'am, your voice is breaking.
There is some problem in the audio. I'm not able to hear you.
Yeah, Meenakshi, there is some problem with the Dr. Meenakshi's side.
Shreya, you can tell us how often repeat bile acid.
Okay. So, ma'am, in most of the cases, I would say in 95% of the cases, I obtained only one sample for serum bile acid estimation after I confirmed that their OTPTs were definitely deranged, because the bile acid.
How do you follow up your treatment? Suppose you found a bile acid of 50 and you started the treatment. How do you follow up? Do you follow up IHCP or not? Do you follow the levels or not?
Ma'am, ideally we do follow the bile acid level, but this is a drawback in my study that first of all, the serum bile acid estimation is was quite an expensive study if it was to be conducted themselves by the patient, and we had a very limited supply of the bile acid kits in our hospital. So we only did the serum bile acid levels once, just to detect whether or not the patient definitively had IHCP, and if the patient had a greater value of serum bile acid level, those patients who were ready to get their bile acid level done on themselves, only those patients we followed up.
I just wanted to tell you one thing, that sometimes even after starting treatment, the bile acids keeps on rising. So
yes, ma'am.
It has to be followed up. I can understand your financial constraint. That is true. Understand.
I don't think anywhere you can condone an IUD if the patient is under your management. I'm sure any patient, however poor they are, if they understand the differences between an IUD or something, you should bile acid weekly maybe, if they were high.
Yes, ma'am. Yes, ma'am. Ideally, I should have done that.
Thank you.
Thank you, Dr.
Shreya.
I would request, that the presenters should keep their video on. Please, the presenters keep their video on, while they are presenting and while the question answers. After that, they can, switch their video off. Thank you.
And again, it's an humble request to all the participants to please stick to time. It's 6 minutes for presentation and 2 minutes for question and answers, because we are already running late by half an hour now. Okay. So with the judges' permission, I would like to call the next participant, Dr. Smriti Anand. Dr. Smriti, are you there? Dr. Smriti Anand, can you hear me? Yeah, Dr. Smriti, are you ready with your presentation?
I'm ready.
Yeah, please start sharing your screen.
Is my screen is visible to all?
No. Yeah, now we can see you.
Visible?
Yeah, we can see you, Dr. Smriti. You have got 6 minutes. Please start your presentation.
Very good afternoon to all my respective judges and my colleagues. So I am Dr. Smriti Anand, and I am an assistant professor in Department of Obs and Gynae, PGIMS Medical College, Rohtak. So I'm going to present on the topic about twin pregnancy and its feto-maternal outcome. So the incidence of twin pregnancy has shown to increase in the last decade, and because of the delayed marriages, which is prompting to the high rates of the subfertility and infertility. Twin pregnancy represents over about 2 to 4% of the total number of births. So as we all know, multiple gestation is considered as high risk pregnancy. Currently, multiple gestation constitute up to 3% of all the pregnancy, and in India, up to 1% of the pregnancies are twin gestation, and 10% of the mortality can be attributed because of the twin pregnancy, because of prematurity and low birth weight, etc. The main major complications because of the multifetal pregnancy can be there, like preterm labor, premature rupture of the membranes, anemia in the patient, pregnancy-induced hypertension, and postpartum hemorrhage. So coming to the material and methods, basically this was a retrospective record-based studies. Study period was included between January 2018 to December 2019, that is between 2 years. And I have included all the antenatal patients which got delivered with twin pregnancy in my study, and antenatal patients with a twin pregnancy who were not in labor or who were not got delivered were excluded from the studies. And APGAR score, like in terms of fetal outcome, were recorded in this study. So in my study, a total of 22,782 deliveries took place, and out of them 260 of them were twins. So making an incidence of twin delivery at our institute was 11.4% per 1,000 live births. Showing basic demographic factors. Most of the common patients coming in our studies related with twin pregnancy will come between the 21 to 25 years of the age. This can be because in our country, because of the early marriages and early pregnancy, most of the patients fall in this age group. Patients were mostly like primary gravida, and there was no any significant correlation between booking status and educational status of the patient. So in our study at our institute, 92% of the patient was from spontaneous conception, only 8% IVC. So coming to the phase of gestation of the delivery, 64% of the patient, of the total patient, delivered between 32 to 37 weeks of the gestation. This is important because this can be the reason that most of the patient underwent into preterm labor. That's why making the twin pregnancy as a high risk pregnancy. So this is the distribution on the basis of presentation of the fetus, onset, and mode of delivery of the patients. So most of the presentation of the fetus in utero was vertex presentation, and majority of the patients got spontaneously in the labor, and 63% of the patient got delivered by cesarean. Coming to the obstetrical complication associated with twin pregnancy in our study. So most common complication was observed in the patient were anemia. That is 48% were having anemia. And coming to the fetal part, most of the patients were landed into preterm labor, like 69.2% of the patients went into the preterm labor. This is a very important figure because because of this, twin pregnancy is attributed for the high risk pregnancy in our study. And other complication associated with twin pregnancy was observed, like hypertension 17% in the patients, 20% of the patients, gestational diabetes in 1.5% of the patient, and PPH was observed in 8.4% of the patients. Coming to the distribution of patients on the basis of their fetal outcome. So there were 520 fetus newborns out of the 260 deliveries. So in these fetuses, we have observed that 39.6% of the fetus got admitted in the nursery because of the low birth weight, because of the lung immaturity, etc. And babies with less than 2.5 kg of birth weight were 69.2% of the newborns. And in the 4.6% of the babies, perinatal death was reported. These were the studies first done by like Rizwan et al. In which their studies they have found the twin rate was 14.4%, which is almost comparable to our study. And mean age of 25 years was reported by Pante MR et al. And Priti P et al. In their respective studies. This is consistent with the study done by Singh et al. And as our study. And Mazhar et al. And Priti P were in their studies reported the mean gestational age of delivery was 35 weeks of gestation. That is also preterm gestational age. And coming to the complication part, Bengal et al. And Chaudhary et al. And various other studies reported that anemia and preterm labor was very common complication in the study, accounting for 66% and 35% of the. So coming to the conclusion part, as we see, hello.
Yeah. Your time is up now. Take another 30 seconds and wind up your presentation.
Okay, so coming to the conclusion part, twin pregnancy can have adverse fetal and maternal outcome. That's why we should always aware and we should always take special antenatal care in such patients so as to avoid the primary detectable complication that can arise because of the pregnancy. So that proper action can be taken and proper referral can be done. These were the references. Thank you.
Dr. Smriti, are you there? We have a question for you. Hello?
Oh, yes, ma'am. Yes,
so
ma'am,
Dr.
I'm there.
Smriti, so how were you following up? I mean, did you decide whether it was monochorionic or dichorionic pregnancy in the first trimester? Because and how frequently were you following them up? Because your complications will be different for both the kinds of twin pregnancies.
Yes, ma'am. Actually, ma'am, this was a retrospective study, and on the basis of that, the patient, whosoever have come with us with their first trimester antenatal scan, on the basis of that scan, we have taken their chorionicity because the patient have which are coming to at the time of labor.
No, so did you group? your complications were different for monochorionic and different for your dichorionic pregnancies, or would you, or it's just one general twin pregnancy that you took?
No, I'm actually antenatal scan with them, and some of the patient have none of them have any of the scan with them, and at the third trimester or second trimester scan for the chorinicity is not a reliable one, so I have not taken the chorinicity parameter.
Okay. You have delivered them, so won't you know about the chorionicity at the end? Ultimately, you could have gone retrospect.
Yes, ma'am.
You have delivered these patients now, so you will know the chorionicity at the time of delivery, at least, if it is not known on the ultrasound.
Yes, ma'am. Ma'am, actually in the delivery notes in some patients, residents,
you could have gone in retrospect and, you know, made different groups according to the chronicity.
Yes, ma'am.
Okay, my question is, you know, that you said that IVF is 8% and rest are all spontaneous conceptions. Didn't you
Yes,
encounter any patients of ovarian stimulation, IUI? These are not spontaneous conceptions. Those who are conceiving after ovarian stimulations, because, you know, in our practice now we see more multiple pregnancy when the patients come after IUIs and ovarian stimulations.
Yes,
in
ma'am.
IVF we have all the ways to control it, you know, by transferring single embryo.
Yes,
But there are no ways to control in IUI and ovarian stimulations where they are done.
Yes, ma'am.
So you had just written IVF and then spontaneous conceptions. So there will
Yes,
be
ma'am.
one group of these patients also who will go for IUI or, you know, ovarian stimulation.
Yes, ma'am. Okay, sure.
I just wanted, what I wanted to know was that, was there a difference in the outcome between the IVF pregnancies and your so-called spontaneous conceptions?
Ma'am, in IVF, I have observed that they have less like prom in these patients, and as they have conceived by IVF, so they have taken better antenatal care like nutritional care and all like that. So we have not found in those patients extremely low birth weight babies in those patients.
Your numbers are also very small, and 8% only of your.
Sorry, ma'am?
Your number of IVF, this thing are also small to compare. It's only 8% of all the.
Yes, ma'am. Actually, ma'am, the expression regarding this, because in our institute, majority of the patients come from the peripheries, like they are lower middle class and middle class, and the patient mostly who are getting IVF conceived and who are getting treatment for infertility will prefer to go some better institute like private, and that maybe.
I want to congratulate you that your rate of vaginal delivery is really good in twin pregnancy. And I'm glad that you must be teaching your students also the art of, you know, twin delivery and you know, internal pedalic versions and all those things. So it is.
Yes, ma'am. Yes, ma'am. Even in cases like one of the IUD or extremely premature baby, we are dealing with this situation and we are doing internal pedalic version also.
Okay, good.
Thank you.
Chalo. So judges, can we move on to the next participant?
Yes, we can move on to the next part.
Yeah, thank you, Dr. Smriti. So now, yeah, I would like to call Dr. Archana Kumari. She is with us. Dr. Archana, are you ready with your presentation?
I'm ready with the presentation, but the previous speaker has perhaps not, she is still sharing the screen.
Dr. Smriti, yeah, now she has stopped. Dr. Archana, now you can start with your slide sharing.
Yeah. So are my slides visible?
Yeah, Dr. Archana, we can see you. Please go ahead.
It's okay. So good afternoon, everyone. I am Dr. Archana Kumari, Assistant Professor in the Department of Obstetrics and Gynae at AIIMS, New Delhi. And I would be presenting my topic, Von Willebrand disease complicating pregnancy and obstetrician's challenge. So von Willebrand's disease is the most common inherited bleeding disorder, and it occurs due to deficiency or a defect in von Willebrand factor. It's a large multimeric protein that mediates the platelet adhesion and acts as a carrier protein for factor VIII. There are three major types. Type 1 is the partial quantitative deficiency. Type 2, where there are several qualitative defects in von Willebrand factor, and type 3, where there is complete deficiency of the von Willebrand factor and a secondary severe deficiency of factor VIII. Patients clinically present with either menorrhagia since menarche or any mucous membrane or soft tissue bleeding, bleeding after surgery, or rarely joint or GI bleed. Pregnancy with von Willebrand disease requires specialized and individualized management provided by a multidisciplinary team of obstetricians, hematologists, and anesthetists. So we present to you the case report. A 30-year-old woman, she was gravid to Paravan Live 2 at 7 weeks of gestation. She was admitted for medical termination of pregnancy. She was diagnosed with von Willebrand disease type 1 at 15 years of age during evaluation for menorrhagia since menarche, following which she took tranexamic acid during her menses. Occasionally, she also gave history of gum bleeding and epistaxis. Her last pregnancy was a spontaneous conception 3 years back, and it was diagnosed as a monoamniotic monochorionic twin on ultrasound. She was booked at AIIMS New Delhi, and a hematology workup was done. Factor VIII levels were 35% of the normal, and the von Willebrand antigen levels were 57% of the normal. All other coagulation parameters were normal. Elective LSCS was planned at 34 weeks due to monoamniotic monochorionic twin after optimization of her von Willebrand disease status. However, an emergency preterm LSCS was done at 32 weeks in view of severe preeclampsia. She developed postpartum hemorrhage requiring multiple blood transfusion along with factor VIII and cryoprecipitate, and she required post-op mechanical ventilation and ICU stay for 4 days. She was discharged after 2 weeks and followed up with hematology unit for the next 2 weeks. During the present pregnancy, her investigations were normal, and the coagulation profile was also normal, and ultrasound revealed a single live fetus of 7 weeks. And on hematology consultation, her DIC profile was done, and factor VIII assay was found to be 50% of the normal, and the von Willebrand factor antigen levels were as low as 18% of the normal. So intermittent purity factor VIII in the dose of 14,000 units was started 2 days prior to her suction evacuation. Injection tranexamic acid 1 gram thrice a day was given, and the aim was to achieve 100% correction of the antigen levels prior to the procedure. And on the day of suction evacuation, her factor VIII levels reached 90% of the normal, and thus a suction evacuation under IV sedation was done along with Mirena insertion. Intermittent purity factor VIII was transfused for another 7 days under hematological supervision to reduce the risk of delayed bleeding. Injection tranexamic acid was continued for the next 5 days, and the patient was discharged in stable condition and asked to follow up in hematology OPD after 1 week. So, women with von Willebrand disease have an increased risk of antepartum, primary, and secondary postpartum hemorrhage. They should start pregnancy after being well characterized as to what is their type of von Willebrand disease, what is their subtype, and the treatments. The key to avoid postpartum hemorrhage is increased awareness of this problem and the use of preventive measures prophylactically, like correction of the coagulation defects and active management of third stage of labor. So all women need to be counseled about increased risk of bleeding, especially in those type 1 von Willebrand disease where the von Willebrand levels do not reach above 0.5 international per ml, or in type 2 or type 3 von Willebrand disease. And we should check the von Willebrand antigen levels and the factor VIII levels at the time of booking, in the 3rd trimester, or prior to any invasive procedures. So individualized management strategy should be formulated collaboratively by the multidisciplinary team of obstetrician, hematologists, and anesthetists for optimal maternal and neonatal outcome. The target is obviously to achieve the factor VIII and von Willebrand ristocetin cofactor activity levels of 0.5 international unit per ml or above to cover any surgical procedure or spontaneous miscarriage. The treatment options are many, and the treatment requires correction of the dual hemostatic defect, the low factor VIII levels as well as the low or abnormal von Willebrand factor antigen levels has to be taken care of. And these goals can be achieved either by increasing the plasma concentration of these factors through their release from the endothelial cells with desmopressin, or by using replacement therapy with human plasma derived low purity von Willebrand factor VIII levels, or with high purity von Willebrand factor products. Desmopressin is safe for use in pregnancy and at delivery, but it should be avoided in patients with history of preeclampsia or preeclampsia. And the target peak activity level should be 1 international unit per ml and levels maintained above 0.5 international unit per ml until hemostasis is secured. The timing of treatment should be as near to the delivery as possible, and the pre and post treatment levels of von Willebrand activity level and factor VIII level should be measured and repeated after delivery or if the labor is prolonged. Tranexamic acid should be considered in combination with treatment for all those with von Willebrand activity less than 0.5 or as a sole therapy for those whose levels have reached 0.5 if clinically indicated. The postpartum care, obviously there is delayed risk of bleeding, so postpartum levels should also be maintained for at least 3 days following uncomplicated vaginal delivery and for at least 5 days following instrumental delivery. And since there is risk of delayed bleeding, the patient should report if there is excessive bleeding, monitor her hemoglobin status and follow up after several weeks. So we have a systematic review that was published in 2020.
Dr. Archana?
Yeah.
Excuse me. Yeah, ma'am, you're exceeding your time. Your time is over now.
Okay, so there was high incidence of bleeding of 34% reported in women, independent of the prophylactic treatment. The prospective cohort studies have also reported high degree of primary and secondary PPH. And all these large cohort studies have showed even though the patient had not received prophylaxis or even if they had received prophylaxis, there was high risk of bleeding. So the conclusion is that von Willebrand disease complicating pregnancy poses a serious challenge to the obstetrician. Close surveillance is required and bleeding may sometimes occur even with normalization of these factors, and antifibrinolytics play a significant role as an ancillary treatment. So the take-home message is that all pregnant women should be inquired about the history of menorrhagia, gum bleeding, and epistaxis. Thorough hematological workup should be done prior to any planned pregnancy event, and women with diagnosed von Willebrand disease should be managed in a tertiary care center under close supervision of obstetrician, hematologist, and anesthetist with facilities for transfusion of factor VIII and von Willebrand factor along with other blood products. And of course, contraception should be encouraged to prevent unintended deliveries in such high-risk pregnancies. Thank you.
Thank you, Dr. Archana. Can you stop sharing your screen, please? Yeah, Dr. Archana. So the cause why the patient wanted termination was because her family was complete.
No, ma'am. Actually, she didn't want to have the pregnancy was a result of contraception failure, and she didn't want to have a child right now.
Okay. So what other contraceptive, you put Mirena in this patient, I understand, but what other contraceptive measures would you suggest in these patients? What other options are there?
Yes, ma'am. These patients can be given progesterone only pills or injection DMPA can also be given safely in these patients.
Yeah.
Okay. Any genetic workup that you would think about these patients if this patient wanted a future pregnancy? Any genetic evaluation for the fetus?
Yes, ma'am. Yes, ma'am. Such patients, actually, this has an autosomal inheritance pattern. Von Willebrand disease has an autosomal inheritance pattern, and especially the type 3 has variable penetrance also. So these patients should be genetically worked up, and they should go for CVS in early pregnancy to diagnose the von Willebrand disease in the fetus. And if it is found out, we have to also go for, we should avoid invasive procedures in like fetal blood scalp sampling or even forceps or vacuum application in these fetus.
You're right. Very good.
Thank you, ma'am. Thank you, ma'am.
Thank you, Dr. Archana.
Dr. Archana, I think we are done.
Okay.
Thank you.
Thank you, ma'am. So I would like to call the next presenter, Dr. Soumya Kulshresht. Dr. Soumya, are you there? Dr. Soumya? Dr. Soumya?
She's scared.
Yeah, she's
sharing her screen. I can see that.
Yeah, now I can see her. Dr. Soumya, are you ready?
Ma'am, 1 second, ma'am. My slide is not.
No, if it's taking time, then I'll call the next participant.
Yes, ma'am, you can call. I'm presenting next, ma'am.
Okay, so with the judges' permission, I would like to call the next participant, Dr. Latika Chawla.
That should be fine, yes.
Dr. Latika, are you ready?
Yes, ma'am, I'm ready.
Okay, then you can start sharing your screen.
Okay, ma'am, I'll do that.
Okay, so I'm giving you 6 minutes for your presentation and 2 minutes for your question and answers. Okay, so try to finish on time.
Actually, ma'am, Dr. Soumya is still sharing, so I cannot upload my slides.
Dr. Soumya, please stop sharing your screen. Let
Yes,
Dr. Latika present first. Yeah. Latika, now it's all yours.
Okay, ma'am, thank you.
Thank you.
Are my slides visible, ma'am?
No, dear. We can only see your beautiful face.
Now, ma'am?
Yeah, now we can see you.
Okay, thank you so much, ma'am. So, a very good afternoon, respected judges. I'm Dr. Latika Chawla. I'm an assistant professor in the All India Institute of Medical Sciences, Rishikesh, and I'll be presenting my slides on management of cesarean scar pregnancy, a challenge. So, a cesarean scar pregnancy is a complication in which an early pregnancy implants in scar from a prior cesarean delivery, and it's not very uncommon. We are more and more coming across this. The incidence documented literature is around 1:500 pregnancies among patients with a previous cesarean section. And cesarean scar pregnancies are associated with significant risk for severe morbidity and mortality as well. In view of life-threatening hemorrhage associated with that, possible uterine rupture, challenges in securing a timely diagnosis, and a lot of times there is uncertainty regarding the optimal treatment once you've been able to diagnose a cesarean scar pregnancy. So the objective of this study is to report the outcome of 6 patients of cesarean scar pregnancy, where we managed them with surgically assisted medical management. So this was conducted at our institute in the Department of Obs and Gynae. 6 patients I'll be presenting the outcome of, and the management, the plan of management was decided upon after intense, and detailed counseling of the patient and the family, and after documenting an informed written consent. So 4 of our patients after diagnosis of cesarean scar pregnancy were managed with intralesional methotrexate under transabdominal ultrasound guidance, and IV intravenous methotrexate was given. One of the patient who had a live cesarean scar pregnancy, in that we reduced the fetus with intracardiac ACL along with giving her intravenous methotrexate injection. And the 6th patient, we had to do a suction evacuation followed by intralesional and intravenous methotrexate. The dose of methotrexate was calculated by the formula 50 milligram per body surface area, and half the dose we injected in the lesion and the other half we gave intravenously. And all these patients were discharged 48 hours after the procedure. We gave them oral antibiotic for 5 days, and then we followed them up with the serial beta HCG and ultrasound. So this slide is showing us the profile of these patients. 4 of the 6 patients had previous 1 cesarean section, and the other 2 had previous 2 cesarean section. The top 4 patients, which I have mentioned, they were referred to us from another center when the doctors, they encountered excessive bleeding at the time of suction evacuation or DNC. In all these 4 patients, we gave intralesional and intravenous methotrexate. The 5th patient, as you can see on the slide, this patient was around 10 weeks and she had a live cesarean scar pregnancy. So here we reduced with intracardiac ACL and followed by intravenous methotrexate. And the 6th patient here, we were not very sure, because this happened just like around 2 months back. And then, with the PP and with the headgear, we were not very sure of the diagnosis. So even we were confused. And however, we did do the procedure in the OT with all anesthesia and everything available for doing a uterine artery ligation or a internal iliac if she bled during the surgery. So so we did a suction evacuation. She did bleed. Then we put in an intracervical Foley. Bleeding was stopped, and followed by that, on day 3 of the procedure, intralesional and intravenous methotrexate. So these are just some images I'll be sharing of the patient. So this was the first patient. You can see this heteroechoic lesion at the previous scar site and the vascularity associated. A very tiny video of the ultrasound guided injection of the methotrexate. So this is the needle. That's the scar pregnancy. And now you'll just see the methotrexate coming out. Yeah, that's it. So, and on follow-up, 1 month post-procedure, you can see the size has decreased by around 25%. This was 2 months procedure. The size has decreased, significantly. And this was 4 months procedure. So the patient resumed a menstrual cycle, absolutely fine, no, lesion remaining on scan. So the second patient and the third patient were absolutely similar. So, this was the scar, and then we injected intralesionally an IV, and on follow-up, around 4 months, the lesion had disappeared. The fourth patient, procedure was almost similar. However, 23 days post-procedure, the patient, came to us in hemorrhagic shock. Apparently, she had been bleeding at home for almost 2 days, and she landed in the casualty at around 11 p.m. So she was resuscitated, and we, had to take her up for an emergency laparotomy. We made an attempt at a conservative surgery, but there was massive blood loss. So, however, she was discharged after a very hectic post-op course on day 5. This is the other patient, the fifth patient with a live cesarean scar pregnancy. And this was on follow-up. This was 1 month procedure, 4 months post-procedure. The size has decreased to more than 50%. Then we lost her to follow-up because of the lockdown. But, we have been managed to contact her on telephone, and she's got her scans done outside, and she's absolutely stable. This is the sixth patient where we did a DNC. During the DNC, she bled. So you can see the intracervical Foley here. This was the lesion. So we injected intravenous and intralesional methotrexate. She's on follow-up, and the lesion has reduced to more than half. In the top 4 patients, we took around 25 days post-procedure for the beta-HCG to come back, and around 95 days post-procedure for the disappearance of the lesion. So this is just like going on to the discussion. A very recent study, this was a retrospective analysis of 101 patients of cesarean scar pregnancy who received ultrasound-guided local injection of methotrexate. And they found that the mean time for beta-HCG normalization was 40 days. We found it as 25 days in our study. And they concluded that the lesion took around 40 days and maximum of 70 days to disappear on the scan. However, we had a significantly longer duration for the lesions to disappear on the scan. The Society of Fetal Medicine, in their recent guideline, has recommended that all patients of cesarean scar pregnancy should be referred to a tertiary care center for surgical resection, accepted treatment, ultrasound-guided vacuum aspiration, accepted treatment, intralesional methotrexate, again an accepted treatment. However, systemic methotrexate alone should never be given. And they absolutely are against expected management once the cesarean scar pregnancy is diagnosed. So to conclude, surgically assisted medical management of cesarean scar pregnancy is effective. It can avoid a major surgical intervention. However, associated with risk of severe bleeding, it requires long-term follow-up associated with significant amount of patient and surgeon anxiety, because, till the patient is absolutely fine, even we were like very, scared as to what is going to happen to them. And the decision has to be taken up after, detailed counseling and informed written consent by the patient and partner. Thank you, ma'am.
Thank you, Dr. Latika.
Very nice series, Dr. Latika.
Thank you so much.
I'm interested in finding out what was the findings on that laparotomy which you did. Can you stop sharing?
Yes, ma'am. I'll just show you the image, ma'am. This was the image. So this was the scar pregnancy. And
so the uterus looks intact. The uterus looks intact. So did the scar rupture?
Ma'am, the scar did not rupture because she was bleeding from below. So and she was unstable. So we thought we'll just give it a nick and take out the scar, the pregnancy.
Yeah, but the scar area is absolutely intact.
But she was bleeding from below, ma'am. She was bleeding vaginally, not intra-abdominally.
Okay.
So we thought we'll just ligate the uterines and take out the ectopic. However, it just the bleeding just did not stop, and
maybe because she was hemodynamically very unstable. You
yes,
take that off, because otherwise, catheterization and all those things can also be done. And
yes, ma'am. No, she came in shock, ma'am. And apart from the hemorrhagic shock, there was also some septic component associated.
Okay.
So, it was like a difficult for us to manage. So what we could do in the emergency, embolization is not available in emergency with us.
Okay. And you did not require to do suction evacuation in any of your patients?
Ma'am, we didn't do. Actually, they were diagnosed, all the 4 patients.
No, I'm not saying that. Because
yes,
I had 2 patients in past in which I had given methotrexate the same way. And they did require, a suction evacuation ultimately. Because after two, this thing also, periods, because the beta-HCG went down. It went below 5, and there was some tissue there sticking at the, scar site.
Yes, ma'am.
And ultimately, in one patient, I had to do, suction. The other was okay. So I was just wondering, because I had only 2 patients to comment upon, but you
Yes,
had a
ma'am.
series and still you were not required to do a suction evacuation in any of your patients.
No, ma'am, we didn't. I ended up doing a laboratory for one, ma'am.
Okay.
So that was a very good series, Latika. I mean, very good
Thank you, ma'am.
cases that you had. Yeah.
Yeah, it's a very nice presentation. Thank you.
Thank you so much, ma'am. Thank you.
Thank you, Dr. Latika. Any more questions, judges?
I think that should be good enough. She's presented everything very well.
Thank you, ma'am.
Thank you, Latika.
So, okay, thank you,
Thank
Dr.
you.
Latika. Okay, now I would like to call the next presenter, Dr. Sadhna Singh. Dr. Sadhna Singh, are you there? Dr. Sadhna Singh.
She has, but
she's trying to share her screen. Yeah, now we can see her.
Hello, can you see me, ma'am? Hello.
Yeah, Dr. Sadhna, turn
Yes,
on your
ma'am.
camera also.
Is Soumya ready to present? Is Soumya also ready to present? We can take her also.
I think, ma'am, Soumya will take her at last. I'll give her the last part.
Hello. Ma'am, can you see me, ma'am?
Sadhna,
Can you
we can
see?
see your slides. Yeah, we can see your
Yeah.
slides. Please turn on your camera also, as requested by the judges. Please turn on your camera. Yeah, now we can see you, Sadhna, and we can see your screen also. Okay, so Dr. Sadhna, her title is Role of Platelet and Indices in Thrombocytopenia in Pregnancy, and her code is HRP 0427. Am I right, Sadhna?
Yes, ma'am. Yes, ma'am.
Yeah, okay, Sadhna. You have got 6 minutes for your presentation.
Okay, ma'am.
And 2 minutes for your question and answers, okay? So you can start with your presentation.
Myself, Dr. Sadhna. I am presenting the case on. I am presenting the study on role of platelet indices in the evaluation of thrombocytopenia in pregnancy. And firstly, we will know about thrombocytopenia in pregnancy. Platelet count below the lower limit of normal range we take in the pregnancy is 1.5 lakh per cubic millimeter, and 75% of the cases of thrombocytopenia contributed by gestational thrombocytopenia, followed by 15 to 25% by hypertensive disorder, 3 to 4% by immune thrombocytopenia, 1 to 2% by constitutional thrombocytopenia. And the reason behind why I did this study is the evaluation of thrombocytopenia during the pregnancy and postpartum is very challenging, as there are many causes that are related directly to the pregnancy or unrelated to the pregnancy. And also the platelet activation lead to the changes in the platelet morphology and shape that indirectly reflects on the mean platelet volume, platelet distribution width, or platelet grid, that are platelet indices. So these are differentially altered in the different etiology of the thrombocytopenia, and combination of them we can use to differentiate the different etiology. That's why in my study I use these 3 parameters: mean platelet volume, platelet distribution weight, and platelet grid. It was a prospective case control study. The sample size was 200. 100 were cases and 100 were controls. All pregnant female with platelet count less than 1.5 lakhs per cubic millimeter during pregnancy were included in study. And patient on antiplatelet drugs and other medications causing thrombocytopenia were excluded. After the allotment of the cases in the control group and study group, the routine workup was done, and their serial complete hemogram along with the platelet count and the platelet indices performed at the first visit, at the delivery and postpartum. At the delivery, maternal platelet count and cord blood platelet count were taken, so that we can find out the association between the maternal platelet count and the cord blood platelet count. And postpartum, maternal platelet count was done within 1 week, and neonatal platelet count was also done at the day 3 of birth. And we found in the control group, the platelet count and the platelet grid from the pregnancy till the delivery were in the decreasing trend. That was significant. And followed by delivery, they increased, but not that significant. In the cases, the platelet count and the platelet grid and MPV decreased from the pregnancy till the delivery. That was significant. After post-delivery, the platelet count were in the increasing trend. That was significant, and also the MPV increased significantly after delivery. Like in this figure, we can see the 99% of the cases and the 100% of the controls. After delivery, 77% of the cases and 52% of the controls were.
Dr. Sadhana, your voice is cracking.
Hello,
Yeah.
ma'am, is it clear?
Yes, it is clear now.
After delivery, 77% of the cases and 52% of the cases has an increasing trend. And in the cases, we distributed the cases into the gestation thrombocytopenia, that was maximum around 89 cases, and anemia had the 5, and gestational hypertension was 4, and ITP had 2 patients. We saw in the gestation thrombocytopenia, platelet count was during the entire pregnancy was between the 1 lakh to 1.5 lakhs. And in the anemia and gestational hypertension, it was between the 50,000 to 1 lakh. In the ITP, it was less than 50,000. And platelet rate also had the same trend, like platelet count in the all of the 4 groups. Initially, it was in the decreasing trend till the delivery. After that, it was increased. In the gestational hypertension patient, we saw the mean platelet volume was much more higher than the other causes of the thrombocytopenia during pregnancy as well as during post-delivery. In the PDW, like in the anemia and the ITP, had the anemia and ITP patients had the maximum of the PDW between among the all of the 4 groups. In the outcomes, we saw that there was no significant difference in the mode of delivery between the cases and control, and there was no increased risk of complication in the thrombocytopenic patient. And thrombocytopenia patient has the maximum, has the more of the preterm bus and low birth weight baby as compared to the controls. And also there was a significant association was found between the maternal platelet count and the cord blood platelet count. Now coming on to the discussion, if we compare our study along with the other study, the prevalence of thrombocytopenia was more or less similar with the other study. Like in my study, it was 13.3%, and the study done by Minodora, it was 11.1%, and mean platelet volume, platelet rate, and PDW showing the same result as in the Minodora study done in 2012. Usually we don't have so much study in which the whole of the four parameters are used, but we compared my study with the Minodora that took the 2 groups, gestational hypertension and gestational thrombocytopenia, and the results are comparable with the respective groups in my study. Finally, I concluded that mean platelet volume is significantly high in gestational hypertension as compared to the other etiology of thrombocytopenia. So it can be used as a predictor of preeclampsia or gestational hypertension. PDW is maximally high in the women with anemia, followed by ITP and preeclampsia. Gestational thrombocytopenia in pregnancy is not associated with adverse maternal complication, and maternal thrombocytopenia is associated with premature delivery and low birth weight baby, and cord blood platelet count is associated with the maternal platelet count. Thank you, ma'am.
So, Dr. Sadhana, you did not include other immunology.
What was the lowest platelet count in your series, in your patients?
It was in the ITP group, 34,000.
Dr. Sadhana, can you hear me?
Yes, ma'am. Yes, ma'am.
How much?
How much? 34,000, ma'am, in the ITP group.
34,000 in the ITP group was the lowest platelet count. Okay.
Yes, ma'am.
So, Dr. Sadhna, you did not include immunological causes as one of your criteria for thrombocytopenia, or just gestational hypertension and the other three?
Ma'am, I took only ITP, immune causes. I took only ITP, that for which I.
But SLE, and other things you did
No.
not take.
Oh yeah, ma'am, I did not take.
And how do you correlate anemia with thrombocytopenia? So, what kind of anemia were you looking at?
Ma'am, actually, we in these cases we perform folate and vitamin B12 and ferritin study and iron studies. Then we found that it was macrocytic anemia more common.
Macrocytic. Okay.
Dr. Sadhna, somehow, can you explain the first line of your conclusion once again? What do you mean to say by the first line of your conclusion?
Ma'am, mean of MPV was significant. In my study, I found mean of MPV is significantly high in gestational hypertension as compared to other etiology like anemia and ITP and gestational thrombocytopenia.
Okay.
In overall entire pregnancy.
So you said that it can be used as a predictor.
Yes, ma'am.
So at what point do you think this can be used as a predictor? Like when it is not set.
Like ma'am, if we are doing in the first trimester and we are seeing that MPV is raised and we are having no cause, then it has been seen in the study that after like in the second or third trimester, these the higher MPV patients are more likely to have gestational hypertension or preeclampsia.
Okay.
Any other questions, ma'am?
That should be done.
Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Thank you, Dr. Sadhna.
Thank you, ma'am.
Okay. So now I would like to call Dr. Sujata Das. Dr. Sujata, are you there with us? Because I don't see your name in the participant list. Backend team, can you please confirm whether Dr. Sujata Das is with us or not?
No, she is not with us.
She is not there. So I think Dr. Soumya. Dr. Soumya?
Yes, ma'am.
Yeah, are you ready with your presentation, dear?
Yes, ma'am.
Yeah, please start sharing your screen. So judges, she is our last participant, Dr. Soumya, because Dr. Sujata has not joined yet.
Dr. Sarmishta, you sound like a school teacher, my kid school teacher.
I think Dr. Sujata has joined in also. She's joined in from, I think, Shrishti's name.
Acha, so I'll give her a chance. I think Dr. Soumya has already started sharing her screen.
Yeah, it is written, I was automatically joined with my daughter something.
This is what happened with all mothers. With all the online classes going on.
Yeah.
Okay, I think Dr. Soumya is all ready. Dr. Soumya?
Yes, ma'am.
Yeah, are you ready, dear?
Yes, ma'am.
Okay, chalo, all the best. And you've got 6 minutes for your presentation, okay?
Okay, ma'am. Thank you.
Okay, please.
Good
all the best.
afternoon, everyone. Thank you, ma'am. Good afternoon, everyone. My topic is introducing clinical debriefing session in COVID positive obstetric patient admitted in trauma center, a quality initiative study. As we all know, effective doctor-patient communication is a prerequisite for a successful and robust healthcare delivery system functioning, and for building a therapeutic doctor-patient relationship. Communication is a key issue in COVID time. There is a challenge in counseling of COVID positive obstetric patients who are admitted in trauma center without any relatives. So we have a problem identified as that use of personal protective equipment is undoubtedly necessary for the prevention of spread of infection from patient to healthcare and vice versa. However, this spacesuit-like attire create a rift between the doctor and patient at the first sight itself, as well as there's the absence of any specific place to communicate with the relatives alone, and another issue leading to the dissatisfaction among the relatives and the patient. Of daily clinical debriefing session with the COVID positive obstetric patient and their relatives from the current base. Study was assigned to done between 1st October to 28th October 2020. In the material method, firstly, we form a quality improvement team with a team leader as me and the senior faculty and junior faculty from the Department of Obs Gynae AIIMS and also the faculty of anesthesia. In the first team meeting, a WhatsApp group for all members was created, and the discussions were held how, when, and where the COVID counseling will be done and by whom, how the data and the report will be recorded, and a performer for the same was made, and the frequency of team meeting was done weekly. After that, we analyzed the problem. After that, we analyzed the problem using the fishbone analysis. As we can see, there was lack of awareness and lack of sensitization regarding the counseling in the people. There was no specific place to communicate with the relatives, as relatives are not allowed to stay with the patient in the ward. There was no specific outline, there was no specific assigned person, and there was no specific time slot about the counseling. So in this study, it's a quality improvement study setting done in tertiary care hospital and academic center. Study population was all the COVID positive obstetric women admitted in trauma center AIIMS. The data were collected from the COVID team posted in trauma center, and the process indicator was the percentage of COVID positive obstetric women and the relative undergoing clinical debriefing session over 1 month, and the frequency of data collection was done daily. In the first PDSA cycle, we plan to assign one doctor, which is senior resident of the COVID team, for the counseling. We make a policy for counseling of patient in the ward itself and the relatives over the phone, and we record the same data and we adopt this idea. After the first PDSA cycle, we can see that some relatives' phone were not available or they didn't pick up the phone. So as a part of second PDSA cycle, we plan a time slot for the counseling session for both patient and relative. We further do the resensitization of doctors regarding the importance of clinical debriefing session, and we further analyze the data, and as a part of ACT, we adopt this idea. As a part of third PDSA cycle, to further improve the satisfaction level of patient and the relatives, we used to call the patient related, ensure the content of the counseling. We implement a checklist and we further analyze the data and we adopt this further idea. This is a checklist. As a part of counseling of both patient and relatives, we updated them about the regular pregnancy status, about the effect of COVID on pregnancy and baby, about the further plan of management, and about the plan of discharge. This is a checklist Excel which we made. Now the result. As a result, we can see from a baseline of 0% counseling of patient, the first day itself with the orientation of resident, we can see a median of 60% counseling satisfaction of relative, which further increase to 80%. Then we can see after the first PDSA cycle, there was no fixed time slot for the relative phone, so there was some dissatisfaction and we can see a downgrade in the run chart. So we further, as a part of second PDSA cycle, we further assign a fixed time for the counseling, so then the relatives, after that we can see the satisfaction level of the relatives reach up to the 80%. With further using as a part of third PDSA cycle, we can use the patient phone, so the satisfaction level reaches to 100%. After that, we can see a dip in the run chart, which implies it's a change of duty team, as the duty team here changes every weekly. So we further resensitizes the senior resident doctor about the importance of clinical debriefing and counseling session. And after that, we can see over the days, there were again improvement in the run chart, and the patient and relative satisfaction level reaches up to the 100%. This is the patient and relative feedback form, from which we can answer whether they are strongly agree or not agree. These are some basic questions which we ask them at the time of discharge after the counseling session. And in the conclusion, I would like to conclude the third and fourth PDSA cycle are still ongoing. From the result, we can conclude that counseling is very important in this COVID era, and according to proper counseling session and handed over to a new team each time before the counseling week start, will lead to further improvement in satisfaction of patient and relatives. And we should also further enhance and implement the counseling content. What should be counseled and how to counsel to the patient and relative. It will lead to further improvement in satisfaction of patient and relative. Thank you.
Very nice study, Dr. Soumya, and very, very relevant in today's time. When you are taking these questionnaires, were you taking from, like, suppose some patients were admitted over weeks, suppose they stayed for 3 weeks. So they were giving this questionnaire every week, so that you know that can they compare their own satisfaction? Can they compare their own satisfaction with 2 teams of doctors?
Yes, ma'am. We are doing counseling every day, and weekly we are taking data if the patient is staying for longer week. And usually on the day of discharge, we are taking this feedback form. then how for how many days, like if you're saying for 3 to 4 days, what is the satisfaction level, how the doctor do counseling, is it good, is it related to content, and also the relatives. Since the relative, when we use the baseline data, relatives are very dissatisfied as they didn't get to meet the patient also, they didn't get to meet the doctor also, so they don't know what is happening with the patient in the COVID ward.
Yeah.
So that's why we started this quality initiative. Okay, we counsel the relative on the daily basis. After morning on, we tell about them the basic status, what is the patient and how is she, what is the about the baby, and what is the further plan, and when we are delivering normal cesarean, whatever, like that.
Very relevant, because we are doing it already. When we go to our COVID patients for rounds, we usually talk to their relatives from their phones, their own phones. And I never realized that could be a big thing, that we always, talk with their own phone, and, they get satisfied, definitely. And after every round, we should talk to the patient's relatives.
I'm very, very proud of you, Dr. Soumya, for taking up this relevant topic, because I think in this difficult time, empathy is extremely important. And for you to have seen that this is something which, specifically people need to be assigned to be doing, and to make a study which is relevant and which other doctors can see, I think I must congratulate your team to think of this, because it's a very difficult time for patients, attendants, and doctors. And most of them have this problem that, they are not being counseled properly. To do a complete study on it and present it, I think you've taken a good opportunity to make a study of this also. But yeah, very good initiative.
Study is ongoing, and we are further implementing the further changes. How can we improve ourselves in this counseling session?
Excellent, Dr. Soumya.
Brilliant idea, yeah. This is what we are suffering. This patient satisfaction is going down because of the COVID times. I think this is brilliant.
Yeah, excellent.
Thank you, ma'am.
Any questions, judges?
I think we are done.
On the last one now.
Yeah. Thank you, Dr. Soumya.
Thank you, ma'am.
Thank you. So I would like Dr. Sujata Das to start with her presentation. Yeah, Dr. Sujata, we can see you. Can you please start sharing your screen? Ma'am, please unmute yourself. Dr. Sujata.
Very good afternoon, respected all judges. I would like to say that the topic of this presentation is COVID-19 reinfection in pregnant women. We are waiting for certainty on antibodies. This is not running. Yeah, the COVID-19 infection is caused by coronavirus. Following the infection, the detectable antibody and an IgM antibodies are produced within few weeks of symptoms. As far as the COVID-19 infection is concerned, this is an emerging disease, and we have very limited data available for our COVID-19 during the pregnancy, and this is even lesser known fact how this is behaving in our population. The changes in the immune system for a pregnant woman make them more susceptible to the infectious process. The COVID-19 is not yet fully understood, and the definitive data on the post-infection immunity is lacking. Amidst the certainty, the public health crisis, thoughtful and rigorous science will be essential to form a public health policy, planning, and practice. Now, therefore, in a bid to answer the burning questions of reinfection in the recovered cases, it is also very important to find out why some individuals do not have the humoral response. Adding to this uncertainty is the unclear relationship of clinical symptoms and the antibody production. Now, there was a descriptive cross-sectional study taking 156 patients of gynae emergency at SGH hospital over the period of 4 months. The relevant information was obtained from all the pregnant women using an administered questionnaire method and presented in the form of simple tables and charts. Now, all the patients were advised to wear masks, and all the healthcare workers were wearing the PPE while taking the samples. Also, we carried out the awareness program also as far as the hand hygiene and social distancing is concerned. The total of 156 patients presented to the gynae emergency during the specified period of the time who presented with the complaints of fever, cough, sore throat. Out of these, 48 patients were RT-PCR positive, and thus giving the incidence of about 30.7% in this study. The most common presenting complaint was fever, almost 86%, followed by cough and sore throat. So this is again very, very important. to know with what complaints they're coming with. Among the COVID positive patients, only 8 patients give the history of contact with the individuals diagnosing with the COVID-19 infection, and rest were the community acquired infections. Now, all the patients were subjected to the relevant laboratory investigations, including RT-PCR, CBC, LFT, KFT, and coagulation profile. As far as the age group was concerned, most of these patients fell into the age group of 20 to 25, both COVID positive as well as the COVID negative groups. Now, if we talk about the gravity, most of these patients were primary gravita in both positive and negative groups. So majority of our patients had mild symptoms, almost 85%, 13% with moderate, and just 2% with severe symptoms. There was only one maternal death amongst the COVID positive patients who presented to us as preeclampsia with severe features. Now, this is a graph which is very nicely showing us the mild, moderate, and the severe symptoms in both the COVID positive and the COVID negative groups, where 85% was seen as the mild group and 93% was seen as the mild group in the negative category. Now, if we talk about the comorbid conditions, anemia and preeclampsia are seen in most of these important, and most conditions are present anemia, since almost 70 to 80% of these patients are already anemic. So almost 18 patients in the COVID positive and 22 patients in the COVID negative, making the p-value significant. Now, this is the most important segment of this presentation. If we talk about the return to the facility, after the average duration of 8 weeks, 13 patients returned to us with and were fully investigated again. 4 patients had running very high grade fever and 9 presented with the low grade fever and some sore throat. None of them were RT-PCR positive. This is a very, very important finding here, but had mildly raised liver enzymes. 2 patients were Vidal positive and 1 was AMP antigen positive. And for rest of them, we could not find out any reason. Also, the facility for the detection of antibodies were not available at our setup, which is a very important thing to discuss here. Now, we talk about this is the utmost importance to find out whether these patients were the case of reactivation or reinfection. Though there are no method to confirm it, we have no confirmed cases from this region of the world so far. If we talk about the review of the literature, it is very, very important to understand. This is a very important recent article which shows that the combination of serological testing along with the antibody, along with the RT-PCR is very, very important. And this increased the sensitivity and the specificity as far as the testing and the detection of the case is concerned. Again, this is a very important review, systematic review, which was presented in July 2020. Antibody testing for the identification of current and past infection with SARS-CoV-2. It is a very, very important strategy. There are several diagnostic techniques that are available to identify the current infection and rule out the infection, identify the people who actually need it. So what we know about the immune response, the patients who had mild or symptomatic COVID-19 have very low levels of neutralizing antibodies. Those patients in this, there is possible innate immunity where the T cell response cleared the viruses. Recent studies have shown that neutralizing antibodies may disappear after 3 to 4 months. So again, increasing the problem in this scenario. As far as the COVID-19 is concerned, it has swept the world, changing the way we view it. Almost 38 million people have been infected and viruses, and over 1 million deaths have been reported. COVID-19 is not yet fully understood, and definitive data on the post-infection immunity again is very, very important, and we are lacking on that. Amidst the uncertainty of this public health crisis, thoughtful and appropriate methods will be essential to reform the public health policy. Also, this is very, very important to understand the public health authorities to investigate the cases of recurrence and reinfection and determine, though there is a remote, the recurrence is a possibility again, because the antibodies are staying with us only for 3 to 4 months. One must also keep in mind the possibility of false positivity and the false negativity of all these laboratory tests available, which we have. Now, this phenomenon actually complicates the clinical as well as the epidemiological interpretation on the test results, especially when serology does not have very high specificity. The serological assay is rapidly increasing. Antibody testing must be available for all, including all those who are asymptomatic. Target antibodies are the excellent markers for the remote and the recent infections, and that the differential isotypes can help in distinguishing the recent and the older infections. More work is needed to be done in this area to detect the reactivation or reinfection, especially in those cases who come with same symptoms or similar symptoms, or those who are asymptomatic. So thank you very much.
Thank you, Sujata ma'am. Judges, please proceed with the questions.
Very pertinent issue you have, addressed, Dr. Sujata. What are your suggestions for this?
Since this antibody testing is not available in our setup, one of this is the requirement, and we have set the requirements through the POPA channel also in our setup, so that we can do the antibody testing and couple this with the RT-PCR for all our patients, those who are symptomatic, those who are asymptomatic, or presented with severe symptoms.
Okay.
Dr. Meenakshi, Dr. Rima, any questions for Dr. Sujata?
What is the cost factor that goes in this if we have to do it universally?
I'm not able to hear you, ma'am.
She's asking what is the cost factor?
Cost factor that goes into it if you evaluate, doing this for all our patients.
The cost of antibody detection is much lower. It is almost 30% of what is done with RT-PCR. So 1,500, 1,600 rupees, but the patients are not affording, so we are not able to ask them also from our setup. So this is very, very important if we get it through our system also, and we can couple this with the RT-PCR and the antibody detection. So we can actually find out what is the prevalence, what is the incidence, and how much is the spread of the disease.
Thank you so much, Dr. Sujata.
Thank you, Dr. Sujata.
Thank you.
Thank you. Thank you to all us wonderful people. Yeah.
Yeah, and very relevant studies. I'm so impressed by all the presenters. And we have really utilized our experience of COVID-19 during these times. And I would, encourage, I'm sure a lot of you are going to publish your work. You should publish your work on COVID-19, which you are doing. Very good work, definitely.
And everybody is doing a wonderful job, especially in these times. Commendable.
Thank you, Dr. Sujata. So with this, we conclude our session 4. Okay, and I really thank my judges, Dr. Neeti, Dr. Dr. Rima, and Dr. Meenakshi. And I request all of you to please mail your scoring sheets to aogdvirtual.com.
Thank you, Dr. Sarishta. Thank you.
Thank you, ma'am.
Thank you, Dr. Thank you.
Thank you, ma'am. So since we had a gap of half an hour, but we are already running late, so I would request my colleague, Dr. Tarun, to take over. I can see Dr. Tarun.
I can exit this meeting from here.
Yeah.
Hello. Thank you so much, Dr. Sharmishta. I am now carrying forward this meeting for another next three session. I would like to invite my judges without wasting much time. I would like to invite to chair the session Dr. Jaya Chawla. Dr. Jaya Chawla is an associate professor, Department of Obstetrics and Gynecology, Atal Bihari Vajpayee Institute of Medical Sciences and RML Hospital. Dr. Jaya.
Hi, good afternoon, everybody. It's a pleasure being here today. Thank you, Dr. Tarun, for the introduction.
Good afternoon, ma'am. I would like to invite Dr. Neha Pruthi. Ma'am is the Assistant Professor, Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences and RML Hospital.
Good afternoon, everyone.
Dr. Neha.
Good afternoon, everyone. And congratulations to AOGT team.
Thank you so much. I would like to invite Dr. Indu Khatri. Good afternoon, ma'am. Ma'am is the senior consultant and laparoscopic surgeon. Hello, ma'am. Mulchand Women's Hospital, New Delhi.
Thank you. Good afternoon,
I invite
everyone.
all of you to judge the session. Thank you. I would like to call upon the presenters. The first presenter is Janithya Pujari. Janithya Pujari, her code is HRP 0529.
Yes, sir, I am present.
Okay, you can start, Janithya. I am starting your time. Your time to start now. You can share your screen.
Okay, sir.
Start, please.
Is my screen visible, sir?
No, actually not.
Sorry.
Just share your screen.
Yeah.
There's a green button down.
Yeah, I'm sharing, sir. Sir, actually, this is not mine.
We can see. Please start.
No, this is not hers. This is somebody else's.
Someone is sharing.
Shivangi's screen.
Sir, someone is sharing her screen, so she
you can share yours.
No, sir, she should stop sharing, then only I can share my screen.
Shivangi, you will have to share it later.
Hello.
Hello.
Sir, is it visible
Janitya,
now?
you can start.
Yes.
It's
Yes,
I
it
can
is
see
visible.
your screen. Okay.
Yeah.
Yes.
Please start.
Yes, sir. Good afternoon, everyone. I'm Dr. Janitya. I'm postgraduate from Lady Hardinge Medical College. My topic is about the predictors of near miss in eclampsia. Coming to the introduction part, hypertensive disorders constitute about 10% of the pregnancies, and they constitute 10 to 15% of the deaths globally. And eclampsia is a complication of hypertensive disorders of pregnancy with severe maternal outcome. However, with appropriate management at a tertiary level, most of them recover. Eclampsia per se is not maternal near miss. According to WHO criteria, near miss is defined as a woman who nearly died but survived a complication that occurred either during pregnancy, childbirth, or within 42 days of termination of pregnancy. Appropriate prevention, prediction, and timely management of impending signs and symptoms and multidisciplinary care at a tertiary level is very, very important for this management of near miss patients. And this study is done to analyze the clinical variables in maternal near miss in eclampsia, and it is important for timely referral, intervention, termination of pregnancy to improve the feto-maternal outcome. And this was an analytical descriptive study including 26 women with eclampsia who had maternal near miss as per WHO criteria, admitted in Srimati Sucheta Kriplani Hospital maternity wards, labor room, and emergency wards. Detailed history, examination, and investigations were done. The hospital course and maternal and perinatal outcome was observed. The causes responsible for maternal near miss and evaluation of avoidable factors which led to maternal near miss were studied. In this slide, we can see the flowchart. Initially, the total cases of eclampsia in all the wards were 48. Among them, 26 cases have become near miss, which were included in the WHO near miss criteria. And these were subdivided into 4 groups. Like near miss when they are presenting with near miss at admission. That means at the first point in the entry to the hospital, they had already become maternal near miss. So the causes of this maternal near miss when the woman presented to the hospital, that is gynae casualty at admission, most of them were presented with uncontrolled seizures. 11 of them presented with uncontrolled seizure and 1 had thrombocytopenia. So a total 12 women at admission had maternal near miss. And in the hospital, in the course of the hospital stay, antenatally, 2 women became maternal near miss. The cause was uncontrolled seizures. And in the intranatal period, 1 woman became maternal near miss during labor. She had normal BP records, and later on she presented during intrapartum period, she had uncontrolled seizures. And in the postnatal period, there were 11 women presented with maternal near miss, and all these women had post anesthesia cesarean section, and they were admitted into the ICU because of the poor respiratory efforts, poor general condition of the patients, and intraoperative high BP records. So these are the subclassification of the women who had maternal near miss with eclampsia. And
slideshow mode, my dear.
Yes, ma'am.
Please carry on if that's taking time.
No, ma'am.
Please try once again.
Yes, sir. Yeah, is it visible now, ma'am?
Yes, please carry on.
Yes. This is the slide which I was talking about. The subclassification of the slides according to the cause at admission, antenatal period, intranatal and postnatal period based upon the WHO near-miss criteria. And these are the demographic and biochemical profile of the patients, of these eclampsia patients who had become maternal near-miss. When coming to the age, most of them, the mean age was 24 years. So they were mostly young females, primi-gravidas, and the level of antenatal care we observe, most of them did not have antenatal care, and even they had suboptimal antenatal care. And when coming to the mean hemoglobin, it was in slightly lower side, that is 9 gram per deciliter. And when coming to the liver function tests, the SGOT, that is transaminases, and these were elevated in most of the patients. And there was hypoproteinemia with a mean value of 5.8, and hypoalbuminemia was seen, and serum uric acid was elevated in these patients. And the mode of delivery was cesarean section in 80% of the patients. And the duration of...
You have 30 seconds only.
Okay. When coming to the discussion, the predictors of near-miss are like antenatal care is very, very important. They lacked antenatal care and they presented with signs and symptoms of impending eclampsia, and intramuscular magnesium sulfate was not given to most of the patients, and the biochemical profile was deranged. According to the study by Irfu Berhan et al., they concluded that the lack of proper antenatal care, delay in arrival to hospital, delay in appropriate treatment was the main factors for these maternal near-miss at admission. And in the hospital, we have seen these factors like BP shooting was present, which requires careful BP monitoring and timely intervention. So the study was conducted by Nakumuli et al., which also said the same. And post-delivery, intraoperative control is very important, and there should be watch for hemorrhage.
Time is up.
Most important things. And finally, I conclude. Sir, conclusion. I'll see the conclusion. So finally,
we have to stop because
the most
running
important
short of time.
factors. Sir, I'll conclude just one point. I'll tell. In the conclusion, the most important
Go ahead.
Yes, sir. Thank you. In the conclusion, the most important factors are these young primi-gravidas, poor socioeconomic status, lack of education, poor antenatal care, anemia, hypoproteinemia, and poor nutrition. So the antenatal care is very important. Antihypertensives and anticonvulsant treatment is important. In the hospital, the multidisciplinary approach is very, very important by senior obstetrician, anesthetist, and physician involved. All the biochemical profile should be managed properly, and there should be proper fluid balance, anesthesia, and management of blood loss. And immediate post-delivery and post-cesarean period is important. And this near-miss can be prevented if antenatal care, awareness, management with antihypertensives and anticonvulsants, and management in the hospital is improved. Thank you.
Thank you, Janita. We have to stop. We are moving on to the discussion part. To all the judges, please, you can start asking them questions.
Janitya, I just wanted to know that you said that there were 11 patients in the postnatal who had introp, high BP, and poor respiratory efforts.
Yes,
so
yes,
why have you categorized those in postnatal, post-delivery period? Because if the BP is rising during delivery time or during cesarean, they have to be categorized in the intranatal period.
Ma'am, actually, according to the WHO near-miss criteria, it is subdivided into clinical, laboratory, and management criteria. IBP recording per se is not included in the WHO near-miss criteria because most of the eclampsia patients already have high BP records. So it is not included in the maternal near-miss criteria. If the woman in the intraoperative period, if she is having high BP records, she can be managed, which is not in near-miss. If she becomes, even after the operation period, in the postnatal period, if she is going into the ICU and she needs intubation, mechanical intubation, and if she is going into the ICU for monitoring, then she is categorized in near-miss.
So I just wanted to know, these 11 patients were all who were operated or those who were delivered normally also?
No, ma'am, these were operated.
All LSCs?
Yes, ma'am, post-cesarean section.
Okay.
Janitya, yeah, I have two questions to ask you specifically.
Yes,
Number one, can you quote the limitations of your study?
Ma'am, the limitations of the study are like, in these studies actually, we didn't, like when the women, they present with near-miss, most of them, they don't have any proper records of their antenatal visits and all. So that was a limitation of the study. And even some women had medical disorders and all, like if she's having any abnormal medical conditions and surgical conditions, she cannot be included in the study. So these were some of the limitations.
We have to stop, ma'am, because two minutes have already done.
Okay.
We are moving on to the next presenter.
Yeah.
May I call Dr. Survi Joshi? Dr. Survi? Dr. Survi? Dr.
Yes.
Survi Joshi?
Yes, sir.
Our
Hello.
code is HRP 05. You can start sharing your screen.
Okay, sir.
Your time starts now.
Is my screen visible?
Yeah, it's visible. You can start.
Good afternoon, everyone. Today I am presenting on challenges and outcomes during cesarean section in COVID patients. As we all know, performing surgeries in COVID patient is a challenge, and cesarean sections are unavoidable surgeries during corona pandemic, which is caused by SARS coronavirus 2019. So here we are sharing our experience of managing these patients along with maintaining the safety of healthcare workers. The study was conducted in Department of Obstetrics and Gynecology, Maulana Azad Medical College. It's a prospective and retrospective observational study conducted over a period of 6 months in COVID-19 positive pregnant women admitted to gyne-COVID block who underwent cesarean section till the time of study, which is 6 months. So COVID positive pregnant women were recruited after taking a written informed consent. Obstetric management was done as per the hospital protocol. Pre-operative, intraoperative, and post-operative findings were recorded. Outcomes were recorded, and statistical analysis was performed. Moving on to demographic profile, most of the patients which were admitted to us were between the age of 19 to 47 years of age, who presented to us at 33 to 41 weeks of gestation, and 38% of them were primigravida, and the multiple pregnancy rate was 3.6%. Categorizing them into the COVID category as per their symptoms, majority of them were mild category 75%, and asymptomatic were 15%, while moderate was 7.5% and severe was 2.5%. In 6 months period, we had 310 deliveries, out of which 141 were cesarean section, which makes it the cesarean rate as 41%. 23 were elective sections and 118 were emergency sections. The most common indications were previous cesarean with scar tenderness followed by fetal distress. Cesarean section were also done for maternal indication in case of severe category of COVID infection. Moving on to preoperative difficulties which were faced, the most common was difficulty in minimizing exposure while the patient was shifted to OT, which was in 32%. Technical problems in shifting patient like non-availability of ambulance, workers, or trolley, difficulty in donning and doffing, difficulty in OT preparation like maintaining the negative pressure ventilation before shifting the patient there, difficulty in arranging blood and blood products as we are short of donors in almost all hospitals because of COVID. The average time for shifting patient to OT was 1.25 hours, and the minimum number of PP used was 6 per section and maximum was 11 per section. And decision to incision interval was 2 hours in emergency LSCS, while it was 45 minutes to 1 hour in elective LSCS. Intraoperatively, we found that there was prolonged duration of anesthesia, average duration being 45 minutes because of difficulty in visibility in PP kit. The most commonly, spinal was used, followed by combined spinal epidural, and GA was required only in 1% patients. The problems faced were decreased visibility due to fogging of goggles, face shield, and oxygen was required intraoperatively with face mask in 86% of the patients. Early cord clamping was done in 42% in order to reduce infection to the neonate. Exhaustion and dehydration was there, especially in the hot weather. Surgical complication and the post-spinal hypertension was seen in 2% of the cases. Post-operatively, the most important was the post-operative desaturation and ICU admission, which was seen in 4% of the patients. Worsening of the Q-SOFA score, which was in 1.5%, followed by paralytic ileus, wound site infection, secondary PPH, prolonged catheterization, breast engorgement, These are same as non-COVID complication, which we see in post-operative patients. And also there was a lot of agitation and restlessness in the relatives and patients because of prolonged hospital stay, as they were not able to contact to the patient and also to the doctor. Moving on to the outcomes in neonatal outcome, if we talk about the COVID positive post cesarean section neonatal infection rate was 4.2%, and they were kept in, they were observed in nursery and they had no other complications. Neonatal resuscitation was done in 4% cases, and 82% of the mother were discharged COVID negative after day 14. And if we talk about the infection in healthcare workers, none of the doctors, surgeon, and anesthetist were infected post-cesarean with the use of level 3 PPE, while it was 0.5% in nursing staff and orderly working in the operation theater. The study was conducted by Balakrishnan et al., in which the decision to incision time was 30 minutes, and most commonly used anesthesia was spinal, but they found the increased rate of post-spinal hypertension compared to the non-COVID patients. They also concluded that there was no vertical transmission, and in order to prevent the neonatal infection, they recommended early cord clamping and reduce mother to...
You have 30 seconds to continue.
Okay, mother to neonatal contact. The study conducted by Haifaz et al., they concluded that spinal anesthesia was safe to use in COVID patients with no increased complications. And the study conducted by Yogina Malhotra et al., they found that there was no increase in cesarean section rate in COVID patients, but we don't have sufficient data of non-COVID time in order to support this study. So we recommend that the planning and set. So
your time, sir. Shall we move to the judges for the question session?
Hello. Yeah. Nicely presented, Surbhi. I just wanted to know that you said there is 32% difficulty in minimizing exposure. So how did you calculate that?
Actually, ma'am, we have the written, we have the printouts of the performer. We were taking the questionnaire, which were given to the SRs who were involved in the sections, and they used.
What was basically the difficulty? I mean, to minimize the exposure. I mean, you were not getting PPEs, or what was the problem basically?
Ma'am, there is red and green area which through which we take the patient to the emergency operation theater, which is separate from the gynae COVID block. So during that course, we need to minimize the exposure while shifting the patient. So in that, we take the patient to the red zone and we go through the green zone. And during that time, like there is non-availability of PP kit also, and the workers who are involved in shifting the patients, they're not following the precautionary measures which are told to them, and sometimes the lift is not operating, so they take another.
So the baby post-delivery was kept with the mother, or it was in the nursery for all the cesareans and deliveries?
Ma'am, for 1 or 2 days, they're observed in the nursery, but after that, the baby is shifted to the mother's side.
Okay, and the sample of the baby is collected when the baby is in the nursery or with the mother?
Ma'am, in the nursery.
Okay.
Thank you, ma'am.
Thank you.
And the relatives, you all were conversing through video calls. How were the relatives being informed?
Ma'am, relatives were being informed through phone calls. We were calling the patients through patient's phone as well, and through our phones, we are contacting the relatives. And also we have the our hospital feedback WhatsApp group, in which all patient relatives are added. So whatever queries they have, all our consultants and SRs are added in that group. So they put their queries there and we solve those queries.
We're done with the time. Sorry to we are extremely sorry. We are moving to the next presenter, Dr. Juhi Mishra.
Yes, sir.
Dr. Juhi, you can share your screen and you can start.
Yes, sir.
Your time starts now. You have 6 minutes to present and 2 minutes of the question and answer session.
So is my screen visible?
It's not visible. Backend team, kindly support her.
Hello.
Yeah, actually, this is a MacBook I'm doing.
Yeah,
They're asking whether it is recording or something. They're asking.
There is an option of share screen. Please click on that.
Okay. Ma'am, ये present में share screen.
Could we go to the next speaker, Tarun, till she gets it ready?
Yeah, we can.
Yeah.
Is it visible now?
Yeah, it's visible.
Yeah.
You can start.
Please open the PPT.
You can start your presentation. Yeah.
Play. Yeah.
So thank you for giving this opportunity at this stage. I'm Dr. Juhi from AIIMS Rishikesh. I am a junior resident from the Department of Obstetrics and Gynecology. My topic is posterior reversible encephalopathy syndrome, which is also called as PRES, and I'll be showing the demographic, clinical, and radiological manifestations and fetal-maternal outcome in these patients. PRES is a misnomer. It is a posterior reversible encephalopathy syndrome, but it is not always posterior and not always reversible. The synonyms of PRES are reversible posterior leukoencephalopathy syndrome, hyperperfusion encephalopathy, brain capillary leak syndrome, and hypertensive encephalopathy. It is a reversible clinico-radiological syndrome characterized by headache, seizures, altered mental status, and visual loss, along with white matter vasogenic edema, which is affecting the posterior occipital and parietal lobes of the brain predominantly. Association has been found with preeclampsia, eclampsia, hypertension, renal failure, infection, sepsis, shock, autoimmune diseases, and certain cytotoxic drugs like cancer chemotherapy drugs and transplantation like bone marrow or stem cell. The first case was presented as a case series by Judy Hinche et al. In 1996 in the New England Journal of Medicine, and it was described as a reversible posterior encephalopathy syndrome. Since then, a lot of case series and studies have been presented, but still the exact pathophysiology and diagnosis of the cases is still under study. The pathophysiology has been explained by cerebral hyperperfusion and hypoperfusion both. In cases of hypertension, there is a breach of the blood-brain barrier because of increased brain blood flow. And in autoimmune diseases, steroids and cytotoxic drugs, there is release of inflammatory mediators, which again leads to endothelial activation, disrupting the blood-brain barrier. So there is an acute rise in blood pressure over a short period of time, which causes a failure of normal autoregulatory mechanisms. There is an endothelial damage due to hypoxia and subsequent cytotoxic edema. There is diminished autoregulatory capacity or enhanced blood-brain barrier permeability. In pregnancy, there is an increased level of vasoangiogenic growth factors and cytokines in maternal circulation. Additionally, in preeclampsia, there is increased blood-brain barrier permeability. All these conditions make the pregnant preeclamptic patients more susceptible to PRES. Posterior brain areas are more frequently affected as the posterior has a minor sympathetic circular vessel innervation, and hence it is primarily involved in the posterior brain areas. The diagnosis can be made on the basis of the history, which is a hypertension, which is present in 20 to up to 65% of the patients, immunosuppressive or chemotherapy history, eclampsia, sepsis, and autoimmune cases. The symptoms which are most commonly affected are seizures and headache, and other conditions are altered sensorium. MRI findings, it is usually a diagnosis of exclusion. If there is a parieto-occipital or posterior frontal cortical involvement in more than 90% of the cases, if other causes have been ruled out, it is PRES. The conditions which we have to rule is that if there is a central edema in the basal ganglia or a diffusion weight MRI shows cortical or subcortical involvement, that can be central PRES, which is atypical, or it can be hypoxic encephalopathy or acute hepatic encephalopathy or pontine myelitis. If there is a DWI SORA negative or ADC dark foci, then it can be, we have to rule out HIE and infarcts or other causes of the seizures. Similarly, there is SWI, which includes hemorrhagic PRES or other cases of brain bleeds. Imaging patterns in MRI of a PRES patient is a homospheric watershed, which is because of the areas which are not covered by the central anterior and posterior cerebral arteries, the superior frontal sulcus in the frontal sulcus involvement, dominant parietal and occipital regions, and partial or asymmetric present found in some conditions. The problem statement can be clearly stated in one line that eclampsia accounts for 50,000 maternal deaths in a year worldwide. So why a further research is needed? First, this is a reversible condition. Second, early diagnosis and control of blood pressure and seizures are the key to recovery. A natural history of PRES is not established in detail, and there is a lack of awareness among many obstetricians. So the objective of my study was to study the demographic, clinical, and radiological profile along with the fetal-maternal outcome eclampsia patients with PRES. The study design was a retrospective observational study in the Department of Obstetrics of Gynecology of All India Institute of Medical Sciences, Rishikesh. Our study duration was January 2019 to February 2020, and the case selection criteria was the diagnosis of eclampsia at discharge. Patients who had eclampsia and had a confirmed PRES diagnosis on neuroimaging were included in my study. There were 34 patients of eclampsia, out of which 6 had a radiologically diagnosed PRES. The patients with eclampsia underwent neuroimaging were identified, evaluated, and the relevant data was extracted from those patients. The modified ranking scale scoring was used to measure the degree of disability at presentation and at the time of discharge. The demographic, clinical, neuroimaging, and fetal-maternal outcomes were analyzed. Coming to the results, this is a demographic clinical profile which we concluded that all the patients were of age less than 30 years with a mean age of 23 years. All were singleton gestations with the primary gravida patient. Yes, sir?
You have 30 seconds left.
Okay, sir. The clinical findings, headache was the most common in all of the patients. Imaging analysis was done. This is a MRI of a patient in which A and B shows the brain MRI and C and D shows the substantial weighted where microhemorrhages were seen in the C. MRI was the most common modality involved, and the parietal lobe was the most commonly involved lobe. Outcome analysis was done. Fetal outcome, intrauterine demise was seen in 2 patients, and the baby was healthy in 1. Maternal outcomes, 2 of the patients had a residual score more than 2, and 66% were treated in ICU setup. So this is a discussion which I've already included that acute rise in BP is important in endothelial damage seen in sepsis, autoimmune, and other cases. In all these literature reviews, different things have been concluded, and we found that
we have to stop. We are moving to the judges for the question and answer session because we are running short of time.
Okay, sir. The strength and limitation are on the screens.
We have to move to the judges. Ma'am, Indu ma'am, you can start.
Yeah. MRI was done for all the patients in this case study?
No, ma'am, that is included in my limitation only because there was no standard diagnostic workup that whether we should whether MRI is to be done or not. It was based on the physician's consultation that MRI was done. Usually, the patients who did not recover in the post-eclampsia phase underwent MRI.
Because MRI would be the diagnostic which can be used in these patients. No?
Yes, ma'am.
Next.
Sorry. Also, did you perform an MR, venogram, etc., or an angiogram in all patients to rule out other possibilities? Because PRES is a diagnosis of exclusion. So you have to about other factors using various modalities.
Yes, ma'am. We have done it in 5 of the patients. Actually, I was running short of time, so I couldn't show it. We have done in 5 of the patients. And in 1 patient, it was not required because the dye could not be injected because of some KFTs were rearranged.
How did you correlate with the fetal-maternal outcome? Like, did you have a logistic regression analysis to say that the outcomes were clinically significant or statistically significant?
No, ma'am. Our sample size was very small, so we could not do an analysis on the basis of that. And we did not have a control group against which we could do a regression analysis.
Precisely, my dear. All the outcomes that we have suggested could be attributable to the disease process per se, whether hypertensive disorder or the fits that the patient was throwing. So correlation with PRES per se with a small sample size may not be possible or feasible.
Yes.
And a very, very well conducted study. Congratulations.
Thank you, ma'am.
Thank you. We are moving to the next session. Next presenter, I would like to call Dr. Supriya Kumari. Her code is HRP 0532. Dr. Supriya, are you there?
Yes, sir.
You can share your screen.
Hello, sir. Hello, ma'am. How exactly to share the...
There is a green button down the screen. There's a share screen.
Yes, sir. Yes, sir. Yes, I found it, sir.
And start your PPT. Your time starts now.
Is the screen shared, sir?
No, not yet. Backend team, please help her.
It's not shared?
First open your PPT, then you share it.
Hello?
Yes, sir.
Yes. You have an option of share screen.
Yes, sir.
So please click on that.
Yes, sir. Clicked, sir.
You have an option of PPT, desktop.
Yes, sir. Yes,
Yeah.
sir. Shared, sir?
Yeah, you have 6 minutes
click on
time
the
to
slideshow.
present and 2 minutes for the cross.
Yeah, please click on the
Yes, sir.
slideshow.
Starting, sir.
Yeah.
So, very good afternoon, everyone. Myself, Dr. Supriya Kumari from AIIMS Delhi, SR, will be presenting my study on a spectrum of liver diseases in pregnancy and their management, a retrospective study in a tertiary care center in northern India. So, liver disorders comprise up to 3% of all the pregnancy complications. The key to the maternal and fetal well-being is an early diagnosis and appropriate management. Therefore, the present study was designed to see the incidence, spectrum, and outcomes of the various liver diseases in pregnancy. So this study was taken up with the objective to study the incidence, spectrum, and the perinatal outcomes of the various liver diseases in pregnancy. The methodology we used was that all antenatal women with the liver disorders attending the antenatal clinic and labor room in the Department of Obstetrics and Gynecology at AIIMS Delhi in the last 9 months. The enrolled cases were studied in respect to the maternal and fetal outcomes. So the results for which we studied was the different diseases showing variable changes in the clinical and the lab parameters were studied. The spectrum of diseases which we studied included intrahepatic cholestasis of pregnancy, hepatitis B, hepatic vein outflow tract obstruction, extrahepatic portal vein obstruction, non-cirrhotic portal fibrosis, carcinoma gallbladder, and gallbladder polyp. The most common variant found in this our study was intrahepatic cholestasis, found to be in 75% cases of liver diseases in pregnancy, which was immediately followed by hepatitis B at our center, which accounted for 13%. The maternal morbidity outcomes were comparable in the various diseases in our study. The different perinatal outcomes in the study showed around 3.5% cases with meconium stained liquor in the IHCP group, and the rates of an ICU admission and respiratory distress was more in them. So this chart shows the baseline characteristics of the different study populations who were included in a study, wherein the age less than 20, there were 2 patients, 20 to 29, there were 50, and 30 to 39 were 13 cases, included this many percentage. And the primary 18 cases were primary gravida and 47 cases were multigravida in our study. So the various among the spectrum of the various liver diseases studied, 50 cases accounting for 76.9% included intrahepatic cholestasis of pregnancy. HbA1c positive hepatitis B was seen in 9 cases, which accounted for 13.8%, of which HbA1c positive was 3, which was infective was 4.6%, and HbA1c negative was 6, accounting for 9.2%. Hepatic vein outflow tract obstruction, we had got only 2 cases in the past 9 months, and NCPF, non-cirrhotic portal fibrosis, extrahepatic portal vein obstruction, carcinoma gallbladder, and gallbladder polyp, each 1 case we had got. So the mode of delivery, it was elective cesarean section in 14 cases, accounting for 21.5%, and emergency in 90. Cesarean section in our cases was non-reassuring fetal status. Vaginal delivery was in 29 cases, and instrumental vacuum assisted delivery was there in 3 of the cases. So this is the classification as per the gestational age at the time of termination. So one of the babies was around 26 weeks of IHCP, which was terminated, and one was between, it was around 31 plus 2 weeks, and the rest 9 cases were between 32, 36 weeks, and 40 cases were more than 37 weeks. Similarly, HbA1c case, only one we had between 32 to 36 weeks, which was around 34 plus 2 weeks, and accordingly for each case. Coming to the LICA status, which is one important finding, that out of the 65 cases, 59 of the cases had clear LICA and only 6 cases had meconium stained LICA. The important fact being, all these 6 cases had intrahepatic cholestasis of pregnancy, which is a known finding. However, all of our cases had meconium. So coming to a few of the lab parameters studied in these cases, the mean of the hemoglobin, leukocyte count, and the platelet count have been shown. So we can see the TLC was raised to 21,000 in the case of carcinoma gallbladder, and the platelet was only 54,000, a known finding in case of non-cirrhotic portal fibrosis. The ALP was 2,085 in the gallbladder polyp case, and the INR was raised in CAGB. So coming to the neonatal outcomes, this is the mean of the birth weight, which was found in these ranges in the different diseases. Among our study, there was 10 cases were premature, less than 37 weeks in case of intrahepatic cholestasis of pregnancy, whereas there was only 1 case of hepatitis B and 2 cases of hepatic vein outflow tract obstruction, which were premature, and 1 case of non-cirrhotic portal fibrosis, and only 1 case of CA gallbladder. Coming to the ICU admission, there were 6 cases in the IHCP group, of which the 5 of them had meconium stained lichens. This is the mean of the APCAs, which did not have any statistically significant difference in the different diseases. So the different treatments which we gave in IHCP, usually we had given symptomatic treatment with Udilim, and the newer drug rifampicin was added in 2 of the cases. HBsAg case we had added tenofovir, EHPVO had undergone the shunt surgery, HVOTO had post-inferior vena cava and right hepatic vein angioplasty, and NCPF with splenic artery aneurysm she had undergone splenectomy post-surgery. The CA gallbladder had undergone post-cholecystectomy with percutaneous biliary drain, and GV polyp was followed up in gastrology. So the strength of our study was a various spectrum of disease studied, and the limitation was the small population we had. So coming to the conclusion, we at AIIMS Delhi Tertiary Care Center, our most common disease was IHCP, and which was immediately followed by hepatitis B. So early diagnosis and proper care can go a long way in saving maternal and neonatal lives. So this is our take-home message, that a multidisciplinary team should be taken into consideration, and appropriate diagnosis and proper management goes a long way. Thank you.
Thank you so much. We are moving to the question answer session. Ma'am,
what age did you keep for IHCP patients, the fetal age for induction? What was the gestational age?
IHCP, ma'am, we are usually yes, ma'am. So, ma'am, until there is any other indication, usually all the IHCP cases we are inducing between 37 to 38 weeks. Usually, when there are some 37 plus 2, usually at that time we are inducing unless there's any other ops indication of pregnancy.
In your study, there was no stillbirth, no IUD, nothing. You're not audible.
Ma'am, no, ma'am. Among the study population, which is, ma'am, I have recruited in the study in the past 9 months. Among them, there were no stillbirth, ma'am.
Maybe because the induction was early, because 37, 38 weeks you have kept as the inducing.
Yes, ma'am. Because further delay will lead to stillbirths. So, as per the recent guidance, we are inducing, ma'am, at 37.
So what was the reason for premature induction in the IHCP group? At 33 also?
Yes, ma'am. Ma'am, one of the cases was REDF, reversed of end diastolic flow. So in that we had to terminate. Actually, it was not induction. We had taken up a cesarean section, ma'am. It was around 29 weeks. No, that termination was not for IHCP, ma'am. No, ma'am.
What was
Were there any patients having hypertension changes also, preeclampsia, eclampsia associated?
No, ma'am.
Not audible.
Among the hello, ma'am. No, ma'am. Among the cases recruited in this study, ma'am, the IHCP cases who were on Udilip, none of them had raised BP records. However, some cases of raised BP records which I have not included in as part of this study.
Okay.
Thank you so much. We have to move on to the next presenter.
Thank you,
Dr. Supriya. Thank you, Dr. Supriya. We have to switch to the next presenter.
Those I have not recruited. However, any of the liver disease patients.
I have to stop,
yes,
Dr. Supriya.
Thank you, sir. Thank you. Thank you.
We are moving to the next presenter, Dr. Shivangi Mangal. Her code is HRP 0534. Dr. Shivangi. Are you there? Dr. Shivangi, good afternoon. Dr. Shivangi, can you hear us?
Hello.
Dr. Shivangi?
Sir. Sir, am I audible?
Yeah, you are audible.
Sir, is my screen visible?
Yeah. You can start. Ma'am, you can start.
Good afternoon, sir. I'm Dr. Shivangi Mangal from All India Institute of Medical Sciences, and I will be presenting case on the multidisciplinary team management in a pregnancy infected with COVID-19 infection with Takayasu arthritis. A lady 20-year-old with gravida 3 previous to abortion presented to us in a labor ward triage area at 33 weeks and 2 days of period of gestation, known case of Takayasu arthritis and chronic hypertension on oral labetalol 300 mg TDS with complaint of pain abdomen. She was triaged in a labor room ward, given a mask to the mother, and was screened on history basis for COVID symptoms. Following which, if the patient was screened negative and the patient is required admission, the patient is kept in the holding area of our labor room ward triage area. And if the patient is screened positive, then the patient is sent to the suspect area. In both cases, the COVID test is done, following which, if the patient is COVID negative, the patient is shifted to the clean labor room ward area. And if the patient is positive, then the patient is shifted to designated COVID facility. The lady was booked at AIIMS at 9 weeks period of gestation and was diagnosed with Takayasu arthritis during the workup of chronic hypertension. On cardiology and rheumatology consultation, she was started on tab ecosprin 150 mg OD, prednisolone, and labetalol was titrated according to the blood pressures, but she had stopped taking prednisolone 3 months before admission due to lockdown. She had previous 2 spontaneous abortions and was diagnosed with chronic hypertension 2 months prior to conception and was started with methyl-dopa 500 mg TDS in a private setup. On examination, her gender condition was fair, but the blood pressures in the right upper limb and the left upper limb were 160 by 110 and 160 by 100 respectively. And a repeat PP was taken after 15 minutes, which remained the same, and a diagnosis of superimposed preeclampsia was made. On per abdominal examination, she was getting mild contraction. On per speculum, the os was closed and a threatened preterm labor was diagnosed. Her investigations were reviewed. MRI showed right common carotid and the right renal arterial stenosis. Echo showed ejection fraction of 50% with mild MR, and KUB ultrasound was normal. Her urine albumin distillate was 1+, and rest all preeclampsia workup was normal. On fetal surveillance, the biophysical profile was 8 by 8 and fetal growth scan showed 1755 grams of estimated fetal weight. But on Doppler, baby had AEDF and impression was made that the baby was diagnosed with absent end diastolic flow. For management, for controlling her blood pressures, injection labetalol 20 mg IV were given and the BP monitoring continued and the BP was controlled after 1 hour. Continuous CTG and Manning score was done for fetal surveillance. And for threatened preterm labor, the NICU team was informed, steroids were started, and Depin tocolysis was initiated, after which the contraction ceased after 1 hour, and the decision to continue the pregnancy to allow the steroid cover was made, and the monitoring continued. While we were managing, the CBNAT report came out to be positive, and the patient needed to be shifted to a designated COVID facility. From the holding area, patient was shifted from the COVID corridor and lift via the COVID ambulance to the trauma center, which is the designated COVID facility in AIIMS. So the story so far was the patient received in the labor room triage area at 5 p.m. At 5:15 p.m., she was kept in the holding area where the management for preeclampsia and threatened preterm labor was started, and the baby was diagnosed with AEDF. And by 7:30 p.m., we received a COVID positive report, after which the patient was shifted to the designated COVID facility. In the COVID facility, infectious disease specialists and NICU team were consulted, and the decision to continue the steroid cover was taken as the patient was asymptomatic for COVID infection, and the maternal fetal monitoring was continued. For fetus, we did a daily non-stress test, Manning score, and fetal umbilical artery Doppler and Likers, and the tocolysis was tapered, and the uterus was relaxed, and labetalol was continued. Till the steroid cover could complete, the repeat Manning score was done at 33 plus 3 weeks period of gestation, which turned out to be 4 by 8, and the decision to do an emergency cesarean was taken place in view of AEDF with poor Manning. She had history of prednisolone intake and abrupt stoppage. So on endocrinology review, she had to be started the hydrocortisone injection, 100 mg at the time of anesthesia, followed by 10 mg per hour for 6 hours postpartum. During cesarean section, minimum number of persons were ensured in the OT, minimum in and out of the healthcare personnel from the OT, regional anesthesia were given, all the healthcare team were in level 3 PPE, NICU team was present, and a female baby of 1640 grams of APGAR score of 7/9 were born. In the post-operative period, the blood pressure was uncontrolled, even on labetalol. So on cardiology review, amlodipine and enalapril were initiated. On rheumatology review, since her Takayasu arthritis disease was not in active stage, prednisolone was not anymore required. After 14 days of stay, her repeat test was negative and she was shifted to a non-COVID facility. Her baby initially developed sepsis, but the baby recovered, and the baby was tested twice on day 5 and day 14 before shifting to the non-COVID facility. And the baby was discharged with the mother in a healthy condition after nearly 1 month of NICU stay. So a 20-year-old gravida 3 previous to abortion came with complaint of came in threatened preterm labor with superimposed preeclampsia and was diagnosed to have a fetus with AEDF and was managed in the COVID facility. And post-operatively, she recovered and the blood pressure was controlled on triple antihypertensives, while the mother and the baby were shifted to COVID ward, non-COVID ward after 14 days. Hereby reviewing the literature, is pregnancy a risk factor for severe COVID? Yes. And also there are increased risk for ICU admissions, mechanical ventilations, anxiety and depression. However, there is no increased risk of mortality. And
you have 30 seconds to continue.
Yes, sir.
You have 30 seconds to complete.
Okay, sir. There is increased risk of hospitalization and ICU admissions in pregnant ladies infected with COVID as compared to non-pregnant, but the mortality rates has been similar in the non-pregnant state as well. So what could be the risk factors? Because of the gestational rhinitis and physiological dyspnea which masks the symptoms of COVID-19, there's already reduced total lung capacity and there's attenuation in the cell-mediated immunity, and there is expression of ACE enzyme, which is the receptor for the SARS-CoV-2 infection. There is increased risk of preterm birth, which is the most common adverse pregnancy outcome infected with COVID-19. And there is a higher rate of cesarean rates, perinatal deaths, and preeclampsia. But yet there has been no evidence of a vertical transmission. There have been various studies.
Dr. Shivangi, we have to stop. We are moving to the question and answer session. Okay. Ma'am, the topic is open for discussion.
My dear, the first question is, would you like to evaluate and discuss your case in the backdrop of the COVID infection that she had, or more prospectively in the backdrop of the Takayasu's arteritis that she was suffering from?
Ma'am, I wanted to present the case of a high-risk pregnancy who again got infected with COVID-19 infection, and how we managed that high-risk pregnancy who was infected with COVID-19 infection. With having so many comorbidities, does COVID-19 infection also increases the risk of management in that pregnancy?
What I'm trying to understand is the clarity on whether her absent end diastolic flow, a reflection of fetal growth restriction, could be attributable to COVID or Takayasu's arteritis. Her preterm labor could be attributed to one of the two. See, the disease has to be seen in perspective.
Okay.
So, perspective, a lady who was asymptomatic for COVID found incidental because of hospitalization to a center. See, that is the perspective that I'm trying to put you on.
Okay, ma'am. Ma'am, her AEDF was because of the chronic hypertension and superimposed preeclampsia, that the blood supply was less because of the underlying chronic hypertension. But yes, because of the studies that have been conducted for COVID-19 infected pregnancies, her preterm labor could be because of the COVID-19 infection, which was not proven in our case.
Okay.
Thank you. We are moving to we are done, ma'am?
Yeah, please carry on.
All the judges, we move to the next presenter. I would like to invite Dr. Vandana N.A. Dr. Vandana N.A., her code is HRP 0535. Vandana, Dr. Vandana, are you there? Dr. Vandana? Dr. Vandana, are you there? Dr. Vandana NA, her code is HR 0535.
It seems the person has logged in, but now not audible.
Okay.
Hello.
Can you backup team? Can you please help us?
Hello.
Maybe
Backup
there is
team?
some problem with her mic. Can you call next presenter?
Okay. She's the last presenter of this session, so we would like to wait for 2 minutes.
Can you hear me? Hello?
Yeah, ma'am.
Yeah, we
Yes,
can hear
yes.
you. We can hear you, Vandana. Share your screen. Since we are very jam-packed with all presenters and everything, so we are running very short of time, and I'm being very rude to the contestant. We are just stopping them in between. But
you're doing perfect time management, I guess.
Yeah, we could go a little more liberal because we have one contestant less in this category. So yeah, we can chill a bit.
I'm present now.
yeah, you can start, Vandana. Dr. Vandana, you can start. Your time starts now.
Yes, sir. Good afternoon to all the dignitaries. I'm Dr. Vandana, first year resident from Maulana Azad Medical College, and my topic is non-stress test changes in the COVID-19 pregnant patients. So coming to introduction, COVID-19 is an ongoing pandemic and it's a viral pneumonia caused by severe acute respiratory distress syndrome, coronavirus, SARS-CoV-2. Its infection is usually associated with the maternal pyrexia, cytokine storm, and the hypercoagulability, which will increase the risk of placental intervillous thrombosis and infarction, in turn affecting the fetal heart rate, leading to NST changes. The NST is a non-invasive screening test which is used in pregnancy to assess the fetal status by means of fetal heart rate and its responsiveness. Parameters recorded on the NST, they basically reflect the fetal autonomic nervous system, somatic nervous system, as well as the oxygenation to the myocardium. Fetus responds to hypoxia by reducing the myocardial workload to maintain the positive aerobic metabolism in the heart. NST is also influenced by the maternal status such as hypoxia, inflammatory conditions, and the maternal pyrexia.
Hello?
Hello, ma'am.
Sound is very less.
You can speak a bit louder.
Not able to change it here.
Okay, just continue.
Yes, sir. Coming to the pathogenesis, the coronavirus are enveloped viruses with a positive sense single-stranded RNA genome. 4 coronavirus genera, that is alpha, beta, gamma, delta, have been identified, with the human strains being alpha and beta. ACE2 is a main receptor for the SARS-CoV-2. Coming to stages of COVID-19, we have basically 3 stages. In stage 1, it is asymptomatic, initial 1 to 2 days of infection, with the virus basically replicates in the nasal cavity. In the stage 2, it mainly involves the upper airway and the conducting airway response. The virus propagates and migrates down the respiratory tract along the conducting pathway. In this stage, the clinical manifestations are present, out of which 80% are milder. The disease will be restricted to the upper and the conducting airway. In stage 3, we have the hypoxia, the ground glass infiltrates and progression to acute respiratory distress syndrome, which is ARDS. Only 20% of the patient progress to this stage and they develop the pulmonary infiltrates, and few of them develops the severe disease. The virus basically infects the type 2 alveolar cells and reaches the alveoli. So it's a broad diagram which shows the entry of the pathogen into the respiratory system, where it keeps multiplying, and later antigen presenting cells will take up to that, to leading to the cellular immunity and the humoral response, and this leads to cytokine storm. So in SARS-CoV-2, there will be dissociation of oxyhemoglobin, carboxyhemoglobin, and the glycosylated HP, resulting in prolonged and progressive hypoxia, causing desaturation and respiratory distress. In order to compensate this with the hypoxia, there is excessive secretion of erythropoietin, which will stimulate the bone marrow, leading to thrombocytosis and hypercoagulability. There's evidence of DIC also. Pregnancy with the COVID-19 infection, leads to reactive response of the fetus secondary to the maternal inflammatory states. In the severity of the COVID-19, we have like asymptomatic stage, and next is mild, where the symptoms of URTI like sore throat, rhinitis, and diarrhea, loss of taste and smell are present. In the moderate, the symptoms of low respiratory tract infections like cough, and the saturation usually will be more than 94% on the room air. And in severe disease, the saturation usually falls to less than 94%, and the respiratory rate usually will be about 30 breaths per minute. In critical, the patient might go into respiratory failure, septic shock, and the multiple organ dysfunction. In my study, I did observational study of 20 NST traces of pregnant women in the COVID-19 infection, which was done during my 15 days of COVID duty in the departments of Obs-Gynae, Lok Naik Hospital. And the NST traces were basically analyzed, and it was correlated with the perinatal outcome, that is mainly Apgar at the 1st and the 5th minute. Poor neonatal outcome was defined by 5th minute Apgar less than 7. So this is a slide which encompasses all the pregnant ladies with gestational age. All were term pregnancies, and all the babies usually had the basal heart rate and the variability, accelerations, mode of delivery, and the Apgar. Out of the 20 patients, only 3 patients showed reduced baseline variability with the absence of accelerations. In those 3 patients, the mode of delivery was LSAS. One of the patients, the indication was previous LSAS and she was in labor, and the second one was grade 3 MSL, and the third one was mainly because of failed induction. These are the pictures showing the normal reactive NST, and the other one usually showed the reduced baseline variability. Coming to results, all the fetuses showed the normal baseline heart rate in the normal range, which is 110 to 160 beats per minute. 3 out of 20, that is around 15%, they basically showed reduced baseline variability, that is less than 5 beats. Accelerations were present in apart from these 3, and Apgar score at 5th minute were normal, that is more than 7. In the discussion, the baseline variability which was reduced is mainly because of fetal CNS depression secondary to the maternal hypoxia and the inflammatory cytokines. The cytokines basically cross the placenta and they reach the fetal blood-brain barrier, causing depression of fetal CNS. Despite the reduced baseline variability, the perinatal outcome was favorable. So it indicates that immediate measures to improve the maternal environment, to correct the maternal hypoxia, pyrexia, and the inflammatory responses has to be undertaken to rectify the abnormal NST prior to considering any intervention. This is because the primary cause of abnormal NST changes is in the maternal compartment, and the COVID-19 infection is currently of immense clinical significance, and therefore we hope that the findings in our study will help to avoid the unnecessary operative intervention, which adds on to the additional metabolic maternal stress. In the conclusion, there is no previous studies which mentions the use of NST in COVID-19. This is the first study which has analyzed the NST changes in maternal COVID-19. However, there was a study on CTG changes.
30 seconds more.
However, there's a study on CTG changes in COVID-19 pregnant women, which showed that fetal tachycardia, absence of accelerations and death decelerations. Maternal COVID-19 infection appears to cause NST changes because of combined effects. NST is a good method to monitor the fetus and predict the perinatal outcome. It's highly likely that by correcting the adverse maternal environment, NST changes secondary to COVID-19 could be reversed. However, no studies could be found in English literature regarding the COVID-19, and more research is required in this field. Thank you.
Thank you so much for the nice presentation. We are now moving to the question and answer session.
So my dear, this was a nice topic for study. My question would be, was there an association between a pathological state of the fetus and the NST changes, or was there a specific correlation with mothers having a more severe degree of COVID infection and NST changes in the fetus?
Ma'am, basically the patients which I took were all around asymptomatic, and few were only with mild. So severe COVID positive pregnant woman was not included in my study. That's a main limitation, because during my study I couldn't find any severe patient, like during my course.
And the fetal conditions?
Ma'am, fetal, all the fetus, like Apgar outcome was well, ma'am. Like all fetuses had Apgar 8 and 9, and the fetuses were a good outcome were present in the fetuses.
No, what I mean to say is, did you have any fetal growth restricted cases in your study?
No, ma'am. I couldn't find any FGR cases at that time. I mean, when my study was taken.
Okay, so what conclusion do you draw from this spectrum of cases?
Ma'am, my main conclusion is that even though there were reduced variabilities and absence of accelerations, so many would take up for immediate interventions like LSCS and all that, like section. So basically, I recommend that first we have to treat the maternal COVID-19 infection prior to treating the, taking the patient to the section.
But there's no treatment per se available. So we still have to
management, ma'am, like according, since my limitation mainly is that the patients which I included were usually come under asymptomatic to mild category.
Yeah.
So there was a study which was conducted which included moderate and the severe cases also. Due to limitations in my study, if they were to be present, the outcome of fetus was good when I read through that journal.
But Vandana, we can't wait for a patient who is having grade 3 MSL to deliver. We cannot wait for a patient who is having grade 3 MSL. You have to deliver that patient. So you can't wait treating that patient for COVID and then deliver her.
Not all the cases in that aspect, ma'am. Like just like based on NST changes per se, we just can't take her. Like if she has meconium, if the induction is usually failed. In my study, only 3 patients were taken for section because of like through 3 indications. The rest all usually progress normally.
Yes,
and
we need more larger studies.
Ma'am?
Yes, it's a good topic, but we need larger studies to be
Yes,
very
ma'am,
sure about.
That was
Yes.
the limitation, actually. Yes, ma'am.
Thank you so much, all the presenters, ma'am, and thank you all the judges to chair the session. It's an immense pleasure to have you all over here. I would like to tell you that you need to send that chart that to aogdvirtuals@gmail.com.
Right.
Okay, ma'am.
We'll be doing that.
Thank you.
Thank you so
Thank
much
you, Tarun.
for your
Thank you, AOG. Thank you, Dr.
Thank you.
Mala.
We are moving. Yeah, thank you. We are moving to the next session. We are moving to the next session. This is a session 6. To judge the session, I would like to invite our own ma'am, Dr. Professor Mala Srivastav. Ma'am is the AOGD President 2020. Hello, ma'am. Ma'am is a senior consultant, robotic surgeon, endoscopic surgeon in Gangavaram Hospital. I would like to invite Dr. Anupam Nidhi. Ma'am is a senior specialist, Dobbs and Gynae, Guru Gobind Singh Hospital, New Delhi. Dr. Anupam Nidhi.
Good evening, ma'am. Good evening, Dr. Tarun.
Good evening.
Hello.
Doctor, hello, we can hear you, ma'am.
Okay.
We can hear you, ma'am.
Hello.
I would like to invite Dr. Nilima Gupta, senior consultant and infertility specialist at Milan Fertility. Dr. Nilima Gupta. Good afternoon, ma'am. Your voice, your mic is muted.
Audible now?
Yeah, we are audible. I would like to directly go to the presenter because without wasting much time, I would like to invite to present her session Dr. Neha Varun. Her code is HRP 0636. Dr. Neha, can you please share your slides?
Yeah, yes, I'm sharing.
Backup team, can you help her in sharing her screen?
Dr. Neha?
Yes.
Yeah, please click on the share screen.
Yes, I have clicked on the share screen, but it is not showing my.
Can you click on the desktop?
Yes.
Yeah, click.
Okay.
And click share.
Yeah, it is showing something access.
Allow it. Hello, Dr. Neha.
Yes.
Yes.
Am I able to share?
Your time starts now, Dr. Neha.
Yes. Okay. Good afternoon, all. I'm Dr. Neha Varun, Assistant Professor, All India Institute of Medical Sciences. Today, I'm going to present my study on observational study of cesarean delivery on maternal request in urban settings. A brief introduction. CDMR, which is a cesarean delivery on maternal request, it is defined as a primary cesarean delivery on maternal request in the absence of any standard obstetrical or medical indication for avoiding a vaginal birth. And CDMR rates appear to be increasing, and it is as high as 50%. The reasons why women are requesting this procedure, known to be associated with greater risk than vaginal birth, needs to be evaluated. So the main aims and objectives are to find out the rates and reasons of CDMR. So it is a self-administered questionnaire-based observational study with a convenient sampling technique, and we have included all obstetricians, residents and faculty practicing in private and government institutions anywhere in India. So an in-house questionnaire developed and validated Over a period of 6 months, we have done this study, and the questionnaire is given as in person as a hard copy or sent via Google link on WhatsApp or via email. So we have a total 230 respondents, and we have divided in two groups. The group 1 include public sector doctors, including 117 respondents, and group 2 include private sector doctors. Average time to fill the questionnaire is 5 to 10 minutes, and survey is anonymous, and the participants are not asked to reveal their identity. Going on to results, we have the total respondents 230, and the mean age is comparable in the two groups. We have seen the designation, which is mainly in group 1, we have majority residents were there, 75.4%, and in group 2, the majority were the senior faculty more than 40 years. When we see the total deliveries, it has been seen that the private sectors are having a less number of deliveries as compared to the government sectors. Regarding the qualification, both the groups are almost comparable and statistically equivalent. Compared to, coming to the cesarean section rate, the cesarean section rate is comparable in both the groups, and it is ranging between 15 to 50%. We have seen the indication of the elective cesarean section, and the most common indication is the obstetrical indication in both the groups. In group 1, it is seen in 82%, and in group 2, it is 77%. Then the CDMR rates, the most commonly the respondents have taken in the less than 15% of the group. But when we see this group of 30 to 50% and more than 50% group, in group 2, we have almost 7.95% respondents in this group, and which is none in the public sector group. And this value is clinically significant. Coming to the most common reason of CDMR, in both the groups, it was a fear of labor pains and the prolonged duration, followed by the fear of fetal complications, past infertility treatment, and the astrological reasons. Then the most common group of patients requesting CDMR, in both the groups, the previous cesarean were the most common group requesting for the CDMR, followed by the primi gravida patients. Coming to our discussion, there is a paucity of literature pertaining to CDMR as no randomized trials are available. And according to the data from NFHS 4, the prevalence of cesarean section in India is almost 20%. And the recent data reveals that at all India level, the rate of cesarean has doubled over the last decade, while in last 20 years, it has risen 6 times. We have compared the previous studies done over this topic. And this Bettis et al. In 2007, they have done the similar study over 1,031 ACOG fellows, and the response rate is 68%. Again, this is a questionnaire-based prospective observational study, and they had recognized an increased demand for CDMR within their practices. Then Yajun et al. In 2011 have done a descriptive analysis of the indications for cesarean sections, and they have included 111,315 deliveries, and they have seen that the cesarean section rate is almost 54%, and the most common indication for cesarean was CDMR. Narayana Swamy et al. In 2016 again have done a study on a CDMR, and they have included all women who have underwent CDMR, and they were 44 out of 3,600 deliveries. And they have seen that the multigravida opted more for CDMR than primi gravida, which is not seen in our study. And various reasons were refusal of vaginal birth, simultaneous tubectomy, painless delivery, prolonged infertility, and afraid of neonatal outcomes. Makhija and et al. Has done a study in the 2019 to find out the root cause analysis of increasing cesarean section rate. Again, this is a hospital-based cross-sectional study, and they have found that most common mode of delivery is cesarean. Elective cesarean were seen in 27%, CDMR rates were 25.2%, and the most common reason is fear of labor pains and anxiety, which is similar to our study. ID et al. In 2019 again done a study which is a bit similar to our study. They have done a semi-structured interviews with the women, 17 women, and a focus group discussion with the 20 caregivers, 9 midwives and 11 obstetricians. And they have also found the most common reason for CDMR is the fear of birth and the labor pains. There is one recent study by Mesesura et al. In 2020, and they have included 2,348 women who delivered by cesarean sections. And they have seen that the CDMR rates were 8.6%, which is similar to our study. In our study, it is mostly less than 15%. And again, the reasons for
30 seconds more.
Yes, sir. Use of ART techniques and the previous operative deliveries. So coming to the conclusion, the CDMR rates can be reduced by comprehensive programs and the health promotion interventions with antenatal counseling and option of providing continuous fetal monitoring, training for trial of labor after cesarean section, and the use of labor analgesia. Thank you.
Thank you so much, Dr. Neha. Now we are moving to the discussion session.
Yes, sir.
Dr. Neha.
Yes.
Dr. Nilima, I would like to ask you one question. In somewhere in your slides, I saw that you have mentioned astrological reasons also.
Yes, ma'am. Yes, ma'am.
So in your questionnaire that you circulated to all the doctors and the faculty in the private setup and the government setup, did you include this question in the questionnaire? Can I get a glimpse of your questionnaire, what you exactly asked all the doctors?
Okay, so ma'am, exactly, I don't have a picture on my desktop, but I have asked these 4 reasons only. That is, the one is the fear of the labor pains and the prolonged duration. The second option is the fear of fetal complications. The third option is the past infertility treatment. And the fourth option is astrological reasons. And fifth, we have kept for any other reply. So these are the 5 options in my questionnaire.
So which one was the most common?
Ma'am, the most common is the fear of the labor pains and the prolonged duration, followed by the fetal complications. Third is the past infertility, and fourth is the astrological reasons, ma'am. And this most common one is common in both the groups, ma'am. It is not, p-value is not significant. In both the groups, in public and private sector, the respondents have ticked that the most common reason is the fear of labor pains and the prolonged duration of the labor.
You think increasing rates of ART is the cause for CDMR?
Yes, ma'am. You're not audible, ma'am.
Do you think that increased rates of ART, assisted reproductive techniques, is the cause for CDMR?
Yes, ma'am. Actually, we have seen in our study and in the previous studies also that the patients who are having a past infertility treatment or who are, like IUI conceived or IVF conceived, we are not considering them as, a patient for elective cesarean section, but they presume themselves as a very high risk patient and they demand for elective cesarean section, maybe because it's a very precious pregnancy and they don't want anything to happen with this baby. So according to the obstetrician, it is not an indication of elective cesarean section, but yes, these patients are, they are very keen to have this elective cesarean section. So one of the options we have kept as the past infertility or the infertility treatment in our questionnaire.
Okay, we can move on to the next candidate.
Thank you so much, Dr. Neha. We are moving to the next presenter, Dr. Anupriya Narayan. Dr. Anupriya, her code is HRP 0637. Dr. Anupriya, you can share your screen. We can see you. Your mic is not working, I think. Just unmute it. We cannot hear you, Anupriya. No, we cannot hear you. Backup team, please help her. Anupriya, unmute, please.
Unmute yourself, ma'am.
Am I audible now?
Yeah, you're audible. Please share your screen.
Yeah.
Anupriya, you have 6 minutes to finish your presentation. Your time starts now.
Okay. Good afternoon, everyone. I would like to thank AOGD to give me this opportunity to present my paper on estimation of maternal serum vitamin D levels and its correlation with hypertensive disorders of pregnancy. As we all know, vitamin D is a fat-soluble vitamin synthesized in the skin through exposure to sunlight. But in India, despite abundant overhead sunlight, several Indian studies have shown high incidence of vitamin D deficiency. Several studies in the past have established contradictory association of preeclampsia and other hypertensive disorders with maternal hypovitaminosis D. So the current study was an attempt to find the status of vitamin D deficiency in pregnant women and to determine whether this deficiency was associated with higher incidence of hypertensive disorders of pregnancy. The study was a cross-sectional observational study conducted at Dr. RML Hospital within a span of 1 year and 4 months 400 term singleton pregnancies were included in the study, and the patients who were excluded were those with history of recent intake of therapeutic doses of vitamin D, with known diabetes, hypertension, and renal disorder, and uncontrolled, untreated thyroid disorders. The patients were enrolled randomly, and detailed history followed by general physical examination and systemic examination was done. The presence of gestational hypertension, preeclampsia, superimposed preeclampsia, was identified according to standard definition based on the patient's records. 3 to 4 ml of fasting blood samples were collected and were analyzed for serum vitamin D levels. Less than 20 nanogram per ml of serum vitamin D was defined as deficient, 20 to 29.9 was insufficient, and 30 to 100 nanogram per ml was sufficient levels of vitamin D. More than 100 constituted potential toxicity. Well, the results were kind of alarming. The overall presence of vitamin D deficiency in the present study was a striking 86.25%. And this was despite the fact that the routine supplementation of vitamin D was taken from the second trimester itself of around 400 to 600 international units. 7.25% of the patients were had insufficient levels, and only 6.5% patients had sufficient levels of vitamin D. None of the patients had toxic levels of vitamin D. The overall mean serum vitamin D level was a meager 14.06 plus minus 9.43 nanogram per ml, which was far below the sufficient levels of 30 nanogram per ml. The mean serum vitamin D levels in the non-hypertensive group was 14.4 nanogram per ml, and in the hypertensive group, it was still lower, that is 12.45 nanogram per ml. However, the association was statistically non-significant. Out of the 400 participants, 6.5% had hypertensive disorder of pregnancy, but none of the patients of hypertensive disorder of pregnancy had sufficient levels of vitamin D. The 23 patients out of 26 had deficient levels, and the rest 3 had insufficient levels between 20 to 29 nanogram per ml. However, the association was statistically non-significant. The prevalence of hypovitaminosis D in the hypertensive group was just a slightly higher than the non-hypertensive group, that is 88.46 versus 86.1% respectively. However, this association was also statistically non-significant with a p-value of 0.282. Let's discuss the result with the studies done in the past. Similar results were obtained by Shant et al., who observed no association between preeclampsia and vitamin D deficiency in a prospective cohort study. In contrast, there have been several studies who have reported association of hypertensive disorders of pregnancy with hypovitaminosis D, like Agazafri et al. In 2013 and Robinson CJ 2010. There have been few studies who have even suggested the protective effect of higher doses of supplementation of vitamin D in the prevention of preeclampsia. In a randomized controlled trial, Mahdi and M et al. Suggested doses of as high as 50,000 international units every 2 weeks to be beneficial in the prevention of preeclampsia as compared to 400 international units daily. There are a few other Indian studies who have reported similar high prevalence of hypovitaminosis D. Sachin et al. From Lucknow has reported 66.7%, and Kumari et al. Has reported 78% incidence of vitamin D deficiency. Similarly, a study from Iran in 2009 reported a similar incidence of 86% prevalence of vitamin D deficiency. We drew 2 important conclusions from this study: that there is a very high prevalence of hypovitaminosis D in the pregnant females attending the institute, that is 86.25%. And although none of the hypertensive patients had sufficient vitamin D levels, there was no statistically significant association between hypertensive disorders of pregnancy and serum vitamin D levels. I would like to highlight few strengths of the study. Unlike other studies done in the past, which mostly were limited to the association with preeclampsia, the present study reported association relating to all forms of hypertensive disorders of pregnancy. It measured the 25-hydroxy vitamin D levels, which is more reliable due to its longer half-life. The study highlighted the epidemic magnitude of vitamin D deficiency in India, and also supports the argument to initiate screening of vitamin D deficiency, at least in the high-risk pregnant females, and the importance of the consideration of universal vitamin D supplementation program in the pregnant females of India. There were few limitations of the study. It was a cross-sectional study with an average sample size, and the cutoff levels that were used could be erroneous, keeping in mind the physiological changes of pregnancy, that is hemodilution. So there might be a need for separate cutoff levels for the diagnosis of hypovitaminosis, specifically in the pregnant population. So every research opens the door for future research prospects. So there were few questions that were raised during the conduction of the study, that should there be separate pregnancy-specific dietary recommendations, and will the routine replacement of vitamin D in the form of supplementation with higher doses be able to reduce the epidemic magnitude of the problem? With this, I would like to conclude. Thank you for your patient listening.
Thank you so much, Dr. Anupriya. Now the topic is open for discussion, ma'am.
Dr. Anupriya, once you diagnose this patient is having a deficiency of vitamin D, do you supplement them, and how do you supplement them?
Yes, ma'am. Because of this concern, we had included the patient at term. So when at term, I found that the patient had deficiency, I supplemented the patients with therapeutic levels, therapeutic doses of vitamin D.
What was your therapeutic dose?
Ma'am, we gave 60,000 international units weekly for 8 weeks, followed by monthly for another 8 weeks, ma'am.
And did you follow them up in the postpartum period as well?
Ma'am, it was not included as a part of the study. So a proper
as a part of a patient care, do you
yes,
think that patient required follow-up in the postpartum period? They needed care so far
definitely,
as
ma'am, definitely.
deficiency was concerned?
Yes, ma'am.
How frequently did you give them vitamin D?
Ma'am, we called them after 6 weeks as the routine. We gave the prescription and then called them after 6 weeks, and then we
What was your prescription?
Sorry, ma'am.
What was your prescription for vitamin D?
Ma'am, the same 60,000 international units weekly for 8 weeks. And then at 6 weeks, when the patient came for the routine puerperal puerperal examination, that time we again advised for a serum vitamin D level as a part of the patient care.
Dr. Anupriya, one question. The serum vitamin D levels that you measured during your study, were they standardized, and was the same lab used, or you used different labs?
No, ma'am, the same lab was used. The same lab, the hospital lab itself was used, ma'am. And it was the
For
same.
all the patients?
For all the patients, ma'am.
Okay.
Thank you, Dr. Anupriya. We are now moving to the next presenter, Dr. Parul Jaiswal. Dr. Parul, her code is HRP0638. Dr. Parul, you can share your screen. You have 6 minutes to finish your presentation, Dr. Parul. Your time starts now.
Good afternoon, everyone. Greeting from the Department of Obs and Gynae, All India Institute of Medical Sciences. We present to you a case of Glanzmann thrombocythemia in pregnancy, which can prove to be a nightmare for every obstetrician, which was managed in collaboration with the Department of Hematology, All India Institute of Medical Sciences, New Delhi. Glanzmann thrombocythemia is a rare autosomal recessive disorder, which is also a platelet aggregation disorder with either a qualitative or quantitative defect in the GP2B3A receptors. It was named after a Swiss pediatrician, Edwards Glanzmann, and is notorious to cause catastrophic hemorrhage and neonatal alloimmune thrombocytopenia in rare cases. We present to you a case of 33-year-old Primi Gravida who presented at 23 weeks with known case of Glanzmann thrombocythemia and chronic hypertension. She was married for 12 years and it was a consanguineous marriage, and was diagnosed with Glanzmann's in adolescence during her workup for puberty menorrhagia. All other siblings were screened negative. At her booking visit, the platelet counts were normal with a BP of 140/90, and she was asked to follow up regularly under hematology as well as for her antenatal care every 2 weeks. But due to COVID-19 pandemic, her routine antenatal care was interrupted, and she presented directly at 36 weeks with epistaxis when the BP was found to be high, and flow cytometry showed a type 3 Glanzmann's thrombocythemia. For the management, nasal packing was done and tablet tranexamic acid 500 mg TDS was started. This is the report of her immunophenotyping, which shows 100% expression of CD41 and 61, suggestive of a type 3 Glanzmann, that is a qualitative and not a quantitative defect of these receptors. At 38 weeks, delivery was planned in view of her severe features and poor bishops, when the BP was escalated to 170 by 110, and per op she was started on injection Maxel, tranexamic acid, and injection recombinant factor 7 at a dose of 90 microgram per kg 3 hourly. She underwent an LACS with Mirena insertion and received injection tranexamic acid and recombinant factor and various blood products. Blood loss was around 800 ml and spontaneous hematomas were noted in the rectus muscle, upper uterine suture line, and the parietal peritoneum. In the post-op period 4 hours, she developed hypotension. The ultrasound showed free fluid in the peritoneal cavity and she was immediately taken up for the emergency re-laparotomy. Bilateral uterine arteries were ligated and partial lumental resection was done in order to attain the hemostasis, and 2 vertical Hayman compression sutures were applied to maintain the uterine tone. This is the transfusion chart, and to reiterate the importance of recombinant factor 7, which was given in the post-op period for a total duration of 36 hours. In the post-op, she had an uneventful recovery and was discharged on day 9 with a weak supply of tranexamic acid. The baby had normal platelet count at birth and at discharge. And in the 1 month post-op period, she presented with secondary PPH when her hemoglobin had dropped, but the platelet counts were still normal. The ultrasound showed the uterine cavity filled with clots. She was started with norethistron 10 mg TDS and was discharged after 15 days on ormeloxifene 60 mg twice a week. Glanzmann thrombasthenia, the pregnancy can be considered hazardous owing to the peripartum hemorrhage it presents with. Thus, such delivery should be managed at a tertiary care center and a written management plan should be present on the table. Be it vaginal or cesarean section, antifibrinolytics and recombinant factor 7 should be started as soon as the labor sets in or pre-operatively. The preferred mode is vaginal, and instrumental delivery and regional anesthesia for section are contraindicated. All neonates should be screened with a complete blood count. In the various case reports cited in the literature, the various complications have been reported associated with Glanzmann's. To enumerate, few are the extraventricular hemorrhage noted at 33 weeks, which led to a stillborn at 36 weeks, in which antiplatelet antibodies were found, along with fetal thrombocytopenia. Another patient presented at 29 and 31 weeks with epistaxis, and secondary PPH was noted that was managed with tranexamic acid. Isoantibodies in another patient who had history of multiple transfusions during surgeries was seen. An ultrasound at 31 weeks showed an intracranial hemorrhage and IUD. Another patient had epistaxis along with the presence of antiplatelet bodies, which was managed with a trial of oral prednisolone 2 mg per kg per day for 3 weeks that abated the bleeding. To differentiate between the various platelet function disorders, Ristucitin-induced platelet aggregometry test is done, which is negative for Bernard-Solier and von Willebrand, whereas it is very effectively positive for the Glanzmann thrombasthenia patient. Thus, to conclude, the incidence of morbidity and mortality associated with Glanzmann's is unknown. Recombinant factor 7 and platelet transfusions can be used as effective hemostatic agents, and preparedness is the key to successful outcome. Thank you.
Thank you, Dr. Parul, for the wonderful presentation. Now the topic is open for discussion. Mala ma'am, hello.
Is this genetically inherited?
Yes, ma'am, it is an autosomal recessive disorder, ma'am.
So did you check the neonate for this also?
Ma'am, the father was negative, and if in case the fetus would be, the fetuses would be heterozygously, they would be carriers as the father would be negative, and the baby was checked for the platelet count, which was found to be normal.
So you need to counsel the mother that in future pregnancies also she needs to deliver in the
Tertiary care institute, ma'am.
That is very important.
Yes, ma'am.
Any other question, ma'am?
No. Excellent presentation.
Okay, thank you so much. We are moving to the next participant. We are inviting Dr. Urvashi Chikara. Her code is HRP 0639. Dr. Urvashi, can you please share your screen?
Yeah.
Dr. Urvashi, you have 6 minutes to present your presentation and
Okay.
2 minutes for your presentation. Your time starts now.
Good evening, everyone. Today I'll be presenting my research on the follow-up and outcomes of very short cervix less than 15 mm, a single center experience. We know that spontaneous preterm births remain one of the unsolved problems for modern obstetrics, and India shared the largest burden of these preterm deliveries. As for screening, we know that the premonitory symptoms like contractions, pelvic infections, vaginal bleeding, they are not good predictors for preterm birth. However, previous obstetric history of spontaneous preterm deliveries and cervical length less than 25 mm are strong predictors. Fetal fibrinolactin, which is a strong marker for preterm births, is not available in India, so cannot be used for screening these patients. So ample evidence is available that cervical screening using a transvaginal ultrasound should be used, and economic models are available which show that cervical screening is cost effective also. And as for the preventive strategy in these patients, we know that both progesterone and cerclage, they work efficaciously in preventing these preterm deliveries. However, the dilemma lies in the cases with very short cervix less than 15 mm, because the obstetrician feels that it might be too late to start the women on progesterones, while cerclage is always thought to increase the risk of infection and premature rupture of membranes. So in our studies, we tried to compare these two treatment modalities in these patients of very short cervix. So ours was a retrospective observational study, and it was conducted at the Department of Fetal Medicine. And we usually screen women in first trimester and at 20 to 24 weeks. So we identified 78 women with singleton pregnancies where the transvaginal cervical length was less than 15 mm. So based on the obstetrician preference and patient choice, 27 patients, they opted for progesterone and 51 underwent cervical cerclage. 1 minute, ma'am. We use the standard technique for advised by the Fetal Medicine Foundation for measuring the cervical length. Just to emphasize that while measuring the cervical length, it is always important to put a fundal pressure, because sometimes a normal looking cervix may manifest funneling while we put the fundal pressure. And also it is the residual functional length of the cervix which is important, and there is no clinical relevance of this U and V sign. So our primary outcomes were preterm deliveries less than 34 weeks, and secondary outcomes were birth weight at delivery, rates of premature rupture of membranes, need for cesarean section, NICU admission, severe neonatal mortality and morbidity. So out of 78 patients which were found to have less than 15 mm cervix, we divided these patients based on the gestational age at diagnosis between less than 16 weeks, 16 to 24 weeks, and 24 to 48 weeks. And this is the distribution of the patients and the allotment of the patient in progesterone and cerclage group. Now, to emphasize, about 45% of these women could be identified by our universal mid-trimester cervical screening before 24 weeks. And also the patients which were identified in the early part of the pregnancy, less than 24 weeks, 77% of them underwent cerclage, while in the later part of the pregnancy, there was an equal distribution between the cerclage and the progesterone groups. Also, comparing the demographic factors in the two treatment group, there was no statistically significant difference. The gestational age at diagnosis was 25 weeks in progesterone group, and it was 22 weeks in cerclage. Mean cervical length was 12 millimeters with progesterones. It was 10 millimeter in the cerclage group. Also, to emphasize, 6 patients which were initially started on progesterone, but on the serial monitoring on the serial scans, there was a progressive cervical shortening, and these patients underwent cerclage. In this chart, I've tried to compare the two treatment modality according to the gestational age at diagnosis in the 3 groups. So again, to emphasize that both the treatment modality, they worked fairly in all the 3 groups, and there was no difference in the primary outcome and the secondary outcome in these 2 groups. Irrespective of the gestation, when we tried to compare the progesterone and cerclage, again, the spontaneous preterm delivery rates were 29% with cerclage, and they were 27% with 29 with the progesterone and 27% with cerclage. So again, they were comparable. we did a subgroup analysis of these patients where a cervical length of less than 10 mm diagnosed before 24 weeks were taken. And we could see that with cerclage, the preterm delivery rates were 23% compared to 50% with progesterone. So at this, in this cohort of patients, cerclage performed better than progesterone. So to discuss, we already know that without treatment, it is very important to screen these patients to identify these high-risk women, because without treatment, the preterm delivery rates in these patients will be more than 50%. And once these patients are identified and they are started on some treatment, the preterm delivery rates fall to 26%. And in our study, both progesterone and cerclage, they performed fairly to prevent these deliveries. Also, in very, very short cervix, less than 10 mm, the cerclage performs better than progesterone. So straight away, these patients should go for cerclage. The strength of our study was that we measured all the cervical lengths transvaginally, and we tried to give an insight for universal cervical screening and for the treatment modalities in these cases. However, it was a retrospective analysis with a small sample size because of the rarity of these cohort of patients. So to conclude, in patients with very short cervix, less than 15 mm, both progesterone and cerclage performs fairly. However, patients on progesterone treatment need more vigilant follow-up with serial scans, and those found non-responsive with progesterone will need cerclage. Women with extremely short cervix, less than 10 mm, appears to benefit more with cerclage, and thus we advocate universal cervical screening to predict and prevent these preterm births. Thank you.
Thank you so much, Dr. Urvashi. We are now moving to the question and answer session. The topic is open for discussion, ma'am.
How many patients in your study had emergency cerclage?
So rescue cerclage was needed in around 4 patients, ma'am.
And what was their outcome?
So I mean, 2 patients, they had miscarriage within 10 days, and 2 patients where cerclage was done at I think at around 7 and 8 mm of length. There we could prolong the pregnancy by about 12 to 13 weeks. So they could be prolonged till 33, 34 weeks around, ma'am.
Can you say that vaginal infections could have been the cause for these preterm deliveries? Where you gave emergency cerclage to patients, they had progressed to preterm delivery, or within 10 days they delivered. You think that vaginal infections was additional cause for that?
Yes, ma'am, it could be, because we know that the infections in these cases, they precipitate labor, and despite the cerclage being put, they may result in preterm, the pains and preterm delivery.
HBS as an additional test in those cases?
So ma'am, once at the time when patient is planned for cerclage, all the infection screening is done. So we do the high vaginal swabs, we do the HB with the like the WBCs, and we try to look at the CRPs also. So at that time, care is taken to prevent all these infections. But later on, 2 of them, because there was excessive shortening, and cerclage was just put as a rescue method, and the labor could not be prevented.
In those cases, did you also give additional progesterones to them?
In which cases, ma'am?
The 2 patients who had aborted within 10
Yes,
days.
ma'am. So this is
progesterone also to them?
Yes, ma'am. Yes, ma'am. Because the obstetrician, they are over conscious and they want to support the pregnancy in all possible ways. So because so they were given progesterones also, ma'am, apart from cerclage.
Dr. Nilima, you want to ask something?
Yes, ma'am. Actually, I had one question, that you mentioned that you did HVS in all the patients who underwent cerclage. So for the group where you decided to give progesterone, did you do an HVS in all those patients also?
Ma'am, cerclage, because it is an invasive, we offer, and like for all the short cervixes,
we would do. But then found to have a short cervix, but you decided to manage them on progesterone only. For them,
Yes,
did you take an HVS?
Yes, ma'am. It is a routine care at our center that any shortening in the cervix, if noted, we do infection screen and rule out any vaginal infection. So it was done in all the cases.
So you mean to say that the patients who were given progesterone, all of them were HVS negative? They were not treated for infection at all?
No, ma'am. If I don't have the data for like there were patients who had infections and they were treated also, and then with progesterone there was a prolongation of pregnancy also. It's not that, but most of these patients, they were asymptomatic patient, and I think very rare cases, there was an infection. These
They
patients
were not asymptomatic because their cervix was short.
No, ma'am. They were asymptomatic. They did not present with pain or contractions. They were asymptomatic, and as a part of our screening, we do cervixes at like second trimester. And later of the pregnancy, yes, ma'am.
And another thing that you mentioned, that in the patients who underwent cerclage, for them also you gave them progesterone. So don't you think that this is becoming a bit of compound? Hello?
No, ma'am. Ma'am asked whether the patient who had extreme shortening of cervix, so the obstetricians, they prefer to give like the progesterones along with cerclage.
So was this a confounding factor in your study?
Yes, ma'am, that I accept, but that is the care because the obstetrician wants to be over cautious of these very short.
That I understand.
We are running short of time, ma'am. We are moving to the next presenter. With your permission, I would like to ask Dr. Aishwarya Chaudhary. Her code is HRP 0642. Dr. Aishwarya.
Yes, sir. Am I audible?
Yeah, you're audible. You can share your screen.
Yes, sir.
We can start. You have 6 minutes to finish your session. Your time starts now.
Good evening, ma'am. I'm presenting a case on congenitally corrected heart disease in pregnancy. Mrs. X, 24-year-old lady, known case of congenitally corrected transposition of great arteries since 15 years of age with situs inversus, levocardia, severe pulmonary stenosis, and large ventricular septal defect. Primary gravida, 29 weeks, 5 days, presented to ANC OPD with complaint of breathlessness on exertion for 2 weeks, which was progressive in onset, NYHA grade 3, no orthopnea or paroxysmal nocturnal dyspnea. There was no history of diurnal or postural variation, cough and fever, chest pain, palpitations, pedal edema, bluish discoloration of the lips, tips of fingers, and toes. The first trimester was uneventful with no feature suggestive of cardiac decompensation. In the second trimester, a high BP record was recorded for the first time, which was 142/92 mmHg. On further visits, no high BP was recorded. An echo was done which revealed CCTGA, situs inversus, levocardia, right atrium towards left, left atrium towards right, AV-VA discordance, large VSD, severe PS with difference in the pressure gradient, 84 mmHg, normal biventricular function with ejection fraction more than 60%. As per the cardiologist, no intervention was required, and the patient had no features suggestive of cardiac decompensation. In the third trimester, she complained of breathlessness at 29 weeks and was admitted for safe confinement. She was diagnosed as a case of congenital heart disease at 15 years of age. She has no history of any cardiac drugs or surgical intervention. There is no history of congenital heart disease in the family. General physical examination, the patient was conscious, cooperative, well-oriented, afebrile with adequate hydration. The pulse was 114 per minute, good volume, no radioradial or radiofemoral delay. Saturation was 90% on room air, 94% on oxygen by mask. BP was 124/82 mmHg. Respiratory rate was 20 per minute, regular, no labored breathing, no cyanosis, no engorged veins. JVP was not raised. On respiratory system examination, bilateral air entry was equal with no added sounds. Cardiovascular system, chest wall was symmetrical with no scars or deformities, no thrill or parasternal heave palpable. Apex beat in the fifth intercostal space in the mid-clavicular line. A pansystolic murmur was heard, grade 2 in intensity, at the left sternal border. Abdominal examination, abdomen was distended uniformly with no scars and sinuses. Fundal height was 28 weeks, and the fetus was in longitudinal lie, Keflick presentation. Leica was adequate. Heart sound was 140 beats per minute, regular. The investigations, including hemogram, liver function test, kidney function test, thyroid function test, coagulation profile were within normal limits. ECG was also done and it was within normal limits. On ultrasound, at 32 weeks of gestation, the estimated fetal weight was below the third centile, but the Doppler findings were normal. A follow-up scan was done at 36 weeks of gestation, and the estimated fetal weight was above the 10th centile with normal Doppler findings. The final diagnosis, Mrs. X, 24-year-old lady, primary gravida, 29 weeks, 5 days of gestation with singleton pregnancy in longitudinal lie and Keflick presentation, Known case of CCTGA with situs inversus, levocardia, severe pulmonary stenosis, large ventricular septal defect with normal biventricular function, with acute onset breathlessness and maternal tachycardia, NYHA grade 3, WHO class 3. The patient was admitted in view of breathlessness and tachycardia, which improved with oxygen by mask and bed rest. Daily vitals monitoring was done. Pulse rate was between 84 per minute, saturation between 86 to 95%, and blood pressure was always normal. Ultrasound showed no congenital heart anomaly in the baby. Daily fetal movement count was adequate. Biweekly non-stress test and biophysical profile assured well-being. Spontaneous labor at 38 weeks, 5 days of gestation. Oxytocin augmentation was started to shorten the duration of labor, and a live baby with Apgar 999 was delivered. Immediately after delivery, intravenous Lasix and intramuscular morphine were administered. The patient refused contraception. Postnatally, patient shifted to ICU for monitoring for 24 hours, and IV antibiotics were given for 5 days. Cardiology referral was taken. The patient was discharged on day 6 with tablet torsemide with spironolactone and tablet ramipril. Why should we study congenitally corrected transposition of great arteries? It is a very rare condition with incidence of 1 in 33,000 live births. In these patients, the right ventricle is a systemic ventricle, and therefore the prognosis of these patients depends upon the function of the ventricle. The survival rate in these patients at 40 years of age is 84%, which is a good survival rate. Therefore, a successful pregnancy can be achieved in these patients with careful monitoring. Counsel against pregnancy in patients who are NYHA class 3 or NYHA class 4 before conception, significant systemic ventricular dysfunction with ejection fraction less than 40%, or significant systemic AV valve regurgitation. In antenatal care for these patients, a comprehensive cardiovascular evaluation to assess the function and to confirm the diagnosis of the cardiovascular lesion should be done. If the patient is symptomatic anytime in the antenatal period, a repeat echo for right ventricular function should be carried out. Hemoglobin and hematocrit in each trimester should be recorded. Safe confinement should be done in 3rd trimester for these patients. For intrapartum care, vaginal delivery is preferred over cesarean to avoid rapid fluid shifts, and cesarean is reserved for obstetric causes when, yes, when cardiac function is severely decreased. Second stage must be shortened to decrease the hemodynamic stress on the patient. Oxytocin causes negative inotropy, chronotropy, vasodilation, and hypotension, whereas misoprostol does not affect maternal cardiac function even at high doses. Therefore, this should be preferred for prophylaxis of PPH. Diuretics should be given in postpartum period to assist in reducing the intravascular. Epidural anesthesia or combined spinal epidural should be given in vaginal delivery to make the second stage of labor a passive process, and in cesarean section to avoid the stress response to intubation and therefore decrease the chances of cardiac compromise. For postnatal care of these patients, under and over fluid resuscitation can compromise cardiac function, especially because maximum fluid shifts occur in the postpartum period.
You have exceeded your time limit. You have exceeded your time limits. We have to go
Sir,
for the. Ma'am, the topic is open for question and answer session.
Okay, sir.
What contraception did you offer to this patient because this patient refused postpartum contraception? What
ma'am, we had offered her intrauterine.
No, but she refused.
Ma'am, we had offered her intrauterine.
So what else did you offer to her?
Sorry, ma'am. Ma'am, we also offered her progesterone-only pills and OCP, but
she refused intrauterine contraceptive device. So what else did you offer her?
Ma'am, we also offered her progesterone-only pills and oral contraceptive pills, which are also recommended by ACOG, but she was not ready for any contraceptive at that time, ma'am.
Did you not follow her up in the postpartum period?
Ma'am, we did follow her up, but we had asked her to come after 2 months. But after, ma'am, she delivered in mid-January. After that, because of COVID, she has not been able to come. Telephonically, I have contacted the patient and she is well and fine, but she did not follow up anywhere else also for contraception, ma'am.
You think contraception is important for her?
Ma'am, definitely important because these patients are a lot of studies have been done, and in not only in the immediate postpartum period, but also at 3 months, 6 months, and up to 1 year also, the morbidity and mortality in these patients have been reported. So they should be advised for contraception, ma'am.
Okay, Dr. Nilima, you want to ask something?
Dr. Aishwarya, I have a question. Hello.
Sure, ma'am.
Yes, ma'am.
Please. Yes, ma'am.
What about the concern of this patient? How is husband reacting to the contraception?
Ma'am, both are graduate, and they are well aware of the other methods, barrier methods of contraception, and they were advised, and they are using, as of now, they are using that, but the patient is not choosing any contraceptive for herself, ma'am. The husband is aware and has been explained about the contraception, ma'am. The need for
What
contraception.
about her risk in the second pregnancy? Because she already has a congenital heart disease, a severe degree, which has been corrected. So do they want to have another child, or do they don't want to have another child at all?
No, ma'am, they are not planning any another child right now. I had recently talked to them about 4 weeks back, ma'am. She is not planning any other child, ma'am.
Did you explain about the role risk involved in MTP in these cases?
Sorry, ma'am, risk of, ma'am?
MTP in these cases. How risky the MTP in case there is a failure of contraception they have been using? Because the wife is not
Ma'am,
willing
while
for annuity. All other contraceptions are compliance.
ma'am, in the yes, ma'am. Ma'am, in the postnatal period, we had also advised her to, we had also sent her to the family planning OPD, and there she was explained about all the consequences that might occur with second pregnancy. But ma'am, right now she had we had tried to, she was with us for 6 days postnatally, but she refused every method of contraception, ma'am.
Okay, thank you, Dr. Aishwarya. Thank you.
So much, Dr. Aishwarya. Ma'am, is there any question need to be asked, ma'am, right now? Any more question?
No.
Okay, thank you so much, ma'am. Thank you all. Thank you all the presenters, and thank you all the judges for this wonderful session. I'd like to request you all to share your charts to aogdvirtuals@gmail.com. And we are ending this session. We are moving to the next session. We are moving to our next session.
Dr. Tarun, sorry to interrupt, but one of the topics is not presented.
Yeah, ma'am. She is not there. She's not there. She's not there.
All right.
Okay.
No problem.
Thank you so much, ma'am, for your kind time, and it's a nice pleasure to have you all in the same dais. I would like to move forward to the next session. I would like to invite to judge the session Dr. Sonia Naik. Ma'am is the director and unit head, Department of Obs and Gynae, Max Hospital, Saket. Welcome, ma'am. Good afternoon.
Thank you, Dr. Varun.
I would like to invite Dr. Sandeep Talwar. Ma'am is a senior consultant at the Southern Fertility IVF, New Delhi. Welcome, ma'am. Welcome, Dr. Sandeep.
Thank you so much. Thank you.
Okay, I would like to invite Dr. Tarang Gupta. Dr. Tarang, are you there?
Yes, sir.
Okay, Tarang, you can share your screen. You can share your screen. You have 6 minutes to finish your presentation, and we have 2 minutes for the discussion session.
Okay, sir. Am I to share the screen?
Yeah, sure. You can go ahead.
Good afternoon to judges. My name is Tarang Gupta, working in the Department of Obs and Gynae, AIIMS, New Delhi. Today, I am going to present on the topic differential expression of
Please share your screen. Can you share your screen? Dr. Tarang, please share your screen.
Yes, sir.
Backend team, please help her.
Hello. Hello. Yeah, ma'am.
Hello.
Yes, ma'am. It's already there. Yeah, please open your Yeah, please from beginning. Yeah.
Good afternoon, judges. My name is Tarang Gupta, working in the Department of Obs and Gynae, AIIMS, New Delhi. Today, I am going to present on the topic differential expression of SFLT1 and PLGF during the pregnancy. Preeclampsia is a disorder of widespread vascular endothelial malfunction characterized by hypertension after 20 weeks of gestation. Placental growth factor is an angiogenic marker, and soluble FMS like tyrosine kinase 1 is an anti-angiogenic marker. Prediction of preeclampsia early in pregnancy is vital for prevention and control of the disease, which will decrease the maternal morbidity and mortality. Our aims and objective are to study the sequential changes in marker vascular endothelial function during the course of pregnancy, PLGF and SFLT1, to investigate whether the alteration in these markers early in pregnancy differ in women who develop preeclampsia later in pregnancy. This is a prospective clinical study and conducted in Department of Obs and Gynae, AIIMS, New Delhi, and our sample size was 120 pregnant women, and our outcomes was development of preeclampsia during the course of pregnancy and to correlate the effect of development preeclampsia and SFLT1 and PLGF. Women our inclusion criteria was women aged 18 to 35 years of age with singleton pregnancy, gestation age less than 11 weeks were included in the study, while multiple pregnancy with heart disease, kidney disease, liver disease, and gestation age more than 14 weeks were excluded from the study. And blood sample was drawn in three time points. One is 12 to 14 weeks, 18 to 20 weeks, and 24 to 20 weeks, 24 to 26 weeks. Then they followed from 26 to delivery till delivery for outcome measures, preeclampsia and gestational hypertension. Out of the 120 patients, 8 patients were the lost to follow-up and 112 patients were analyzed. Gestational hypertension developed in 14.4% patients and preeclampsia developed in 7.2% cases. Preeclampsia occur more frequently in extreme of age with 12.5% incident in 18 to 20 years and 50% incident chances in 30 to 34 years of age. Placental growth factor. The results showed in normotensive pregnancy, serum placental growth factor were gradually decreased in the results show that normotensive pregnancy serum placental growth factor were gradually increasing till 18 to 20 weeks and they gradually decline in 24 to 26 weeks. While pregnancy with complicated like preeclampsia and gestational hypertension was significantly decreasing trend in preeclampsia, PLGF level and pregnancy advance. In SFLT level, in normal pregnancy, the SFLT values did not change as much in mid-pregnancy and gradually increasing further pregnancy. But in complicated pregnancy, the SFLT1 values significantly rise and it is more pronounced to preeclampsia, as this graph is showing in preeclampsia groups. In interquartile graphs, the graph is showed the normotensive pregnancy, the SFLT1 levels were low throughout the pregnancy, but in gestational hypertension and preeclampsia graph, SFLT1 levels were higher throughout the pregnancy, but PLGF level in normotensive pregnancy were increasing, but till mid-pregnancy, then decreasing at 24 weeks. But in gestational and preeclampsia, preeclampsia level, the PLGF level were decreasing throughout the pregnancy. So we discussed that the normal pregnancy present in higher level of PLGF and very low level of SFLT1 in early pregnancy. And in preeclampsia patient, there was a significant low level of PLGF and very high level of SFLT1 in women developing preeclampsia. And in gestational hypertension patient, PLGF level was significantly low in T1 than normotensive groups. So in ROC curve, SFLT1 level in 12 to 14 week of gestation, cutoff range was more than 5,800 to 28 is 87.5% sensitive. And in PLGF level, 12 to 14 week of gestation, more than 548.8 or 4.9, 72% sensitive. And so we can say the SFLT1 level more than 5,828 is 49 49 is the unadjusted odd ratio, and the 30% is the adjusted odd ratio. This study strength are, this is a prospective study, and sequential changes in markers were measured, and the limitations are very low, very small sample size and limited time period of study conducted. So we conclude that this study conclude the variation circulating level of these marker proceed the commencement of clinical feature of the disease, suppression of SFLT1 or augmentation of PLGF forms novel therapeutic target or preeclampsia. Gestational hypertension developed differently from preeclampsia with hydrodynamic circulation and angiogenic marker profile almost similar to those in normotensive pregnancy, suggested that a different therapeutic approach may optimize management. Thank you.
Thank you so much.
Hello.
Hello. Thank you so much, Dr. Tarang. The topic is now open for discussion, ma'am.
Yeah, Tarang, over here, you basically have studied the SFLT and the PLGF over a course of time. But
Yes, ma'am.
But any of these markers, I mean, both these markers that you have studied at different points of time, do you see a difference in both the markers, in the sensitivity of both the markers, which was better at any period of gestation over the other period of gestation? I mean, was it better in the 12 to 14 or in the 18 to 20 weeks? I mean, to diagnose, to basically predict PIH at 18 to 20 weeks is probably too late. So did the sensitivity change at any point of time versus both the markers?
Yes, SFLT1, sir, ma'am, SFLT1 came out to be the single most predictor of preeclampsia at the first trimester.
Because, if we see practically, we don't have SFLT as commonly used as PLGF. So in your study, you found that the SFLT was a better marker compared to the PLGF.
Yes, ma'am.
In the first trimester.
Most predictor of preeclampsia in first trimester.
Okay.
23. What is the cost of this? What is the cost if you commercially get it done?
Ma'am, for SFLT1 it is a kit for 25,000 to 30,000 and depend on vendors.
And how many tests you get it done in one kit?
80 samples.
80 samples. Okay. Yes, so it's around 3,000, 4,000 rupees per test. Sonia, am I right?
Yeah, correct. And then the one kit, once you open it, you have to use it in many weeks.
Yeah. So that means you have to have that kind of a patient load to do it. In commercial settings, I'm not talking of academics. I'm talking of commercial.
And did you combine any of these SFLT or the PLGF with the uterine artery Doppler? Or with any other markers of predictability of the PIH?
No, ma'am, I didn't do this.
Okay. And did you also notice that the markers showed any preference towards the fetal growth restriction other than the PIH?
No, ma'am.
As a secondary outcome?
No, ma'am.
Okay.
Okay. Thank you, Tarang. Dr. Tarang, thank you so much. Ma'am, we are now moving to invite next participant, Dr. Priyanka Katuria. Dr. Priyanka has scored HRP 0744. Dr. Priyanka, are you there?
Yeah. Yes, sir, I'm here. Can I share my screen?
Please share your screen, Dr. Priyanka.
Yes, sir.
Dr. Priyanka, you have 6 minutes to finish your session. Your time starts now.
Good afternoon, seniors. I am Dr. Priyanka Katuria. I am presenting the spectrum and prevalence of congenital anomalies and their preventable associated factors in Northwest India, which is a tertiary center study. The congenital anomalies are defined as structural, functional, and metabolic disorders. These conditions develop prenatally and may be identified before or at birth or maybe later. The congenital anomalies may be minor if they are present at birth and have minimal effect on clinical condition but may have a cosmetic effect. They are major if they are severe enough to reduce life expectancy or compromise normal function. The prevalence of congenital anomalies worldwide is around 6%, while in Indian studies it has been quoted to be 1 to 3% of all live-born infants. The actual prevalence may be much higher because most of these anomalies end up in spontaneous abortions. Also, the pregnancies which are terminated or are stillborn or those who are which are home deliveries are very underreported. The cause for congenital anomalies in 50% of the cases is not known, while in other 50% it may be genetic or environmental. The effect of congenital anomalies is detrimental as it may be incompatible with life, psychological stress to the parents, develop long-term disabilities, and have significant impact on the individual, his family, the healthcare system, and the society. In India, the congenital anomalies account for 8 to 15% of the perinatal deaths and 13 to 16% of neonatal mortality. We carried out this study after taking ethical clearance, and this study was done as congenital anomalies are still not considered as an important factor of neonatal mortality. There has been an epidemiological transition as far as the cause of neonatal mortality is concerned. This is so because the infections and malnutrition, which were the most common causes of mortality, are on a decline because of the good immunization program, the nutritious food availability, and good antibiotics availability. And also, this has not yet been done in this population, and most of the previous studies suffer from methodological issues such as non-random sampling, etc. Also, the effectiveness of surveillance and healthcare system in this area was to be studied. This was a cross-sectional study carried out in the Department of Obs and Gynae at AIIMS Jodhpur. It was done over a period of 1 year, and all the pregnant females who presented to the facility for delivery or for medical termination of pregnancy for diagnosed or suspected congenital anomalies in fetus were included. The females in whom anomaly was diagnosed after delivery of the neonate were also recruited after delivery. The consent for participation was taken from each participant, after which they were asked to fill up a questionnaire which had 3 segments, which focused on the demographic data and the complete detailed history of the patient with special considerations on the risk factors. Also, it included the time and diagnosis of anomaly in the present pregnancy. The congenital anomalies which we came through were classified and categorized according to ICD-10 version 2019, and the cases version 18 was used for data analysis. Results showed that over a period of 1 year, total number of deliveries at our institute were 2360, out of which 86 were the anomalous pregnancies. Of these 86, 24 underwent MTP and 62 reached the period of viability. Mean age of the population was 25.8 years, and around 80% of the study population were educated. Most of the studies by religion and primary gravida and multi-gravida formed almost the equal part of the study population. Of these 86 anomalous babies, 69 were diagnosed antenatally, while 17 went undiagnosed till the time of delivery. 51 were born alive, while 35 were born dead. These dead newborns include the MTPs also. This is the outcome of the babies which were delivered. 5 were the IUDs were delivered by LSCS, while 6 were delivered by vaginal deliveries. 24, as we have seen, were MTPs. This is the table which shows the systemic involvement and the prevalence in the ICD classification of the particular congenital anomalies. We found that the most common anomaly in the patients who underwent MTP was CNS, and anencephaly was the commonest amongst them. And in those who reached the viability, gastrointestinal system was most common, with congenital diaphragmatic hernia topped the list. The mode of the delivery, how the frequency distribution of systemic involvement and pregnancies were terminated. Out of 86 anomalous babies, only 2 patients had taken preconceptional folic acid, while 65 were taking folic acid during the pregnancy. That is, 75% of the patients had taken folic acid during the pregnancy. The glucose intolerance test glucose tolerance test was done, and glucose intolerance was found in patients who had anomalous babies. Out of these 8 patients, 3 were on insulin and 5 were controlled on MNT. Of these 3 who were on insulin, the CNS, CVS, and GI anomaly. While of the 5 who were on MNT, yes, sir.
You have 30 seconds left.
Yeah, sir, I'm almost done. The prevalence of congenital anomalies in our study was 2.6 per 1,000 lives, which is in concurrence with the previous studies of India. The predominant system which was involved depended on the geographical geographical area. The studies which were carried out in the South India, musculoskeletal system involvement was the most common, while in other Indian studies, cardiovascular system was the most common. Also, a pooled prevalence was calculated to account Indian studies, and it came out to be 184 per 1,000 live births. The prevalence of congenital anomalies in tertiary care center in Jodhpur was 2.6%, and we concluded that even after so many government policies and folic acid tablet free supplementation, the prevalence of CNS anomalies was the maximum. The lack of education and awareness may be one of the reasons. That is why a strict policy to educate the rural areas and adequate supplementation is the need of the hour. Genetic counseling centers are must, and people need to be desensitized about the stigma related to congenital. Thank you.
Thank you. Thank you so much, Dr. Priyanka. The topic is now open for discussion, ma'am.
Yeah, Priyanka, did you actually analyze these cases? Did you do an autopsy for these cases?
Yes, ma'am. Autopsy were done in around 8 patients. Out of these 86 patients, these 8 patients. Yes, ma'am.
And was there any association noticed with any, I mean, did you do any genetic screens for any of these patients?
Ma'am, that was not done, but genetic counseling in the subsequent pregnancies was advised to the patients, and we will be doing preconceptional and parenting counseling in next pregnancy.
No, was there any association seen with any genetic, I mean,
ma'am, your voice.
Sonia, ma'am, please unmute.
Oh, I had unmuted. Again, went to.
Yeah. We can hear you, ma'am.
So what I was saying was there any association noticed between any genetic association noticed? Because South Indians have more of musculoskeletons, and you said that you had more of CNS. Is there some association with consanguinity in your area, or any other genetic association probably in that area? Because if in case most of them had taken folic acid, these were all preventable sort of CNS abnormalities.
Yes, ma'am. Ma'am, in our area, what we observed was that the preventable factors dominated the list of the anomalies, and also ma'am, in genetics, there was no such associated factor, but consanguinity was also ruled out, because in this area consanguinity is not followed.
Okay. Okay, so I think a genetic association was probably not studied, and could be the second factor was, I think, one of the important factors could have been the compliance of taking folic acid.
Oh yes, ma'am.
That could have been.
All patients were booked patients.
Ma'am, a few patients were the referred patients, which were referred from the periphery for termination of pregnancy.
So it's very important for you to tell how many of unbooked patients had anomalies and how many had booked, because if in your booked patients you have missed congenital malformations, then that's not done in today's day and age.
Ma'am, yes, ma'am.
Why did you miss those malformations? Was the ultrasound not done in time? Because that's not acceptable as of now, no?
Yes, ma'am. Ma'am, we had got screening done for all the booked patients, but even after the screening, 10 of the patients have missed in the screening also, and they were diagnosed postnatally, while 9 of the patients who were diagnosed postnatally were the referred patients, which were referred to us at they were the unbooked patients.
That's understood then. That's okay.
Thank you. Thank you, Dr. Priyanka. Thank you so much. We are running short of time. We are moving to the next presenter, Dr. Asta Srivastav. Dr. Asta, are you there?
Yes, sir. I'm there.
Can you please share your screen, Asta?
Yes, sir.
Okay, you have 6 minutes time to finish your presentation and 2 minutes for the discussion.
Yes,
so time
sir.
starts.
Good afternoon, everyone. I am Dr. Asta Shrivastava from GTB Hospital, and my study is on apprehensions and experience of childbirth among COVID positive mothers in a low resource setting. This, as we all know, a positive childbirth experience is one which fulfills women's beliefs and expectations, giving birth to a healthy baby in safe environment. And a very important thing is practical and emotional support from birthing companion or technically competent staff. Now, in this COVID time, there is a significant psychological impact on pregnant women due to the fear of disease, social distancing, the fear of disease being transmitted to child, changed hospital policies, restrictions on presence of birth companion. So the aims and objectives of our study was to describe the perceptions and apprehensions and fears of COVID positive women who recently delivered at GTB Hospital, and to document both positive and negative experiences of childbirth among these women. It is an cross-sectional observational study conducted in the Department of Obs and Gynae from 1st October to 1st August to 15th October. Inclusion criteria being COVID positive women who delivered at GTB Hospital during the study period, and exclusion criteria was patients requiring ICU admission or patients with known mental illness. A pre-tested questionnaire was used. The questionnaire mainly had 4 parts: demographic details, delivery details, apprehension prior to coming to hospital, and experiences during birth and labor and delivery. The patient admitted postpartum patients were contacted telephonically after a wait period of 12 hours to allow recovery and before discharge. This is a image of the questionnaire that was used. It had demographic details. We questioned perceptions before childbirth, birthing experience. Now coming to the new normal, GTB has been transformed to a dedicated COVID hospital. Labor ward is manned by a team of healthcare professionals. Intermittent monitoring of patients and fetal heart is done in early labor, while in advanced labor, continuous electronic fetal monitoring is done. Baby is shifted to NICU for observation, all the babies. Express breast milk is provided to them, and baby is discharged only after testing for SARS-CoV-2 within 24 hours and repeat sample at 5 days if negative. And as far as the discharge policies of patients is concerned, patients are discharged only after 10 days of being tested positive or 10 days from the onset of symptom. So coming to the results of our study, total 51 women had delivered during this time frame, with the mean age being 26 years. And coming to the educational status, most of them were educated up to class 12th. And standard definitions of ICMR was used to categorize the patient. 67% patients were asymptomatic, 29% had mild symptom, and rest had moderate symptom. The patients who delivered, 49% were primary gravidas and 51% multigravida. NVD and LSCS were 45% and 55%. Coming to the baby outcome, only 2 babies had tested positive for COVID-19, and 1 baby had expired in NICU due to prematurity. The baby was COVID negative. Now, the patients, when they came, they had various apprehensions. More than 90% of the patients had anxiety on being tested positive for COVID-19. They had the fear of not receiving respectful maternity care, fear of receiving substandard care, fear of loneliness, fear of their baby getting infected, apprehension as to whom they will contact in case any problem arises, fear that there won't be other patients or healthcare workers around, and fear that they won't be involved in decision making. But post delivery, so these patients, they had the fear which they told at the time of presentation. Post delivery, when they were asked, these patients had a positive birthing experience. They told that they were treated with respect and there was a good communication and were regularly examined by the doctors. None of them reported any kind of abuse. So we see that prior to coming to a hospital, anxiety was the most prevalent emotion. We just asked patients yes or no. We did not grade them. And Of the 26 multiparous women, 73% patients reported that they would have felt better if there was physical interaction as it was there in their last delivery. And rest of the patients, they said that even in the last delivery, attendants were not allowed. One of them rather felt better as there was no overcrowding this time. Some of the patients were concerned due to the delayed discharge policy. 58.8% patients reported that they wished to go home as they had no symptoms. And only 3 patients, they had apprehensions due to healthcare worker as they were unable to recognize the face of the doctors and they were unable to differentiate between doctors and rest of the staff. However, they acknowledged that PPE kit was necessary for the protection of doctors. Rest of the patients did not have any problem. So this study assessed the relationship between COVID-19 and its effect on perceptions of expecting mothers. Few studies have been done in recent times to assess the psychological impact.
30 seconds more. Dr. Asad,
Okay.
30 seconds.
All these studies have a similar result. So what we, but they have assessed the psychological impact. They have not assessed their birthing experiences. Ours is the first study to assess the birthing experience. The limitation was small sample size and strength was that commitment of our healthcare workers has can help the laboring patient to adapt the new normal. So this is the first study to address the apprehensions and birthing experience, and we conclude that continuous support provided by the healthcare worker can make the intrapartum and postpartum journey smooth. Thank you.
Thank you so much, Dr. Astha. Now the topic is open for discussion, ma'am.
Okay, sir.
Dr. Talwar.
Yeah. How many? Nobody had severe symptoms, no? Out of your COVID positive patients, nobody had.
Ma'am, the patients with severe symptoms were admitted to ICU. So we had excluded the patients of ICU stay because ICU will cause prolonged hospitalization, other comorbidities, and we had to assess only the bad.
You have excluded those the bad ones, no?
Yes, ma'am. We excluded them.
You've taken either the mild symptoms or the moderate.
Or the moderate symptoms, the one who were admitted with us.
And how many babies were positive out of these?
Ma'am, only 2 babies were positive, and rest of the babies were negative.
And that's okay. So that's very little incidence, no?
Yes, ma'am. We have seen in other studies also that there is a vertical transmission in COVID.
Any problem that you noticed with any of these the mothers who were moderately to severely affected? Any problems that you had with these mothers?
Clinically, ma'am, they severely affected patients had stayed in ICU. Moderately affected women had only the fear that their COVID may further progress and it may affect their newborns.
What were the challenges that you faced? What were the challenges that you faced with these moderate to severely affected mothers for the intrapartum and the postpartum?
Ma'am, for the severely affected women, we face that delivery has even been conducted in ICU, or when the patients were shifted, we had to involve a multidisciplinary team. And in moderately affected women, we tried to postpone the delivery if possible to try this crisis period. At least we tried that we can postpone the delivery by a week so that the cytokine storm may get over by that time.
You didn't have to, induce any patient earlier for that reason because she was getting sicker because of the COVID. Was there any such case?
No, ma'am, we have not induced because we tried to postpone the delivery only, and we had not because COVID storm generally occurs at around 10th day. So we wanted patients not to be delivered during that period unless obstetrically.
Okay, and this COVID storm did not cause any problems to the baby as such?
No, ma'am, as we have discussed in the nursery,
the interleukins are so high at this COVID storm. Usually there's so much of a uteroplasmal abnormality during this COVID storm. So did you face any such problems? Therefore, I asked you whether did you have to induce any such patient because...
And some of the patients, a few of the patients who were of severe category and they had preeclampsia-like features. they had because of this cytokine storm or because of the changes induced by COVID, which in other studies also have said that there are cases where preeclampsia-like symptoms are presented. But one more thing that is common at the time of cytokine storm is oligoamnios. But somehow in our patients, we have not induced patients because of these reasons. Severe category patients we have not induced. We tried to wait unless until it was obstetrically indicated.
Thank you so much, Dr. Asta. We are running short of time, ma'am. I want to invite the next session. The next,
session.
yeah.
Thank you,
ma'am. Thank you so much,
AC
Dr.
बंद करना है, AC बंद कर रहे हो।
I would like to invite Dr. Garima Kachua.
गोली खा ले, गोली खाने से तब तक
The code is 4746. Dr. Garima? Dr. Garima, are you there? Ma'am, can you unmute your mic?
I have unmuted. Can you hear me?
Please.
Chalo.
Yeah, sure, ma'am.
एक से
Yeah,
तुम
we
पता
can
नहीं क्या
hear you,
बात
ma'am.
कर रहे हो, मैं इतनी पढ़ाई की बातें बता रही हूँ।
You can share your screen, ma'am. Yeah, sure, ma'am. Your time starts now, ma'am.
Okay, good afternoon, everybody. So I will be presenting my studies of oxidative stress markers and endothelial function assessment during pregnancy and correlation with the development of hypertension in pregnancy. It was a prospective cohort study. We all know that preeclampsia is associated with early oxidative stress before the development of the disease. And isoprostane F2 alpha, which is a very stable oxidative marker, is found to have significantly increased in women developing hypertension as compared to normal pregnant women. Isoprostane causes vasoconstriction and affects the vascular function. So we also assessed the vascular integrity markers, that is flow-mediated dilatation and pulse wave velocities, which are functional and structural markers of vascular function. We also did uterine artery Dopplers to find correlation with the oxidative markers. So a longitudinal assessment of endothelial integrity might represent to evaluate the satisfactory evolution of pregnancy and could help in early detection of development of preeclampsia. So the aims were to study the sequential changes at two time points in pregnancies, isoprostane F2 alpha, flow-mediated dilatation, and pulse wave velocities, to investigate whether the alteration in these markers early in the pregnancy differ in women who later develop gestational hypertension or preeclampsia. So the outcome measures were development of preeclampsia and gestational hypertension later in pregnancy. This was a prospective clinical study wherein the women aged 18 to 38 years with singleton pregnancy less than 11 weeks were included in the study, and women more than 38 years, multiple pregnancy and advanced pregnancy beyond 14 weeks, or with comorbidities, diabetes, or on some drugs were excluded from this study. So basically we included singleton low risk pregnancies for this study. So around 120 women were recruited, and at 3 point that is 12 to 14 weeks, 18 to 20, or 20 to 26 weeks, we did the physiological markers and taken sample for the blood markers, and the pregnancies are followed till term for development of hypertension or any other outcome, and the data was analysis. So our results showed that out of 112 patients, around 7% developed preeclampsia, 14% developed hypertension, and 85% of women remained normotensive. And the demographic profile of the women in the three groups were almost similar. So this is the slide showing the distribution of isoprostane F2 alpha throughout the pregnancy. Now, the most important thing is that in the course of the normal pregnancy, that is in low risk normotensive women, there was gradual increase in the isoprostane level till mid pregnancy, that is 18 to 20 weeks. And after that, there was a gradual decline later in the pregnancy. And while in gestational hypertension cases, it was a very significant finding in our study that the women developing gestational hypertension later in pregnancy showed very high levels of isoprostane alpha in first trimester, that is less than 14 weeks of pregnancy. However, if we see the women developing preeclampsia, their levels were higher than the normal, but their trajectory was almost similar to the normotensive women. So at around 18-20 weeks, when the second wave of placentation is almost complete, the isoprostane alpha has the maximum value. When we saw the physiological markers of pregnancy during the pregnancy, we found that in normotensive women, the values of FMD and pulse wave velocity were almost similar throughout the pregnancy. But in gestational hypertension patients, again, at first trimester, the flow mediated dilatation, which is a marker of functional endothelial integrity, was decreased, as well as for preeclampsia, but it was much more significantly decreased in women developing gestational hypertension. Now, pulse wave velocity. Pulse wave velocity is a marker of a structural abnormality, meaning thereby that the vessels, it is a marker of cardiac vessels stiffness, and it has shown that it was decreased in women with preeclampsia. That is, the vessels were more stiff and the arterial stiffness index was increased when the pulse wave velocity is decreased in women with preeclampsia. When we try to correlate with the isoprostane levels and these vascular markers with the birth weight, we did not find significant correlation between low birth weight or average birth weight women, but definitely in low birth weight patients, it was slight, the isoprostane levels were more, but the value was not statistically significant. So when we compared only the preeclampsia patients developing IUGR or not IUGR, we found that preeclamptic women, that is with development of IUGR, had significantly higher values of isoprostane as compared to women who did not have, meaning thereby mild preeclampsia without severe features in terms of fetal affection, they were not having very high levels of isoprostane. So in the discussion, this was one of the first studies where we had differentiated the preeclampsia with gestational hypertension to correlate the oxidative stress markers. And F2 isoprostane is one of the reliable biomarkers of oxidative stress and is very stable in biological fluids. So it is one of the preferred biomarker to be assessed for oxidative stress. Isoprostane F2 alpha was reported to be higher in pregnancy as compared to non-pregnant level, and was much higher in pregnancies with preeclampsia than normotensive patient. This was shown by Laros et al. In 2013. The elevated urinary F2 isoprostane were also associated with 5 times increased development of hypertensive disorders in pregnancy. When we try to correlate the development of hypertension with isoprostane alpha and we created the ROC curves, we found that the ROC for I'm just finishing, for development of gestational hypertension was best correlated with isoprostane. So isoprostane had an area of curve under 0.7 for prediction of development of gestational hypertension. So the strength is that it is a prospective study, sequential changes were measured in the pregnancy, and limitation is small size and limited period of study. So to conclude, the differential expression of oxidative markers is there in hypertensive disorders of pregnancy. If we study these markers in detail, we will be able to differentiate in the first trimester whether this patient is going to develop gestational hypertension or preeclampsia, as there is an increased oxidative stress in women developing gestational hypertension as compared to preeclampsia, wherein in the first trimester, the preeclamptic women behave mostly as a normotensive women. Thank you so much for your patience.
Thank you so much, Garima ma'am, for this wonderful presentation. Now the topic is open for discussion.
Sure, thank you.
Hi, Dr. Garima.
Hello.
Hi. I just wanted to know how, how did you actually analyze the sample of the isoprostane? Is it very easily available?
Actually, this is practically we recommend only in the research setting.
Research center.
Yeah, because we are just trying to correlate the levels of oxidative stress. Usually, we have seen that it is very closely related with chronic disorders, essential hypertension, chronic vascular disorders. So we want to see that what is the effect of oxidative stress in pregnancy, and does it behave similarly in gestational hypertension and preeclampsia? Because from our clinical experience, we know that preeclampsia is a very different entity of a disease as compared to gestational hypertension. So if we are able to differentiate them in the first trimester, it will be a very good study, and we'll be able to triage the low risk women into two categories where they can be referred for higher services if they are at risk of developing preeclampsia.
So according to you, these three are oxidative stress markers: the isoprostan, the FMT, and the PWV.
Isoprostane is basically a oxidative stress, and
these were the endothelial assessment.
They too are which are affected by the oxidative stress.
And how did you measure the endothelial assessment with these two
Yeah,
parameters?
these two tests are very easily measured. They are non-invasive. They are measured like an ultrasound. They have a probe. So as an advanced ECG plus ultrasound.
Which blood vessel do we use?
Yes, ma'am.
Which blood vessel do we use for the assessment?
We usually do in this test, we usually do the carotid femoral or the carotid radial, when we can see the aortic arch is taken into account. So we usually do carotid brachial and carotid femoral. So we can see the changes in the large vessels, and then we can correlate with so it's a very simple non-invasive way of, but still it is in the research setting. But we have done a lot of work on FMDs, and we have found that in preeclampsia, it has shown an effect, but the correlation is mostly at 24 to 26 weeks, a little closer to the clinical presentation of the disease. We want to go a little further at first trimester.
First
We need
trimester.
a bigger studies, so we are now planning a big study because the sample size was too less to, definitely say that it has an effect.
Thank you so much, ma'am. Thank you for your time. And it's a wonderful presentation. I would like to move on to the next session with the permission of the chair. Thank you so much, ma'am. I would like to invite Dr. Anju Singh. Dr. Anju Singh, her code is HRP 0747. Dr. Anju?
Yes. Good evening, everyone. Am I audible?
Your screen? Yeah, we can hear you.
Should I start?
Yeah, you can share your screen.
Yes,
6 minutes for the presentation and 2 minutes for the discussion.
Is it visible, my screen?
No, not yet. Not yet. Backup team, please help her.
Dr. Anju?
Dr. Anju?
Yes.
Yes, please click on the share screen button.
Yes, I have clicked that.
Yeah, please click on the desktop. You see that option. Dr. Anju?
Yes.
Yes, ma'am. Please click on the share screen.
I have clicked on that.
Ma'am, you have options there.
Yes, I have clicked on desktop also.
And please click on share.
Is it visible?
Yeah, ma'am.
Yeah, it's visible. You can start, Dr. Anju. Your time starts now.
Okay. Good evening, everyone. Myself, Dr. Anju Singh. I will be presenting my study done to know the distinct pro-inflammatory markers in gestation hypertension and preeclampsia. It was conducted as a prospective study. As we all know that the hypertensive disorders of the pregnancy have an underlying mechanism of endothelial dysfunction and elevated immune response. There are a number of markers for the prediction of hypertensive disorder of pregnancy, and the neutrophil lymphocyte ratio being a new addition to the group. Now, the current evidence suggests that the diagnostic accuracy of neutrophil to lymphocyte ratio has acceptable sensitivity and specificity of 74% and 64% respectively necessary for the diagnosis of preeclampsia. Still, the study in literature has mainly focused on the predictive role of NLR and the platelet lymphocyte ratio, mainly for the prediction of preeclampsia. But we conducted study to evaluate these values to differentiate between the normal patients' preeclampsia and gestational hypertension. The aim of my study was to evaluate neutrophil lymphocyte ratio, monocyte lymphocyte ratio, and platelet lymphocyte ratio in early pregnancy, and to correlate these inflammatory markers in first trimester with development of hypertensive disorder later in the pregnancy. It was conducted as a prospective observational study, the Department of Obstetrics and Gynecology AIIMS, and in this study we recruited women with singleton pregnancy at the early gestation 12 to 14 weeks, and a total of 136 pregnant females were recruited over a time period of January 2019 to July 2020. The main outcome measures were gestation hypertension and preeclampsia. For the statistical analysis, SPSS version 20 was used. Unpaired and independent student t-test were used to compare two group means. One-way ANOVA was used to compare mean between different groups, and ROC curves were made to obtain the cutoff value for an optimum sensitivity and specificity. P-value of less than 0.05 was considered as statistically significant. So this is the flow diagram showing the recruitment of the patient in our study. In this, all the pregnant women attending the antenatal clinic were screened, and the exclusion criteria of my study were multiple gestation and any chronic illness like chronic kidney disease, chronic hypertension, autoimmune disorders which affect these inflammatory markers were excluded. And then the blood sample were collected to know the total and differential leukocyte count at 12 to 14 week of period of gestation, and each study subject was followed till the time of delivery and were looked for the development of either gestational hypertension, preeclampsia, and then the data was analyzed. So we could see that out of the 136 women who were recruited into the study, 25 women developed preeclampsia later in their pregnancy outcome, and 12 women out of 136, that is 8.82% women developed gestational hypertension, while 99 women remain normotensive. So this is the table showing the baseline characteristics among the three groups. As we can see that the age was similar among the three groups. The BMI, although was more in the gestational hypertension and preeclampsia group, but the difference remained statistically non-significant. And as expected, the systolic blood pressure and diastolic blood pressure was more in the patient developing gestational hypertension and preeclampsia, but the difference was significant only for the diastolic blood pressure. Now, this is the table showing the value of the different systemic pro-inflammatory markers. First, the total leukocyte count. As we can see, it was more in the patient developing gestational hypertension later in the pregnancy, and it is more than the patient who remained normotensive and developed preeclampsia, and it was statistically significant. Then we calculated the different ratios, and we could see that the neutrophil lymphocyte ratio, it has a significant, it was more in the women developing gestational hypertension later in the pregnancy, and the difference was also statistically significant. However, there was no difference between the neutrophil lymphocyte ratio between the normotensive group and the preeclampsia group early in the period of gestation. The platelet lymphocyte ratio was also statistically more higher in the patient developing gestational hypertension in the course of pregnancy. This is a table showing the outcome measure among the three groups, and we could see that there was the mean gestational age as delivery was more in the control group and hypertensive group, but this difference was not statistically significant. Similarly, there was no significant difference in the mean birth weight, Apgar score at 1 minute and Apgar score at 5 minutes among the three groups. Then we made the ROC curve to know a cutoff value for the prediction of to find out a cutoff value for these markers for prediction. And we could see that the TLC has an area under curve of 0.73, and at a cutoff of more than 10.5 per microliter, it had a sensitivity of 67% and specificity 74% for prediction of gestation hypertension later in the pregnancy. Similarly, for the NLR and PLR.
Dr. Anju, we have 30 seconds.
NLR has a...
We have 30 seconds for this session.
Yes, sir, I'm just finishing. NLR at a cutoff of 3.76 and PLR at a cutoff of 11.8 has a sensitivity and specificity of 67 and 66% respectively. Now, there are similar study in the literature which has shown that the NLR has a reasonable sensitivity and specificity for the prediction of hypertensive disorders. So we can conclude that at first trimester, there is differential response of the inflammatory markers in normotensive pregnancy patient remaining normotensive or developing hypertensive disorder of pregnancy. And there is exaggerated inflammatory response right in the first trimester in the patient who destined to develop gestational hypertension.
ये आप ये एक डॉक्यूमेंट भेज सकते हो कैसे भी करके, मतलब ये डॉक्यूमेंट शेयर नहीं हो रहा.
The strength of my study was it was a prospective study and it used a non-invasive test for prediction of hypertensive disorder of pregnancy, and the limitation was it had a small sample size. Thank you for your kind attention.
Thank you so much, Dr. Anju. It's a nice presentation. Now the topic is open for discussion.
Yeah, so basically, I mean, Anju, I found that, I mean, why are we actually doing a study to find out some marker not for preeclampsia but for gestational hypertension? I mean, preeclampsia being much more required situation wherein we would want to find or predict something early rather than a gestational hypertension. And then as we found out that oxidative markers or any of these markers that the pro-inflammatory markers, they are almost the same as in a normotensive or a preeclampsia patient. I mean, a patient who develops preeclampsia later, whereas with a gestational hypertension. So probably the placental factors have a much bigger role than these factors in this condition.
The idea behind my study was that it used the simple blood test which we are routinely doing in our pregnant patients.
Yeah, definitely. I mean that I agree with you that I mean it's a very cost-effective thing which we do it for everybody. We do a CBC for everyone and we can just compare the study. But then I mean we are trying to look for any marker which is there. I mean which can predict a preeclampsia than any other situation. So.
Ma'am, secondly, these markers can be easily done at some peripheral center also. So if we can predict early in the course of pregnancy, then we can triage the pregnant patient to make an appropriate referral at a time, because the timely intervention can definitely make a difference in the final outcome of the patient. And secondly, it also shows that the gestational hypertension follow a similar course like essential hypertension, because it has a inflammatory change. So it points towards the etiopathogenesis also, that it has a similar pathophysiology as essential hypertension. So this can give some insight in future more in the pathophysiology of the disease. And
I think a very big strength is that it's very easy to do. Yes. In smaller, it is not a hi-fi thing. You don't require very big equipment, and could be done at small rural setting also. This could be done because I think CBC can be done in a rural setting also. Yeah.
And then, ma'am, we can refer the patient timely by triaging them, so that because we know the outcome is different in the hypertensive disorder and normal patient.
Thank you so much. Any other questions, ma'am? Any more questions?
No, that's it. We can move to the next one then.
We can move to the next. Thank you so much. We can move to the next presenter, Dr. Sonam Yadav. Dr. Sonam. Her code is HRP 0749. Dr. Sonam.
Dr. Tarun, she is facing some technical issue. Can we wait for
Okay.
minutes?
So should we? She's the last presenter as of now. We are waiting, ma'am. Sonia ma'am, Sandeep ma'am. We can wait for some more time because she's the last presenter.
Okay. Fine, we'll wait.
Okay. Yeah, we can wait for 5 minutes. She's relogging, ma'am.
खा लो, आज तो प्रसाद है।
I should congratulate you all. I mean, it's such a beautifully organized this thing. I mean, hats off to you all people. I mean, you all have organized it really well.
Thank you so much, ma'am.
Very nicely.
On behalf of the team, I am taking the compliments.
It's very well organized.
And it just stayed on time, Sonia. If you notice.
And the way, I mean, and the communication is so good.
Yeah.
I mean,
yeah.
sending the things earlier and then confirming it again half an hour before, 15 minutes before. Very superb.
Lot of coordination they have done. Very good coordination.
Yeah, very nice.
I would also like to add that it was not only on time, it was before time. I
Yeah,
got a call,
yeah.
ma'am, please join it. It is before time.
And because I was driving, I was coming home from the clinic and he just said that, ma'am, aapko link bhej rahe hain. I reached at around 4 o'clock only. Yeah.
And it is flawless. It is amazing.
Amazing.
Yeah, very good. Very good.
Great effort. Hats off.
Thank you so much. I'll convey these all compliments to my team.
Oh yeah. And hats off to both the judges. You literally killed all of them with your questions. I was so scared when my turn came. मैंने कहा कैसे भी करके सोनिया का तो चला जाना चाहिए connection.
Sonia.
गरिमा की तो मेरे को तो ऐसा लग रहा था गरिमा की पता नहीं is गरिमा really coming or she's sending someone? I was like looking at your name and
no, actually both times I didn't present because of some reason, so I thought let me do it. Until unless you don't take it, you don't get a picture for your own study. आपको लगता है आपने बहुत बड़ा तीर मार लिया. जब आप present करने लगते हो तो लगता है नहीं, a lot of improvement is required.
It's always
Ma'am,
nice to present. Yeah.
Yeah, good afternoon, ma'am. Ma'am, there's some technical
Yeah.
error from the last presenter. So we have to stop over here this session. She can be adjusted in some other session in the later one.
So we'll send our sheet then. We will send our sheet
Yeah,
to
yeah.
you. Yeah.
Yeah, you can send sheet to aogdvirtuals@gmail.com. You can send it to this email. Okay.
Yeah.
And
You just do it. Just do it.
yeah, thank you.
Thank you so
Thank you
much.
so much. Thank you so
Thank you.
much, all the
Thank you.
judges, and for your kind time, and we can end up in the right hours. Thank you so much.
Thank you so much. Thanks.
Okay, bye-bye. Thank you.
Bye.
Bye, bye, ma'am.
Hello, Dr. Nancy.
Yeah, hello.
Yeah. Wait a
Hi,
second, ma'am. I am adding the judges. Then start.
Yeah, and Shivam, welcome address I have to give or you will say?
Ma'am, you will say.
Okay, okay.
Yeah.
Hello?
Hello. Hello, ma'am.
Yeah. Hi, Dr. Nancy.
Hi, ma'am. Hi.
We are connected.
Yeah, we are connected. We have our presenter has also been connected. And as I informed you, Dr. Sonal Yadav is one which has joined and Dr. Shea Blani will not be joining us.
Yes. Yes.
We'll be just starting in a short while as soon as.
Yeah. And Dr. Sonal will speak right in the end.
Yes. And Dr. Shushma has not joined. We are not able to contact her. So she's the third judge. So we are just waiting for her also for 2 minutes. She can join us. Dr. Natasha.
I think we can see our first presenter.
Yes. So, ma'am.
Yeah, good evening, Natasha.
So I welcome everyone for this free paper session and this free paper session of 42nd annual virtual AOGD conference. And before starting the session, I'll just remind all our presenter, the oral presentation is for 6 minutes and the question answer session is for 2 minutes. And being on time has got in your marking system also, and you can score your mark if you are on time. So just stick to your time so that all the presenters are able to present the thing, and we can also finish the sessions on time. So now introducing the judges. Our first judge is Dr. Leena Sridhar. She is the head of the department, Academics and Research, Manipal Hospital and Delhi. Then she's also the consultant Obs and Gynae, Manipal Hospital. Then we have Dr. Rashmi Malik. Madam is an associate professor, University College of Medical Sciences and GTB Hospital. Our third judge is Dr. Sushma Sinha, Senior Consultant, Apollo Hospital. We will just be waiting for her, but we can start the session. If she can join the between. So, and our first presenter is Dr. Natasha Tyagi. Her topic is prevalence of satisfaction and complication rate in IUD users in low resource setting. So over to judges now.
Thank you, Dr. Nancy.
Dr. Natasha.
Yes, good evening, ma'am.
Yeah, good evening, Natasha. Please go on.
Okay. So good evening, everyone. I'm Dr. Natasha. The title of my study is the prevalence of satisfaction and degree of complications in IUD using women in North India. The study was conducted at the Department of Obs and Gynecology in UCMS and GTB Hospital, New Delhi. So copper IUD is a very important part of the armamentarium of contraceptive methods in India. In fact, it is one of the most effective contraceptive measure, but only 1.5% of the currently married women between age 15 and 49 years use it, according to the NFHS 4 data. The reason being the baseless myths and misconceptions associated with it, and these need to be broken based on objective data. The aim and objective was to study the prevalence of satisfaction and the degree of complications in IUD users. The materials and methods, study design, it was a cross-sectional observational study. The place of study was the Obs and Gynae department of GTB Hospital. The sample size included 200 patients attending the family planning OPD, and the study duration was of 2 months. The methodology was questionnaire-based. The patients were interviewed by pre-designed performer for the demographics, the complication, and the degree of satisfaction. Appropriate tests for statistical analysis were applied. The inclusion criteria was the current IUD users who were attending the family planning OPD, and the exclusion criteria were people who were not willing for interview. The outcome measures included satisfaction rate among the IUD users, the complication rate among the IUD users, and the removal rate of IUD due to its complications. The results were: the mean age of the women in our study was 27.59 years. 51% of the women were illiterate or had primary education. 87% of the women belonged to the lower or the lower middle socioeconomic strata. 52% of the patients were para 2 and 87% of the patients were housewives by occupation. Now, 91% of the women had copper T380A inserted and only 9% of the women had multi-load insertion. 45% of the women had postpartum insertion, followed by 44% who had interval insertion, and only 12% had post-abortal insertion. The degree of satisfaction out of 200, 179 patients, that is 89.5% were satisfied, and only 21, that is 10.5% were unsatisfied with their IUD. The complication and distribution: the patients with complications were 87 out of 200, that is 43.5%. Out of these 87, all had cramping pain. 80 patients had change in menses, which were increase in amount in 75 patients, increase in frequency in 52 patients, increase in duration in 64 patients, intermenstrual bleeding in 49 patients, and dyspareunia in 48 patients. Now, the association of complications with satisfaction was studied. So, complications were present in 87 out of 200 women. Out of these 87, 70 women fell in the satisfied group and 17 women fell in the unsatisfied group. That is, 39.1% of the women who were satisfied had complications and 81% of the women who were unsatisfied had complications. So this association was statistically significant with p-value less than 0.001. Now the duration of bleeding problem. Out of the 200 patients, 80 patients had bleeding problems. Out of these 80, 61 had bleeding problem only for the first 6 months. And as the duration exceeded, the bleeding problem decreased, with only one user having problem of bleeding lasting till 36 months. Now, patients seeking treatment: out of 87 patients with complications, only 26 patients sought treatment for their complications. The reasons for seeking treatment among these were: change in menses in 26 patients, increase in amount in 26, increase in frequency in 16, increase in duration in 19, intermenstrual bleeding in 12, pain in 20, and dyspareunia in 14 patients. Now, patients wanting removal: out of the 200 patients, only 18, that is 9% of the patients wanted removal of their IUD. Out of these 18, 8 patients wanted to conceive, 1 patient had come under family pressure, 1 had time completed, and only rest of the 8 patients wanted the removal of IUD for their complications. That is, only 4% of the total patients wanted removal due to its complications. So, the mean age of the patients in our study was 27.59 years. Out of 200, 89.5% of the population was satisfied. 43.5% of the population had complications. The commonest complication was cramping pain, seen in 87 patients, followed by change in menses, seen in 80 patients. Out of these 80, 61 had change in menses, which lasted only for the initial 6 months. So only 13% of the patients needed treatment for their complications, and only 4% got the IUD removed for its complications. So we conclude that despite complications, the patients had a good satisfaction rate of 89%, which implies that the side effects present were either short-lasting or insignificant. So our study proves the requirement for better counseling and public awareness for increasing the usage of IUD, and instead of highlighting the complications which instill fear in the minds of laymen, its many advantages need to be highlighted. Also, if the patient is properly counseled that there will be some complications, but they are not long-lasting and can be treated medically, the patient will be more satisfied with her choice of contraceptive. Thank you.
So we have 20 seconds still left.
Yeah. She scored on that, on the timing, I think.
Yes. Yes.
So, ma'am, Dr. Leena.
Yeah. So I think, Natasha, you got the point that you wanted to highlight by doing this study very well across. That is that they are basically the myths which are,
Yes,
preventing women from more and more coming forward for using this very simple method.
Yes,
and this kind of a study and these kind of statistics are what we can actually discuss with our patients when we are going in for counseling.
Yes, ma'am. Actually, there are complications, but the so-called complications are not enough. That the patient wants removal of the IUD for that. So that is an objective data which came across in our study.
Correct, because when we sit in an OPD and we want to, one I noticed is that most of your patients were of the low socioeconomic. So
Yes,
when you
ma'am.
go a slightly higher up, start getting like in the higher end, you find that women come with a lot of preconceived notions. The ones who are very well educated also, so they put these points across that it's going to cause this, and they don't want to even accept that measure. So I think this message is very nicely brought across, and we could use these statistics to counsel our patients. That's more important, and more come forward.
Yes, ma'am. Instead of
And I'm glad you've kept to the time, Natasha. That's good. That's a good start.
Thank you, ma'am.
Natasha, I just wanted to know, like, your patients were complaining of cramping and bleeding problems.
Yes, ma'am.
Right? So was it related to the duration of since when they were using IUCD?
Ma'am, the bleeding problem, ma'am, 80 patients had bleeding problem. Out of those 80, 61 had problem only for the first 6 months. So, so the patient gradually, after a certain amount of time, the complications settle down on their own. Only 26 opted for treatment.
So what does the literature say? How much like you have to do? You said you think that
the literature
better
says
counseling. Yeah.
The literature says that the complications decrease over a period of time. The complications are more only for the initial period.
You have to quantitate, no? When you are doing the counseling, you have to actually quantitate and
So,
tell
ma'am, in
them.
our study, the bleeding problem was significantly present in only for the initial 6 months.
6 months, yeah.
Yeah.
60 out of 80, that is 2/3, almost 80% patients had complication only for the first 6 months.
Yeah, so this is a very important message.
Yes, ma'am.
Yeah, so you brought it across quite well that it should come under the first 6 months, and that's what we'll tell our patients. Yeah.
Yes.
Okay. Natasha.
Okay.
Thank you, ma'am.
Thank you.
So
Can
now
we go to the next?
I think we'll just
speaker?
take 1 or 2 minutes to score.
Shall I leave?
So our second presenter is Dr. Shivangi Sharma, and her topic is ultrasonographic assessment of cervix for prediction of successful induction of labor. Over to Dr. Shivangi.
Good evening, ma'am. Today I will be presenting my study on the topic ultrasonographic assessment of cervix for prediction of successful induction of labor.
Can we have your video, Shivangi?
Yeah, sure, ma'am. Just a second, ma'am. Sorry, just a second. Ma'am, I'm not just okay, ma'am. I hope it's visible, ma'am.
There you are.
Sorry.
Yeah, hi, Shivangi. You can start.
Hello, good morning, good evening, ma'am. I'll be presenting my topic, presenting my study on the topic ultrasonographic assessment of cervix for prediction of successful induction of labor. Induction of labor is done in 20 to 30% of all the pregnancies, and nearly 20% of labor induction ends up in cesarean delivery. Successful induction depends majorly on the readiness of cervix or cervical ripening. Bishop score is a gold standard traditional method for assessing the cervical favorability. However, Bishop score lacks objectivity and is biased by inter-observer variations, and it does not measure the cervical characteristics very precisely. And it is also associated with the fear of examination, anxiety, pain, and discomfort amongst the parturian. High-resolution ultrasonography has permitted more accurate imaging of the uterine cervix and the lower uterine segment during the pregnancy, and can help us in standardizing the way to assess the favorability of cervix. However, these studies till now has focused upon the transvaginal sonographic measurement of few parameters like cervical length and funneling. Some studies have also been done on the determination of fetal head station by head pain progression distance and angle of progression, but the literature on the relation to induction of labor is scanty. Our aim of our study was to assess the role of transvaginal sonography in prediction of successful induction of labor. It was an observational cohort study that was conducted in Department of Obstetrics and Gynecology in Vardhaman Mahavir Medical College and Safdarjung Hospital on 140 antenatal women who were admitted in our ward with a single life pregnancy in cephalic presentation with intact membrane and at 37 to 42 weeks of period of gestation with a normal AFI. In our study, every fifth patient who was planned for induction of labor and fulfilled the inclusion criteria was recruited, and informed consent was taken, and patient was asked to empty the bladder. This was followed by a transvaginal sonographic assessment of the cervix, which was done within 1 hour of induction by a single observer who was to avoid the inter-observer bias. And the ultrasonographic cervical length, funneling width, position of cervix, cervical width, angle of progression, and head progression distance was measured. This was followed by digital cervical assessment by another observer who was blinded to the transvaginal sonographic findings. And followed by this, the labor outcomes were measured in terms of women who entered the active phase of labor within 24 hours. That is what we said as successful induction. And also the patients who needed augmentation, and the mode of delivery was also recorded. This is the transvaginal sonographic images showing the cervical length, cervical width, funneling length and funneling width, straight shape of cervix, angle of progression, as well as the head progression distance. In our results, it was found that out of 140 women who were enrolled for the study, 124 had successful induction, that is, they reached a 4 centimeter level of dilation, whereas 16 women had cesarean section done for failed induction. Out of these 124 women, 85 women had their labor augmented. And out of these 85 women, 3 had cesarean section done for indications other than the failed induction, whereas rest 82 women had normal vaginal delivery. This is a table showing the predictive accuracy of various ultrasonographic parameters for successful induction of labor. And it can be seen that amongst all ultrasonographic parameters, angle of progression had the maximum sensitivity, whereas ultrasonographic cervical length and angle of progression has the maximum positive predictive value. The combined sensitivity and specificity of the ultrasonographic parameters was 89.52% and 100% respectively. This table shows the predictive accuracy of various components of Bishop's score for successful induction of labor, and it is seen that position of cervix was found to be more sensitive, whereas station of head was found to be more specific. And among the Bishop parameter, Bishop's cervical length was having the maximum positive predictive value. The combined sensitivity and specificity of the Bishop score was 83.06% and 50% respectively. This is a table showing the comparison between the predictive accuracies of ultrasonographic and Bishop parameter, and it was evidently seen that the ultrasonographic parameter have a better predictive accuracy as compared to the Bishop score, and the difference between the two was statistically significant. In our study, ultrasonographic parameter were found to be more sensitive, specific, and had a better positive predictive value as compared to the conventional Bishop score. Presence of nearly 2 out of 6 ultrasonographic parameters greatly improves the prediction of successful induction of labor and has a higher diagnostic accuracy as compared to the conventional Bishop score. In contrast to ultrasonographic parameter, a Bishop of more than 4 was taken as a cutoff for successful induction, but it was not statistically significant, and the predictive accuracy was visibly feeble as compared to that of ultrasonography. Similar results similar to our studies were found by Park et al., Bartha et al., Weir et al., and Gabriel et al., as well as Bajpai et al., wherein they all concluded that ultrasonographic cervical length is a better predictor of successful induction of labor as compared to the conventional Bishops. Also, cervical wedging measured ultrasonographically was also found to be a better predictor than cervical length and Bishop in a study done by Buzameri et al. In a study recently done by Al-Edbi et al. In 2018, it was demonstrated that posterior cervical angle is a better predictor of successful induction of labor as compared to the Bishop score and the cervical length. The strength of our study was the previous study evaluated a combination of maximum 3 ultrasonographic parameters. However, in our study, 6 ultrasonographic parameters were assessed and their accuracy has been calculated. Evaluation of the cervical width as a predictor of successful IOL has been done the very first time in our study. Also, the sonographic assessment was done by a single observer who was blinded to the results of the transvaginal sonographic findings, and who was blinded to the results, and therefore inter-observer variation was reduced. However, the limitations of our study was the consistency of cervix with elastography was not measured, and also other parameters which are new in this field like posterior cervical angle, cervical area were not included in our study. So hence we reached this conclusion based on our study that ultrasonography as an objective method for pre-induction cervical assessment has better predictive accuracy than conventional Bishop score, and thus can be used for induction of cervical for prediction of successful induction of labor. Thank you, ma'am.
So now we can start the question answer session, ma'am. Just 15 seconds.
Shivangi, I have a very small question for you. You haven't mentioned what tool was used for inducing labor.
Ma'am, here we use the dinoproston gel only, ma'am, for induction.
All cases?
All the cases, yes, ma'am.
There was absolutely no difference?
No, ma'am. We use the dinoproston gel for every patient that we have induced in this study.
Okay.
So, okay, because in your flow chart, you had mentioned that the patients who needed induction of labor, then they had augmentation of labor also.
Ma'am, after induction with dinoproston gel, after
you had added oxytocin. Oxytocin was added.
Yes, ma'am. If it was added, then we have also recorded that whether these patients needed oxytocin further or not.
Yeah, so and quite a big number, isn't it? 85 required augmentation.
Yes,
and only I think 32 had spontaneous delivery, right?
Yes, ma'am.
Yeah. Okay. So you used only dinoproston gel?
Yes, ma'am. Yes, ma'am.
Okay.
How many maximum doses you used?
Ma'am, in our institution, we use maximum of 2 doses.
You use only 2 doses?
Yes, ma'am.
Okay. And after 2 doses, you labeled them as failed induction. If they did not go, the labor was not.
Ma'am, no. After, if in our study, ma'am, failed induction was taken as those cases who didn't progress to 4 centimeter after induction with dinoproston gel and after symptom augmentation. If they didn't progress to 4 centimeter within 24 hours of 24 hours of the induction, ma'am, then we label them as a failed induction.
Just a thing I would like to add, just by the way, of course, that has nothing to do with what Shivangi, because Shivangi was assessing basically the ultrasound predictors, you know. I do feel that we have a lot to say about the kind of, route that we use for inducing labor. I personally find Propes, the long-acting dinoproston 3 much better than using the gel. But that is, of course, a different issue.
Surely, ma'am, we'll consider it in the maybe next time.
What do you think, Shivangi? Which one is better, gel or the insert, like Dr. Leena is saying? So,
ma'am,
the inducing method with Serbi means dinoproston, different methods. Which one is better?
Ma'am, amongst dinoproston and the gel form, are you asking, ma'am? Sorry, ma'am.
Yeah, gel and insert.
Ma'am, to be honest, in our institute, we have been more exposed to the dinoproston gel, but we have also tried some of the inserts also. But according to me, I guess dinoproston gel is.
Have a knowledge also, no, not.
Yes, ma'am. Yes, ma'am. Yes, ma'am. We have a propase insert. We insert propase in our institute, ma'am. We have more exposure to the dinoproston gel.
Okay.
Okay.
And out of elastography and ultrasound and Bishop, which one, as per evidence, is the best one?
Ma'am, currently ultrasonography, in the newer studies, it has been found that ultrasonography is more objective and is a better predictor than Bishop, because Bishop is quite subjective.
About elastography.
Ma'am, elastography in terms of our patients, it will be only measuring one of these 5 or 6 parameters that are necessary for us. So only one parameter, I don't think it's fair to compare one parameter with the rest of those. So,
correct.
But if it had been included, it would have been a much better. It would have been a direct comparison between the two.
Okay, fine. Thank you, Shivangi.
Thank you, ma'am.
I think that is well said, Shivangi. And personally, I feel you should all start using Propes, because you can keep it for 24 hours. And it's giving me excellent results.
Surely,
instead of putting dinoproston.
That's a better means that is a better method of it.
Much better.
Okay, surely. Thank you so much, ma'am.
Okay, thanks.
Now we'll call upon the third presenter, Dr. Ayushi Pal, and her topic is role of vaginal pH on the efficacy of dinoproston gel in cervical ripening for labor induction. Over to Dr. Ayushi.
Good evening, ma'am. Is it visible?
Yeah, it is visible. Slideshow kar do bachche. Please do the slideshow.
Yes, ma'am.
You are not visible, Ayushi.
Yes, ma'am, I'm doing video. Good evening, ma'am. Today is my topic for presentation. It is the role of vaginal pH on the efficacy of Dinoprost gel in cervical ripening for labor induction. Induction of labor, it is defined as an intervention intended to induce labor before its spontaneous onset, which initiate uterine contractions and leading to progressive dilatation and effacement of the cervix and the birth of the baby. The prostaglandins are organic acids that have low solubility in aqueous solution with a low pH. Their absorption and cervical ripening, it is affected by change in vaginal pH during pregnancy. Recently, the vaginal pH, it is investigated as a potential factor influencing efficacy of prostaglandin for cervical ripening and labor induction. The vaginal pH in pregnancy, it is acidic 3.5 to 6. A variety of factors alter normal vaginal pH, such as presence of cervical mucus, amount of vaginal transudate, lower genital tract infections, bacterial vaginosis, and the ruptures of membrane. Aims and objective. Study the role of vaginal pH on the efficacy of Dinoprost gel in cervical ripening for labor induction. Study design was prospective observational study. It was conducted in Department of Obs and Gynecology, Dr. RML Hospital. Study duration was from 1st November 2018 to 31st March 2020, including 95 pregnant women admitted for induction of labor. Primary outcome, improvement in Bishop score after 6 hours and 12 hours. Secondary outcome, induction delivery interval. And third was mode of delivery, whether it is vaginal or cesarean. Inclusion criteria, singleton pregnancy with cephalic presentation at term, Bishop score of less than 6, assuring fetal heart rate. Exclusion criteria, known case of cardiac disease, glaucoma, asthma, placenta previa, suspected chorionitis and vaginal infection, history of uterine surgery, and contracted pelvis. Methodology, each patient underwent a speculum examination and vaginal pH was assessed with pH indicator paper strip. Works on the basis of the principle of the change in the color of the strip containing a reagent on exposure to a particular pH. The indicator paper was placed on lateral vaginal wall between two valves of the cuscus until it became wet. Color change of the strip was immediately compared with manufacturer colorimetric scale within 15 seconds. Vaginal examination was performed to determine the pH score, Bishop score. All patients received Dinoprost gel intracervically. After 6 hours of gel installation, Bishop score was reassessed. Depending on the Bishop score and uterine contraction, either Dinoprost gel was repeated or labor was augmented to up to maximum 2 doses. Association of Bishop score with vaginal pH. The patients with vaginal pH more than or equal to 5 had significant improvement in the Bishop score at 6 hours in 94% patients as compared to 40% patients with low vaginal pH less than 5 with a statistical significant p-value. Patients with vaginal pH more than or equal to 5 had significant improvement in the Bishop score at 12 hours in 58% patients as compared to 25 patients with low vaginal pH with a statistically significant p-value. Induction delivery interval was less than 12 hours in 81% patients with high vaginal pH more than or equal to 5 as compared to 21% patients with low vaginal pH. Induction delivery interval was more than 12 hours in 78% patients with vaginal pH less than 5 as compared to 18% patients with low pH. There was significant association between induction delivery interval and vaginal pH. Patients with higher vaginal pH more than or equal to 5, it had normal vaginal delivery in 79% patients as compared to 15%. 42% patients underwent LSES, of which 83% patients had low vaginal pH as compared to 15% patients with high vaginal pH. There was significant association between vaginal delivery and vaginal pH. It has been observed that higher vaginal pH alters efficacy of intravaginally administered prostaglandin. PGE2, it has low solubility at lower pH, so absorption of PGE2, it increases at higher pH. Present study results were supported by Sumati V et al., Singhu et al., and Goswami et al., all of which show significant association with high vaginal pH in respect to improvement in Bishop score, induction delivery time interval, and mode of delivery. The results were in contrast to Ramsey et al., which noted no statistically significant association in induction delivery time and mode of delivery. Therefore, use of vaginal pH for pre-induction cervical assessment will help healthcare workers to predict labor outcome. Accordingly, patients can be referred to tertiary care centers early for better management. Major limitations in the present study was small sample size. The influence on maternal and the fetal complications have not been analyzed. The strength of our study was that it was non-invasive technique, objective, easy, reliable, and gave a reproducible documentations of finding, which can help any healthcare worker to predict the labor outcome. The present study was conducted on 95 patients only. 55 patients had normal vaginal delivery, and induction delivery interval was also reduced. It is an objective, more reproducible, and the quantitative method which can be performed easily in any setup by any healthcare worker. Determining vaginal pH prior to induction, it may help us in predicting the success of labor outcome. Thank you.
Okay. Okay, Ayushi.
Yes,
So
ma'am.
what was the cesarean rate in your patients? Like you said, out of 95, only 55 had vaginal delivery.
Yes, ma'am.
It was very high cesarean rate, no?
Yes, ma'am, mostly, but the cesarean rate, the indication was due to the failed induction.
Yeah, so that is a very high rate.
Yes, ma'am.
For a failed induction. So how much Cerviprime you had used?
Ma'am, maximum 2 doses. In our institute, we use maximum.
What is the quantity? What is the quantity?
Ma'am, 0.5 mg.
So you had put in intravaginally?
Ma'am, intracervically, ma'am.
Okay. So you use maximum of 2 doses?
Yes, ma'am.
So can we use 3 doses?
Ma'am, we can use, ma'am.
So why you people don't use 3 doses? What are the recommendations?
Ma'am, we can use up to 3 doses, ma'am. After 3 doses, it will be labeled as a failed induction.
So you were labeling failed induction after 2 doses?
Yes, ma'am, because we were seeing the improvement in Bishop score at 6 hours and the 12 hours. So we were considering only the 2 doses for that.
So after 12 hours, if there is no improvement, so then you take up for failed induction?
Yes, ma'am.
What is the definition of failed induction?
Yes, ma'am.
What is the definition of failed induction? When do you call it a failed induction? Because it's a very high number that you people are doing cesarean for failed induction, approximately 50%, no?
Yes, ma'am.
Okay.
Yeah, so I also feel that, the cesarean section rate is really high.
Yeah. Okay. So how means from this study, what have you gained? Means what is the knowledge that you are gaining?
Yes, ma'am. By assessing the pH prior to the induction, we can patient is more likely to land up in the failed induction, or there may be the such induction delivery time can be reduced by if we know the vaginal pH prior to the induction. Like high vaginal pH less than 5, it will going to support the normal vaginal delivery.
Okay. But again, hello?
Yes, ma'am.
Yeah.
Can I add something?
Yeah.
Yeah. So I personally feel that, the methodology or the method for inducing labor was not just two gels. Like I said, the cesarean section rate was too high.
Yes.
And what could have used, like I said, the long-acting pessary, because even that can be used in PROM patients. So that could have improved the vaginal pH findings and would have led to a better, better rate of vaginal delivery.
Okay.
That is my feeling, when I see the statistics that you have shown in front of us.
Ayushi, what are the other methods that you could have used for induction? Just tell me to have a better response.
Ma'am, we can use propase also, ma'am. Propase.
What else? What are the methods that you know of?
Ma'am, medical and surgical, we can induce by the misoprostol, ma'am.
Any other methods?
Ma'am, amniotomy can be ma'am, surgical methods, amniotomy.
Anything else to improve the results along with medical method? What are the other methods? Mechanical methods are also there, right?
Yes, ma'am.
So you can even combine the mechanical and medical methods, because this rate is highly unacceptable sort of a thing. What is the acceptable level of rate of cesarean section as per WHO?
Ma'am, around 20%, ma'am.
20 is also high. Okay. Okay. Thank you, Ayushi.
Thank you.
Yeah, Dr. Leena, you are not, we can't see you.
You can't see
Leena,
me?
yeah, I think your video is off. Camera is off, I think. Okay, Ayushi, thank you.
Let me see.
Thank you, ma'am. Thank you.
Thank you, Ayushi. Now I'll call upon the next presenter, Dr. Kritika, and her topic is minoxidil and decanoinositol combination on menstrual cycle regulation in young girls with PCOS, a randomized open label study. Over to Dr. Kritika.
Good evening, ma'am.
Yeah. Good evening, Kritika. You can start.
Yes, ma'am.
1 minute. Dr. Leena is also not there. Nancy. Achha. Okay.
Start my video.
Okay, fine. Okay, start.
Warm evening to everyone, ma'am. Today I'll be discussing the paper on the effect of myoinositol and decanoinositol combination on menstrual cycle regulation in young girls with PCOS. This was a randomized open label study. As we all know, PCOS is the most common cause of menstrual irregularities in the reproductive age women. In this women, the menstrual regularization is not only the primary outcome. We need to address the long-term cardiometabolic consequences also. To treat the menstrual dysfunction, the hormonal therapy has been the mainstay of treatment till now. But considering since PCOS is not only a disease confined to the ovaries, we have to keep in mind the cardiometabolic manifestations also. We need some other alternate therapy which will be effective in addressing the main causes. Since OCP was used for a long time, there is a lot of anxiety among the patients and the treating physician also in prescribing OCP pills, as it has some contraceptive effect. It causes only withdrawal bleeding, as it seems to be a non-physiological method of bleeding. And once when the pills are given for a long period of time, it has some adverse effects in the form of thromboembolism and metabolic adverse effects. And the OC pills, they are mainly used to treat the cycle, they are used to bring about the cycle regularization and also to treat the hyperandrogenism. But in India, the majority of PCOS or phenotype D, which are non-androgenic, it seems to be a sort of overprescription. Hence comes the next category of drugs, which are insulin sensitizers. And since the early 20th century, they have been used. They are the inositols. Out of the 9 isomers, 2 isomers are most commonly used. And they are most commonly used in the artificial reproductive technology cycles. And they have shown to improve the ovulation rate and the pregnancy rate. Hence, we aimed to study the effect of these inositols in young girls to mainly regularize the menstrual cycle. This was a randomized controlled study conducted in AIIMS from Feb 2018 to July 2019. And we compared the effect of myoinositol decanoinositol combination with the hormonal pills to regularize the menstrual cycle. The primary outcome criteria was the resumption of the spontaneous cycle, the percentage of women having spontaneous cycle, and the menstrual cycle length. The secondary parameters were the metabolic parameters and the hormonal parameters were also studied. Totally 130 girls were screened, and the girls who were planning to become pregnant or who had BMI more than 30, known diabetes, who were on hormonal therapy in the last 3 months were excluded from the study. The girls who attained menarche 2 years, who were at least 2 years after the onset of menarche in the age group of 15 to 24 years were included in the study. And excluding the 60 subjects, totally 70 subjects were eligible, and they were randomized into 2 groups. The first group were allotted to take myoinositol and decanoinositol combination 2 times a day for 6 months, and the second group were given combined hormonal contraceptive pill containing drospirenone and ethinyl estradiol. The patients were followed up at 3 and 6 months of treatment, and they continued to follow up even 3 months after stopping treatment. And the 2 patients in myoinositol D-chiroinositol group and 1 in the CHC group were lost to follow up, and the data were analyzed for the remaining patients. The baseline parameters in the form of menstrual cycle, the metabolic and the hormonal parameters were comparable with both the groups. After treatment, after 6 months of treatment with myoinositol, the cycle length was reduced from 124 days to 57 days, which was 53% reduction. And the girls who were given the hormonal contraceptive pills, they almost all of them, they had a regular menstrual cycle since it was a withdrawal bleeding. So the percentage reduction in the menstrual cycle length at 6 months of treatment was 71%. The girls were even followed up 3 months after stopping the treatment, and it was seen that the menstrual cycle length in the myoinositol and D-chiroinositol group was 67 days, and in the CHC group it was 69 days, and it was comparable with between both the groups. Hence, after stopping the treatment, both the girls in both the groups were comparable, and they continued to have almost 70% continue to have the regular cycles, spontaneous cycles. This is a graph showing the menstrual cycle pattern of girls treated with myoinositol, D-chiroinositol. Here we can see at baseline, the 13 girls were oligomenoric and 20 were amenorrheic. After 6 months of treatment, 9 girls out of the 33 had regular cycles, spontaneous regular cycles, and out of 20 girls, only 5 remained amenorrheic. This is the fall in the number of patients having amenorrheic and the oligomenoric cycle was significant, and the girls, they started to have spontaneous regular cycles. 3 months after stopping treatment, only 9 girls persisted to have amenorrheic cycles needing withdrawal bleeding, and 4 continued to have spontaneous regular cycles. We performed univariate analysis among the 5 girls who remained amenorrheic at 6 months of treatment, and we found that the baseline testosterone, baseline AMH were higher in the girls who did not respond to the inositol therapy. And we also saw that among 5 girls, 4 girls belonged to phenotype A, which is severe phenotype. The secondary outcome parameters in the form of metabolic parameters and the hormonal parameters were analyzed, and it showed among girls who were treated with inositol, the fasting insulin and HOMA-IR, they decreased significantly, addressing the basic pathophysiology of the disease process. Whereas among girls who were treated with CHCs, the LH and testosterone, they showed a significant fall, whereas AMH was significantly decreased in both the treated groups. There were fewer studies which compared the myoinositol and D-chiroinositol combination primarily in regularizing the menstrual cycle. Majority of these studies were carried out with myoinositol 2 to 4 grams per day, and it was compared with the metformin. This was one of the, and it was shown that the results in the form of menstrual cycle length and the LH testosterone were comparable with both the insulin sensitizers. This was another study which was conducted in 2019, and in this study they compared the different ratios of myoinositol, D-chiroinositol, and in this they have shown that the isomers in the ratio of 40:1 has regularized menstrual cycle in majority of the girls compared to the other ratios. However, this study had a disadvantage in the form that the number of girls categorized in each group were very minimal, and only 8 girls were studied in each group. This is another study conducted in 2019 in IVF, in which the myoinositol D-chiroinositol combination in 2 different ratios were studied, and have shown that the combination in the ratio of 3.6:1 compared to 40:1 is superior in gaining the pregnancy and the live birth rate. So even though the isomer has been in use for more than 2 decades, there has not been any peculiar data showing the superiority of one ratio to the other, and the supplementation alone improves the outcome in these girls. The strength of the study was that the effect achieved with the combination was significant and sustained, and it was comparable to the mainstay of treatment which is used commonly, like hormonal pills. Also, in our study, we included girls with a higher BMI and insulin resistance, so that there is no overestimation of outcome in milder phenotypes. However, our study was conducted in a very small sample size, and there was lack of blinding.
Kavya?
Yes, ma'am.
I don't know why internet connection is unstable.
Ma'am, am I audible, ma'am?
Yeah, Kritika, you finish off. Kritika?
Yes, ma'am.
Yeah, continue.
Hence,
You have
we
exceeded
conclude
the
that.
time actually. Yeah.
Hence, we conclude that the combination was effective in resumption of the spontaneous menstrual cycles without causing ovarian as is caused by ossiples, and this is a good alternate non-hormonal treatment for menstrual dysfunction in girls. Since there is no ovarian suppression, it causes menstrual bleeding in a more physiological way, and it can be used for a longer time without side effects. Even though we use the drug for only 9 months, there are even studies in which they used for 24 months without any side effects, and there is no socio-cultural taboo associated with hormonal pills, and it is preferred in non-hyperandrogenic PCOS. Thank you, ma'am.
Okay.
Okay, Kritika, all of the patients, how many patients were hyperandrogenic in your PCOS population?
Ma'am, in our study, considering both the clinical and biochemical parameters, out of 70 patients, 18 patients were hyperandrogenic, and it was almost equally distributed in both the groups, ma'am. 8 patients.
How do you diagnose? Just tell me, how do you diagnose PCOS in adolescents? Because you were taking patients who were 2 years of the menstrual age, right?
Yes, ma'am.
So,
Ma'am, we diagnosed these girls. Yes, ma'am. We diagnosed these patients based on the Rotterdam criteria, considering the presentation with irregular cycles, hyperandrogenism diagnosed clinically and also biochemically, and based on the
patients, like in the patients in which hyperandrogenism was not there, right?
Yes, ma'am.
The girls. So, how did you made a diagnosis of PCOS?
Ma'am, we diagnosed based on the Rotterdam criteria only, ma'am. We excluded the girls who were in the early menarche, within 2 to 3 years of menarche, and our majority of patients were in the age group of 18 to 24 years, ma'am. So
the question is what criteria that you used apart from the, the ones who were not having hyperandrogenism. What was the other criteria? One was your irregular menses.
They used the ultrasound.
Yes, ma'am. Ma'am, based on the ultrasound, ma'am, the polycystic ovarian morphology and ultrasound, based on that, we labeled them as PCOS, ma'am.
So when can you label a girl PCOS based on the ultrasound parameters? At what age?
Ma'am, since the perimenarcheal transition itself, the girls in that period itself will have the polycystic ovarian morphology. We usually don't label them only based on ultrasound within 3 years of menarche. But if the girls have persistent irregular...
Okay, fine. Right. So that you have to see. What is the menstrual age? You have to see the menstrual age. It is not 3 years. It is generally, say, up to 8 years, you don't diagnose them. Okay?
Yes.
You don't label. That is what the recent guidelines say. But otherwise, it was a very good and well-planned research study. So, but you exceeded the time, Kritika. You should stick to time also. You know, if you have a good study, you should always, because you're just starting presentation, your slides were also good, but you exceeded the time. So you should always stick to, from next time, always stick to the time.
Okay, ma'am.
Thank you, Kritika. Kritika, one small question for you.
Yes,
tell me one thing, that the use of myoinositol and the inositol, what do you feel? I mean, did you get better results in those who only had menstrual irregularity, or was there any statistical difference? Because I think I lost you in between. There was some problem.
We mentioned actually
with those who had hyperandrogenic features.
Yes, ma'am. Ma'am, almost 75% of girls, they had improvement, but we personally noted that the girls who were hyperandrogenic, the improvement was not that good, and there was no improvement in hyperandrogenism also. So we personally felt that in non-hyperandrogenic girls, this would be an alternate option compared to ossiples, as it is a nutritional supplement and it can be given for a prolonged time without having any side effects associated with ossiples.
But was there any better changes if you use the ossipils for those who had hyperandrogenism? Was there any other...
Ma'am, we gave the drug only for 6 months. In our study, we did not find any significant difference.
Okay. Okay.
Thank you, ma'am.
Just tell me, Kritika, just one more question.
Yes, ma'am.
Inositol, is it produced in body also? Or is it?
Yes, ma'am, it is produced in the body.
And what are the other effects?
Ma'am, they act as insulin sensitizers and they maintain the insulin sensitivity in the body.
Any other effect?
Ma'am.
Huh? It is present in large quantity in the brain, and it is a neurotransmitter.
Yes,
so it is effective in depression also, and schizophrenia also. I think its role is coming up. So it has lot of role.
Yeah.
Right?
Okay, ma'am.
Chalo, okay. Good
Thank you,
stuff.
ma'am.
Very nice presentation, Kritika.
Thank you, ma'am.
Very nice.
Thank you.
Thank you, Dr. Kritika. And now we'll be requesting our next presenter to join, Dr. Jyotsna Mishra. And her topic is torsion ovary laparoscopic management. Over to Dr. Jyotsna.
Good evening, ma'am.
Good evening, Jyotsna. You can start.
Good evening, ma'am. My topic is torsion ovary the laparoscopic management. So just a brief introduction. Ovarian torsion is the most common surgical emergency in young and reproductive age group. The incidence is around 1 to 2% of all the gynecological emergencies. And conventionally, the management of choice is excision. So detorsion is mainly done to preserve the ovarian function and fertility and decrease the risk of premature ovarian failure. Laparoscopy holds the advantage of improved diagnosis, enhanced patient recovery, and a short hospital stay. Mine is a case report, and the objective is to present a case of ovarian torsion who presented to us and our experience about the salvageability of the ovary in case of torsion by laparoscopy in spite of grade of necrosis, number of turns, and assess the subsequent viability. It is a 19-year-old unmarried girl who presented to us with complaints of severe lower abdominal pain since one day associated with nausea and vomiting. On examination, patient looked mild to moderate distress. There was no pallor. Pulse was around 120 beats per minute. BP was 100/60. Tachycardia was there. Her abdomen, significant left lower quadrant tenderness was present. Rebound tenderness was present. No rigidity and bowel sounds were good. Her total count was normal. Urine microscopy and was normal. UPT was negative. Tumor markers were negative. Ultrasound pelvis showed a large left ovary of size 6.6 into 5.2 centimeters with few hemorrhagic follicles with hyperechoic stroma. Right ovary was not seen. Color Doppler was done, and that was showing no stromal vascularity. That was suggestive of left ovarian torsion. So this patient also had a past history of laparotomy and right oophorectomy in view of right ovarian torsion 1 year back. So this patient underwent emergency laparoscopy and ovarian cystectomy with left ovariopexy. So I would like to show the steps, the procedure. So this was the ovary, bluish black in color, around 6 centimeters with 3 twists. So this step shows the untwisting of the ovarian ligament, and it is a bluish black ovary. Along with that, there were a lot of omental adhesions from the umbilicus to mid abdomen. Sigmoid was adherent to the pelvic brim, and mild hemorrhagic fluid can also be seen in the POD. This slide shows about the ovarian cyst and the cyst wall being removed. The total of about 3 cysts were present, and cystectomy was done, and the cyst wall was sent for histopathology. On histopathology, it was reported as a corpus luteal cyst. The next slide shows after the cystectomy, the dead space being obliterated. And in this next, I wanted to show that because this patient had a recurrent history of ovarian torsions, and there was a long ovarian ligament, so the shortening of the ovarian ligament along with fixing of the ovarian ligament of the ovary to the ovarian ligament. The ovarian torsion remains one of the most challenging diagnosis and is based on clinical symptoms, examination findings, and the imaging modalities. The post-operative period of our patient was uneventful and she was discharged after 2 days. The left cyst wall was sent for histopathology and which was reported as hemorrhagic corpus luteal cyst with features of ovarian torsion. No abnormal findings in the ovary, and the patient was followed up after 3 months, and ultrasound done showed a normal left ovary with normal follicular development. Similar study was conducted at GEM Hospital, Coimbatore between 2015 to 2018, namely laparoscopic detorsion and fertility preservation in twisted ischemic adnexa. And they concluded that the laparoscopic detortion of the ovary is the best treatment modality, irrespective of the grade of ischemia. Ovarian structure and follicles were preserved following the detortion in all cases, even in gravely ischemic ovaries. And they had total number of cases where adnexal torsion was around 69, and out of that, they had 46 attempted detorsion, and in that 45 ovaries were preserved, that is around 97.8%. So conclusion is that diagnosis of ovarian torsion requires high degree of clinical suspicion, and ovarian salvage can be done irrespective of delayed presentation, a number of twists, grade of ischemia, and ovarian follicles were preserved following detorsion. Laparoscopic management of ovarian torsion is safe, feasible, and facilitates enhanced patient recovery. These were my references, ma'am. Thank you.
We still have seconds left.
Yeah, that was good. Jyotsna, tell me, you mentioned about doing the cystectomy, and you also mentioned that there were 3 cysts in that, which you could see in the video presentation.
Yes, ma'am.
So were these all interconnected? Because they looked like in the video to be sort of, quite separate. So this was the entire, all the cyst wall that was sent, all reported as a hemorrhagic corpus luteum cyst?
Yes, ma'am.
Okay.
3 cysts were there, ma'am, and it was left infundibulopelvic ligament cystectomy was done. Total 3 cysts were removed, and that was sent for histopathology, and they reported as it was a corpus luteal hemorrhagic cyst.
Okay.
What was the size of the cysts, all the cysts, Jyotsna?
Ma'am, one cyst was 4 into 3.2 3 centimeters, 3 into 3 centimeters, and 3 into 4 centimeters.
So I guess this was this had to be done because she had a cystectomy on the she had an ovarectomy.
She had an oophorectomy on the opposite side, ma'am.
Yeah, so this was thing like you had to take a chance with the thing, but yes, I think had it been that the patient had a proper she had an ovary on the other side, you wouldn't have gone in for this, or the message is that we go in for a detorsion for each and every case.
Ma'am, cystectomy with oophorectomy is very controversial. So many studies are suggesting that we should preserve the ovaries followed by oophorectomy, and later follow up of these patients showed that they had normal ovarian and follicular development.
So regardless of the parity of the patient.
Yes, ma'am. It's very
regardless
controversial.
Of the parity of the patient.
Yes, ma'am.
Okay. Okay.
So basically all the torsions you will first do the detorsion and see, or you plan to leave all the ovaries after means you plan to do the cystectomy, right?
Yes, ma'am.
Or intraoperatively you see something and you decide.
Intraoperatively, ma'am, like we will decide.
Yeah. So if intraoperatively we have to decide what would be the pointers towards which we would say that we can preserve it, and what would be the pointers which would tell us that there is no point in preserving?
Ma'am, if the ovary is slightly discolored, normal size, and after
this was quite discolored. This
yes,
one which you showed us.
But ma'am, this patient had had a history of previous oophorectomy, and she was 19-year-old unmarried girl. So we had to take chances and preserve the ovary.
Exactly.
And,
what I'm saying is, supposing she was not a unmarried girl and she did
have a normal the other ovary, right?
Yeah. She had.
That is what we want to ask you.
Yes, ma'am.
Then would you have gone for this detorsion, or would you have straight away gone for a simpler procedure of removal?
Ma'am, actually, there are no particular guidelines regarding ovarian preservation or oophorectomy.
But what do you think, Jyotsna? What do you think? Suppose you are a surgeon, and then what will you do?
If the ovary was really bluish black in color and after detorsion it does not come back to normal, then better is to do a oophorectomy. But if it is grade 1 like ovarian, if it is slightly discolored and returns back to normal color after detorsion, then ovarian preservation can be thought of.
And an ovariopexy, you would have gone
Can
and
be
done that.
Yes, ma'am.
So the most important thing is that after detorsion, you have to give
Wait.
some time and then you reassess.
Yes, reassess and see
Don't
the
go on the first look.
yes,
Yeah.
ma'am.
You should not go for with the first look that it may be looking necrosed, but most of the time it recovers. Some tissue, viable tissue, is always there.
Yes, ma'am.
Okay.
She did not see Jyotsna actually. She did not put on the video, the camera, no? Jyotsna?
Yes, ma'am.
You showed on the video of your surgery, but not yourself.
Yeah, we can't see you.
Okay.
I just realized, ma'am, that I was not visible.
Okay.
You're in the theater?
Ma'am, I am on duty today.
Okay.
I'm in labor room.
Okay. Okay.
Fine. Okay.
Right.
Okay, Jyotsna, thank you.
Thank you.
Thank you, Dr. Jyotsna. Next presenter, Dr. Ramya Mishra, is not able to join, ma'am. So we'll be moving to Dr. Sonam Yadav. Her topic is, I'll request Dr. Sonam Yadav to join. Her topic is maternal thyroid function at 11 to 18 weeks of gestation as a predictor of preeclampsia in primary gravida.
Good evening, ma'am. Am I audible?
Yes, Sonu.
Good evening, ma'am.
Switch on your camera also, Sonu.
Yes, ma'am. Yes. Camera. Yes.
Okay.
Good evening, ma'am. Ma'am, my topic for today is maternal thyroid function at 11 to 18 weeks of gestation.
Can't hear you too well, Sonam. Can you speak up?
Yes, ma'am. Ma'am, now?
Yeah, better.
Okay. Ma'am, my topic for today is maternal thyroid function at 11 to 18 weeks of gestation as a predictor of preeclampsia in primary gravida. Preeclampsia is a pregnancy-specific disorder, and it is a major cause of maternal mortality in developing countries, and it is associated with 5-fold increase in perinatal mortality. Maternal hypothyroidism is most common disorder of thyroid function in pregnancy, and it is usually associated with adverse fetal and maternal outcomes. Pregnancy is usually associated with mild hypothyroidism, with preeclamptic patients having higher incidence of hypothyroidism. During pregnancy, there is an increased thyroid demand and increased iodine uptake and synthesis of thyroid hormones. There are only few studies in literature that have assessed the predictive value of serum TSH in preeclampsia. Therefore, this study is being conducted. In material method, it is a prospective observational cohort study, and it is done in the Department of Obstetric and Gynecology in conjunction with Department of Pathology in VMMC and Safdarjung Hospital, Delhi, with duration of 18 months and the sample size of 200. In inclusion criteria, primary gravida with singleton pregnancy at 11 to 18 weeks of gestation with age group of 20 to 35 years. In exclusion criteria, patients with any history of thyroid disease such as hyper or hypothyroidism or thyroid surgery, or if any history of consumption of thyroid related medication, patient who had a history of chronic hypertension, known case of diabetes, chronic renal disease, alcohol or smoking. In results and discussion, in my study, majority of patients were in the age group of 21 to 25 years, and in 18 to 20 years, only 6% cases were there, and 26 to 30 years of age, only 5% cases were there. In my study, 64% of women had normal TSH, while 36% of patients had higher TSH level. 75% of women had normal free T4 level, while 25% of patients had abnormal free T4. And in anti-TPO, 85% of women had normal anti-TPO, while 14.5% of patients had raised anti-TPO. In my study, preeclampsia was absent in majority of cases, while in 19% of cases, preeclampsia was present. And patient with sign and symptoms of hypothyroidism, preeclampsia was present in 42%, while patient with sign and symptoms of hypothyroidism, preeclampsia was absent in 6% of patients. Coming to maternal outcome, preterm delivery was present only in case of 9%, and spontaneous delivery was present in 16%, while the induced delivery were present in 83% of patients with preeclampsia. Coming to mode of delivery, it was normal vaginal delivery in most of the patients, that is 83% patient, followed by cesarean section in 13% and instrumental delivery only in 3.5%. In fetal outcome, low birth weight, the patient usually they had normal. There is no low birth weight was present only in 14% of cases, and APGAR score was more than or equal to 7 in 99.5% of patients. NICU admission. No NICU admission in 88%, showing that the hypothyroidism having no association with fetal outcome. Comparison of my study with Kharab S. et al. In 2013, he analyzed the thyroid hormone in preeclamptic women and normotensive women and observed that preeclamptic women had raised TSH and total T4 as compared to normotensive pregnancy. The result is similar to my study, and Alavi et al. In 2012 observed that there was no significant association in TSH with total T4 level in preeclamptic women as compared to normal pregnancy. While in our study there was a significant difference. Deshpande et al. In 2015 found that there was a significant association between preeclampsia and thyroid dysfunction. The result is similar to my study. Limitation of my study, it is a small sample size, that is only 200 sample size were there, and trimester specific assessment of level of serum TSH which was not taken, and facility for evaluation of thyroid function is not universally available, and it was a single center study. Strength of my study, our study shows a significant prevalence of thyroid dysfunction in the pregnancy and highlights the need for more rigorous thyroid screening of women in early pregnancy, and this study provides the cutoff of thyroid function at 11 to 18 weeks of gestation. So the conclusion of my study is thyroid dysfunction has a significant association with preeclampsia, and it can predict preeclampsia in early pregnancy, and among these TSH level being the best predictor. Monitoring of thyroid hormones in women during routine pregnancy might also help with early diagnosis and management of preeclampsia, and consequently reducing the adverse maternal and neonatal outcome. Thank you.
She's well on time, ma'am.
Okay, Sonam, just tell us what happens to the thyroid functions during pregnancy, normal pregnancy,
And
in all the trimesters.
During normal pregnancy, there is mild hypothyroidism, and there is increased demand of thyroid hormones with iodine uptake. And because the alpha subunit of TSH, it is similar to the alpha subunit of FSH, so there will be stimulation of that receptors.
So what happens? What happens in first trimester, second trimester, and third trimester? Is there any difference in different trimesters, or is it same uniformly? The levels are raised, like you are saying.
Ma'am, it is more in first trimesters. Therefore, the normal range of hypothyroidism in first trimester, it is taken from normal range is taken from 0.1 to 2.5. In second trimester, according to American Thyroid Association, it is taken from 0.2 to 3, and in third trimester, it is also taken from 0.3 to 3.
In your study, what was the cutoff between 11 to 18 weeks? What was the cutoff?
Ma'am, we measure and we took up to 3, 0.3 to 3.
To 3. Okay.
Yes, ma'am. Trimester specific, that is we did from 11 to 18 weeks, but we took up to 3. Trimester specific range was not taken.
Okay.
Yes.
Okay.
Thank you, ma'am. Thank you.
What was the prevalence of thyroid disorder in your study?
Ma'am, it was 38%.
38%. And what was okay? So means what is the conclusion that you have drawn from this study regarding the association with preeclampsia? No,
Yes,
your main aim was to see the association, whether it increases the risk of preeclampsia.
Yes, ma'am. Yes, ma'am. Ma'am, thyroid hormones, the preeclampsia was more in patients with thyroid dysfunction. So thyroid hormones and more of TSH, more specific is TSH, can be taken as a predictor of preeclampsia. So by following TSH, we can reach the
You
conclusion
mean to
that
say that higher TSH is a predictor of preeclampsia?
yes, ma'am. And in
Higher TSH, right?
yes.
Okay.
At 11 to 18 weeks of gestation.
Yes, ma'am. Pardon me.
At a predictor at the 11 to 18 weeks.
Yes, yes, ma'am. Yes, ma'am.
So
And
what does the literature say? What are the other things people are studying regarding thyroid dysfunction and association with preeclampsia?
ma'am, other studies they have mentioned this TSH level and other levels with preeclampsia, and they have also found that preeclampsia is more in patient with hypo or hyperthyroidism. With patient with thyroid dysfunction, preeclampsia was more.
Both with hypo as well as hyper?
Ma'am, in my study, of 200 patients, only hypothyroidism was there. There was no single case of hyperthyroidism.
What is more likely to cause preeclampsia, hypo or hyper?
Ma'am, hypothyroidism.
Hypothyroidism. Okay.
Thank you.
Okay. Thank you.
Since that's the main thing of the study, her correlation is with hypo with preeclampsia.
Yeah. But otherwise, they say that hyper is more likely to
cause preeclampsia.
And even people are studying the HCG level, means
yes, ma'am. HCG level also.
HCG level also, and they say if T4 is raised and HCG is normal, then they are more likely
to
develop preeclampsia.
Yes, ma'am. Yes.
So hypo, I was not aware.
Thank you.
This is interesting. Only thing is, I felt that the sample size is a little small. Although you did bring in the studies which were there in support of your own study, but I still felt that your sample size was little small, to come to this conclusion.
Associations, right?
Okay. Thank you, Dr. Sonal. So now this is the end of our session 8, and I'd like to thank all our participants and our esteemed judges for this wonderful discussion. And and I'll also request both the judges to please share the score sheet on the aogtvirtual@gmail.com, ma'am.
Yeah, I just sent you.
Yes, Nancy will do it.
Thank you so much.
Thanks so much. Thank you so much. Thanks, Dr. Rashmi.
Wonderful.
Okay, bye, Dr. Lina. It was great.
Nice meeting you.
Thank you.
Okay.
Bye-bye.
Bye-bye. Bye. Bye, Dr. Nancy.
Bye, ma'am. So now we'll be moving to our next session, session 9 of the free paper session. And I'd like to introduce our judges for the next session. And our judges are Dr. Shweta Balani. She is the Senior Consultant, Department of Obs and Gynae, Sun Permanent Hospital, New Delhi. Then we have the second judge is Dr. Anubhuti Rana, Assistant Professor, Department of Obs and Gynae, AIIMS, Delhi. Then we have Dr. Neeru Banerjee. She is a Senior Consultant, Obs and Gynae, and in practice since 1990. She has done her MBBS and MD from MJMS Wardha. So I welcome all my judges. And now I'd like to invite the first presenter. Our first presenter is Dr. Shweta Singh, and her topic is maternal predictors for early onset neonatal sepsis and premature rupture of membrane at term pregnancy. Over to Dr. Shweta.
Good evening, everyone. Ma'am, I'm audible to everyone?
Yes.
Yes, you're audible.
Dr. Nancy, I just have a question. What is the time limit which is being given to all the candidates?
The time limit is for oral presentation, it is 6 minutes, and for question answer, it is 2 minutes. And because that being on time is also being marked in the score sheet, so I'll remind all my presenters to be on time and to stick on to the time.
Ma'am, should I start?
Yeah.
Okay. I, Dr. Shweta Singh, presenting before you maternal predictor for early onset neonatal sepsis in premature rupture of membrane at term pregnancy. Introduction: premature rupture of membrane. It is a syndrome characterized by rupture of fetal membrane beyond 28th week of pregnancy, but before the onset of labor. And if it occurs after or at 37 completed week of gestation, it is called term prom, and before 37, it is called preterm prom. Rupture of membrane for more than 18 hours before delivery is called prolonged rupture of membrane. Prom occurs in 10% of all pregnancy, with incidence generally varies between 2 to 18%. Infection of lower genital tract, amniotic cavity are common etiology of prom. Sepsis is the commonest cause of neonatal mortality. It is responsible for about 30 to 50% of total neonatal death in developing countries. Based on the onset, neonatal sepsis is categorized into 3 categories. In early onset, the onset is at or within 72 hours of life. Source is from maternal genital tract. So it is a vertical transmission. In late onset, it is after 72 hours of age. Source is usually nosocomial or community acquired. So it is a horizontal transmission. In very late onset, it is after 1 month of the life. Source is actually hospital or community. Very low births, it actually occurs in very low birth weight babies requiring prolonged intensive care. Various risk factors seem to be associated with increased risk of early onset neonatal sepsis, that is low birth weight, prematurity, febrile illness in mother, foul smelling or meconium stem liquor, rupture of membrane more than 24 hours, single unclean or 3 or more than 3 sterile vaginal examination, prolonged labor, perinatal asphyxia, maternal urinary tract infection, poor maternal nutrition, and lower socioeconomic status. So we have studied various maternal risk factors for early onset neonatal sepsis in premature rupture of membrane at term. So it's a prospective observational study conducted in Department of Obs and Gynae at Vardhman Medical College, Safdarjung Hospital, New Delhi, in collaboration with Department of Pediatrics over a period of 18 months. So my study population inclusion criteria was from between 37 to 40 weeks of gestation, exclusion, multiple pregnancy, antepartum hemorrhage, VDRL, HIV, any genital infective lesion, congenital fetal anomalies, or IUD. So coming on the procedure, 140 term pregnant women with a history of leaking per vagina were recruited on the basis of history of gross vaginal fluid loss and the physical examination. Along with ANC, specific investigation was done, in which total leukocyte count, urine for culture sensitivity, and high vaginal swab for culture sensitivity was also done. Antibiotics, as per our hospital protocol, was given to cover various gram-positive, gram-negative anaerobic bacteria. If the patient was not in labor, then induction of labor was done with the Subuprime gel or oxytocin drip, depending on the Bishop score. And the cesarean section was performed depending on the indication. Both mother and baby were followed till 72 hours after delivery. So newborn were categorized into 3 groups: healthy baby, clinical sepsis, and the proven sepsis. And mother followed for any postpartum complication. So observation and result. I have studied various variables: age, gestation age, leaking PV, duration of antibiotic course, duration of labor, number of digital examination, total leukocyte count, OGTT, TSH, antenatal care, socioeconomic status, parity, urinary tract infection, HVS culture sensitivity. Out of these all variables, the significant risk factor for early onset neonatal sepsis came to be increased duration of leaking PV, increased total leukocyte count, increased duration of antibiotic course before delivery, increased duration of labor, multiple digital
We can't hear you, Dr. Shweta.
There's no volume.
I think she has lost the internet connection.
Maybe she's muted herself.
Dr. Shweta,
We can't hear you, Dr. Shweta.
Hello. Dr. Shweta, please check your internet connection.
a technical team.
I think she has to unmute herself.
Do we have her number? Can we contact her?
Yeah, ma'am, hold for a moment. I'll check in.
Yeah, so I think Dr. Shweta has some internet issues. So we'll just wait for a few seconds for her to join, or otherwise we'll move on to the next.
Ma'am, please move on the next participant.
Okay. So so let me call the second presenter. Our second presenter is Dr. Sabina, and her topic is colonization of vagina with aerobic bacteria detected in active labor and its association with puerperal and neonatal sepsis. So over to Dr. Sabina.
Are my slides visible?
Yes, they are visible.
Yes, ma'am, this is visible. Please slideshow. Please click on the slideshow.
Yeah, I'm doing it.
Yeah.
Good evening, everybody. Myself, Dr. Sabina. I'll be presenting my paper on colonization of vagina with aerobic bacteria detected in active labor and its association with puerperal and neonatal sepsis. Introduction. According to WHO, more than 5 lakh women die every year due to the complications of pregnancy and childbirth. Puerperal sepsis is the third most common cause of maternal mortality. Early onset neonatal sepsis contributes to around 23.4% of all the annual neonatal deaths. The present study evaluated whether the aerobic bacteria colonizing the maternal genital tract causes puerperal sepsis and early onset neonatal sepsis. The aim of my study was to find the prevalence of vaginal colonization with aerobic bacteria in active labor and its association with puerperal sepsis and early onset neonatal sepsis. It was a prospective cross-sectional study conducted over a duration of 18 months. My sample size was 920. The inclusion criteria were period of gestation more than 28 weeks, and the patient should be in active labor but with intact membranes. Cervical dilatation more than or equal to 4 centimeters were included. Exclusion criteria were fever or taking antibiotics within 7 days before the active labor, HIV, active perineal infection, per vaginal examination more than or equal to 5, emergency LSCS, congenital major malformations incompatible with life, Apgar score less than 3 at 5 minutes. The total women screened were around 10,800 women, out of which 1,200 women were eligible to participate in the study, out of which 280 women were excluded, 10 did not give consent, and 270 underwent emergency LSCS. Total women included were 920. 2 high vaginal swabs were taken for culture from each woman, and out of which 47.4% turned out to be culture negative and 52.6% turned out to be culture positive. All the mothers and the neonates were observed and followed for the signs and symptoms for puerperal and early onset neonatal sepsis. In my study, none of the mothers or the neonates developed sepsis. The results were as follows. The majority of the women belong to 20 to 30 years of age group. They belong to upper lower socioeconomic status, had a normal BMI. One significant finding in my study was that the multigravida women were at a higher risk of colonization when compared to the primigravida, making the p-value significant less than 0.05. And this table shows the titerated by the gram-positive organisms at around 19.6% of the patients, once being the most common gram-positive organism. Gram-negative organisms were 13.2%. Most common gram-negative was E. coli, followed by Klebsiella. And 19.4% patients, we found the reports were mixture of more than or equal to 2 organisms. This particular table shows the relationship between vaginal colonization with per vaginal examination, with the number of per vaginal examination till sample collection. And we found that with increased number of PV examination, the incidence of vaginal colonization increases. This logistic regression table shows that one multigravida women are at 1.4 times higher risk of vaginal colonization than the primigravida, and the women in whom the sample was collected at the first per vaginal examination were at 0.34 times lower risk of vaginal colonization compared to the women in whom sample was collected at more than one PV examination. For discussion, in my study, the multigravidas were at higher risk of colonization than primigravida, more so because multi might have had more contact with the health system and may have undergone more number of genital examinations in their reproductive tenure when compared to the primi. And in our study, cons was the most common organism. In other study, it was dominated by gram-negative organism. One finding in my study was that in out of total births in mothers with vaginal bacterial colonization, 78.1% were term at all. This suggests that the vaginal colonization does not increase the risk of preterm delivery. It could also be due to the fact that I have not included subjects with the incidence of colonization increases with progressive number of vaginal examinations. That was one finding in my study. In our study, none of the cases developed early onset neonatal sepsis, irrespective of the vaginal colonization status of the mother, which was similar to studies conducted by Buckler, Foro, and Fabiani. Whereas one study which was conducted by Popolo, this one study, it showed that the mother with vaginal colonization was 30 times more higher risk of developing, babies were at higher risk of developing sepsis when compared to the mothers without colonization, possibly due to the difference in the inclusion criteria of the subjects from our study. Popolo has included all culture-proven sepsis cases and has studied the risk factors retrospectively. In the present study, we did not find any association between colonization and puerperal and early onset neonatal sepsis. Possible reasons could be that the vagina was colonized by less virulent strains. In my study, the conch was the most common organism isolated, and maybe because it was colonized with insignificant load of bacteria, my limitation is that we haven't studied the bacterial load of vagina against the colonized organism. And the samples were collected in low-risk women. The strength of my study was that the vaginal samples were taken in active labor when the delivery was imminent. So the culture report can be directly correlated with puerperal and neonatal sepsis. And our study tried to answer whether the vaginal colonization in low-risk mother is a cause of early onset neonatal sepsis. And the limitation, we did not measure the bacterial load as well as we did not study neonatal colonization. To conclude, vaginal colonization with potentially pathogenic bacteria in low-risk women may not always lead to infection in mother and neonate. Maternal age, BMI, socioeconomic status of the subjects does not have any statistically significant association with colonization. Vaginal colonization with pathogenic bacteria does not predispose to preterm delivery in low-risk women. Early onset neonatal sepsis and genital infections in low-risk women may not be acquired from the mother's vagina, but from the external environment due to unclean delivery practices. For recommendations, our study reinforces that the low-risk mother should not be given routine antibiotic prophylaxis during labor and postpartum for prevention of puerperal sepsis and EONS. Routine bacteriological screening of vagina should not be a part of protocol for prevention of sepsis. Further studies are required to evaluate the virulence and load of the bacterial pathogens colonizing the vagina and its relation to puerperal and early onset neonatal sepsis. Thank you.
Hello. Excellent presentation.
Hello.
Yeah, excellent presentation. I just want to know, did you carry out the Nugent score as well, or it was just the culture?
No, ma'am. Only the culture, ma'am. We have just culture. We have taken 2 high vaginal swabs. One was culture on the enrichment media and chrome agar, and the other one for blood agar and McConkey agar. We haven't studied Nugent score.
Yeah, otherwise, asymptomatic UTI, we always say all NT should be given treatment, but here already patient was
yes,
liver
ma'am.
and all asymptomatic.
Right.
So
Yes,
that
ma'am.
concludes asymptomatic vaginal discharge, even
Yes,
if it is
ma'am.
infected, shows growth of bacteria, we should not give her any treatment. So that is the message, I think,
Yes,
your
ma'am. Yes,
presentation.
ma'am. Yes, ma'am.
That's good. Nice.
Yes, ma'am. Okay, ma'am. Thank you.
Any other question, ma'am?
Dr. Sabina, what is the usual protocol in your institute? Do you give antibiotic or you don't give antibiotic to any laboring patient?
No, ma'am, we don't give antibiotics in laboring postnatal patients also, only with patients who have undergone, the ones who had instrumental delivery and 3rd degree, 4th degree perineal tears. We follow the WHO protocol. We don't give antibiotics routinely. We don't give.
Okay.
Only for prolonged leaking and prolonged labor, those patients we give antibiotics.
And Dr. Sabina, can you explain why there could be a possible explanation why the multis would have a higher incidence of this colonization compared to primi-gravidas who have a
Yes,
long
that is one possible. So one possible reason I've just given that they must have undergone more number of per-vaginal examination. They have come in contact with the health system more than the primary.
A multi-gravida would deliver faster and undergo less number of per-vaginal examinations, especially even in the antenatal period. She would have never had a PV or a pelvic assessment. Primies, we assess pelvis. Primies would take a longer time in induction and delivery and repeated PV. So why would a
yes, ma'am.
This is quite.
Agree with Dr. Anubhuti. Why should a multi undergo multiple exams?
I have.
Yes, a primi-gravida would undergo.
I'm including her entire. I have included an entire reproductive tenure from the first baby, second baby, third baby, not in the present pregnancy alone.
All right. Okay.
Presentation.
Okay, ma'am.
Thank you,
Nice.
Dr.
Thank you,
Sabina.
ma'am.
And we have our previous presenter has joined, Dr. Shweta. So I'll request our judges, shall I ask her to summarize her presentation in 2 minutes and 2 minutes for question answers?
That will be good. We should give her time.
Yeah, so or shall I ask her to start from the beginning, but that will take a lot of time. So
no, maybe halfway through where she left.
So I'll request Dr. Shweta to join again. And if you can summarize your presentation in 2 minutes, and then there'll be 2 minutes for question answers. Over to Dr. Shweta. Dr. Shweta Singh. Dr. Shweta. Our technical team, Mr. Shivam, is Shweta there?
Yeah, ma'am, she is there. Yeah, ma'am, she is there.
Okay.
Ma'am, please move to the next participant. Maybe her mic is not on.
Okay. Again, we are having some internet issues with Dr. Shweta Singh's end. So we will move to our next presenter. Even Dr. Ekta Chillad is not able to join, right, Mr. Shiva?
Yes, ma'am.
We will next move to the next presenter, Dr. Shivani Verma. So her topic is left ventricular function in women with hypertensive disorders of pregnancy. I'll request Dr. Shivani Verma to join, start sharing her slides.
Ma'am, is the screen visible?
Yeah, it's
visible.
Good evening, everyone. I'm Dr. Shivani Verma, and my paper is on left ventricular function in women with hypertensive disorders of pregnancy. The cardiovascular changes in hypertensive disorders of pregnancy are associated with greater cardiac afterload, reduction in cardiac preload by diminished volume expansion, and endothelial activation. Serial echocardiographic studies have documented a diastolic dysfunction in 40 to 45% of hypertensive women, which is an adaptation to the response to maintain normal contractility despite increased afterload of preeclampsia. And the cardiovascular changes are seen to persist for at least several months postpartum, predisposing to long-term cardiovascular risk. The study was done to evaluate left ventricular function in women with hypertensive disorders of pregnancy and to compare it with normotensive antenatal women and correlate with maternal and neonatal outcome. My study is a prospective observational case control study done at Safdarjung Hospital, and my study included pregnant women after 20 weeks of gestation with singleton pregnancy, development of new onset hypertension with a systolic blood pressure of more than equal to 140 mm of mercury and or diastolic blood pressure more than equal to 90 mm of mercury with or without proteinuria on a semi-quantitative dipstick test. And my study excluded women with chronic hypertension, overt diabetes or gestational diabetes mellitus and pre-existing cardiovascular disease. The study population included 160 women in the case group who had hypertensive disorders of pregnancy and 160 women, normotensive pregnant women. And they were both matched for the demographic data, and the case group was further divided into women with gestational hypertension, preeclampsia without severe features, severe preeclampsia and eclampsia. My study observed that in the case group, there was a higher value of LVIDD, which is left ventricular internal dimension in diastole, and LVIDS, which is left ventricular internal dimension in systole, and a lower value of fraction shortening and ejection fraction, and all these values were found to be significant. Similarly, with increasing severity of hypertensive disorders of pregnancy, a higher value of LVIDD and LVIDS was seen, and a lower value of fraction shortening ejection fraction was seen. Also, none of the women in gestational hypertension group had any abnormal echocardiographic parameters. However, higher percentages of abnormal values of echocardiographic parameters were seen in women in the preeclamptic and severe preeclampsia group, which was significant. And in development of maternal complications, only 49 women with hypertensive disorders of pregnancy developed any complication, and 5 women who had maternal complications had more than one complication and required ICU admission. None of the women in the control group developed any complication, and 10% of women developed HELL's syndrome, which was the most common complication, followed by atonic PPH, eclampsia, pulmonary edema, abruption, Press syndrome, and acute kidney injury was seen only in 1 woman. Development of maternal complications was seen in 46.9% of women with severe eclampsia, preeclampsia, and only 10.2% of women with gestational hypertension. Higher values of LVIDS and were seen in women with who developed maternal complication, whereas significantly lower values of fraction shortening and ejection fraction were observed with women who developed complications, and also higher percentages of abnormal values were seen in women who developed maternal complications, and they were all found to be significant. In an ROC curve, the ejection fraction at a cutoff of 63% was seen to predict maternal complications with a sensitivity of 78% and a specificity of 75%. Coming to the neonatal outcome, there were no stillbirths in the control population, and it was found to be significant as compared to the case population. And higher rates of NICU admission were seen in the case population, and low birth weight and respiratory distress was the most frequent cause of nursery admission in case population, and in the control population, respiratory distress was the most common cause of nursery admission. Though case population had a higher rate of neonatal deaths as compared to controls, but it was not found to be significant. The development of adverse neonatal outcome was also seen to be higher in severe preeclampsia, 39.1%, and lower in women with gestational hypertension. Also, in the women who developed adverse neonatal outcome, significantly higher values of LVIDD and LVIDS were seen, and lower values of fraction shortening and ejection fraction were seen. Also, abnormal values were seen to be more in women who developed adverse neonatal outcome. In an ROC curve at a cutoff of 67%, ejection fraction was seen to predict adverse neonatal outcome with a sensitivity of 83% and specificity of 49%. Coming to the discussion, a study by Liu and co-workers also had similar results in terms of significant left ventricular structural changes in women with increasing grades of hypertensive disorders of pregnancy, and this was associated with a significant impairment of systolic function. Our results are similar to other studies conducted in Indian population. In another study by S. Vyas and co-workers, no significant differences were observed in
left ventricular ejection fraction between the normotensive and preeclamptic groups. In contrast to mild systolic dysfunction observed in our study, a large number of studies showed no significant differences in left ventricular systolic function observed between the groups. However, these studies did show significant diastolic dysfunction. The strength of my study was it was a prospective case control study, and it was and a higher number of patients were evaluated within a limited time, and also a study measured the diagnostic efficacy of left ventricular ejection fraction predicting adverse maternal and fetal outcome, which was not observed in other Indian studies. However, it was a single unit study and only local population was included, and postpartum period follow-up could not be done because of the scarcity of resources. And now concluding, I'd like to say that women with hypertensive disorders of pregnancy are associated with changes in left ventricular and structure and function, and it is seen to be more significant in women with increasing severity of hypertension, such as severe preeclampsia. And also this abnormal left ventricular function is seen to be associated with development of adverse maternal and neonatal outcomes. Hence, assessment of left ventricular function using echocardiography as a routine maternal evaluation in women with severe preeclampsia is useful to detect early signs of cardiac dysfunction, to prompt close monitoring, timely intervention, and regular follow-up. Thank you.
Nice presentation. Timely concluded. That was good.
Thank you, ma'am.
It was good. Well done.
Any questions, ma'am? Or shall we move to the next presentation?
When was the echo done for all the patients?
Ma'am, like in women who had gestational hypertension and preeclampsia without severe features who were admitted, for them the echo was done at the time of admission within 24 to 48 hours. And however, in women who were sick and in ICU, the echo was done post-delivery or post-cesarean. However, literature has shown that the cardiac changes post-pregnancy are seen to persist for a period of over 3 months. So that is the literature, what is the literature says. So then they were done later because they were intubated or something. And if the patient was admitted in ICU setting, then from ICU we can take the patient for echocardiography. So then that was done.
Hello.
Thank you, Dr. Shivani. And now to our first presenter, Dr. Shweta Singh, who dropped in between because of the technical issues. She has joined back. I'll request her to summarize her presentation and then 2 minutes for question answer session. Over to Dr. Shweta Singh.
Sorry for inconvenience, ma'am. Ma'am, I audible to you?
Yeah. Yes,
Hello?
Dr. Shweta.
Yes. So, ma'am, based on the different variables, the significant risk factors were prolonged leaking PV, increased leukocyte count, increased duration of antibiotic course, increased duration of labor, multiple digital examination, urinary tract infection, lower genital tract infection. So all these factors actually basically increases the ascending infection. So the risk of early onset neonatal sepsis, that the source is from the maternal genital tract, is further increases. So ma'am, so pregnancy complicated with prompt care givers should explain all the risk, and thorough history and examination of the patient should be done. Labor must be supervised and individualized. Prophylactic antibiotic and minimal digital examination should be advocated. A team approach comprising of a skilled obstetrician, neonatologist, along with good NICU care, anesthetists help in reducing the problem due to a greater extent. Based on this conclusion, there is a great potential to reduce early onset neonatal sepsis with early diagnostics, recognition, diagnosis, and proper treatment. Thank you, ma'am.
I'll request my judges for the question answer sessions.
What is the routine prophylaxis or antibiotics that you give for PROM patients in your hospital?
Ma'am, we give injection ampicillin 500 milligram QID after test dose, injection metronidazole 100 milligram TDS, injection gentamicin 80 milligram IVB.
Okay.
Okay. That's all. It was nice, Shweta.
Thank you,
Nice
ma'am. And sorry,
presentation.
ma'am. Sorry for the
Absolutely
interruption, ma'am.
fine. This happens, you know, this is not in our hand. Absolutely fine.
No problem.
Thank you,
Shweta.
ma'am. Thank you, ma'am.
Thank you, Dr. Shweta. And now the next presenter, Dr. Ekta Chillar, is also joined. So I'll request Dr. Ekta Chillar to take over. And her topic is correlation between body mass index and mid-upper arm circumference as a screening tool for classifying nutritional status of pregnant women, a prospective control study. Over to Dr. Ekta. Dr. Ekta.
Yes, ma'am. Yes, ma'am.
Dr. Ekta, please click on slideshow.
Yes, sir.
And please keep your video on, Dr. Ekta.
Hello.
Is my screen audible? Oh, sorry, is my screen visible?
Yeah. Yes, please click on slideshow.
Is my screen visible?
Yeah. Yes, ma'am.
Okay. Good evening, everyone. Myself, Dr. Ekta Chillar, and the topic for my presentation is correlation between body mass index and mid-upper arm circumference as a screening tool for classifying nutritional status of pregnant women. India at present is facing dual burden of malnutrition, which includes both undernutrition and overnutrition. At present, about 23% of women of the reproductive age group are having low BMI and then resulting into fetal growth restriction and prematurity. And according to NFHS 4 survey, 20.7% of adult women have BMI of more than 25%. And this maternal overnutrition and obesity is on rise in India, and hence it is leading to further complications such as gestational diabetes mellitus, preeclampsia, fetal macrosomia, and a higher cesarean section rate. At present, Government of India recommends that nutritional risk assessment should be done for all pregnant women under the National Poshan Abhiyan for early diagnosis and timely intervention. At present, BMI is being used as the gold standard to classify nutritional status of antenatal women, and that has to be ideally calculated by pre-pregnancy and the early pregnancy weight. However, in countries like India, most of the women are belonging to lower socioeconomic status, and hence they are able to access to the medical facilities late in their pregnancy, and the pre-pregnancy weight is either not available or it is not known. So in those women, the nutritional risk assessment according to BMI is frequently not possible. On the other hand, mid-upper arm circumference is an established tool. It is used for assessment of malnutrition in infants and children, and very few studies have explored mid-upper arm circumference for identifying wasting among pregnant women. Such studies in India were not available, and hence we planned this study. My research question was that is mid-upper arm circumference comparable to early pregnancy BMI for assessment of nutritional risk? And the aim of my study was to compare body mass index and mid-upper arm circumference for assessment of maternal nutritional status in various trimesters of pregnancy. My primary objective was to study correlation between BMI and mid-upper arm circumference, and then to further study changes in both the variables during various trimesters of pregnancy. The prospective cohort study conducted at Lady Hardinge Medical College, and we included 80 women. However, due to loss to follow-up, the 300 women were left in our study, and hence then we concluded our results in these women. All the women who had singleton pregnancy and who presented in the first trimester were included. For sample size calculation, as I've said that 380, the calculated sample size was 384, and 84 women were lost to follow-up.
So in the first trimester, a detailed history was elicited and examination, and mainly focusing on the anthropometric measurements, including BMI and mid-upper arm circumference, was done at the first visit. Then both these measurements were subsequently repeated at a fixed interval of time in their different trimesters. Mean difference was calculated in the three values of BMI and mid-upper arm circumference, and then correlation was calculated between the first trimester BMI and the different trimester mid-upper arm circumferences. So BMI was calculated using the standard formula, and for this the Asian classification was used. Mid-upper arm circumference, there is no Indian classification, so we use Tanzanian adaptation for Indian setup, and the normal mid-upper arm circumference was 23 to 29.9 centimeter. So in the mean body mass index, we observed that in the first trimester, it was 22.9 and it increased to 28.2 in the third trimester. However, on the other hand, only an increase of 4% was seen in the mid-upper arm circumference. It increased from 24.2 to 25.3 in the third trimester. We also applied the ANOVA test to see if the change in both the variables is significant or not, and found out that the change in the mid-upper arm circumference category was statistically insignificant. Comparing the changes in the various categories according to body mass index, we observed that in the first trimester, majority of women were belonging to the normal category. However, in the second trimester, most of these women moved to the obese 1 category, and an increase of 11.7% was seen. And this further increased by 18% in the third trimester. So this graph depicts that if a woman is presenting in the second trimester, then she will be wrongly classified into either the obese category or the overweight category, while she will be having normal BMI. Also, the underweight women will also be skipped if you're using body mass index. However, on the other hand, in mid-upper arm circumference, the change was significantly lesser than compared to the body mass index. Only a change of 10% was seen from first to second trimester, and 5% was seen from second to third trimester. And most of these women remained in the same categories. Nutritional category changed in overall 84% women in body mass index compared to only 28% when we were using mid-upper arm circumference. Coming to the correlation, there was a positive correlation found between the first trimester BMI and mid-upper arm circumference, and only 0.5%, the Spearman's-Rowe correlation coefficient was found to be 0.5%. Also, we observed a positive correlation between the second and third trimester mid-upper arm circumference and the first trimester BMI. This shows that we can, if the correlation is positive between the different trimester mid-upper arm circumference and BMI, then mid-upper arm circumference was considered to be a reliable marker. Similar studies have been conducted in the East Asia in 2000 antenatal women, and they found a positive correlation between BMI and mid-upper arm circumference. However, a higher correlation coefficient was observed in this study. In India, a similar study was conducted. However, it was conducted in non-pregnant adolescents, and a positive correlation was found of 0.82. No such studies have been conducted in antenatal population in India. We concluded that mid-upper arm circumference and BMI were comparable. Yes, ma'am.
Your time is up. You can conclude.
Okay. So positive correlation was found between BMI and mid-upper arm circumference, and hence it can be used for replacing body mass index in women who are presenting late in their antenatal care. Thank you, ma'am.
I'll request my judges if they have any questions for Dr. Ekta.
It was just the comparison between BMI or anything else was during pregnancy, the diet or anything which was included?
Ma'am, we included the socioeconomic status of the antenatal women, the age. We also compared if undernutrition is more prevalent in which age groups, in which socioeconomic status, and we also compared the education status. However, we included only body mass index and mid-upper arm circumference for this presentation.
And all
diet and their
Yes, ma'am, diet and socioeconomic status. Diet was also calculated, and all those women who were having lower nutritional status, they were counseled also at their first trimester.
In the first trimester.
Yes,
and you included both, whether they were anemic or not?
Yes, ma'am.
All right. Nice presentation. It was good.
Thank you, ma'am.
Let's see how it works out, because more we are bothered is their anemia and bad obstetrical history. Like if you take only primigravidas, or you take multi, or those who have multiple pregnancy losses and something. And the most important part is their anemia, which we think of, before she conceives or during conception period, first trimester.
Yes.
But yes, of course, BMI we cannot rely on second and third trimester, because she's going to go increase her weight. Yes. So that is a reliable method, the mid-arm circumference. Yes. Good. Nice.
Very nicely presented, Dr. Ekta. But after you have done this study, can you conclude what is the major problem? Is it a malnutrition or obesity is the major?
Malnutrition was found to be more prevalent, with a prevalence of 56% women belonging to the undernourished. However, only 32% women were having overweight or obese according to BMI. And most of these women, both undernourished and overnourished, were found to be higher in the lower socioeconomic strata.
Okay. Well done.
Thank you, ma'am.
Thank you, Dr. Ekta. Now we'll be moving to the next presenter, and our next presenter is Dr. Sugandha Bansal, and her topic is prediction of placenta accreta spectrum by placenta accreta index in high-risk pregnancy. So I request Dr. Sugandha to join.
Good evening, ma'am. Am I audible?
Yes, you're audible.
My screen is visible?
Yes.
Yeah. Thank you. Good evening, everyone. I'm Dr. Sugandha Bansal, and I'll be presenting prediction of placenta accreta spectrum by placenta accreta index in high-risk pregnancies. Sorry, I'm not able. Placenta accreta spectrum includes placenta accreta, increta, and percreta. The most important risk factors are previous cesarean section and placenta previa. And in patients having both the risk factor, the risk of placenta accreta spectrum is seen to increase with increasing number of cesarean deliveries. The placenta accreta index uses clinical and ultrasound findings to predict the disorder in high-risk patients. For example, number of previous cesarean deliveries, grade of lacuna, sagittal smallest biometrial thickness, anterior placenta previa, or bridging vessels. Each parameter is given a weighted value and a total score from 0 to 9. So that a score of 9 means that 96% chance of having placenta accreta spectrum, and 1 score means 5% risk of having placenta accreta spectrum. Studies by Samisor et al. And Hamid et al. Have shown promising results for diagnosis of placenta accreta index. However, they have not evaluated the predictive value like sensitivity and specificity and area under ROC curve for each individual parameter. Neither have there been any studies associating a score with the risk of placental invasion and severity of maternal outcomes. Hence, this study was planned to study the placenta accreta index for evaluating each parameter and the total score, as well as to assess the association of the score with the invasiveness of the placenta along with the severity of maternal outcomes. It was a prospective study conducted in Safdarjung Hospital. A total of 71 women were taken with more than 28 weeks of gestation with placenta previa and 1 or more previous cesarean section were enrolled in the study. Informed consent was taken and procedure was explained. History taking and examination was done, and a transabdominal ultrasound was done, and placenta accreta index score was calculated. We have figure 1 showing bridging vessels, and we have figure 2 showing ultrasound film with placental lacunae. Operative findings and histopathological results were corroborated with the score. The patients were followed up post-operatively till discharge from the hospital. The ROC curve of each individual parameter and the total score was evaluated, and the correlation of the total score with maternal outcomes was calculated. Among 71 patients, 30 were found to have the disorder, while 41 were used as a control group. Table 1 shows the correlation of the individual parameters as well as the total score for predicting placenta accreta spectrum. we can see that breed of Lacina had 100% specificity and positive predictive value, while sagittal smallest myometrial thickness had highest sensitivity and negative predictive value, giving both these individual parameters an 88% predictability. The cutoff value for placenta creta index for predicting past disorders was calculated as 4.75 with an area under curve of 0.87 as shown in figure 5. The p-value came out to be less than 0.0001 with sensitivity of 73, specificity of 95, positive predictive value of 91, and negative predictive value of 83%, giving it a diagnostic accuracy of 85%. We have table 3, which shows the association of the placenta creta index with the histopathological findings, where we see that the mean of 2.95 was for focal placenta creta, 6.10 for complete placenta creta, 7.66 for placenta in creta, and 7.9 for placenta per creta. We can also see that the past disorders had more blood loss, and hence more units of blood products were transfused, and the patient stayed in the ICU for more number of days than those without past disorder. Table 4 shows the correlation of the score with the maternal outcomes, where the Spearman rank correlation coefficient came out to be approximately 0.7 for estimated blood loss, total blood products transfused, and post-operative ICU stay, and the p-value of less than 0.0001 for each of the parameters. Thus, we can say that all individual ultrasonographic parameters had a significant association with past disorder, and it was known that these disorders are more prevalent in higher order cesarean. But because we could not evaluate this parameter satisfactorily because we had very few patients with more than one cesarean section, which is similar to the study by Samis et al., probably due to cultural and social factors in the population that we cater to in our hospital. And it is unlike the study by Hamid et al., where majority of the patients that they took for the study were more than 2 previous cesarean section. A p-value of 0.97 for differentiating invasive and adherent placenta suggested that an increase in score is associated with increasing placental invasion. Also, increase in the score is associated with increased severity of maternal outcomes like blood loss, number of blood products transfused, and post-operative ICU stay. The strength of our study was that it was a prospective study, thus reducing selection bias. All the ultrasounds were carried out by a single investigator, thus no inter-observer bias. All the pathologists were blinded to the study, to the total placenta creta index score. The clinical relevance of our study is in establishing the value of the index score for not only diagnosis, but also prognosticating the disorder, thus helping in timely referral of the patients to Center of Excellence and improving the maternal outcomes by by a multidisciplinary approach, as well as allocating adequate resources in a higher center. Limitation of our study was that most of our patients were from a small demographic area, as it was a single institutional study. Factors like mode of conception, history of other uterine procedures known to be associated with the disorder were not included in the score we evaluated. Thus, by the study, we can conclude that the placenta creta index score is a useful tool for establishing a standardized criteria for diagnosis of placenta creta spectrum with a cutoff value of more than 4.75, and the score is also useful for predicting placental invasiveness and severity of maternal outcomes. Thank you so much.
You're well on time, Dr. Sugandha. We still have 15 seconds left.
Thank you, ma'am.
Now I'll request my judges if they have any questions for Dr. Sugandha.
Very nicely presented, Dr. Sugandha. I think we should congratulate Safdarjung Hospital. Most of the candidates are from Safdarjung Hospital. And my question is that many times we see lacunae. How do you grade them?
Ma'am, in our study, we have used the Williams and the Finberg principle, where the grading, grade 0 is where none of the lacunae are seen. Grade 1 is where 1 to 3 lacunae, small in size, were seen. Grade 2 is where 4 to 6 lacunae were seen, large in size and irregular. Grade 3 is where multiple large irregular lacunae were seen throughout the placenta with turbulent flow inside them.
Did any of your patients had antenatal MRI?
Ma'am, no, we didn't. Ma'am, MRI is it's seen to be equivalent to ultrasound in diagnosis of the placenta creta spectrum. It is used as an adjunct in patients where there is where we suspect creta or we suspect posterior placentation. Ma'am, in our institution, it is difficult to get an MRI done for patients unless they get it done from outside. We're not able to get a date.
In government sector, it's difficult to advise MRI.
So if your patients had a placental index of more than 4 or 4.75, as you said, were any special thing, or did a hysterectomy was done, but it was planned sort of from the very beginning?
Yes, ma'am. Ma'am, in our hospital, in such a case where we are suspecting a placenta creta spectrum, we plan a hysterectomy as an elective cesarean. Hysterectomy is planned during the morning time between 35 to 37 weeks. And ma'am, by a multidisciplinary approach, ma'am, so a surgeon is kept on call, urogynecologist, ma'am, senior obstetrician, senior neonatologist, anesthetist. Ma'am, blood is, ma'am, we have 1:1:1 ratio. Blood is for packed cell, PRP, and FFP is arranged for the patient.
Yeah. Dr. Nancy, now.
Thank you, Dr.
You have another presenter?
No, ma'am. Thank you, Dr. Sugandha. And I'd like to thank all my presenters for wonderful presentation. And we have made all in the time, and we are well on time. And I'll also thank all my judges for the wonderful discussions. And I'll also request the judges to please send the score sheet on aogdvirtual@gmail.com, ma'am.
Sure. Thank you for giving us an opportunity. Thank you.
And Dr. Sonam and Dr. Anjali were not there?
No, ma'am, they are not there. We have almost finished all the presenters.
Okay. Oh, nice.
Okay, ma'am.
Done. Thank you very much.
Thank you so much, ma'am, for your time.
Anubhuti and Dr. Shweta Balani.
Thank you, ma'am.
Thank you very much. Thank you, Dr. Nancy, to conduct the whole sessions so beautifully and smoothly. Thank you so much.
We had some technical glitches initially, but we managed it well on time.
Yeah.
We have been conference and we are doing it well.
Yes, ma'am.
Yes, we're doing that.
So I think now for the day we can leave.
Yes, ma'am. Thank you so much. Thank you, everybody. Thank you, all the participants.
Okay, thank you. Bye-bye.
Okay, ma'am.